Yeah. Good morning, everyone. Good morning. Yes. गुड मॉर्निंग। या हाँ, आराम से 2 बजे तक तो हो जाएगा। क्यों नहीं होगा? 2 बजे तक क्या करेंगे हम? 4 घंटा किसके लिए? हाँ, उससे पहले ही हो जाएगा। इज इट ठीक है? यू नो वेल, राइट? ये हो जाएगा कि नहीं? ओके, फाइन। चलो, shall we start without wasting a single minute? राइट। या इसमें कुछ लिखने ऐसा कुछ नहीं रहता। हर चीज हम ओके वी कीप ऑन गोइंग कंटिन्यूअसली, राइट? चलो, आई एम straight away starting, so hoping that your revision is going at a well pace. Okay, and okay, fine. So again, before exam also I'll be releasing a short video again, so don't worry. The even most okay concise topics also short video I'll again okay. Right, chalo. So you know the how we go first year, okay? So first in the year we'll be going to the pinna, and coming to the pinna, you know it is a single piece of yellow elastic cartilage, and you have the outermost elevated border helix, right? So this is your helix, antihelix, anterior pointed cartilage tragus, and this is your antitragus. The central C-shaped depression is your concha, right? So you know all these things. The only area where there is no fat in the pinna is called as lobule. There is no sorry, which is containing only fat. No cartilage area is this lobule. That's why in perichondritis, where your perichondrium is involved, which is present surrounding the cartilage, entire pinna is involved, but the lobule will not be involved. The sign of lobule sparing will be seen in perichondritis. You know that, right? And coming to the embryology, you know first and second pharyngeal arches, and the first arch gives rise to tragus, right? First arch gives rise to tragus. The second part gives rise to remaining part of the pinna. If they do not fuse properly, first and second do not fuse properly, a small gap may arise in between them. A tract, sinus tract may be present in between them, and the outer opening of this will be presenting outside on the surface of the skin. On the surface of the skin, you can see a small opening, and inside the continuous tract may be seen inside. So this is called as pre-auricular sinus, which is most common congenital ear anomaly, as the sinus single-sided opening sinus is present anterior to the auricle. So pre-auricular sinus. If no infections, you need not do anything. If repeated infections are there, go for surgical excision. Simple. A patient present with repeated infections from the lesion shown in the image. So this is preauricular sinus, and this is derived from first and second arches. From the first cleft, your external auditory canal will develop. From the first pouch, eustachian tube will develop, right? And coming to the pinnaplasty or otoplasty, more than it is done usually after or at 6 years. Minimum 6 year age to आना चाहिए बच्चों को. और because the reason is that the rib cartilage, chondral cartilage will get enough strength, and it attains the pinna will attain almost near adult size, and the co-students, other colleagues, okay, peer teasing maybe okay there at that age. So before sending to school, get this otoplasty done and send the child to school from 6 years of age. So if pinna is normal, peer teasing won't be there. Now the surgery that should be done under 6 years of age, less than 6 years of age, should be the cochlear implantation in prelingual, congenital, prelingual, before development of the speech. जिसको hearing loss हो गया, severe hearing loss, congenital hearing loss है, उन लोगों को less than 6 years you have to undergo cochlear implantation, because in this age only, under 6 years age only, you have this flexibility of the neurons to adjust to the external stimuli, neural plasticity. In postlingual deaf people, there is no age limit. So this is you need to remember. Okay, so coming to the perichondritis pinna, most common organism is Pseudomonas. Pseudomonas infecting pinna is perichondritis. Pseudomonas infecting external auditory canal, malignant otitis externa. Clinical features: pain, tenderness, erythema. Classical sign is lobule sparing. Why lobule sparing? No cartilage. So where is the perichondrium? So no perichondritis. And if you press the tragus, there will be pain. So tragal sign is positive. If I am pressing the tragus, when I am pressing the tragus, if the patient is getting giddiness, that is fistula sign seen in perilymph fistula, right? Now treatment here is anti-pseudomonal antibiotics, ceftazidime, cefoperazone, fluoroquinolone, ciprofloxacin, ofloxacin, piperacillin. All these are anti-pseudomonal, right? And coming to the nerve supply, I already told you it is difficult to remember which all areas of the pinna is supplied by greater auricular. So you remember the auriculotemporal, anterior-superior portion of the pinna, that is your crest of the helix and tragus. So these are supplied by right auriculotemporal nerve, which is a branch of mandibular division of trigeminal, right? And this nerve is supplying not only the anterior superior portion of the pinna, it goes inside also in the same way. Inside also it goes in the same way and supplies anterior superior portion of the external auditory canal. Still it continues anteriorly and it supplies the anterior half of the tympanic membrane outer surface also. Okay, and now coming to the vagus, the concha is supplied by the vagus nerve, right? And from the concha along the posterior wall, your vagus and facial branches will be supplying. And from there on the outer surface of the tympanic membrane, posterior half is supplied by the same vagal and facial branches. Hope you got it. Okay, so these are the major nerves that are supplying the majority portion of the ear. Now coming to the pinna, greater auricular nerve, except concha and anterior superior surface, the remaining entire area is supplied by greater auricular nerve. Greater portion of auricle is supplied by this nerve, greater auricular nerve. Okay, fine. अभी समझने का समझाने का सेशन नहीं है ना. ओके, अभी रिवीजन का सेशन है. दिस इज रिवीजन. ओके, फाइन. Now coming to the external auditory canal. Yeah. Now coming to the embryology, it develops from the first cleft, right? Now coming to the anatomy, outer one third is cartilaginous, inner two third is bony. How to remember? To a central piece of bone, outside one cartilage is attached, inside one cartilage is attached. So if you take external auditory canal, you see outer one third cartilaginous, inner two third bony. And if you take the eustachian tube, outer one third bony and inner two third cartilaginous. What is the length of the external auditory canal? 24. So outer one third becomes 8 mm cartilaginous portion, inner two third becomes 16 mm out of this, and this becomes the bony portion. And what is the orientation of the outer part? The outer part is directed in this way, right? Upwards, backwards, and the inner part is directed downwards, forwards. Now to examine the pinna, to examine the ear, in which direction you have to pull the pinna? Upward, backward. So when you pull the pinna upward, outward and backward, the outer part will go in this way. This will get aligned with the inner part. Now when you pass the otoscopic light from here, it directly falls on the tympanic membrane and you can see the complete ear. So complete ear examination can be done. Direction of pull of the pinna is upward, outward, backward. Okay. Now, okay, so for ear examination, pinna pulled upward, outward, backward. Now, you have the lining is the keratinizing squamous epithelial lining is there outside. So keratin cells will be produced. Squamous epithelium. So the squamous cells will be coming here. So desquamated cells will be there. Here in the cartilaginous part, you will be having the pilosebaceous unit. Pilosebaceous unit. Okay. So what is this pilosebaceous unit? Means pilo means hair, sebaceous gland. Under the skin, sebaceous gland will be there. From there, hair follicle, hair will arise. So that entire unit is pilosebaceous unit. So desquamated hair, sebaceous gland, sebum secretions, ceruminous glands, cerumin secretions, all these will mix. Dirt from outside. So keratin, desquamated cells, sebum, cerumin, hair, all those things will mix here in the outer part to form this wax. So you all know this, right? Now coming to the otomycosis, most common is Aspergillus niger, Fungal sinusitis most common is Aspergillus fumigatus. Oral may Candida is the most common. So patient may complain of pain, itching, musty odor, discharge, block, hardness of hearing. Variety of mixed presentations will be there. Not exact typical presentation won't be there. Each patient will be presenting with different mixture of symptoms. The first treatment, the first management option is you have to completely clear the fungal debris. You have to remove everything out. Oral toileting needs to be done, and then antifungals. Yes, right now systemic and topical, both systemic and topical needs to be given NSAIDs and antihistamines. So the appearance that you see is called as wet newspaper appearance. You can see that wet newspaper in your previous PDFs, right? Now coming to the Ramsay Hunt syndrome caused by herpes zoster virus. I mean, exactly, varicella zoster virus is the causative organism. So if varicella zoster is causing, during childhood it might have infected and lying dormant somewhere in the ganglion, geniculate ganglion. Now during childhood it has caused the chicken pox. So this chicken pox history during childhood will be there in these cases. Geniculate ganglion is the site of residual dormant lying virus, and so whenever you go into some immunosuppression, this virus will reactivate and it starts spreading along the facial nerve. The geniculate ganglion is related to facial nerve. You all know that. Now, so where is the facial nerve distributed? Concha, posterior wall of the external auditory canal, outer surface, posterior half of the tympanic membrane, outer surface. So everywhere you will see what is the typical feature: small blister like vesicles you will see, and severe pain will be there to the patient. In Bell's palsy, there is no pain in the ear. In Ramsay Hunt syndrome, there is pain in the ear. And along with that, sometimes you can see facial palsy, and very rarely you can see SNHL also. Treatment is you have to give antivirals and corticosteroids. So patient presenting to you with the painful vesicles inside the ear and facial palsy, this could be Ramsay Hunt syndrome. And the history of chickenpox during childhood is there, then this is confirmed even. Okay. Patient is presenting with painful vesicles on ear and facial nerve palsy. So cause will be Ramsay Hunt syndrome and geniculate ganglion. So what is this Mulkerson-Rosenthal syndrome? Alternating facial palsy episode. One time right side, one time left side. Fissured tongue, edematous lips. Gradenigo syndrome, petrositis UC. We know that. Yeah, acyclovir can be given and corticosteroids can be given. Now coming to malignant otitis externa, it is a misnomer because it behaves like a malignancy. Why it is called as a necrotizing otitis externa? Because whatever tissue it enters into, it damages that tissue, necros the tissue and go inside, spreads inside, invades inside. So it is necrotizing otitis externa. Skull base osteomyelitis. So what is the partition bone? The upper superior wall of your ESC and middle ear. All these are forming a part of the skull base. Above that, you are entering into the skull. So that skull base bone is getting infected. So it is also called as skull base osteomyelitis. The causative here is Pseudomonas, immunocompromised, uncontrolled, elderly, uncontrolled, severe diabetics. So there will be severe excruciating pain more during the night times. Purulent discharge. Why purulent discharge? Bacterial infection. Granulation tissue. Why granulation tissue? Because the organism is going into the tissue and the tissue is trying to protect itself by forming the granulation, by surrounding the, this invading organism, it forms a granulation tissue. Okay. Now, what are the investigations? So, doubting, if you have a doubt that this should might be Pseudomonas, then take the ear swab and send it for culture sensitivity and CBP with ESR. So mostly it is seen in elderly uncontrolled diabetics. So get a diabetic profile done. Now treatment is anti-pseudomonal. For 6 weeks you have to give. Every week the patient needs to be on follow-up. Along with that, NSAIDs needs to be given. Complications are if the organism getting spreaded inside completely, facial palsy. If it goes intracranially, intracranial complications, as you see in CSOM, those may be there, SNHL. And so if the patient by the time he has presented to you, already complications are there, means it's better to go for surgical debridement. So, okay, you haven't gone for surgical, patient has just come with these complaints, you diagnosed it as malignant otitis externa and you have given treatment for 6 weeks. Now, whether this condition is improving or not, the patient will come every week for follow-up. So during every week, you have to get these tests done. Gallium for checking the soft tissue, amount of soft tissue involvement, technetium scan for bony tissue involvement. If at all you have to choose in between these two, you may go for gallium alone. Okay, if these two are given in the options and the examiner asks you to select the best method of these two, not this one, of these two, then you need to go for gallium. See, okay, right? So, and if these are not available, you are practicing in a remote area, village area, these are not available for the patient, then you can just check for ESR. So, if three options are given in your exam, even in exam also, you need to answer gallium only. Okay, if you are sitting in your clinic after you are, okay, if provided you are taking, okay, ENT, provided, right? Now, ESR will be your best choice. Okay. Okay, right? Am I going fast? No, 10-15 दिन पहले लैब टू हुआ था ना. दिस इज रिवीजन. नो, नो. जिसको पहले लैब 1 लैब 2 का आइडिया है, वो लोग कैन इजीली कैच दिस लैब 3. Lab 3 is beneficial for those who followed Lab 2 and Lab 1. It's not that, but Lab 3 alone can give you a fast revision. Okay. Don't try to. Those who are coming immediately for Lab 3 directly here, just try to follow just the class. Okay. Yeah. Okay. Fine. Okay, a 60-year-old diabetic presented with severe pain in the ear, otorrhea, not responding to regular antibiotics, granulation tissue, facial nerve palsy. So you know the diagnosis malignant otitis externa. This is your wet newspaper appearance, your otomycosis, and this you can see tympanic membrane normal. Inside the middle ear, within the middle ear, you can see the serous fluid, the brownish serous fluid here down, okay, collecting in the middle ear cavity. You can see the air fluid level. Okay, air fluid level. Can you see here? Okay, this is air normal content in the middle ear, and this is your serous fluid collected in the middle ear. And this is eczematous otitis externa. Just the skin over the low conchal area will get involved here. Okay. What happened? Is it difficult to follow? But see, 4 hours marathon है तो ऐसे ही जाना पड़ेगा, isn't it? Fine. A diabetic patient with excruciating ear pain, blood stain discharge, facial nerve involvement. What is the diagnosis? If you see here, this is your necrotizing otitis externa. See, excruciating diabetic patient, excruciating ear pain, blood stained ear discharge. Why blood stained? Bone damage is happening here. It's skull base osteomyelitis. So blood stained ear discharge. So facial nerve involvement. So here in diffuse otitis externa, you won't see this facial nerve involvement, isn't it? So this is diffuse external ear will get involved diffusely. You see a completely congested edematous reddish, and you can see the purulent discharge coming out, right? So this is how the entire surrounding walls of the canal are completely inflamed. What have become what see the lumen of the canal, it has become very narrowed due to the surrounding bulging, diffuse bulging edema of the surrounding mucosal layer, I mean squamous layer, right? Now come to serous otitis media. See the normal tympanic membrane and see multiple air fluid levels, bubbles you can see inside the middle ear, inside to the tympanic membrane, and this is granular meningitis iatrogenic. Okay, so someone new surgeons may cause this. Okay, so this is granular meningitis or meningitis granulosa. Painless purulent discharge will be there. Here only you can see the small micro granulations on the surface of the tympanic membrane. If you take the entire canal, which is everywhere normal, on this only tympanic membrane only you can see this. So mostly they will be having a history of ear surgery. So iatrogenic and a painless otorrhea is the typical feature in meningitis granulosa or granular meningitis. Now, you know what is wax. Okay. Now, what are the methods to remove the wax? Syringing, not this one. Syringing, okay, and mopping and probing. So the best one is suctioning. So under endoscopic vision, try to suction out whatever the contents are there inside. There is a probe called as Jobson horn probe, which has an angled thing here, and you can go behind. It will be angled. If this is the wax, go behind to that and pull it out. So that's how you utilize the Jobson horn probe. Syringing is obsolete nowadays. Mopping, if there is slight here and there stains is there, you can just mop it up. So these are the methods. Suctioning under vision is the best method. Patient diagnosed with earwax subjected to syringing. In which direction you are syringing? Posterior superior. Posterior superior wall is supplied by which nerve? Vagal and facial branches. See, this patient while syringing developed syncopal episodes, means facial vagal got stimulated. सिंकोपल एपिसोड आया तो कौन स्टिमुलेट हो गया? फेशियल स्टिमुलेट होने से सिंकोप नहीं आएगा, तो वेगल स्टिमुलेट होने से सी पैरासिम्पैथेटिक ब्रेडिकार्डिया सिंकोप हो सकता. So patient has developed syncopal episode when the tip of the syringe touched the ear canal. The responsible nerve is Arnold's nerve. Okay, right? A patient presented with following finding. See, what is the finding here? Entire clotted, blood, already some trauma has happened, and the blood whichever has come earlier has been clotted. Completely it was clotted, and there is no active bleed now. When there is no active bleed, don't do anything. Okay, your eardrum is normal, even though it is perforated, you don't actively do anything. Now, the next step in management, aspirate the clot. Never aspirate a clot. Identify the source of bleeding. इधर bleeding है ही नहीं तो कहाँ से? Okay, what you will identify. Now coming to the next option, keep the ear dry and give oral medications. Yes, this is very important. So some bleeding occurred means some fracture, maybe there's some edema, maybe there's somewhere else. So just give some oral medications for 5 days and then review after 5 days. And if there is hemotympanum also, blood in the middle ear also, you can wait for at least 15 days for it naturally to resolve. After 15 days, then you go for Puton audiometry, right? So hope you are able to follow, and I think we are going with the proper speed. Okay, so that within 4 hours we can revise, right? Because 15 days earlier only we have completed lab 2, no? Right? So you'll be having a decent idea provided. Okay, terms and conditions apply. Right. Now coming to the anatomy. So the tympanic membrane is oval in shape, right? And yes, 8 to 9 mm wide, 9 to 10 mm tall, 0.1 mm. Okay, no one is going to ask you this. And what are the parts of the tympanic membrane? Pars tensa and pars flaccida. So what do you mean by pars flaccida? This is your lateral process, lateral, outside projecting part of the malleus, lateral process of the malleus. Okay, so this is lateral process, and this is handle of the malleus, right? And this is your tip of the malleus. So lateral process of the malleus, handle of the malleus, tip of the malleus, and a cone of light. These four are landmarks of tympanic membrane. Above the lateral process of the malleus, here, this one, okay, this is pars flaccida part. This is your pars flaccida part, right? And below one, all this entire thing, okay, this entire thing is your pars tensa part, right? Okay. Now, what is the differences between tensa and flaccida? The name itself is telling tensa. So it is tense, tight, strong, because three layers are present here, and the peripheral part is thickened to form a ligament. See the peripheral whitish thickening band over here. Can you see? That is the peripheral thickened part of the middle fibrous layer. Annulus ligament, you call it as. In the flaccida, the middle layer is absent. Only two layers are present. So obviously, the annulus itself is being formed by the middle layer. When the middle layer is absent, obviously the annulus is absent here. And the name itself speaks flaccida, flaccid, weak. The strength imparting layer to the tympanic membrane is fibrous layer. Because inside mucosal will be very, loose layer. Outside squamous epithelium will be very loose layer. In between these two, the fibrous layer is the actual strength imparting layer, but that is absent in pars flaccida. Right? Now, hope you are able to follow. Okay, I think you are able to follow this, right? Okay, how to identify the sites? If you are seeing cone of light, so at 5 o'clock position, cone of light is there right side. 7 o'clock cone of light is there left side. Another way down, if your handle of malleus is directing towards 1 o'clock, that is right side. Handle of malleus is directed toward 11 o'clock, that is left side. Or you can draw a line along the landmarks of the tympanic membrane. Along the handle of malleus and cone of light, you draw like this continuous line. Now this is facing towards, greater side is facing towards right. So this is right ear tympanic membrane. Okay. For a left ear tympanic membrane, if you draw lines like this, it will come like this. So this will be facing towards left side. So this could be left eardrum. Okay, tubercular otitis media, mycobacterium, it's a causative organism. Treatment will be ATT, anti-tubercular treatment for 6 months. Then after you will go for meningeoplasty and tympanoplasty. The most important thing you need to remember here is multiple perforations. And wherever TB is there, it will be painless. Granulomas, it will be forming. Okay, multinucleated giant cells, small granulomas, it will be forming. Tough fibrous granulomas, it will form. But no active, okay, red inflammation will be going because it's a very slow chronic process. So painless. Only larynx, TB larynx is painful. All other TBs are painless. So whenever you see multiple perforations, suspect tuberculosis first and take some specimens, send for culture sensitivity or do some Mantoux test and chest X-ray, all those things for primaries. So now, okay, and so once detected, confirmed as tuberculosis, go for ATT for 6 months, right? Then after 6 months, once the TB is gone, now you go for the repair of the tympanic membrane. So the futures will be multiple perforations, painless otorrhea. So pale granulomas, you can see here and there, pale granulomas, and discharge will be there. Okay. Now coming to the middle ear. Now, so what are the ossicles in the middle ear? Malleus, incus, and stapes. So this is malleus, head, neck, processes, handle, and tip. And so your incus has got no head, बॉडी शॉर्ट प्रोसेस लॉन्ग प्रोसेस लेंटिकुलर प्रोसेस और दोनों के बीच में फंस गया है एंड योर स्टेपिस हैज गॉट अ हेड नेक एंड क्रूरे एंड फुट प्लेट्स सो the malleus and incus are developing from first arch and stapes is developing from second arch and but exception is your foot plate which develops as a part of your inner ear bony labyrinth. That embryonic structure of inner ear bony labyrinth you call it as otic capsule. Okay. ओके फंस गए आप लोग भी बट ठीक है नो प्रॉब्लम सो द मोस्ट कॉमन ऑसिकल टू गेट नेक्रोज इज इनकस राइट Right. Okay. Which of the following middle ear structure is a derivative of neural crest cells, foot plate of stapes, right? This is, I told you, as per another standard textbook, this is okay. But okay, don't get unnecessarily worried now. Okay. At this moment, it's better you remember the malleus incus develops from stapes. It's first arch. Stapes develops from second arch. S, S. Stapes second arch. S, S. Okay. इनकस को दो प्रोसेस है भाई शॉर्ट प्रोसेस है लॉन्ग प्रोसेस है इनकस को दो प्रोसेस है शॉर्ट प्रोसेस है लॉन्ग प्रोसेस है ओके आपका हेड निकालूंगा मैं तो आपको क्या होगा एक शॉर्ट प्रोसेस होगा नीचे आपका पैर है वो लॉन्ग प्रोसेस होगा ठीक है नीचे आपका फुट रहेगा ना वो लेंटिकुलर प्रोसेस होता ओके ओके राइट फाइन नाउ which of the, so this is over. Now coming to the walls of the middle ear, anterior wall, because your eustachian tube has to come and open anteriorly into the nasopharynx. Compared to your ear, nasopharynx is anterior. So if a tube, okay, has to run anteriorly, it arises from the anterior wall. So eustachian tube anterior wall, ET, along with ET, TT is there. Tensor tympanic origin is there. So these are the two openings you see on the anterior wall. Lateral wall, what is the lateral wall? It's nothing but your tympanic membrane and the bone above that, that is your scutum. So this forms your lateral wall. That is very simple, right? Right, fine. Now coming to the posterior wall. So we'll discuss about posterior wall later. Now come to the medial wall. रूफ और फ्लोर में क्या है, एक प्लेट ऑफ बोन है बस, ओके। और मीडियल वॉल, आई टोल्ड यू वेन एवर यू प्रैक्टिस मीडियल वॉल, ऑलवेज ड्रॉ इन द सेंटर promontory, postero superiorly oval window, postero inferiorly round window, antero superiorly processes cochleariformis. What is this promontory? Basal coil of the cochlea. See, this is your cochlea coiling inside. See, this is your middle ear, this is your inner cochlea. See the cochlea forming bulge over here? That is nothing but promontory. Now, okay, so postero superior you have oval window and round window postero inferiorly. So your oval window will be leading into the sound waves which are going through the stapes footplate attached in the oval window. They will be going into scala vestibuli, and at the apical coil, helicotrema, where it is continuous, the scala vestibuli is continuous with the scala tympani. Now the sound wave will come back through this and it will hit the round window back. Whenever oval window, I mean stapes footplate and round window membrane, both will be moving in the opposite faces to each other. Okay. Now, इतनी बुरी कॉकलिया, कैसे बुरी कॉकलिया? तो यू आर एबल टू लिसन ऑल एंटायर थिंग इन योर लाइफ बिकॉज ऑफ दिस कॉकलिया। अगर ये नहीं होगा तो सुनाई नहीं देगा, तो कुछ भी समझ में नहीं, अगर सुनाई नहीं देगा तो समझ में नहीं आएगा। ठीक है, राइट, ओके। Now, coming to the posterior wall, only structure here is the pyramid. Immediately as I turn from medial to posterior, near to the medial wall, the pyramid will be arising from the posterior wall. Okay, right. Yeah, cochlear implant will be through the round window, will be inserting into that scala tympani part. Okay. Now, so you know the medial wall structures mainly promontory, postero-superiorly oval window, postero-inferiorly round window, antero-superiorly processes cochleariformis. Now, little bit, now just what happens here from the, if you see on the postero-superior, still if I go postero-superiorly, a semicircular canal will be forming a projection here. So if I am telling you a projection of one of the canals is seen on the medial wall of the middle ear, see that medial wall of the middle ear is a common partition for the inner ear also. If I am telling you this wall as the medial wall of middle ear, right? This is middle ear, this is medial wall. For inner ear, this will be lateral wall. Now for inner ear, I am telling you lateral, one semicircular canal is coming and forming a projection on the lateral wall. So out of three canals, which could be that lateral canal? Isn't it? As it is lateral, it is named as lateral canal. Now lateral canal will be forming a projection, most posterior, superior, okay, medial, posterior, superior junction, the lateral semicircular canal will be present. So inside your cochlea will be arranged, inner ear will be arranged in this way, inside to the middle ear. Right. Now coming to the ponticulus, from promontory, one bony elevation will come and touch to the pyramid, that is called as ponticulus. From the round window, another bony elevation will go towards posterior wall, that is subiculum. Between ponticulus subiculum, the depression cavity is called as sinus tympani. See, this is your promontory, this is your pyramid. So the bony elevation here is the ponticulus. This is your round window. From here, see, subiculum is going. In between ponticulus and the subiculum, you have this depression cavity, that is your sinus tympani. The residual site of cholesteatoma, leftover cholesteatoma, can be present over here. क्या हो गया? Facial nerve. So you know the facial nerve is coming from inside. Now it is passing over the inner ear. Above to the inner ear it is passing. Now it is coming and entering into the middle ear. Now as it enters into the middle ear, on the medial wall as it enters, immediately it forms a ganglion. This is the first bending of the facial nerve, first genu of the facial nerve. Okay, right? Now, this is geniculate ganglion. From here, greater superficial petrosal nerve will arise, right? Now, as it touches the medial wall, then it starts running horizontally on the medial wall. It starts running horizontally on the medial wall. Once it touches the posterior wall, now it starts running vertically, obliquely downwards. Once it touches the posterior wall, it starts running vertically, obliquely downwards. Now, after crossing the level of the middle ear, See, from there, one more branch arises, chorda tympani, that will again enter back into the middle ear cavity laterally. Now, see here, the facial nerve is coming medial to lateral direction like this. Now, as it crosses the level of the middle ear, it gives rise to a branch, chorda tympani, that enters into the middle ear and runs anteriorly, exits from the anterior wall. So this is going into the cavity of the middle ear from this wall here, right? From here, right? Now, there is a triangular area in between the descending vertical mastoid segment of the facial nerve, vertical segment of the facial nerve, other name is mastoid segment, because posterior to this wall, what is there? Mastoid is there. Posterior to this wall, what is there? Mastoid is there. So this wall is called as, so this segment of the facial nerve is called as mastoid segment, or vertical segment, or posterior segment, or descending segment. So this is your medial, okay, this forms the medial boundary of this triangular recess here. Chorda tympani forms the lateral boundary of this triangular recess here. Above you have in the cavity, the incus short process is there here, right? So the three boundaries, I mean your facial, chorda and incus, all these are enclosing a triangular recess here that you call it as facial recess. Okay, so you can see here. Now, what are the lesions of the facial nerve? See, if the lesion is translabyrinthine towards the inner ear side, if it is there present towards the inner ear side, now what happens? Your GSPN cannot send impulses. Okay, nerve to stapedius cannot send impulses. Chorda tympani cannot send impulses. Now, what happens? Three are not able to send the impulses. So, if there is a lesion in the translabyrinthine area, okay, towards the inner ear side in this area, now none of these tests will be positive. Now, if there is a lesion on the horizontal segment, now what happens? GSPN will be able to conduct the impulses, but chorda and nerve to stapedius, these won't be able to send the impulses due to obstruction by the lesion here. Now, so GSPN is functioning, so lacrimation is there, but stapedial reflex and chorda tympani taste are absent. Now, if the lesion is on the vertical descending mastoid vertical segment, now what happens here? Your nerve to stapedius is functioning, GSPN is functioning, but what happens to the chorda? Chorda is not functioning. Okay, so taste is not absent, not present here, absent here. Baki dono present hai. Now, when the lesion is even distal, peripheral, now what happens? Only facial palsy may be there. The other remaining three things may be present. Now, from geniculate ganglion, GSPN will be arising. Right? Yeah, through the geniculate ganglion, they'll be going. Clear? See, in trauma, okay, road traffic accidents, RTS, trauma cases, the most common part of the facial nerve that gets damaged is the vertical or mastoid. So clinically, we will be seeing these cases most commonly. So the examiner is more prone to ask this one to you in the exam if he wants. A post-trauma patient presents with the facial palsy, okay, angle of mouth deviation, and he may ask you, okay, and he may ask you the taste is okay. The patient cannot sense the taste in the anterior two-third of the tongue, and but his stapedial reflex is intact, and his squamous test is okay, normal. Now, what does that mean? The lesion is on the vertical or mastoid segment. ओके, सो अगर कोई लोग है ये पूरा टॉपिक पता भी नहीं, ओके, जस्ट ये, ओके, अभी पहली बार ईएनटी सुन रहा है, पढ़ रहा है, तो एटलीस्ट ये लाइन याद रखना. ओके. Yeah, FNP will be seen in all, no? Wherever lesion is there. Lower motor neuron, FNP will be there. Now coming to facial recess, see this is the posterior view. During cochlear implantation, the electrode will be sent through the facial recess. This is superior view. I'm seeing the facial nerve here medially, chorda tympani laterally. So this is the facial recess area in between those two, and I'm sending the electrode through the round window into the scala tympani of the cochlea, right? So I'm entering the middle ear posteriorly. I'm entering into the tympanum, opening the tympanum from posterior wall. Posterior tympanotomy. The recess I'm utilizing here is facial recess, right? The window I'm utilizing here is round window, where I'm exactly inserting the electrode into the scala tympani. Now, what is Prusak space? This is the most common site for cholesteatoma. You know that, right? So between the, okay, the scutum bone, the bone which is present above the tympanic membrane, scutum bone, and the malleus, you have this Broussard space. Tuning fork test, I told you very simple. Rinne's test, what you will do for Rinne's test? Okay, you will check for air conduction and bone conduction. And this side also you'll check for air conduction and bone conduction. And for a normal person, air conduction better than bone conduction, air conduction better than bone conduction. And when I do the Weber is central, no lateralization to any side, central, right? This is how a normal person presents. Now, if there is conductive, for example, right side conductive hearing loss is there. Rini is negative, means Rini air conduction is less, but bone conduction is better. Because if conductive hearing loss is there, means air conduction is affected. So air conduction decreased, bone conduction normal. So BC, bone conduction better than air conduction, indicates Rini negative. That means conductive hearing loss. This side normal ear, so Rini positive. Now if I do a Weber should confirm the Rini finding by telling that Weber lateralize towards the affected ear. If this ear has got conductive hearing loss, Weber will lateralize towards the affected ear. So this confirms my Rini finding. So this right side I am having conductive hearing loss. This is confirmed. So if I am having right conductive hearing loss, Rini negative, Rini positive, Weber right side. Done. Now, if I'm having right side SNHL, sensory neural hearing loss, now what happens? Rini will be positive only because both are affected equally. Rini positive. This is here, normal here, Rini positive. Now, if I take the Weber will lateralize towards the normal ear. Now that means the affected ear has got SNHL. So this is how an SNHL patient tuning fork test will be coming up. Right. Now there is a condition called unilateral severe SNHL. One side cochlea is not functioning at all. Now here if I do a Rini, now I may get air conduction, the patient will not feel. Now when I do for the bone conduction, as this cochlea is completely dead, almost severe to profound loss is there. Now what happens to the sound? The opposite cochlea, which is perfectly normal, now this picks up the opposite sound. This cochlea will hear the bone conduction sound here. So what the patient will tell you? Bone conduction is there, but air conduction is not there. Why? Because during air conduction, the sounds are entering into only this canal, going to this cochlea only. But when I am placing it on the bone, during bone conduction, the sounds are traveling through the intact skull towards the opposite cochlea. Now, the patient will hear bone conduction but not air conduction. BC more than AC. So, Rini, you will get negative. But when you do Weber, if this is really conductive loss, Rini negative, the Weber should lateralize towards the affected side. But to your surprise, Weber will lateralize towards the normal side. Now, Rini is telling negative conductive, but Weber is telling, okay, this side SNHL. Weber is confirmatory always. Now, this tells that the negative Rini which you have got here is not true negative. This is false negative. This occurs due to transcranial transmission of the sound waves to the opposite cochlea. Understood the false negative concept? So this is false negative Rini seen in severe unilateral severe SNHL, right? Okay. If both sides equal amount of SNHL is there, you may get Rini positive and Weber central. Now in these cases, you will do absolute bone conduction test. You put it on the patient's, okay, mastoid. Once the patient stops hearing, you take it and put it on your mastoid. If you are still hearing, the patient's bone conduction is reduced, means patient is having SNHL, right? So this is provided here. Limitation is your ear should be normal, right? Okay, can we do directly Weber? No, no, no. इसलिए डायरेक्टली लैब थ्री को नहीं आना, लैब वन लैब टू करके लैब थ्री को आना, तो लैब थ्री का पूरा ओके आ जाएगा. ओके, यू कैन स्क्वीज आउट एवरीथिंग. Right. Now, perforation in tympanic membrane. So, if there is a problem in the pinna, external auditory canal, tympanic membrane, middle ear, you will get conductive hearing loss, Rainy negative. If there is a problem in the cochlea or nerve, auditory nerve, you will get SNHL. The name itself tells you sensory neural hearing loss. Okay? हम क्या कैसे पढ़ते हैं हम sensory neural sensory neural sensory neural sensory. But if you split it, if you okay listen what it is saying, sensory neural hearing loss. What is the sensory organ? Cochlea. What is the neural organ? Auditory nerve, cochlear nerve. So if there is a problem in the sensory part or neural part, that causes sensory neural hearing loss. Okay, so remaining all will cause conductive hearing loss because this is concerned with the conduction of the sound to inside. Okay, this part is related to conducting the sound from outside to inside. So conductive hearing loss you'll get. Okay, here. A young lady presented to ENT OPD with history of sudden onset unilateral hearing loss, dentist disease following an episode of acute operative media 2 weeks back. Rini was positive. 2 weeks back, Rini was positive. Means at that time, SNHL was there. Okay. She refused treatment then. Currently came with complaints of worsened. Mild sensory neural SNHL was there. Now it converted to severe SNHL. So likely findings, unilateral severe SNHL. This will be false negative. Okay. कुछ डाउट्स है तो मेरे को पर्सनली मैसेज करना. ओके. A 35-year-old patient presents with hearing difficulty, Rini positive in the right ear, negative in the left ear. Okay, now see, Rini positive in the right, negative in the left. If you are getting Rini negative in the left, first of all, what you think is left conductive. Now you go for the Weber. See, if this is really conductive, Weber should lateralize towards left. But see what the question is telling, Weber is lateralizing towards the right. So there is something, this is not true negative, this is false negative. अगर ये false negative है तो इस side severe SNHL है. Which side? Left side. So this is SNHL in the left ear. A female patient with hearing loss is examined, found to have Rini negative 250 512 Hz. So this I have told you. Remember the multiples of 15. One tuning fork negative 15 into 1 plus 15. So 15 plus 15, 30. Two tuning forks negative 15 into 2, 30 plus 15, 45. Now, three tuning forks negative, 15 into 3, 45. Add 15 to that, 60, 45 to 60. So likewise, you can remember. This has to be by hearted as it is. Okay. Now, a patient presents to OP with complaints of hearing loss. Okay, I can understand only shouted or amplified. Before going to that, if I am whispering, that is 30 decibels. If I am normally conversating, that is 60 decibel sound. If I am shouting loud, that is 90 decibel sound. So hope you understood. So 30, 60, 90 and see 120. If you put loud sounds and you put your speakers, then that becomes, okay, your ear will be off light, discomfort will be there. So up to 25 decibels, you will be, okay. Up to 25, I am getting an audiometry done and my audiometry says that my bone conduction, air conduction curves are at 20 decibels. That does not mean that I am having hearing loss. Unless my hearing loss goes above 25 decibels of loss, then this can be taken as I am having hearing loss. Okay. Now, so up to 25 decibels of hearing loss can be taken as normal. 26 to 40 mild, 41 to 60 moderate, 61 to 80 severe. More than 80 can be taken as profound or deaf ear. Okay, so he can understand only shouted speech. That means it is severe, and this is clearly given here. Able to hear when shouted into the better ear. So this becomes okay severe. What causes maximum hearing loss? Remember, see, there is ossicular discontinuity. Only one problem here. But here, ossicular discontinuity is there. Tympanic membrane perforation is also there. Here, two problems are there. Here, only one problem is there. Tympanic membrane is normal here. Only one problem is there. But still, maximum hearing loss is seen in this condition only. Don't think that as two problems are there here, there will be, okay, more hearing loss here. Compared to this will have more hearing loss. Why? Because whatever the sounds are coming and striking on the surface, because tympanic membrane is completely normal here, all the sound energy will be falling on the tympanic membrane only, and all that sound energy is transferred like this. But now, no continuity. So all energy is dissipated and wasted here. No chance of sound conduction happening inside to the cochlea. So severe hearing loss will be there here. Now, due to this perforation, of course, the sound energy is coming. Some waves are hitting this. Some waves are entering through the perforation. They may come and hit the round window, and due to the vibrations of the round window, cochlear fluids will vibrate, basilar membrane vibrates, organ of Corti vibrates, hair cells vibrate, rub against tectorial membrane, potassium channels open up, and nerve impulse gets generated, and sound conduction occurs towards the brain. So, okay, so this is okay. In this, you will have, even though two issues are there, two problems are there, but even though one problem only is there, but this will have more amount of hearing loss. Now coming to pure tone audiometry, if you are getting two waves in the upper part, that is okay without any gap, normal. If you are getting air conduction wave in the abnormal, means more than 25 decibels. See, this is 20 decibels, 30, 25 decibels. If you are getting air conduction in the abnormal, bone conduction normal, there is a gap between them, that is airborne gap, that is conductive hearing loss. And if you are getting both in the abnormal range, okay, 30, 40, 50, 60, anywhere, both in the abnormal range without any gap, that is SNHL. And so mixed means conductive plus SNHL. What is the criteria for SNHL? Both waves should be in the abnormal range. So see here, both waves are in the abnormal range only. What is the criteria of conductive? Gap should be there. And see, gap is there. So this is mixed hearing loss. Now see, so if you are seeing this pattern, that is normal. If you are seeing this pattern conductive, if you are seeing this pattern essential, if you are seeing this pattern, see this is 25. So two waves are in the abnormal range and there is a gap between. So this becomes mixed. So right side audiogram is represented in red color. Left side audiogram is represented in blue color. So RR, right, red. Okay. So identify the PTA type. Now see here. This is of blue color, so this should be left, right? And see, this is 25 is the normal range, isn't it? Up till here, we can take it as normal. One wave is in normal, other wave is abnormal. There is a gap between them, so this is conductive. Now see, this is a red color. Okay, see the red color. So this is right. So this is right conductive. And see here, right side, left side, both are well within the normal range. So this up to 25 is the normal, isn't it? Now, left side, both are in the normal. Right side, both are abnormal near to each other. So right sensory neural hearing loss. Now see here, left side, blue color, both lines are near to each other in the abnormal. And right side, both lines are in the normal range. All eight. At only one frequency it may be coming down, but if you take all other frequencies, it is almost normal. So you can take right side normal, but left side completely abnormal. Two lines near to each other. So this is left SNHL. अरे वही तो बोल रहा color differentiation. Now coming to the PTA identify. Now see here, okay, you have two waves in the abnormal range. Okay, more than 25, you have the okay losses. Both waves are in the abnormal range, and there is a gap between them. So this becomes the mixed one, right? Identify the audiogram. See if there is a dip at 4000 hertz called as Boyle's notch. That is your noise induced hearing loss. And dip at 2000 hertz, Carhart's notch is seen in otosclerosis. Ascending curve is seen in Meniere's disease. And okay, middle frequencies affected more, mostly banana, trough shaped or cookie bite. This is usually seen in retrocochlear acoustic neuroma. Middle frequencies affected more. Meniere's disease, you are getting ascending curve means lower frequencies affected more. A woman presents with impaired hearing, her audiometry findings are given below. You can see left side, both curves, okay, blue color, both lines are in the abnormal near to each other. So this is left SNHL. So when there is left SNHL, Rini positive, Weber to right ear. So this is the correct option, right? A pure tone audiometry shows results an air-bone gap with normal bone conduction. Bone conduction normal, air-bone gap, air conduction abnormal. So this is conductive hearing loss. And you know, both waves are in the within the abnormal range near to each other, sensory neural. Both are in the abnormal range, also having a gap in between them. This is mixed. Now coming to the impedance, A is normal, AS, S is for sclerosis. Okay, see the normal amplitude at the zero resting pressure. Due to the fixation, see the reduced amplitude at the resting pressure. Now D for ossicular discontinuity, widely mobile. So at resting pressure, they are almost somewhere high above they will meet. So very high due to free movement. Okay, dislocation is there, no? So no continuity, no? So freely mobile here and there. So that's why they meet somewhere above high here. And this is usually seen most commonly. Clinically, most commonly seen conditions are these: otitis media with effusion and CSOM. So almost you have a flat curve here. And C means you have a sharp spike at the maximum negative pressures, retracted, completely retracted inside, right? In which of the following conditions is the B tympanogram? B is seen in serous otitis media. AD is seen in ossicular dislocation. AS type is seen in sclerosis. And this is your normal, right? In normal. Stapedial reflex. So whenever a loud sound is going inside, first the cochlea hears it. From the cochlea, it goes through the eighth nerve. Through the eighth nerve, it is going. It reaches to cochlear nucleus, olivary complex, cochlear nucleus, olivary complex. Now, when the olivary complex detects the incoming sound as a loud sound, sudden loud sound, it detects that sound. Once it detects, it's what it does. It sends impulses to facial motor nuclei on either sides. So facial motor through the facial motor nucleus, through the facial fibers towards the nerve to stapedius, the fibers will run, and through the facial and the nerve to stapedius, the stapedius muscle will contract, which is holding the stapes here. And once the stapedius contracts, it holds the stapes tight. It will not allow the stapes to go suddenly inside and dislocate. It helps protect your ear. So stapedial reflex is a protective ear. Okay, so got the sensory and a central unit, and these are the facial is the motor unit. Vestibulocochlear, sensory, facial, motor. Even if you don't know, okay, this cochlear stapedial reflex, vestibulocochlear nerve itself is a pure sensory nerve. Facial nerve itself is a pure motor nerve. So okay, ingoing, okay, inside going, afferent is sensory, outcoming, outside coming, efferent is motor. So obviously motor, efferent, outcoming, that should be facial. Afferent, sensory, ingoing, okay, inside, going inside, that should be sensory. Means vestibulocochlear is sensory, facial is not sensory, isn't it? Otosclerosis. So you know this very well, otosclerosis, right? So there will be fixation of the foot plate in the oval window. Due to that, the stapes gets fixed here tightly. It does not won't be able to move freely, causing hearing loss. I mean hardness of hearing. This will be the only clinical feature in most of the cases, apart from the tinnitus, vertigo, and paracuresis. Paracuresis means patient hears better in noisy surroundings. On otoscopy, where is the problem? The problem is in the foot plate. When you do an otoscopy, all these things will be looking normal. So otoscopy will be mostly normal, and when you do tuning fork test, so this otosclerosis causes conductive hearing loss. Pure tone audiometry will confirm that. Impedance will show you AS type. In the pure tone audiometry, you may get Carhart's notch. So diagnosis is otosclerosis and treatment is always stepidotomy. Okay, sometimes in 10 to 15% of the cases during otoscopy, you may observe a reddish hue on the promontory, that is called as quad sign. Some cases only you can see this, right? So Carhart's notch on the audiogram, you can see the Carhart's notch at 2000 hertz. Okay, in otosclerosis. Most common site is called as fistula antifenestrum, most commonly seen in females, middle-aged females, and it aggravates during pregnancy. Most common type is stapedial and Van der Waals triad, otosclerosis, blue sclera, and osteogenesis imperfecta. Treatment is always stepidotomy is treatment of choice. Sodium fluoride is obsolete nowadays. Hearing aid is the next option. Okay. So now coming to Carhart's notch, this is seen in otosclerosis, right? Sudden SNHL, what happens? One side completely, ear hearing is completely, okay, maximum gone. So you can see this pattern in sudden SNHL. And Meniere's disease, you get the ascending audiogram. Acoustic neuroma, unilateral SNHL, and mostly middle frequencies will be affected more. In this picture, maybe all are affected, but initial patterns will be like this, banana shaped or trough shaped or cookie bite audiogram will be there in initial stages. What is the procedure being done in the image? In paracusis means patient hears better in noisy surroundings. No. Vanderhoof, it's SNHL. Why SNHL? No. Vanderhoof also it is conductive only. What is the procedure being done in the image? So you can see this is a stapes piston. See, I have shown you a stapedotomy video also. Okay, so you will remove the stapes and you place the piston in place of the stapes. Now the sounds will come, strike, and it will go through the piston. The sounds will go into the inner ear. Now the inner ear fluids will vibrate and there the movements will occur and okay, the sound conduction will occur. This is ossiculoplasty, where ossicles are absent. See here, incus is absent. Here, incus and stapes are absent. So this is forming the bridge, the artificial processes. This is ossiculoplasty. The perforation is filled with a graft. That is your meringoplasty. And this is removing the infected mastoid bone is mastoidectomy. A primipara is being evaluated, which for a hearing impairment worsened during her pregnancy. So by this line, you can see this is a otosclerosis. Rinne negative for both ears means both bilateral otosclerosis. Weber lateralist right side means right side having more otosclerosis than left side. On tympanic membrane appears normal, obviously. Carhart's notch is seen and treatment of choice is stepidotomy. Okay, always stepidotomy is better than stepidectomy. Here, the foot plate is removed. Here, a hole is made in the foot plate. Now, in that hole, the piston is fixed. The chances of dislocation of the piston is very less here. But in the stepidectomy, foot plate completely removed. And if you place the piston like this, it may fall like this also, or it may go like this also. Now, the chances of dislocation of the piston are high here. No, no, it is stepidotomy only. Is stepidotomy, stepidotomy, otomy, 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 otomy. Okay, right? No other option. Okay. An audiogram of a 30-year-old female patient is given below. Okay, so you can see Carhart's notch over here. See carefully. See the color carefully. Okay, so this line is given thick and this is given thin. Okay, so be careful in exam. Don't run just by saying this. It is SNHL. Don't think like that. Okay, ascending Meniere's hoga. So first option Meniere's दिया है. So don't get confused. See properly. Okay, एक बार बड़ा करके देख लो. Okay, see 2000 hertz there is a dip. So that is otosclerosis. And this is your ascending curve Meniere's. 4000 hertz dip NIHL and down sloping. Okay, pressed by causes age related. Hearing aid is the only option here. Okay, high frequencies are affected more. Down sloping curve. Otoscopy will be normal. Audiogram of a patient below, see the Carhart's notch here. So here you can also see spot sign here. And glomus tumor is a vascular. There are two types. The one which arises in the middle ear is tympanicum. The one which arises from the jugular bulb is jugular. So what is this rising sun sign? When I put an otoscope from here and see, I can see some tumor rising above from below. That is called as rising sun sign. Aquino sign, whichever side tumor is there, that side if I compress the internal carotid, so that will reduce that pulsatile tinnitus of the patient. So the pulsatile tinnitus, this is the typical clinical feature in case of glomus tumor. Pulsatile tinnitus. Okay. Now, coming to the investigation of choice is CECT because this is vascular. So go for contrast. Brown sign or pulsation sign. You put a seagull speculum and inflate the bulb. Pressure increases inside, exerted on the glomus. So the glomus, the vessels will branch immediately. For pressure, the pulsations may become vigorous and thereafter the tumor blanches. The pulsatile tinnitus goes away. Now that is what is called as Brown sign or pulsation sign. Right? Okay. So the treatment is surgical excision. Before going for surgical excision, if you want to reduce the bleed, go for embolization. Okay. Now, a female presents with conductive hearing loss and otoscopy red and bulgy mass behind intact tympanic membrane. So this is glomus. I told you here, see the tympanic membrane is intact here. See, the tympanic membrane is intact. Inside, in the middle ear, you can see the reddish tumor filling the middle ear cavity from below. Rising sun sign you can see here. And this is your serous otitis media. See the multiple air fluid levels. See the brown is serous fluid. This is the air. This is the fluid, right? This is CSOM. You have a perforation and you have the purulent discharge. And this is otosclerosis. You will have tympanic membrane normal. The problem is in the stapes footplate inside. 35-year-old woman presents with complaints of difficulty in the hearing in the right ear, slowly progressive pulsatile tinnitus, reddish mass behind tympanic membrane, audible bruit is heard. So too many features given here. So this is very clearly glomus tumor. Okay. On the promontory behind the tympanic membrane, there is a red mass. CT is given diagnosis. On the promontory behind the tympanic membrane, there is a red mass. See, in the CT, if the erosion of this bone is shown, what is this is Phelps sign. In between internal jugular and internal carotid, there is a bony spinous process called as carotico-jugular spine. Carotico-jugular spine. If a tumor arising from here completely erodes that bone, so erosion of this spine is called as Phelps sign. Okay. So in jugular, you will have Phelps sign. Whereas in tympanicum, you won't have this Phelps sign. The spine is normal only here. Here it becomes eroded. So in glomus jugular, you see the Phelps sign. In glomus tympanicum, you don't see the Phelps sign. If a CT scan is showing you the Phelps sign, it's erosion of this bone, this side it is normal, this side it is gone. Now this becomes glomus jugular. Yeah, salt and pepper appearance also. That also you can see. In MRI, you will see it more clearly. Salt and pepper appearance. Coming to the eustachian tube, first pouch, it develops from anatomy, 36 and outer one third bone, inner two third cartilaginous. And see in the nasopharynx where it is opening. See the inner side, it is opening into the nasopharynx from the middle ear, right? So where this is opening in the nasopharynx, posteriorly it forms elevation, torus tubarius, you call this as. And behind this elevation, there is a depression that is fossa of Rosenmuller, which is the most common site of nasopharyngeal carcinoma. Audible bruit. So if you put a stethoscope there, you will be hearing the bruits. Even your vascular sounds, blood vessel sounds, the water flowing inside. Okay, okay. So you will be hearing like some corresponding to heart rate, synchronous with heart rate. It will be coming now. So identify the structure marked here. The structure marked here is fossa of Rosenmuller. This is torus tubarius. This is eustachian tube opening, and here adenoid is not there here, but if it arises from here, posterior pharyngeal wall. Which opening is present posterior to the marked structure in the image? See, this image is inferior turbinate they are showing. Behind the inferior turbinate, you have eustachian tube opening. Behind the middle turbinate, you have sphenopalatine foramen. Coming to the differences between adult and infant eustachian tube. Infant eustachian tube is short when compared to adult, and the angulation it makes compared to the adult is very small, almost straight eustachian tube, and the lumen is very wide open. Here it is very narrow. You can see the angulation and narrowness. You can see the straightness of this eustachian tube. Short, straight, wide. The short, straight, wide in infant compared to the adult. So this is responsible for the spread of infections from here to here, from the nose side, nasopharynx side towards the ear side. So that's why obviously children will be having more frequency of URTI, upper respiratory tract infections. So from there, so acute otitis media, ASOM episodes will be more in case of children. Are you able to follow? Able to follow? Clear? Able to recollect everything? Yeah, I think the speed is very decent here. Hopefully we should come. Okay. Yeah, fine. That's good. Now coming to otitis media, so you have the, what is the first stage in ASOM? Tubal block. The tube gets blocked, eustachian tube block. When the tube gets, the mucosa becomes edematous completely. What happens to the lumen? Becomes narrower. When the lumen becomes narrower, what happens? Tube gets blocked. Ventilation of the middle ear gets affected. Now what happens? Eustachian tube block, negative pressure in the middle ear because it has become a airlock, tight airlocked cavity. Negative middle ear pressure develops. Due to this negative pressure, the tympanic membrane gets pulled inward. Okay, so at this stage, patient will have mild block in the ear. Now, due to this constant pulling of the tympanic membrane inside due to negative pressure, due to eustachian tube block, negative pressure, retraction of the tympanic membrane, due to this constant pressure over the tympanic membrane, the blood vessels here will get dilated due to that pressure, constant, consistent, acute, sudden change in the pressure. So now they keep on getting engorged, dilated. Now they start appearing prominently on the surface of the tympanic membrane. Normally, these vessels are arranged in a radial manner, spokes of a wheel. So you call this tympanic membrane as cartwheel tympanic membrane. As here, the inflammatory process has started, patient, apart from having block, now he will start having the pain. Now, block and pain, increased block sensation and pain will be there in this pre-suppurative stage where cartwheel tympanic membrane is present. Now the next stage is, so the due to constant negative pressure from the surrounding blood vessels, first the serous fluid will come and settle. Now into that serous fluid, I mean stagnant fluid. Okay, now the bacteria will come and settle down and starts producing pus. Once the bacterial infection occurs, pus formation, suppuration occurs. What happens? It starts pushing due to the filling from inside. It starts putting pressure on the tympanic membrane, pushing it outside. Now see the pushing out of the tympanic membrane. The whitish one which is inside is the pus, creamish one. That is the pus. See the bulge in the tympanic membrane. Can you see that bulge in the tympanic membrane? So red bulged tympanic membrane you can see, and pus in the middle ear can be noticed clearly. So there is a bacterial infection, pus formation. So apart from pain and block from the previous stage, now in this stage fever starts. Okay. Now, coming to resolution. So, if you are not treating that patient, the pus increases, and there occurs small perforation at the weakest area, mostly in the anteroinferior quadrant. Pinhole sized perforation occurs, and the pus starts coming out. Now, when the pressure is released inside, patient will feel pain relieved. Okay, pain relieves, but discharge starts. So, pain gets relieved, but discharge starts. Pain initially followed by discharge later is typically seen in ASOM. So this can resolve on its own by forming a perforation and draining out the pus outside. Or if you treat him promptly, see the tympanic membrane will not perforate. There is no perforation here, but you can see the inflammation completely gone, and slowly the fluid will level will become okay normal. The treatment here is antibiotics and NSAIDs, antihistamines, all those things you can use. Now coming to the otitis media with effusion, here what happens mostly due to the obstruction by the enlarged adenoid blocking the eustachian tube, or nasopharyngeal carcinoma blocking the eustachian tube in the pharynx side. What happens? The secretions, natural secretions, which are supposed to drain out like this, will get blocked, and the fluid starts accumulating, and it keeps on filling in the middle ear. Now that's why already air was present. Now the fluid is filling. So you can see air fluid, multiple air fluid levels you can see in this case of otitis media with effusion. Only difference is here no bacterial infection occurs, no pus formation. The fluid stays okay, sterile, serous, your own secretions. Okay, but purulent secretions are by bacteria, serous secretions are by your own body. So serous sterile secretions will be filling. So tympanic membrane will be normal. If you put an otoscope from here and see the tympanic membrane normal and serous fluid inside, you can see. Okay, so that is OME, otitis media with effusion, or serous otitis media, secretory otitis media, or glue ear. So there are so many names to this. This is only, okay, there is no tubal block, okay, in the lumen of the tube. Only a mechanical obstruction is there. Of course, mechanical obstruction is there, but at the corners, okay, slight seepage of the fluid may occur, but not as normal as earlier. Inflammatory, active mucosal edema and inflammatory process. Infectious process is not there. So active inflammation is not coming. If inflammation occurs, then you can see the cartwheel sign and pus formation, that thing. Okay. See, on long standing, initially it is serous. Initially it is serous. And if it gets infected later on by any bacteria, now it gets converted to ASOM. Now the patient child will start having pain. Till now only hearing loss. Now pain is also there. That may even also happen. It depends. If secondary infection occurs, then it turns into ASOM. Okay, clinical features is only hardness of hearing, dull, air fluid levels. Rene will be negative, Weber will be towards affected. So conductive hearing loss, Puton audiometry, conductive loss you will see. Impedance will show you B type. Impedance will show you B type. You know that flat audiogram, right? Treatment, if it is recurrent in nature, you have to go for myringotomy with the grommet. Where do you do myringotomy? In the anterior-inferior quadrant, in radial manner, from the center to periphery, radial manner, you will give an incision and you will insert a grommet, right? So this is how the grommet will look like, or ventilation tube, directly from outside, without the help of eustachian tube. Through this tube, what we have kept from outside, this tube will be ventilating the middle ear normally. So once normal ventilation gets restored, the mucosal, yeah, okay, edema, inflammation, all things will get cleared up and middle ear becomes normal. So within 3 to 4 months time, and by this time, the grommet will slowly fall away. Okay. A 5-year-old child presents with reduced hearing for the past 2 to 3 months. Otoscopy finding is given. Multiple air fluid levels. This is serous otitis media. Multiple bullae on the surface of the tympanic membrane. This is meningitis bullosa. See the red bulging tympanic membrane. Red bulging tympanic membrane. That is acute otitis media. Pneumotympanum is seen in decompression sickness. So pressure induced trauma, you see pneumotympanum. Yeah, anterior inferior quadrant means cone of light, where cone of light is there. There only you will insert the grommet. Cone of light means there inside no light bulb is there. अंदर में कोई बल्ब नहीं है, तो बाहर से आप जो लाइट डाल रहे हैं वही आपको रिफ्लेक्ट होता है, उस एरिया में रिफ्लेक्ट होता है ड्यू टू एंगुलेशन ऑफ द टिम्पैनिक मेम्ब्रेन. You see a child, delayed speech development is there, hearing loss is there. On endoscopy, you are seeing this pattern. So that is serous otitis media. This is ASOM, this is CSOM, this is glomus. Okay. Now coming to the cholesteatoma, what is cholesteatoma? So the squamous epithelium, which is supposed to present outside, goes inside and it occupies, okay, it completely, okay, trespasses, right, and it completely, okay, damages the middle ear structures. So wrong skin. What is the wrong skin? Squamous epithelium at wrong place. What is the wrong place? Middle ear. So squamous epithelium going into the middle ear and damaging all the structures whichever it comes in contact with. That is cholesteatoma. So it can be congenital acquired. Congenital means so tympanic membrane will be normal. Keratin mass you can see inside, epithelial mass you can see in the middle ear with the intact tympanic membrane. If you see the endoscopy appearance, you can see in the anterior-superior quadrant cotton wool type mass sitting behind normal intact tympanic membrane. That is how your congenital cholesteatoma will appear. Now coming to acquired cholesteatoma, you have two types, primary, secondary. In primary, what happens? There is no perforation, that the tympanic membrane itself retracts inside. No pre-existing disease was there earlier. No pre-existing disease was there. Now, what happens? The tympanic membrane itself goes inside. The keratin, it starts depositing keratin inside and it starts damaging the structures. This is Whitmark's retraction pocket theory. Secondary means already there is a perforation. Through that perforation, the epithelium is going inside and depositing keratin inside. Epithelium invading inside through the perforation. Haberman's epithelial invasion theory. Right? Meningitis bullosa, it is very difficult to move that bulky tympanic membrane. So you may get almost a flat curve there also. Okay. CSOM, permanent perforation with a recurrent discharge, means the margins of the perforation should get covered by the squamous epithelium. You call them as epithelialized margins. So if the margins are epithelialized, now see the growth has occurred in this way inside. Now there is no option that these two layers will come and close with each other. There is no option that these mucosal layers will come close to each other and move and join here. There is no such possibility. So this perforation will not heal. So that is called as permanent perforation, epithelialized margins. So that's why during tympanoplasty, meringoplasty, before placing a graft, we will remove the margins first. Okay, and repeated due to repeated middle ear infections from outside, so you will have discharge episodes. Okay. Types of CSOM. So the safe type, unsafe type, tubotympanic or okay, tubotympanic. The problem lies in the eustachian tube, and this eustachian tube is connected to nasopharynx. So any nasal pathologies, nasopharyngeal pathologies, right? You are chronic rhinosinusitis, deviated nasal septum, turbinate hypertrophy, allergic rhinitis, or any inflammatory condition of in this, okay, or any nasopharyngeal condition, juvenile nasopharyngeal angiofibroma, consistently blocking the eustachian tube, and your nasopharyngeal carcinoma, or whatever, okay, somehow the adenoid hypertrophy, all these things, okay, constantly, repeatedly, more amount of AOM acute episodes are going on. One fine day, it will convert into CSOM. Any pathology that is blocking the tube and due to that causing tympanic pathology, tubotympanic, tympana means middle ear, tubotympanic, okay, this is called as safe type or mucosal or tubotympanic disease. Okay, so here you will have a perforation, central or subtotal perforation you will have, and mostly you will have mucoid discharge here. Okay, mucoid discharge will be happening, profuse mucoid discharge will be happening here. Now if you see here, mostly the pars flaccida attic perforation or marginal perforation will be there, and the disease is transmitting from attic. This is epitympanomer attic, and this cholesteatoma goes through the adductors into the antrum behind. It is traveling from attic to antrum, attico-antral, and the disease is caused by squamous epithelium which is coming inside and damaging the surrounding bones. So this is also called as squamosal disease. This is okay, is spreading from attic towards antrum. This is also called as attico-antral disease. This is very unsafe because this is damaging the surrounding bones whichever it comes in contact with. Incus, malleus, stapes, facial nerve, pyramid, okay, promontory, okay, a promontory, lateral semicircular canal. Now if it goes into the mastoid completely, tegmen, it can damage the tegmen roof and can go into the cranium. It can damage the canal and go into the semicircular canal inner ear. It can damage the cochlea, go into the cochlea, and still may go into the petrous and can affect the petrous apex as well. From behind mastoid, it can go back into the sigmoid sinus as well, and above it can go to the meninges. Okay, it can form meningitis. It can go into the brain, cerebritis, and even it can go and wherever. Okay, it keeps on damaging all those things. Okay, so here the discharge will be scanty, mucopurulent, and blood stained due to bone damage, blood stained, foul smelling, bony. Okay, infection is happening, so it will be foul smelling discharge. Treatment of CSOM is purely surgical. So what are all the surgeries you need to do? If there is only perforation, middle ear is normal, mastoid is normal, no other complications. You are finding only one negative thing, that is perforation. In those cases, you can go myringoplasty. Temporalis fascia is the most common. And if you are placing the graft under the annulus, that is underlay. If you are placing it over the annulus, then it is called as overlay. See the middle fibrous layer, that is annulus, isn't it? Middle fibrous layer, peripheral thickening is the annulus. So if I am placing under the middle layer, that is underlay. Over the middle layer, that is overlay. स्लो हो गया हम? नहीं, CSOM है ना, क्वेश्चन पक्का एक्सपेक्टेड है ना. Okay, ossiculoplasty. So partial, the first ossicle that goes is the, okay, incus, and next ossicle that goes is the stapes suprastructure. So if only incus is gone, partial ossicular loss is happened, you go for partial ossicular replacement prosthesis. The prosthesis that replaces the ossicles partially. Now if incus and stapes are also gone, then you go for total ossicular replacement prosthesis. The prosthesis that is replacing the ossicles totally. So that is top PowerPoint point top. But nowadays these are not used. You are using the tragal and conchal cartilage, sculpturing them into that particular shape and placing it inside to maintain the continuity. Coming to the mastoidectomy, what is the incision you take here? Wilde's incision. So just, okay, near the post-auricular groove, you can take a, okay, along the groove, you'll take an incision. That is Wilde's incision. Once you give an incision, you separate the both skin flaps and you apply a mastoid retractor, Mollison's mastoid retractor. So they will keep the two. Once you give incision, this side one skin flap, that side one skin flap. So two will be opened, kept opened by the retractor. Now, okay, subcutaneous tissues are dissected. Now mastoid is in front of you. Now, when mastoid is in front of you, you have to identify a triangle called as McEwen's triangle. So, okay, so here along the postero-superior wall of the ESC, you draw a line, and there is a temporal, superiorly, there is a bony ridge passing through. You call it a superior temporal line, and you draw for this line, you draw a tangent, 90-degree line. So you enclose a triangle here that is called as, okay, McEwen's triangle. In this triangle anteriorly, you have a bony spine called as spine of Henle. Spine of Henle is also here only. So these are the landmarks. McEwen's triangle marks the landmark for your antrum. For if I go on drilling from here, 1.5 centimeters deep, I will land in the antrum. If I go on drilling 1.5 centimeters deep, I will land in the antrum. So what does that mean? When if I have opened the antrum means I have removed the entire mastoid. It's not that I have left over some mastoid inside and removed only outside. So checking for antrum patency, that is most important. So what happens, what I will do? So I will push some saline here. That saline will go through the adductors into the attic, and through the perforation, this will come back like this. When I'm pushing the saline from here, if it is coming back from here, what does that mean? There is a continuity. There is a continuity means I have completely removed this mastoid bone. So my mastoidectomy is complete. Understood? Clear, no? Easy, no? Right? Now, coming to the canal wall up and canal wall down. If I am telling you canal, what is meant by canal? External artery canal. Okay. In mastoidectomy, if I am talking about a canal means that should be external artery canal. Right. And if I am talking about canal wall, which wall of the canal is associated with mastoid? Posterior canal wall, which is a common partition between external artery canal and mastoid. So if I'm talking about canal wall means that is posterior canal wall. If I am not removing this, that is canal wall up. If I am downing this, if I am removing this, that is canal wall down. So see here in canal wall up, see here there was disease. I have opened that this, okay, flap, okay, tympanic flap I have opened, come inside, I have done a mastoidectomy and I have, okay, patency, I have checked for the patency. Now I have placed the graft again and I have closed this and I have stitched it up here and came back. Now this looks like a normal ear only, your ear and my ear only, isn't it? Normal ear. Okay. So usually, okay, so in this here, see, I am removing this wall. I am removing this wall. I am entirely, okay, making this into a common cavity. Now what happens if disease occurs again here? I may have to go for a surgery again. I have to again open this graft which I have placed here. Again, I have to check any disease. Again, I have to remove that and again I have to replace this back. But here, the patient comes to my OP, I put a scope here and I will be able to see this entire. If any recurrence of disease is there, I can directly remove it without posting for any surgery. No need for me to open anything from here, like here, this one, isn't it? So here, recurrences are not present here, but here, recurrences are a possibility here. See, in unsafe type, I don't want any recurrences to happen because the disease is unsafe. I don't want any recurrences. So, in unsafe disease, I prefer going for canal wall down mastoidectomy. If it is a safe disease, I prefer going canal wall up mastoidectomy. Okay, because if recurrence occurs here also, then there won't be any problem. I can again remove it. Okay, by second look surgery, I can remove it. Okay, even the disease recurs here also, the patient is not going to be critical, right? But here, if the disease is recurring, it is unsafe, it is dangerous, it may spread to the brain and can cause, okay, any damage, right? So here, I don't want to take any chance. Okay, here safety comes first. So I will go for canal wall down. Okay. But what are the contraindications? The patient should not go for swimming. If he goes for swimming, the water will directly go and hit here. Lateral semicircular canal is present here. It stimulates and patient may get sudden giddiness. Oh, Aditas itself means a continuity tube. Okay, it is already there. Aditas is already there. It's a natural one. Okay, Woolstein's types of tympanoplasties. Now, apart from tympanic membrane, meringoplasty, underlay, overlay, if you are seeing in the middle ear, any other problem also you are seeing, okay, like your ossicles are necrosed. Now you go for tympanoplasty also. Now, what are the types of tympanoplasty? If you are placing the graft directly on the malleus, that is type 1. Now, if I am placing it on the incus, type 2. Now, if I am placing it on the stapes, type 3. If I am placing it on the foot plate, type 4. If I am placing it on the lateral semicircular canal, type 5. 1, 2, 3, 4, 5. Malleus, incus, stapes, foot plate, lateral semicircular canal. So stepwise, okay, anatomy wise, okay, it is very, okay, serially, okay, staged. So Woolstein's types of tympanoplastics. Type of tympanoplasty shown in image. See, this is directly placed over the foot plates. Please identify the retractor. So this is your Mollison's mastoid retractor. While doing mastoidectomy, to keep both flaps separated, we use this Mollison's. And this is also Perkins mastoid retractor. Perkins retractor. So this is also done for mastoidectomies. One side it is smooth. The smooth one will be towards the pinna side. Okay, if I'm cutting here and pulling this anteriorly, so that prongs in Mollison's I have sharp prongs. The prongs will be damaging the pinna this side. So if I have a smooth surface, so that may not damage the pinna this side. So that's why one surface is smooth here compared to the Mollison's pronged surface, right? And Langenbeck's, you know well, this is George retractor used for thyroidectomies. Yeah, slightly possible to do tympanoplasty after wall down surgery. Yeah, nowadays that is what is called as modified radical mastoidectomy. So usually canal wall down, which I have told you is radical mastoidectomy, where complete middle ear structures are removed. So that is radical mastoidectomy. Now, if you are adding, trying to reconstruct the hearing, okay, now that is called as modified radical mastoidectomy. Okay. So complications of, see, after year we'll take a break. Okay. Now coming to mastoiditis, most common complication, group A beta hemolytic streptococcus, sagging of posterior metal wall, lighthouse sign, reservoir sign, all these signs you know. Now, reservoir sign is seen in acute mastoiditis. So this is your lighthouse sign. You already know this. You can see here clearly. Okay. Lighthouse sign. Okay. Light is pulsating. Okay. That is lighthouse sign. Now coming to the various abscesses, you have post-auricular abscess, right? Post-auricular abscess is the most common of all the abscess, okay, here. And the zygomatic, okay, bejeweled abscess, Citelli abscess, and within the lumen if it happens, within the canal if it happens, Lux abscess. What is bejeweled abscess? So between angle of mandible, okay, and sternocleidomastoid, angle of mandible, and digastric inside. Medially digastric, anteriorly angle of mandible, posteriorly sternocleidomastoid. So below the tip of the mastoid, this is the tip of the mastoid. The pus is coming, draining down below the tip of the mastoid and collecting in the space between the anterior angle of mandible, posterior sternocleidomastoid, and medial digastric. This is bejeweled area. The abscess here is called as bejeweled abscess. Post-auricular abscess is the most common abscess that you see in case of CSOM. Right? Zygomatic means towards zygoma. If there is abscess, that is zygomatic abscess. Citelli means towards occipital area. If there is abscess, that is citelli abscess. Within the lumen, if there is abscess, that is Lux abscess. What is battle sign? Battle sign means this happens in case of trauma only, mastoid ecchymosis. This is your perichondritis. See the lobules pairing sign, only the cartilage part is affected. Okay, fat part is not affected, right? Now see this, okay, raccoon is periorbital hematoma. And you can see here, so this is your bejeweled abscess area, right? Fine. Which of the following is a cause of SNHL? So inner ear, labyrinth means inner ear. Inner ear condition will cause SNHL. Otosclerosis, earwax, CSM all are outside. Okay, this cause conductive hearing loss. What happened? Which nerve affected in visual? In visual, nearest is facial nerve is there that can get affected. Okay. Now coming to facial branches can get affected. Now coming to the perilymph fistula. What is this perilymph fistula? The wall over the lateral septum. See the cholesteatoma or CSOM coming inside and damaging this lateral wall of the lateral semicircular canal. Now the perilymph which is present inside can get exposed to outside. This is called as perilymph fistula. Now see the greenish one is the perilymph here. Okay, perilymph, and inside this black one is the bony labyrinth. The blue one is the membranous labyrinth. The sky blue one is the endolymph inside. So this is how your canal is arranged here. Now this perilymph is directly communicating with the middle ear outside. That you call it as fistula, perilymph fistula. Right now, what is that fistula test? How to a case of CSOM who has got recent onset vertigo, recent onset giddiness, already a known case of CSOM. How can you tell it is a known case of CSOM? Repeated episodes of on and off ear discharge were there already in the history of the patient. Now, recent onset giddiness has started. What does that mean? Disease spreaded from middle ear to inner ear. So which structure comes first? Lateral semicircular canal. So possibility of perilymph fistula is there. So to detect whether this is there or not, fistula test you will do. Press the tragus. If there is any giddiness, now that is true positive. This is seen in perilymph fistula. False positive is seen in Hennebert's and you call it as it is seen in Meniere's and syphilis. In Meniere's what happens? See, this is normally saccule. Okay, this is foot plate. So there is a slight distance between them. During normal vibrations of the foot plate, okay, the foot plate will not touch the saccule if this is present normally. Now what happens? During Meniere's, in Meniere's, the saccule dilates. The entire membranous labyrinth dilates. Now when this enlarges, the enlarged saccule will come and lie attached to the foot plate. Now, whenever you press the tragus here, the air column pushes the ossicles inside and the foot plate touches the saccule and causes giddiness. Now, in case of syphilis, here the saccule is normal only, but the problem is with the foot plate. In syphilis, ligaments are very lax. What happens? The foot plate, usually normal amplitude of movement is this much. Due to laxity of the ligament, stretchability, hyper stretchability of the ligament, the foot plate can vibrate here and from too heavy amplitude, it can vibrate with. Now, Due to this, it goes and touches the saccule, unnecessarily stimulating it, causing vertigo. Now, coming to the true negative, no disease, fistula is also negative, normal. So, in normal people, you see this. False negative means disease is present inside, but even though you are doing fistula test is coming negative, but disease is present inside. If disease is absent, test is negative, then that is true negative. If disease is present and test is negative, that is false negative. That is not true negative. That is false negative. That is seen in dead labyrinth. Inside labyrinth is dead. Okay. Take a cricket bat and hit it inside also. So already it is dead inside. Nothing will happen. So dead labyrinth and cholesteatoma covering the fistula. In those cases, you will see false negative. Now coming to the caloric test or Fitzgerald-Hallpike bithermal caloric test. Bithermal. So two temperatures you will use. Water you will use here. 44 and 30 degrees. And remember the mnemonic cows. Cold opposite warm same. So if I install, okay, if I pour warm water here, the nystagmus will be towards the same side. And if I pour cold water here, the nystagmus will be towards the opposite side. Okay. So the position of the patient will be supine with 30-degree head and elevation. Supine with a 30-degree head and elevation. So the horizontal canal, lateral canal will become vertically oriented in this position. Neurosyphilis, tertiary. In tertiary, you will see this. Petrositis, near the petrous apex, if you see, the abducens is running in the Dorello canal. So infection in this area can affect that nerve and cause diplopia. And the fifth nerve ganglion, Meckel's ganglion, is sitting near the petrous apex. So infection of this can cause pain behind the orbit area in the Meckel's ganglion area. So retroorbital, deep-seated retroorbital pain will be there. This is a case of CSOM. So discharge episodes were there. Discharge, deep-seated retroorbital pain, diplopia. All these three Ds will form a triad called as gradient equals triad seen in petrositis. And a patient completes the ear discharge, retroorbital pain, and visual disturbances. So the diagnosis is petrositis. And coming to meningitis, most common intracranial complication is CSOM. Most common overall complication is mastoiditis due to direct continuity to mastoid. Most common intracranial one is meningitis. So you have Kornick sign and Brudzinski's neck sign here. Okay. In caloric test, cows is what normally you get. In a normal person like me and like you get cows pattern normally. But in an abnormal patient, you don't get cows pattern. For your level, if you can remember this one, much needed. Much, okay? Enough. Now coming to the sigmoid sinus thrombosis, see from the middle ear, the disease has gone through the adductors, antrum and into the mastoid. Now still it is not okay. Its hunger hasn't subsided. It wants to damage even more now. Now there is a mastoid emissary vein connecting the mastoid to the sigmoid sinus posteriorly. To the sigmoid sinus posteriorly. Now the infection will start infecting the mastoid emissary vein, entering into the mastoid emissary vein. Now this becomes thrombosed. When this becomes thrombosed, veins are superficial. So due to the thrombosis, the skin over that gets erythematous. So the erythema over the posterior mastoid area. This is your mastoid. This is anterior mastoid. This is posterior mastoid. Posterior mastoid erythema. You call it as Griesinger sign. I skipped one slide. Kaha? No, I didn't skip. So Griesinger sign. Okay. Griesinger sign. Okay, now still okay, its hunger hasn't subsided. Now from here it goes into the sigmoid sinus. Now it starts infecting the walls. The walls react by forming a thrombus. So that is called as sigmoid sinus thrombosis or lateral sinus thrombosis. Now what happens? The thrombus will block the lumen of the sinus. Now once the lumen is blocked, what happens? The venous drainage from the cranium. See, input carotid is supplying into the cranium. Now from the cranium outside, through the sigmoid sinus, it has to come outside. Venous drainage should be there. And down they come and join with the jugular vein. Now, see, as sigmoid one side is getting affected, blocked, retrograde congestion inside the occurs, increased intracranial pressure causing headache, fever, okay, I mean headache, okay, papilledema, vomiting, all those things will, giddiness, all those things will occur. Now, picket fence fever will be there, irregular spikes of fever you will see here. The triangular cross section, if I take a triangular cross section here, I mean, if I take a cross section of the sigmoid sinus here, if I take a cross section, the cross section will look like triangular. So on CT scan, if I see what happens, a central thrombus is present and peripherally, okay, slight, okay, gap may be there. So through that gap, the contrast will be passing. Okay, the central filling defect, that filling defect, the deficiency in filling is due to the presence of the thrombus. Central filling defect, triangular shaped, that you see on CECT is called as delta sign, triangular, okay, delta sign you call it as. Krobeck sign, Toyer test, you know. Okay. Management of is drug of choice is vancomycin, warfarin. You have to, because thrombus has to get dissolved. For 6 weeks, you need to give. After 6 weeks, repeat imaging. And if thrombus present, again repeat the same cycle. Now, if the thrombus is not present, then you proceed for mastoidectomy. What mastoidectomy? Anyone? What happened? क्या चल रहा? Okay, fine. Canal wall down because unsafe disease. Going into sigmoid means posterior cranial fossa is going, right? Okay, canal wall down. A patient with history of CSOM presents to seizures, headache, vomiting, photophobia, homonymous hemianopia, epilepsy. So, or cerebral symptoms are also present. CT scan is showing a lesion in the temporal lobe. So, it is called as temporal abscess, right? Fine. So, coming to the inner ear, you want to take a break? No problem. Have a break. Take a break. No problem. 5 minutes enough? गोगा सर को पूछना. Cephalosporins to cover broad organisms. Okay. It will finish. It will finish. It will finish. No problem. 11:44 it is. 10 minutes will be fine. Okay. So 11:54 will start again. Fine. Sharp 11:54. Please come fast. Okay, still students are yet to. Yeah, you will get this PPT. You will get this PDF. So it will be shared in the group after the. Okay, Telegram group में भेजेगा. ये कौन है? रफ्तार. खुद तो पढ़ता नहीं है, डेली बस टीचर का मजाक बनाने आते. अच्छा, ऐसा है क्या? रफ्तार. ये कौन है रफ्तार? वो खुद को गिरेगा. आप सोचना मत उसके बारे में. वो गिरफ्तार हो जाएगा बाद में. ओके. अगर डिस्टर्ब करना ही मेन एम है तो रफ्तार गिरफ्तार हो जाएगा. ओके. आई गॉट माई टी लेट. जस्ट. ओके. आई एम फ्रॉम हैदराबाद. मैं चाय पी रहा हूँ भाई. आप लोग 10 मिनट में क्या किया आप लोग? ओह, ग्रेट ग्रेट. उस्मानिया बिस्किट खा के बोर लग रहा है. या आई स्टे एट उपल ओनली. क्या क्या बात कर रहे हो चैट में आप लोग? कुछ समझ नहीं आ रहा, क्या क्या बात कर रहे हो आप लोग? इतना टिप्स दे रहा हो ना. इतना ज्यादा टिप्स देने से उसको टिप नहीं कहते ना. वो भी बड़ा कंटेंट हो जाएगा. सो कभी ज्यादा टिप्स मत मांगना किसी से. एएसओएम स्टेज भी पूछना है. एएसओएम स्टेज 1, स्टेज 2, you may get C type. But if it is suppuration already started, then fluid comes. Once the fluid fills up, it may become B. So in exam, pre-suppurative stage means you go for C. Suppurative stage means you go for C. Sorry, B type fluid. Okay, चलो. हाँ, चलो. We'll start from the inner ear, right? So just little bit be careful here as you. So who are clear with the anatomy, for those this inner ear will be looking much easier. So those who are directly sitting here, just okay, try to have a look. So you have the basic orientation of the inner ear like this. And so if you take the cochlear part, you have the outer, okay, bony. The black one is your bony part. Okay. See the cross section part. So the black one is the bony part. In that bony part, you have, okay, perilimb filled up completely. Okay. In that bony part, you have perilimb filled up completely. Are you understanding or not? The cross section part, you have to concentrate on the cross section. If I cut the cochlea here and see the cross section, it will be round, right? Now, so in this bony labyrinth suspended within the perileaf, you have this bluish membranous labyrinth. Okay, this membranous labyrinth. Okay, you can see this membranous labyrinth, right? So this is your membranous labyrinth, and this is filled with endolymph. Endolymph is present within the, okay, this one, membranous labyrinth. So this is how you see, this is the membranous labyrinth and endolymph inside. Now on the lateral wall, you have the stria vascularis. Two membranes will be running on either side of the scala media, and they will be, okay, dividing the cochlea into three chambers. So right from here, if I start from the basal coil of the cochlea, and if I go till the apical coil of the cochlea, wherever I take cross section at any area, in whichever area I want, wherever I take a cross section, it will look like this. At any place, if I take a cross section, it will to look like this. So the membrane that is separating the scala vestibuli from media is the Reisner's membrane, and the membrane that is separating the tympani from the media is the basilar membrane. On the basilar membrane, there is organ of Corti sitting over here. Okay. Now, so hope you got a basic idea. Now you already understood that. See, outer one is bony, inner one is membranous. Bony is filled with the perilymph, membranous is filled with endolymph. Now, if I take only bony labyrinth, see, there is a bony cochlea outside, and inside this parallelly sitting is the membranous labyrinth inside. Okay, see the violet one is the purple one is the bony, and inner bluish one is the membranous one. Exactly in the same orientation it is sitting. Now, if I take the bony labyrinth, I have a vestibule here. The bony cochlea is opening into the bony vestibule. See, I have the bony vestibule here. Inside this bony vestibule, I have membranous sacs, two membranous sacs which are present inside. Two membranous sacs which are present inside. So this is bony vestibule and two membranous sacs which are lying inside. And to this bony vestibule, bony semicircular canals will open. Bony semicircular canals. To this membranous utricle, three membranous semicircular ducts will open into this. Okay, into this utricle, three semicircular ducts will open. Okay, into this utricle, semicircular ducts will open into that. From the utricle and saccule, two ducts will join to form endolymphatic duct, and they dilate at the periphery to form a sac-like structure called endolymphatic sac. Now, all along the length of the cochlea, you have stria vascularis. This endolymph is getting produced here and it is circulating in the entire inner ear. Now, this is going here, and from the sac part, this is draining outside. How much amount is produced here by the stria vascularis? That much amount is secreting out from here. So amount of production is equal to amount of excretion. Okay, amount of secretion, amount of excretion, both should be running at an equal rate. So this homeostasis is maintained throughout your life. If some imbalance occurs and stria vascularis starts producing more fluid, or endolymphatics of gets blocked and the excretion reduces, now what happens? The quantity of endolymph inside increases, but this endolymph increases, but there is no outlet for it to go anywhere. Now this starts putting pressure on the surrounding membrane, and now this membranous labyrinth keeps on expanding. And when the membranous labyrinth expands here, what is this called as endolymph expansion? Meniere's disease. I'm telling you, this is Meniere's disease. Okay. Right. So in Meniere's disease, now what happened? More amount of endolymph putting pressure on the organ of Corti here. So pressure on the organ of Corti will cause hearing loss. Which hearing loss? Sensorineural hearing loss. And pressure on the saccule, utricle, macula are present here. Crista, cupular complex are present here in the semicircular canals. So pressure on these sensors which are detecting your movements, balance. So this will cause giddiness. So that's why Meniere's patient will present with SNHL and the giddiness. Understood? Okay, now come to the anatomy. Okay, so now come to the anatomy. So these are the basic things you need to keep in mind. Now let us go inside. So this is what I was telling you about the cross section of the cochlea: scala media, scala vestibula, scala tympani, Reisner's membrane, basilar membrane, stria vascularis laterally producing endolymph, and this is your organ of Corti. And one more thing you need to remember: the cochlear. How many coils the cochlea has got? 1, 2, 2.5 to 2, 3/4. Okay. So if you see here also, if you see here, see the cochlea at the top right corner. So till here, 1, and then 2, and 2.5 to 2, 3/4, half to 3/4 like that. So 2.5 to 2, 3/4 coilings are there. At the basal coil, higher frequencies are heard. And if I travel from basal coil till the apical coil, at the apical coil, lower frequencies are heard. Okay. So the frequency range is 20 to 20,000 hertz. Apical most point 20 hertz sound is heard. Basal most point 20,000 hertz is heard. Anatomy. Now, in the organ of Corti, you can see outer hair cells 3 rows and inner hair cells 1 row. So the differences between outer and inner is, so outer hair cells are more, inner hair cells are less. Outer hair cells will modulate the inner hair cells. Whenever outer hair cells are rubbing against to the tectorial membrane during fluid movements, what happens? Hairs will bend and potassium channels open up. Unless this potassium efflux occurs, from he see this is endolymph, this is perilymph, so this is rich in potassium. Endolymph is rich in potassium, perilymph is rich in sodium, weak in potassium. So the potassium passes from high potassium area to low potassium area whenever potassium channels open here up. Now what happens when this potassium efflux occurs, a nerve impulse gets generated and travels inside, carrying that sound information towards the brain. So it's this outer hair cell movement that is opening the potassium channels, so generating the potential that is required for the nerve impulse to get generated. So outer hair cells modulate the function of inner hair cell, but not vice versa. Reverse is not true. Vice versa is not true. Okay. Outer will modulate inner, but inner will not modulate outer. So autoacoustic emissions are produced from outer hair cells. Coming to autoacoustic emissions produced by outer hair cells, these are the tests used for congenital hearing screening. So OAE and BERA, these are the tests used for congenital hearing screening. So at the time of birth, you will do autoacoustic emissions. If they are pass, nothing to be done. If they are refer, repeat autoacoustic emissions at 3 months again. If they are pass, okay. If they are not pass, then do BERA at 6 months. For newborn hearing screening purpose, which test is most commonly used? Autoacoustic emissions is most commonly used. Coming to ototoxicity, stria damaging drugs, antimyelin, diuretics, damage, outer hair cell damaging drugs are aminoglycosides and chemotherapeutic drugs, and vestibulotoxic drugs are GST, Genta streptotobra, right? Now coming to the sense organs, so you have this saccule. So this is the saccule, this is the utricle. So there are the structures, the sensory structures present in the saccule and utricle are called as macula. Macula in the, okay, you see the macula. If I take a small cut and expand this, and I will see the macula like this. So these are the hair cells and these are the, okay, otoconia, calcium carbonate crystals studded over the surface of the macula in the saccule and utricle. So the calcium carbonate otoconia are present here only, okay, not here. They are present here. Now what happens? See, if you take the utricle, the macula are arranged horizontally. And if you take the saccule, the macula is arranged vertically. Saccule detects vertical linear movements. Utricle detects horizontal linear movements. Okay, now coming to the semicircular canals. Okay, semicircular canals. You have crista here. Crista, so this is your crista. Okay, and above that you have cupula. Right now, if you see the three-dimensional, this is how it is present. Now, okay, hair cells are present in that. Right now, during okay movement, what happens? The horizontal linear movement is there. Now what happens? The macula will bend and hair cells bending, potassium channels opening up, nerve impulse generation. So that is what happens normally. And when you are moving angularly, angular movement is happening. Now what happens? The crista will get okay deflected and bending of the hair cells, potassium channel open up and okay nerve impulse generation. So this is how the movement, the balancing detection will occur in the ear. So now see, linear acceleration is detected by utricle and saccule. Utricle, horizontal linear acceleration, saccule, vertical linear acceleration. Hearing high frequency sounds, basal coil of cochlea, low frequency sounds, apical coil of the cochlea, angular acceleration is by semicircular canals, isn't it? Right. Now coming to the nerve supply of okay inner ear, I told you the lower two parts. Okay, I mean your parts during embryonic development, your otic sac, the membranous labyrinth. Okay, membranous labyrinth develops from otic sac. Otic sac gets divided into two parts, inferior one and superior one. Inferior one and superior one. From the inferior one, saccule and cochlea, cochlea and saccule. the inferior lying structures will develop. From the pars superior, the superior lying structures will develop like utricle and semicircular canals, right? Now, inferior lying structures, what are the structures? Cochlea and saccule. But function wise, saccule is different, detecting balance, cochlea is detecting hearing loss. So, hearing. So, cochlea has got its own nerve called as cochlear nerve. Okay. And coming to the saccule, this is supplied by inferior vestibular nerve because this is developing from, okay, inferior sac, pars inferior. Now, remaining utricle semicircular canals, they are developing from pars superior, utricle semicircular canals. They are supplied by superior vestibular nerve. Superior vestibular nerve, inferior vestibular nerve. One exception is there, that posterior semicircular canal. If you see the posterior or vertical semicircular canal, the crista cupula, the actual sensory detecting structure, is present near to the saccule. So this is supplied by inferior vestibular nerve. This is one exception. So inferior vestibular nerve, apart from supplying the saccule, it also gives another branch to the posterior semicircular canal. What is the name of this branch? What is the name of this branch? Singular nerve. Very good. So in BPPV, where posterior semicircular canal is the most common canal to get involved in BPPV, so you cut medically with epilepsy, it is not responding, then you cut this nerve called as singular neurectomy. Hope you are getting this. Okay, coming to the internal auditory canal. So there are four quadrants, from the anterior inferior part of the inner ear, I mean your cochlea. The nerve will go into the anterior inferior quadrant. That is your, okay, of the external of the internal auditory canal. Anterior inferior quadrant is occupied by cochlear nerve. Now come to the posterior part. From the posterior part, two nerves are arising, superior vestibular, inferior vestibular. So superior will go into posterior superior quadrant, inferior will go into posterior inferior quadrant. So these three quadrants are occupied by three nerves arising from the inner ear, right? According to their concerned positions, okay? Respective positions, they will be occupying the respective quadrants. Now the leftover is anterosuperior quadrant. The facial nerve will be passing from brain. It is motor nerve. It is passing from inside to outside. These are sensory nerves. These are passing from inside to outside. See, the cochlear is going inside. See, both the inferior vestibular nerve and superior vestibular nerve, both once gone into the internal acoustic canal inside, they join to form common vestibular nerve. Common vestibular and cochlear will join to form vestibulocochlear nerve. Now, from one side, four nerves are okay present. If you see here, these two vestibular nerves and cochlear are joining within the canal to form vestibulocochlear. Now, inside opening, if you see, only two nerves are coming out. Your facial is running as it is. बाकी तीन नर्व जो है कॉक्लियर वेस्टिबुलर वेस्टिबुलर, these are joining to form vestibulocochlear on the other side. Okay, so four nerves will be present towards inner ear side, two nerves will be present towards, okay, brain side. Are you able to follow now? The vertical division is called as partition is called as Bill's bar. Horizontal partition is called as falciform crest. Auditory pathway E. colima, right? Eighth nerve. So the nerve impulse is passing through the eighth nerve, cochlear nucleus, olivary complex superior, lateral lemniscus, inferior colliculus, medial geniculate body, auditory cortex. So this is how the nerve impulse will go. Fine. Now, remember E. colima. Now coming to the bera. Bera is detecting the integrity of the auditory nerve. See how your external auditory canal tympanic membrane is present. By directly putting an otoscopy, you can see whether this structure is normal or not. By doing an impedance, you can know whether middle ear is normal or not. By doing otoacoustic emissions, you can know whether cochlear is functioning normally or not. By doing a bera, you can know whether this tract is normal or not. If your otoscopy, impedance, okay, otoacoustic emissions, bera, all these are normal. That means the entire tract is completely normal. The sounds which are coming here are easily going inside to the brain. So that's what the interpretation you get. So beta is actually checking what? It is checking the integrity of the auditory nerve. Now see, wave, if you check the normal wave pattern of the beta, you have various prominent, okay, peaks. Each peak is corresponding to each structure in the auditory pathway. So for beta, you need to remember E. coli. So for the first two waves of the beta peaks, first two peaks in the beta wave will be concerned with the eighth nerve. So the proximal part of the eighth nerve and distal part of the eighth nerve. Now coming to the Cochlear nucleus, third nerve, third peak. The third peak is related to the cochlear nucleus. Fourth peak is related to the olivary complex superior. Fifth peak is related to the lateral lemniscus, like that. Now, if you take the normal wave and see, of all the waves, wave 5 is more prominent. In Vera, wave 5 is more prominent. The time taken for one, okay, from the peak, for the graph, to travel from one peak to another peak, the time taken should be only 1.1 milliseconds. If it is increasing, okay, if it is increasing, means, see, between 1 and 3 it has increased. Now between 1 and 3 it has increased, means between 1 and 3 there is some lesion here in this way. That's how I interpret the Bera. Now once I come to 4, 5, 6, the gap is same, okay, the latency is same here. Understood? Which of the following is true about Bera? It is used for screening of hearing loss. It is an invasive. No, just put electrodes here, they will pick up the electrical signal. It can be used for assessing SNHL. No, not exactly. It can be used for assessing hearing loss. It can't say whether conductive or SNHL. It is a subjective. No, it is objective. Your pure tone audiometry, speech audiometry, where patient has to respond, subject has to give responses to your questions. That is subjective. The participation of the subject is there. The patient himself is participating in the test. That is subjective test. Whereas all your Bera, auto questioning, all these are your objective tests. Patient need not participate. How a newborn will participate in the test? How a newborn will tell you responses? So this is simple logic. Is it common sense? Apply common sense. See, autoacoustic and Bera, I told you these are done to assess the congenital hearing screening test. So what does that mean? OE and Bera are objective tests. If they are subject, how can a newborn tell that he's hearing or not hearing? How can he tell? So he can't. You understood this? Okay. Gusa. Now coming to Meniere's disease. Why not SNHL? You go for lab 1 and lab 2. Now coming to Meniere's disease. So I told you already increased endolymph. The clinical features will be vast. Vertigo, oral fullness, SNHL and tinnitus. Fluctuating SNHL is seen in Meniere's disease. Fluctuating SNHL. Fluctuating conductive hearing loss is seen in OME, सीरस ओटिटिस मीडिया. पानी मिडिल ईयर में ज्यादा हो रहा, ओके, ज्यादा हो रहा कम हो रहा, ज्यादा हो रहा कम हो रहा, तो कंडक्टिव हियरिंग लॉस ज्यादा हो रहा कम हो रहा, ज्यादा हो रहा कम हो रहा, तो फ्लक्चुएटिंग कंडक्टिव हियरिंग लॉस. व्हाट हैपनिंग हियरिंग? अगर पानी अंदर, ओके, ऊपर नीचे हो रहा, पानी ज्यादा हो गया, ज्यादा एसएनएचएल, पानी कम हो गया, कम एसएनएचएल. सो हियर फ्लक्चुएटिंग एसएनएचएल, हियर फ्लक्चुएटिंग कंडक्टिव हियरिंग लॉस, फ्लक्चुएटिंग एसएनएचएल. मीनियर्स इधर होता है, ओएमई इधर होता है. Okay, right? Now coming to the, okay. Now in these cases, okay, otoscopy will be normal because where is the problem? Problem is in the cochlea. When I do an otoscopy, this all things will be normal. So on tuning fork test, what I will get? SNHL will be there. Which pattern? Ascending pattern of SNHL. Impedance will be A type. Why? Because middle ear is normal. So impedance will be normal, A type. Now, when I am getting complaints of vertigo, SNHL, oral fullness, roaring tinnitus, okay, when I'm suspecting Meniere's and PTA is showing ascending curve, my suspicion over Meniere's has increased. Now, for confirmation, I ask the patient to undergo electrocochleography. This is the investigation of choice. On electrocochleography, SP by AP, if it is more than 30%, that is confirmatory for Meniere's disease. Okay, so you can see upsloping audiogram here. And the medical management, first you start with medical management, diuretics, salt and fluid restrictions, vestibular sedatives, beta statins, and if it is not improving, you can go for chemical labyrinthectomy, inject gentamicin inside the inner ear, and it will damage the vestibule part separately and may suppress the vertigo. Or still, if it is not useful, you go for surgical methods where one type of surgery is preserving the hearing, another type of surgery is sacrificing, removing the hearing. So in hearing preserving surgeries, ELS decompression, endolymphatic sac decompression is the surgery used. Here, Donaldson, see endolymphatic sac already you know where the endolymph is moving outside. In Meniere's disease, the problem is more amount of endolymph. The what treatment you have to give? You have to facilitate the outflow of the endolymph from inner ear. So from where you can facilitate the outflow? From its normal outflow area. What is the normal outflow area of the endolymph? Endolymphatic sac. So if I open up the endolymphatic sac and put a shunt there, from through that, okay, inside whatever excess fluid comes, that will drain out through the, okay, shunt I have kept in the endolymphatic sac. Now what happens? So whenever excess production is there, excess excretion is also there. So amount of fluid remains normal inside. Okay. So to decompress the endolymphatic sac, to open up the endolymphatic sac and to put a shim, first I have to identify where it is. Where it is with the help of Donaldson's line. Draw a line along the lateral semicircular canal area posteriorly such that it bisects the posterior semicircular canal. This is your posterior semicircular canal. See, in the plane, if I'm drawing a straight line, it is bisecting the posterior canal. If I continue the line beneath, now below that line, in the floor of the mastoid, medial wall of the mastoid inside, there endolymphatic sac will be there. I'll give a slit, put a shunt, and that's it. My job is done, right? Okay. It will drain into the extra tissue spaces, right? It will drain into surrounding spaces, right? Now, so definitive surgery is labyrinthectomy, okay? Or see, if this also is not helping the patient, then finally, so patient has to get relief of giddiness, then you have to completely damage the labyrinth completely. Here, hearing is also lost, but this is definitive. इनर ईयर ही नहीं है तो इनर ईयर का प्रॉब्लम कहाँ है? Okay, so this becomes the definitive surgery. Miniate device is intermittent low pressure pulse waves. Okay, it gives counter pressure to the already present pressure from inside. This device will give counter pressure from outside. The 35-year-old male present to the clinic with complaints of vertigo, ear pressure, fullness, decreased hearing, roaring tinnitus. So this is clearly a case of Meniere's disease, right? 50-year-old male presented with vertigo, tinnitus, and fluctuating hearing loss. So you see ascending audiogram, that is Meniere's disease. Acoustic neuroma. See, what is the eighth nerve tumor? You call it as another names neurilemoma, vestibular schwannoma. Most common site is from inferior vestibular nerve and in the CP angle area, cerebellopontine angle area. So this acoustic neuroma is the most common. So the patient will be usual typical clinical presentation. Unilateral hearing loss with the tinnitus is the typical presentation in case of acoustic neuroma. If this tumor increases in size and compresses the nerves at the brainstem, fifth nerve compression can cause corneal anesthesia, hypoesthesia, decreased corneal sensation. Seventh nerve compression can cause Hitzelberger sign on the posterior meatal wall. If you remember 1 hour back, okay, there is a concha. From the concha, facial and vagal branches are supplying here. So facial compression can cause decreased sensation in this area. Facial nerve will not function normally. Hypoesthesia of the posterior meatal wall. And ninth and 10th dysphagia, hoarseness of voice will be there. And so whenever these patients come on otoscopy, if you see where is the problem is here. When I do an otoscopy, all these things will be looking normal. Tuning fork test will give me SNHL pattern because neural part is okay, and pure tone audiometry, banana shaped or trough shaped or cookie bite, some SNHL pattern I'll be seeing. Impedance, middle ear is normal, so impedance will be A type. So when I am suspecting acoustic neuroma, so this is a tumor, physical tumor. Now I will send the patient for gadolinium contrast enhanced MRI. It will show ice cream cone appearance. So I will see ice cream cone appearance here. So treatment is surgical excision and radiotherapy also is a beneficial. After excising, I will send the tumor for biopsy. It will show Antony A and Antony B patterns. That is confirmatory. So there are retrocochlear cochlear tests. You know that. I told you to remember these two, recruitment and CC score. Recruitment is present in cochlear. CC score is very high in cochlear. If you remember these two, remaining all are related to retrocochlear, tone decay, stapedial reflex absent, Bera abnormal, speech discrimination score. I mean speech audiometry, very poor in retrocochlear, rollover phenomena is seen in retrocochlear. All these except these two. See the color coding. So just remember recruitment is seen in cochlear lesion, CC score is high in cochlear, whereas all other are abnormal in retrocochlear. Likewise, you can remember easily. Coming to the BPPV, the name itself is telling you paroxysmal means short episodes, few seconds it will be there. Position change, positional means on position change it will be there. The problem here is the otoconia which are present within the saccule and utriculum macula, they get dislodged and go into the semicircular canal. Most commonly involved is posterior semicircular canal. Now, the diagnostic test is Dix-Hallpike and the therapeutic maneuver is Epley's maneuver. And if Epley's maneuver is not okay working, so after 3 to 4 episodes of Epley's also, the BPPV is not relieving, then that is called as intractable BPPV. In that case, you will go for singular neurectomy. Okay. Which nerve affects first in acoustic neuroma? So on the whole, if the question is asked, the tumor is arising from which nerve? Inferior vestibular nerve means eighth cranial nerve. Okay, understood. Which of the following is responsible for balance and equilibrium semicircular canal? Now coming to the Bell's palsy, lower motor neuron palsy, angle of motivation, loss of nasolabial fold, ptosis, okay, and absence of frowning, and Bell's phenomena, okay, and drooling of saliva, difficulties, okay, eating. So is a lower motor neuron palsy treatment of choice. Corticosteroids are the mainstay of treatment, right? Okay, all those things you know, right? Okay. And temporal bone fractures, there are two types, longitudinal fractures and the transverse fractures. Remember one thing, longitudinal means, see the longitudinal fracture, transverse fracture. Whenever you are sitting in your reading room and you are studying, longitudinal, transverse. So, but don't beat the other person sitting beside you, okay? Longitudinal and transverse. You have to study longitudinal, okay? Beat yourself and read as longitudinal and transverse. So when I'm, okay, this is longitudinal, the fracture line is passing like here. Transverse, the fracture line is passing from here, okay? Right? Now, coming to the middle ear, I mean longitudinal. So when longitudinal fracture is happening, see the middle ear is getting involved here. So you have middle ear symptoms here. And when you see, take the transverse is causing the inner ear. See, this is the cochlear part. Inner ear is getting affected here. Your facial nerve is also running like this, isn't it? Facial nerve is running like this and entering the middle ear, medial wall and posterior wall and going out. Now, so the transverse fracture is having the chances of transecting the facial nerve also. So facial nerve is also involved in transverse fracture. Inner ear, facial nerve are related to transverse fracture. So conductive hearing loss is a symptom of middle ear. Hemotympanum is a symptom of middle ear. So in longitudinal, you will see these two. In transverse, inner ear, SNHL, vertigo, tinnitus, you see in transverse fracture. So types of hearing aids I do. So what are the basic components in a hearing aid? Mic, amplifier, speaker. Mic, amplifier, speaker, right? So behind the ear and a receiver in the canal. These are the types which are most commonly given. ITC in the canal and completely in the canal. Even though aesthetically more acceptable, but as the mic is very near to the speaker, the sounds emitted from the speaker are again heard back by the mic and the sound will be echoing inside. The quality of the sound output will be very less here. So that's why these are not preferred. Most commonly used are these two. What is Baha? See, whenever I am okay using a hearing aid, if you see here, various types of hearing aid, everywhere I am putting the hearing aid okay in the canal conventionally. Regularly आगे में डालते हैं, पीछे तो डालते नहीं regularly. Okay, it's not a regular thing, right? Okay, now okay, so अगर आगे में नहीं हो गया तो हम क्या करते हैं, तो हम पीछे वाला रूट को यूज करते हैं. अगर see if there is any external artery canal atresia or CSOM case, repeated ear discharge episodes are there, or canal wall down, this wall I have removed, canal wall down mastoidectomy has done, so आगे में मैं कर नहीं सकता हूँ तो मैं पीछे से hearing aid को डाल सकता हूँ. Understood? So this is bone anchored hearing aid. Okay, I am talking about hearing aids as you know, right? So this is called as Baha, bone anchored hearing aid. So bone anchored hearing aid. So this hearing aid is anchored to the bone. Which bone? Posterior, okay, occiput bone. There I will make a well, fix a fixture there. To that fixture, whenever I want, I can insert the screw up the hearing aid. Whenever I don't want, I will screw it out and I can remove it. In which of the following conditions is Baha used? Congenital EAC atresia, right? Okay, you know that. Cochlear implant. What are the parts of cochlear implant? External microphone, amplifier is there, and this is external transmitter. So I am telling you external transmitter. This is present externally outside, and this is transmitting to what? Internal receiver. So this is running internally, and this is receiving the transmitted sounds from outside. So this is internal receiver, and this is also sending an electrode into the cochlea. So this is stimulator. So this entire thing is a receiver stimulator package. So this is internal receiver, and you have the electrode, intracochlear electrode, one more grounding electrode for earthing purpose, which is left in the temporalis muscle area. Now these are the parts. So external amplifier and the external, okay, microphone amplifier, okay, and speech transmitter, external transmitter, internal receiver, cochlear electrode, grounding electrode. A child with bilateral sensory SNHL was given hearing aids which have not been beneficial. Before going for cochlear implantation, give 6 months of hearing aid trial. If the child is happy with hearing aid, continue with hearing aid only. Don't go for cochlear implant. Even after 6 months of hearing aids, if the child is not having any benefit, then you go for cochlear implantation. Right? Okay, now. Now, auditory brainstem implant. See, if I am inserting a cochlear implant means, see the sound is getting outside stimulated and the sound is coming to the cochlea. Till the cochlea, I am sending the outside sound to the cochlea in cochlear implant. Now, from here, the information has to be carried inside by the auditory nerve. But if this auditory nerve is not functioning, the point in inserting a cochlear implant is useless if this nerve is not functioning. So one of the functional criteria, important criteria for cochlear implantation is normal auditory nerve. But in some cases, okay, auditory neuropathy, where auditory nerve is not functioning, your cochlear implant may not be beneficial. In that cases, you need to bypass this area also, and you put an implant directly on the brain stem. So that is called as auditory brainstem implant. So the sounds are directly conveyed to the brainstem like this. Okay, where you are inserting it, lateral recess of the fourth ventricle, you will insert the, okay, electrode. And this is done in case of bilateral vestibular schwannomas, neurofibromatosis type 2. Okay, and auditory neuropathies. Now coming to the nose. Okay, आधा घंटा में nose खत्म होना है. So parts of external nose, upper 1/3 bony, lower 2/3 cartilaginous, upper lateral, lower lateral or alar cartilages. Rhinophyma. What is rhinophyma? Hypertrophy of the sebaceous glands. The oiliness here is due to the sebaceous glands here. So hypertrophy of such that glands can cause a tumor like this called as potato tumor also. And this is seen in long-standing case of acne rosacea. Treatment is surgical excision. A middle-aged man presents following lesion on the face. He has history of acne rosacea. The condition is rhinophyma. Now, coming to the vestibule, the anterior most the entrance part, which is lined by skin, okay, with the hair, okay, that is called as vestibule. Same, if you enter the ear, the entrance part, the cartilaginous part is lined with hair. Here also the entrance part is lined with hair, but here नहीं है, इधर नहीं है, अच्छा नहीं होगा, इधर बाहर ही है, okay. Now, so now coming to the pilosebaceous units, again the same pilosebaceous units, here also pilosebaceous, again the same infection, staph aureus, furuncular ball, you call it as, if entire vestibule is infected, you call it as vestibulitis. So very easy. Lateral nasal wall, this is important, you have 3 turbinates on either side and 3 meatai, corresponding meatai on either side, and this is your inferior turbinate, normal size, and during the chronic nasal pathologies like chronic rhinosinusitis, allergic rhinitis, the turbinate becomes enlarged and blocks the nose. So inferior turbinate hypertrophy will cause nose block. One more important point is inferior turbinate is a separate piece of bone. It itself is a separate piece of bone. So you can think ये bone है क्या, थोड़ी ना, ये bone कैसे कहते हैं इसको, ये क्या दिख रहा है इधर, ये bone नहीं है ना. See, inside a plate like bone will be coming like this. Surrounding this vascular sinusoidal tissue will be present here. Over that mucosal covering will be there. When I am seeing from outside, I am seeing the outside mucosal covering. If I remove this cover, okay, I will see the vascular sinusoids. If I remove that vascular sinusoids, I will see the bone inside. If I remove the dress, okay, your dress, what happens? I can see, okay. And if I remove that also, I can see bones skeleton inside. Understood? So, turbinate, this is bone part of the turbinate, vascular sinusoidal tissue covered by mucosal layer, right? Now coming to the inferior meatus, into the inferior meatus, which one opens? Nasolacrimal duct. So this is a part of the lacrimal apparatus, right? So the lacrimal gland secretes the tear secretions. They flow here at the medial canthus. Above and down, you have medial puncta. So through the puncta, the fluid will, the tear secretions will go inside and through the common canaliculus into the lacrimal sac and through the nasolacrimal duct into the inferior meatus. So your tear secretions which are produced here are traveling down into the nasal cavity, and once they enter into the nasal cavity, they will be going along to the pharynx and along there from down into the esophagus and stomach acids, they will get destroyed. So this is how your normal drainage pathway is present. Okay. Now, come to the various pathologies here. Now, whenever there is nasolacrimal duct obstruction, distal obstruction, see, this is the proximal part of the lacrimal apparatus. This is the distal part of the lacrimal apparatus. See, DCR, dacryocysto rhinostomy, lacrimal sac, lacrimal sac, rhino, nose, stomy, opening, dacryocysto rhinostomy, DCR. This is a common opening between lacrimal sac and nasal cavity. So, see, if you do this opening, when you do this surgery, DCR opening, whenever there is a distal block, whenever there is a nasolacrimal duct obstruction, as in congenital like that, then you will go for DCR. Before going for DCR, for 2 months, you will advise massage, and while massaging, the lumen may open up and the natural luminization may occur. If this does not occur even after 2 months, then you go for DCR. Okay, and in chronic dacryocystitis, repeated lacrimal sac infections. Okay, in these cases also, what happens? You can open up the sac if this is patent. So you can open up the sac and you can connect it into the nose. Now, if the block is proximal, if the block is in the canaliculi, proximal, if I do a DCR here, there is no use because the tear secretions which are coming here can get blocked here and again epiphora will be there. If I do a DCR for proximal blocks also, there won't be much use. So for proximal blocks, you go for external approach. You will open up and you will relieve the block from outside. For distal blocks, you will go from inside, from endonasally, from endoscopically, you will go for DCR. There is a probe test. So I take a Bowman's probe and I will pass through the puncta medially. Now, when I pass the puncta medially, if there is distal block, my probe will go and touch the bone here. My probe, if there is no block, my probe will go and touch the bone. So when I am feeling the hard stop, if I'm getting a stop hardly, means I'm touching the bone. If my probe is going and touching the bone, what does that mean? There is no proximal block. The block may be distal. Okay, so in these cases, DCR will be helpful. But here, if there is proximal block, when I'm passing the probe through here, this tumor will restrict my probe and I will feel the softness of the tumor. I will come to a soft stop. So when I'm getting a soft stop, compressible, pressable, soft stop, that means that is proximal block. You're understanding? Hopefully you're understanding. Okay, but okay, this is not the time to understand even. Lacrimal sac is present on which wall? Medial wall. Lacrimal gland is present on which wall? Superolateral wall. My natural way of teaching it is going. I'm okay. Even though I want to run, that's going towards that side. Now coming to the middle turbinate. So first part, there are 3 parts of middle turbinate. First part, second part, third part. So first part arises from the middle turbinate. Cribriform plate, first part arises, right? In between lamina paprica and the middle turbinate, you have the ethmoidal air cells. You have the ethmoidal air cells here. When I see from superior view, see the first part running in the sagittal plane, second part running in the coronal plane, third part running in the axial plane. So first part, second part, and third part. Okay. Okay. Maybe some books are telling 6 months, but usually it is given for 2 months. Okay. Surgery to karna padega na. Okay. Now, okay. Okay, if any standard book is telling 6 months, that's up to you. But yes, in Dingra or in this, regular books, it is mentioned as 2 months. We are taught as 2 months only. Okay. Now, first part, second part, third part. Anterior to the second part, anterior ethmoidal air cells. Posterior to the second part, posterior ethmoidal air cells are present. So middle turbinate has got 3 parts, right? So middle turbinate and superior turbinate are parts of ethmoid bone. I told you inferior turbinate is a separate bone, right? So let us go further. What is concha bullosa? Pneumatization of the mid. See, normal middle turbinate should be like this. If the ethmoid sinuses expand into the middle turbinate and pneumatize that also, middle turbinate also. Now, what happens to the middle turbinate? It will bulge like this from inside. Now, this is concha bullosa. Another name for turbinate is concha, and the concha is not like this. It is appearing bulged, bullous like appearance. So, concha bullosa, pneumatization of the middle turbinate. Now, coming to the agar nasi. So, if the anterior ethmoids spread anteriorly into the lacrimal bone also, then a formation of agar nasi may occur. This is the anterior most ethmoidal air cell. You call agar nasi cell is the anterior most. It impedes the frontal sinus drainage, and the largest ethmoidal air cell is ethmoidal bulla ethmoidalis, right? मराठी वाला बहुत अच्छे से याद रख सकते हैं. What are the air cells located at the anterior most part of the anterior ethmoidal air sinus called? Okay, air cells located at the anterior most part of the anterior ethmoidal, agar nasi. So agar nasi are the anterior most ethmoidal air cell, whereas your bulla ethmoidalis is the largest ethmoidal air cell. Our onodi cell is near to the optic nerve. See, onodi cell is near to the optic nerve. See the ethmoids extending over the sphenoid. See the ethmoid extending over the sphenoid on the left side. On the right side, there is no onodi cell. On the left side, above the sphenoid sinus, you can see the onodi cell. The arrow mark is showing onodi cell. The star shapes are showing you sphenoid sinuses on either side. Okay, so this is your optic nerve. See the onodi cell lying very near to the optic nerve, right? And Haller cell. See, this is the floor of the orbit getting pneumatized. That is Haller cell. Now coming to middle meatus, I told you already, uncinate process is there. Okay, on endoscopic view, you can see the uncinate process, bulla ethmoidalis. The two-dimensional gap between them is hiatus semilunaris. Through this, if I enter inside, there is a three-dimensional space called as ethmoidal infundibulum, and where your maxillary sinus is opening with maxillary ostium. So this is middle. Most common set of obstruction by nasal polyp from the maxillary sinus is middle meatus. Maxillary sinus opens into middle meatus, right? Haller cell, see the Haller cell floor of orbit. See, this is not Haller cell. For your information, if the pneumatization is at the floor of the orbit, this is Haller cell. This is not. This is Haller cell. This is actually bulla ethmoidalis. Large. See the large size of the cell. Bulla ethmoidalis extending inferiorly, but not Haller cell. This is Haller cell. Please be careful. Coming to superior turbinate, you already superior meatus, posterior ethmoidal air cells will open, sphenoethmoidal races, sphenoid sinus will open, that's okay. Coming to the septum, what are the major bones forming the septum? Perpendicular plate of ethmoid superiorly, vomer posterior inferiorly. You have that later. We have that later, don't worry. And anterior inferiorly, you have the quadrilateral cartilage. Septal trauma, so you have, if the blow is from the front, you have Jarjaway fracture. If the blow is from below, Chavalet fracture. If you have any confusion, read only one thing. Blow is from below, Chavalet fracture. So the line also passes in the same direction. Blow is from below, the fracture line also passes, Chavalet. So remember only this one. Read only this one. The other one is Jarjaway. Likewise, you can remember. If the blow is from the side, that is C-shaped. Now, closed reduction is usually done after 5 to 7 days because to reduce the edema, right? For nasal bone reduction, what is the forceps you use? Walsham forceps. For septal reduction, the forceps used is Asch forceps. Okay, a young adult presents with deformed nose after falling from a ladder, displaced nasal fracture is there. Ideal time is 5 to 7 days to reduce the edema. And so, this is your, what is this? Walsham forceps for nasal bones, Asch forceps for septum. So whenever you are reading this Walsham forceps, Walsham nasal bone forceps, you read it like that only. Walsham nasal bone forceps, Asch septal forceps, Walsham nasal bone forceps, Asch septal forceps. So if you read like that, it will be okay given to the brain. The input to the brain will be given like that. It retains like that, and the way it is retained inside, it comes out in the same way during your exam. So always whenever you are reading Walsham nasal bone forceps and ask septal forceps. And how to identify if two are given? The slight angulation will be there in the septal forceps. Are you following or ज़्यादा हो गया? Saturate हो गया? Now, coming to the septal deviation, it may occur due to trauma during vaginal delivery, adenoid hypertrophy, various types of dislocations, deviations. Okay, ethmoidal neuralgia. What is ethmoidal neuralgia? In the middle turbinate area, the septal spur formation may occur and impinge on the middle turbinate, causing pain in the anterior ethmoidal region. In this area, anterior ethmoidal region, the patient will be complaining of pain. Okay, so that is due to the septal spur deformity in the middle turbinate area. You call this as Sludder's neuralgia. Anterior ethmoidal nerve is getting compressed by the septal spur. By septal spur. This is the region of middle turbinate. Okay. Cortils test. If you pull the, okay, if the patient is complaining on the, okay, right side block, nose block, you pull the cheek outside and the patient is feeling better. So that is Cortils test positive, right? So Cortils test means pull the cheek away. So the patient will feel better breathing through the blocked nose. That is Cortils test. Okay, that is telling that the DNS is causing block in the nasal valve area. So what is the test detected? This is Cortils test. And Epley's maneuver. What are the angles in Epley's maneuver? 45 degrees, 30 degrees, 90 degrees and 90 degrees. Do you remember that? 45, 30, 90, 90. Dix Hallpike 45, 30. Epley's 45, 30, 90, 90. Yes. Heimlich maneuver is for choking. Trotter's method, initial method. Pitch the nostrils, lean forward and okay, pitch it for 5 minutes. Keep breathing through the mouth. That is for epistaxis first method. एसएमआर जिसमें 5 फोटो वो एप्लीस है। अच्छा, एक ही यही फोटोज देगा एग्जाम में? फोटोज नहीं देगा, सिर्फ एंगल्स बताएगा, तो क्या करेगा? ओके, SMR septoplasty. So this is done for submucous resection, septoplasty. These are the surgeries done for deviated nasal septum. So in submucous resection, read the name submucous resection. Below the mucus layer, what is there? Your septal bone is there, cartilage bone is there. Now what you are doing? Below the mucus layer, the bone which is there, you are removing that. You are resecting that submucous resection. There are chances of perforation here. In septoplasty, the resected bone is made into small pieces and again kept back and the mucosa are replaced. So chances of perforation are not there here. Here chances of perforation will be there in SMR. Septal hematoma, road traffic accidents, trauma is the most common cause. Just like your pinna hematoma, here also same. So on either side of the septal cartilage, the blood gets collected and smooth round swellings will be there. Nose block will be there. Bleeding will be there. So between mucosa and cartilage, it will be there. Nose block, nose bleed, soft, smooth, rounded swellings on either side. Fluctuate because they are filled with blood fluid. So on they are compressible, fluctuate. If you press from this side, that side, it will be coming. So that is fluctuant. What is the treatment? Immediate incision and drainage. In pinna hematoma also, in pinna hematoma, boxers, wrestlers, cauliflower ear. So there also immediate incision and drainage followed by pressure dressing, here packing. 6-year-old boy fell from the bed, developed swelling in the nose, difficulty with smooth rounded swellings on either side of the septum, soft, fluctuant. So incision and drainage. See, this is how it occurs. See the smooth, rounded swellings on either side. See the septum, how it bulged on either side. So see the septum, blood on either side. Now see, you give an incision, you drain out all the fluid and you put a pack. Incision, drainage, packing. So this is how you go in case of this, right? Now coming to the next one. If the septal hematoma is very minimal, not enough pressure is there on the septum, mild blood has collected, that is not causing any symptoms. The stagnant blood collected in the septum on either side, okay, that may attract some bacterial infection later. So what happens? Okay, so that bacterial infection can occur and pus accumulation can occur. Now the bacteria starts increasing pus production. Now it can become, okay, completely it may become abscess, septal abscess. So here again the treatment is incision and drainage. And due to this pressure, if the septum gets necrosed, now what happens? See, the septum gets necrosed. How it will become if the septum gets necrosed in one area? It gets depressed. It gets depressed in one portion. So when it gets depressed, how it will look? See like this, saddle. On a horse saddle you will sit, no? So that is how horse saddle nose deformity. You are able to follow both. Right, very good. Okay. Septal perforation, cocaine abuse. Okay. So granulomatous diseases, all the granulomatous diseases and iatrogenic in submucous resection you can see. Mostly no symptoms. If the perforation is small, sometimes whistling may be there. If it is large, crusting and epistaxis. Septal buttons can be used. If they are small, you can make it large. If only whistling is the complaint. After making large, if again crusting epistaxis is there, then you can go for mucosal advancement flap technique surgically. So these are bony septal perforation. Remember this line, in syphilis, bony septal perforations occur. Perpendicular plate of the ethmoid, vomer, there syphilis perforations can occur. Other perforations occur in the anteroinferior cartilaginous area. Now coming to the epistaxis. So blood supply to the septum is by anterior ethmoidal, posterior ethmoidal. These are branches of ophthalmic artery, which is a branch of internal carotid artery. Now coming to the major part, artery of epistaxis, 70% of the entire nose is supplied by sphenopalatine. So this completely on the lateral wall, septum, everywhere, this will be supplying sphenopalatine artery. And another one from palate is coming is greater palatine. These two are branches of maxillary artery. In anteroinferiorly, you have superior labial artery, which is a branch of facial. Facial and maxillary are branch of external carotid. External internal carotid is a branch of common carotid. Now, little's area or Kieselbach's plexus. What do you mean by this? On the anteroinferior part of your septum, except to posterior ethmoidal, baki subchar, anterior ethmoidal, sphenopalatine, greater palatine, superior labial. All these will form a arterial plexus, thick vascular plexus that is called as Kieselbach's plexus, and that area is called as Little's area. This is the most common site of epistaxis. Epistaxis is most common in children. Why? Because of nose picking. Okay, so anterior inferior part is getting rubbed, so chances of epistaxis will be more. Right. Most common cause of epistaxis in adults is uncontrolled hypertension, but in children it is nose picking. Which of the following is true with respect to Little's area? So it is present in the Kieselbach's plexus is present in the Little's area. It is situated in the anterior-inferior part of the nasal septum. It is the Little's area is the most common site for epistaxis. Four major arteries anastomose here. Woodruff's plexus. Woodruff's plexus is present posterior-inferiorly on the lateral wall. Little's area is present anterior-inferior part of the septum. Posterior-inferior part of the lateral wall, Woodruff's plexus is present. Little's area is arterial. Kieselbach's plexus is arterial. Woodruff's plexus is venous. Sometimes in hypertensive patients, posterior epistaxis, Woodruff's area is the site of a posterior epistaxis. But in general, if the question is asking you, an adult patient comes with a nosebleed due to uncontrolled hypertension. Which is the artery involved in epistaxis? It is again sphenopalatine. If the option is giving you whether anterior or posterior, whatever bleed it is, if the options are mentioning sphenopalatine artery, sphenopalatine is the correct option. Epistaxis treatment. So first you will go for Trotter's treatment and other conservative approaches you will go for. And if you are able to identify that point bleeder, cauterize it. And if cauterization is not helpful, you go for packing, anterior packing and then posterior packing. Even if it is not helpful, then you go for ligation techniques, the artery ligation. So most amount of blood is supplied by sphenopalatine. So first you ligate that. If still not beneficial, then ligate its parent artery, maxillary. If still not bleeding stopped, then ligate its parent artery, that is external carotid. If still bleeding not stopped, now don't block this one. You just block the anterior ethmoidal, right? Okay. Don't go for CCA. Now coming to the inflammatory conditions. Dr. Dhania, you want to ligate CCA? All the best. Now coming to the atrophic rhinitis. So atrophic rhinitis, everything is getting atrophied. All the blood vessels, nerves, everything are getting atrophied. Okay. Yeah, cauterize before packing only. After packing, how can you cauterize? जगह कहाँ है? तू खुद ही पैक कर दिया तो जगह तो कैसे तू अंदर डाल के कॉटरेज कर सकती? ओके. Now coming to so All the blood elements, blood vessels and nerves are getting atrophied. Now, so what are the turbinates made up of? Vascular tissue. So if the blood vessels are atrophied, so vascular tissue is gone, turbinates are gone. Complete resorption of the turbinates will occur. Right. So what happens to the nasal cavity? Wide, roomy nasal cavities will be there. Nerves atrophy is there. That sensation of the airflow. Nerves are not functioning, not detecting the airflow. So patient will feel as if she is not breathing. So she will complain of nose block. But on examination, wide roomy nasal cavities. Olfactory also nerves also gone. So anosmia. But due to infection, okay, for foul smelling, pus discharge is coming, but she is not able to sense that. So this is called as merciful anosmia. Now, mucociliary mechanism is lost. So you know that mucociliary mechanism. So due to that, what happens? The clearance is lost. Whatever the dirt is coming from outside, that is piling up inside. So that is piling up and forming heavy bulky material inside. So crusting. So Klebsiella is the most common. So usually you will see greenish. Klebsiella causes greenish discharge, foul smelling. These are the various causes of the atrophic rhinitis. So coming to treatment, you have to remove all the crust. So you can give nasal irrigation with chemisettin solution, sodium solutions, placental extracts, okay, chemisettin solutions. And surgically, you need to go for young surgery or modified young surgery. 35-year-old female, persistent nasal congestion, foul smelling greenish black nasal crust, anosmia, dry nasal cavity with crust formation. So all these are pointing to atrophic rhinitis. Roomy. Turbinates are atrophied, no? So cavity becomes wide. Okay. A patient presents with foul smell from nose and nasal obstruction. The image of the finding is given below. What is the diagnosis? So greenish nasal crusting you are seeing, that is foul smell and nasal obstruction, and image is also showing heavy crusting, greenish crusting, that is atrophic rhinitis. This is rhinosporidiosis. Housewife presents with complaints of blocked nose, loss of smell, dry, greenish, crusty nasal discharge, roomy nasal cavities, atrophy turbinates. Now, this is the case of atrophic rhinitis. Young's operation is done for here. Video neurectomy is done for vasomotor rhinitis. Okay. Allergic rhinitis. It is a IgE mediated. As this is mediated by IgE, if you give anti-IgE antibodies like omalizumab, so you can reduce the symptomatic severity of the allergic rhinitis. This is a type 1 hypersensitivity reaction. Sneezing, watering, itching will be there. And so on examination, pale mucosa, mulberry appearance, cobblestone mucosa, these are the various patterns you will be noticing. Allergic salute will be there, Denny Morgan lines, allergic shiners will be there. So on investigation, IgE eosinophils will be elevated, and so treatment involves levocetirizine, antihistamines, majorly antihistamines and corticosteroid sprays, topical corticosteroid sprays. If all four of these are given as options. I mean, one option is telling you levocetirizine, another option gives you topical corticosteroid, another option gives you omologimab, okay, and another give one belastin. So इनमें से better one choose करना है, तो choose for topical corticosteroid sprays. So choose the first line should be topical corticosteroid space should be the best. Okay, if at all any medicines needs to be given, but always the best management is avoidance of the causative agent allergen. Okay. Vasomotor rhinitis. Here, this is non-allergic rhinitis. Symptoms will be same as allergic rhinitis, but IgE is normal, eosinophils are normal. So here, parasympathetic overactivity will be there. So increased secretions are the pathology. So the treatment is here, video neurectomy. Coming to the rhinoscleroma, it is caused by Klebsiella rhinoscleromatis. Another name is Frisch bacillus. It has got three stages: atrophic stage, which resembles atrophic rhinitis. Granulomatous means here small woody fibrous rubbery granulomas will form. You call it as woodinose or hebranos. Now these rubbery nodules will harden up, okay, due to increased deposition of fibrous tissue, and they'll form hard nodules, narrowing the nasal cavity, stenosing the cavity. You call it as tapirnose. This stage is called cicatricial stage. The treatment is antibiotic, streptomycin, tetracycline, rifampicin, and you have to remove already formed fibrosed nodules to make the nasal cavity patent. to widen the nasal cavity and facilitate for breathing. So surgical excision, and if you send them for histopathology, you will see Mikulicz cells and Russell bodies. Rhinosporidia is caused by Rhinosporidium seabury, which is a protozoan. This is seen in people taking bath in the ponds where crocodile is also taking bath. Coastal areas. Okay. Clinical features will be a strawberry-like mass protruding from the nasal cavity with yellowish whitish dots all over, and so epistaxis, that will be the strawberry mass and epistaxis. Treatment is surgical excision and dapsone can be used, right? And South Indian male cattle breeder complaints of epistaxis, biopsy done. HP shows multiple sporangia. You can see the multiple sporangia. Okay, so that is rhinosporidiosis. In hemangioma, you don't see this sporangia, right? Also, cattle breeder is the clue here. Polyps do not bleed. Rhinophyma is a potato tumor. Here, sebaceous hypertrophy. This is outside, not in the cavity. Okay. Now coming to inverted papilloma virus, human papilloma virus, HPV is the causative, males more than females. Why it is called as inverted papilloma? The growth occurs inverted. So new cells present at the base, old cells present at the periphery, right? Normally what happen if any tumor is there? Old cells should be present at the base, new cells should grow outward. So new cells should be present at the periphery, old cells should be present at the base. But here reverse happens. Old cells are pushed outward and new cells are growing inward. Okay, so that is inverted growth, inverted papilloma. And clinical, so it is males most commonly seen in elderly males, mostly unilateral. Epistaxis, nose block will be there. Benign and locally invasive. It can invade into the local. Invade locally means adjacent organ is orbit. It can invade into the orbit and can cause proptosis. Treatment is medial maxillectomy. A patient presents with complaints of unilateral nasal obstruction and bleeding. Diagnosis of inverted papilloma is made, and a true statement regarding the diagnosis: inverted papilloma is benign and locally invasive. Right? Coming to the paranasal sinuses, so frontal, maxillary, and anterior ethmoidal. These are anterior group. Posterior ethmoidal and sphenoid are posterior group. So coming to the maxillary, most commonly infected sinus because of anti-gravity drainage. The secretions has to ascend against to the gravity and come outside. So see the against to the gravity, they have come and they have to go outside. So that is why anti-gravity drainage leads to stasis of the secretions. Stagnation of the secretions will attract more bacterial infections. So most commonly infected sinuses. Identify maxillary. So this is maxillary sinus is completely infected here. Maxillary sinusitis easy. Ethmoids means bunch of grape appearance. I told you in between middle turbinate and the lateral wall, lamina papricia, you have the ethmoidal labyrinth here. The second part is separating the anterior ethmoidal air cells and posterior ethmoidal air cells, right? Okay, so this is like a bunch of grapes like appearance or honeycomb like appearance, and this is the most common sinus infected in allergic polyposis. In infective polyposis, anthracoinal polyp, maxillary sinus is most commonly affected. In ethmoidal, allergic polyposis, in ethmoidal, bunch of grapes appearance will be there. Okay, so differences between anterior and posterior ethmoids. Anterior ethmoids are small in size, posterior ethmoids are large in size. Anterior ethmoids are more in number, posterior ethmoids are less in number. The largest ethmoidal air cell, bulla, is present in anterior ethmoids. Frontal is the most common site for osteoma, biocele, mucocele. The cause for formation of mucocele means a lining, okay, a lining, the mucosal lining. So with the glands secreting inside into the cavity, mucus filled cavity, mucocele. The glands are secreting mucus into the closed seal-like cavity. If due to the trauma, if the mucosa becomes inverted and closes from inside, what happens? The glands, instead of secreting outside, they will be secreting inside. And due to trauma, due to the abruptions, if they close up and completely form a closed cavity, mucosal forms. So inside, mucosal will keep on forming. As the mucosal keeps on forming, mucus secretions keeps on happening, the mucosal keeps on increasing in size. So in the frontal sinus, if the mucosal keeps on increasing in size, this will take years together. So slowly, the orbit will be shifting towards outside. So So the axis of the orbit changes, not in this way. So the axis of the orbit may change, and due to the pressure, if the proptosis occurs, it will be not axial, it will be non-axial proptosis will be there. Okay, so this is about frontal. In frontal, most chances are there for osteoma formation, mucocele formation, pyocele. If inside this mucocele, bacterial infiltration occurs and pus forms, that is pyocele. That becomes pyocele. Mucocele, pyocele, Pott's puffy tumor, all these things most commonly seen in frontal sinus. Sphenoid sinus is the least commonly infected sinus. Anterior ethmoidal sinus drains into. Where does this drain into? Middle meatus, right? What are the other sinuses that drain into middle meatus? Maxillary, anterior ethmoidal, frontal. These three will drain into the middle meatus. Okay. Okay. And into the inferior meatus, nasolacrimal duct. Into the superior meatus, posterior ethmoids will drain. So this is how it is showing, right? So into the sphenoethmoidal recess, sphenoid will be draining into the sphenoethmoidal recess. This is your superior turbinate, superior meatus. Into the superior meatus, posterior ethmoids will be draining. All others, frontal, anterior ethmoids, and maxillary, all these are draining into your middle meatus. Into the inferior meatus, nasolacrimal duct is present. That you know very well. Sinusitis, conca bullosa, DNS, Haller cell, all these, And fungal sinusitis, most common, already fumigators. Mycetoma means a fungal ball. A ball like fungal mass is sitting inside the maxillary sinus. That is fungal ball or mycetoma, non-invasive. It just infects the maxillary sinus. AFRS, allergic fungal rhinosinusitis, most common in coastal areas. Humidity, dry, humid, hot, humid area is there. So wherever humidity is there, fungus tries to grow there. Ethmoid is the first infected site. From ethmoids, it can spread into the other sinuses. And invasive fungal sinusitis, again, aspergillus is the most common, not mucor. Mucor, in fact, is the least common. Mucor seen in severely immunocompromised people only, right? So CT will show you double density sign. See the hypodense area and see the hyperdense area. So two kinds of densities you see in case of fungal sinusitis. Which of the following fungal infection is most commonly seen in maxillary sinus? See, this is your fungal ball. FB means fungal ball, mycetoma sitting inside the maxillary sinus. See the double density sign. See the allergic fungal rhinosinusitis in the ethmoid area, eosinophilic mucin, sticky mucin like charcot-laden crystals due to allergy. You have seen here. What is the post-COVID patient non-diabetic unilateral facial pain, loosening of teeth? So this is a case of mucormycosis, and for confirmation, you need biopsy. To know how far it has extended and how much damage it has done, for that you need MRI. Confirmation is always by histopathology. So you can see a black turbinate sign. And also in case of mucor, the branching is 90° and aseptate. Whereas in aspergillus, 45° branching of the hyphae and septate hyphae will be there. An elderly diabetic female treated with steroids and remdesivir for COVID, now presented with the black false smelling discharge from the nose, blackish necrotic mass filling the nasal cavity, eroding the septum and hot palate. So mucormycosis, right? See the blackish discoloration of the palate. This is your oral airway. Now see the black discharge inside the nasal cavity. Steps of this. Remember, first we will remove the uncinate. Once I remove the uncinate, I am coming anteriorly from here. So I am coming from anterior. So I have to remove the uncinate first. So the uncinate, if I remove the uncinate here, which is present here like this. So I will remove the uncinate. Once I remove the uncinate, I will see the maxillary ostium, ethmoidal infundibulum here. And I will widen the opening of the maxillary sinus, maxillary ostium widening, middle meatal antrostomy will be done. And then I will remove all the anterior ethmoidal air cells. First bulla will be there. So I will remove the bulla. Okay, Marathi people, feel mat hona. So here I am referring to, this one, anterior ethmoidal sinus. So bullectomy, then other anterior ethmoidectomy. Then I will, pierce the ground lamella, the second part of the middle turbinate. Then I will remove the posterior ethmoids. See, anterior ethmoid, ground lamella, posterior ethmoid. Then I will go for sphenoid. I will widen the sphenoid opening. Then I will go for frontum. I will widen the frontal area, frontal opening here. Understood? Okay. Complications, mainly you are operating in and around the orbit only. So all orbital complications, cellulitis, abscess, hematoma, all superior orbital fissure syndrome, orbital apex syndrome can happen. Nasal polyposis, two types are there, antrochoanal and ethmoidal. Ethmoidal, I just told you, is allergic in nature. Allergic polyposis mostly occurs in ethmoidal. Bunch of grapes, honeycomb appearance is there. So this recurrence is high positive possibility. Antrochoanal polyp is infective. Antrum, this is maxillary antrum. From here, antrum, the polyp is growing towards coena, posterior coena, anterior coena. So this is antrochoanal. Antrochoanal polyp. So how many lobes are there? Three lobes are there. So this is usually trilobed, right? Okay, both of them you have to remove. Treatment is always surgical. Dot sign or crescent sign. So if a tumor is growing from anterior, there is a gap between posterior pharyngeal wall and the tumor. This presence of this gap between tumor anteriorly and posterior pharyngeal wall posteriorly. This is called as dot sign. If a tumor like JNA or NPC is arising from the posterior pharyngeal wall, there is no gap here. Okay, so that is dot sign absent. Following image shows which X-ray view. This is Townes view for skull fractures. This is your Waters view from maxillary sinus. This is Caldwell's view for frontal sinus. And this is for Sculler's view is for mastoid. Sculler's view is for mastoid. And this is your, see here, frontal sinus, okay, Caldwell's view, maxillary sinus, nose chin position, maxillary, Waters view, maxillary sinus, sphenoid sinus, submentovertical or basal view, Peary view also comes for sphenoid sinus, or this one, Waters view with open mouth is Peary's view, and ethmoid sinus can be seen by Rese's view. What is Law's view? For what? For which purpose you use Law's view and Stenver's view? Stenver's view is for mastoid, right? Okay, Law's view is for, what is for? Last view, anyone? Anyone? Last view is for? No? No one? Last view is for? Anyone? Last view is for? What is colors view? See here. Where is this going on? Mastoid. So I will see the mastoid better in colors view. Last view is also for? Last view is also for? क्या हो गया? कोई आंसर कर रहा है? Same. Last view is also for mastoid. Okay. Stenver's view is for inside. From the mastoid, if I go inside, I will go into the internal auditory canal area. So I will write it here. Internal acoustic canal. This is mastoid. Okay. पहली बार लिखना पड़ा आज. Fine. So I will share this PDF, go through this. Malignancy, most common set is maxillary. Nickel exposure causes squamous cell carcinoma, and hardwood dust exposure causes adenocarcinoma, woodworkers, carpenter's carcinoma. So nasal mass, epistaxis, cheek swelling, infraorbital nerve damage, loss of sensation of the cheek area, orbital invasive proptosis, loss of vision. So here comes here. This incision is called as Weber-Ferguson incision done for maxillectomy. Remember this incision. So if I give incision like this and open the skin flap, I will be on the surface of the maxilla bone. I will remove the maxilla tumor, whatever cancer is there. And this is Orngrens line. From the medial canthus to the angle of mandible, you draw a line that divides the maxilla sinus into two parts. Upper part is lying near to vital areas. So that's why it is dangerous. Any tumor above to the Orngrens line is having bad prognosis. Tumor below the Orngrens line is having good prognosis, because if it spreads also, it damages the mandible. So you can reconstruct it, remove it and reconstruct. So this is okay, fine, good prognosis. This is bad prognosis. What happened? Coming to trauma phase, zygoma fracture, blowout fracture, tear drop, hanging drop. So, okay, hanging drop or blowout, what happens? The orbital contents, the infraorbital fracture, it goes down, herniates into the maxilla. See the orbital contents going into the maxilla sinus. This is occurring, appearing like a teardrop or hanging drop. So the inferior rectus goes inside and gets trapped. So the movements are not possible. Eyeball movements get restricted. So you will have diplopia. A patient with a history of trauma presented with diplopia, epistaxis, and restricted eye movements. Looking at the CT image, see the herniation of the orbital contents inside, that is blowout fracture. Okay, CSF rhinorrhea. So the defect lies in the cribriform plate. The CSF will be leaking through the nose through the cribriform plate. Now, cause is most common cause is always trauma, idiopathic, hypothyroidism, obesity, benign intracranial hypertension. These are other causes. Unilateral watery drop by drop rhinorrhea. On bending forwards, it increases. Okay, so that is your typical presentation in case of CSF rhinorrhea. Reservoir sign, double ring sign, or target sign, or halo sign. Central red spot, okay, formed by the blood surrounding to that peripheral yellowish halo. This is called as double ring sign or target sign or halo sign. What is handkerchief test? If you whatever is coming from the nose, you put it on the handkerchief. If it is not stiffening, that is CSF. If it is stiffening, that is mucus. What is beta 2 transferrin? Whatever the secretion coming from the nose, send it for lab testing. If beta 2 transfer is present, it is CSF. Not present, it is from the nose. And high glucose levels, CSF. Localizing test or cystoscopy to know the site of defect before surgical planning, right? So bed rest, elevating head end of the bed, stool softeners, all these things will, okay, help relieve the symptoms first. What is the sign shown below? This is central red spot, peripheral yellow halo. Central red spot, peripheral halo. Double target sign. All of the following are initial management options. See, CSF rhinorrhea is a defect in the cribriform plate. The CSF is leaking outside. Steroids are given wherever there is inflammation. So if you give steroids here, what is the use here? The problem is not inflammation, as is sinusitis. No itis is there, no inflammation is there. It is CSF leaking through the defect. So here, how is steroids or FES, how a sinus surgery will help here? No. Okay, so bed rest, HRCT to know the site of defect, antibiotics and acetazolamide, diuretics, reduce the fluid, relieve the pressure inside. Okay, so this is for chronic rhinosinusitis, right? 23-year-old male presents to you with a nasal discharge, which has a following appearance on handkerchief. What is this sign? Halo sign. Central red spot, peripheral halo. And this is your squat sign. And this is your Phelps sign. So you can see the erosion of the bone here. Compared to this one, you can see here erosion of the bone, that is Phelps sign. Glomus jugular you see here. Coming to the larynx. So what is the framework of larynx made up of? 3 paid and 3 unpaid cartilages. What are the 3 unpaid cartilages? Thyroid. The thyroid has got 2 alae on either side, superior cornu, inferior cornu. And the other one is cricoid. Cricoid has got anterior thin arch, posterior big lamina. See, from anterior to posterior as you go, it enlarges in size, okay, in height. Now, what is the other unpaid one? Epiglottis. It arises from the posterior surface of the thyroid and goes upward. Upward it attaches to the hyoid bone. Now coming to the paid cartilages, arytenoid. So these are the 2 arytenoids sitting on either side of the cricoid lamina. Above each arytenoid, corniculate is sitting. Above each corniculate, cuneiform is sitting. So why? You know, your arytenoid has got a vocal process. If you see the arytenoid, see it has got a vocal process to which vocal cord is attached. It has got a muscular process. It has got a muscular process posterolaterally. To this, muscles of larynx are attached. Now, what is happening with this corniculate and cuneiform? They are just sitting there. Okay, एक रहने से भी ज्यादा है, दो है, पता नहीं क्यों है वो. ओके, हाउ मेनी ऑफ यू आर सिटिंग हियर? जस्ट ऐसे ही बैठ रहा है, पर पता नहीं क्यों बैठ रहा है. ओके, कोई है सर? Okay, okay. Which of the following laryngeal cartilage is least likely to be calcified? So I told you this trick how to remember. So you have to practice this diagram first. Okay, thyroid cartilage. Okay, cricoid cartilage, arytenoid, corniculate, cuneiform, and epiglottis. Now draw a line such that it separates the upper 3 cartilages from lower 3 cartilages. Upper 3 cartilages are elastic, do not ossify, do not harden. Lower 3 cartilages are hyaline, they ossify. If you get any doubt which cartilages ossify and which do not ossify, you just press your pinna like this. So this is elastic cartilage. If it gets ossified, hardened, it should not move like this. It should be stiff like that. Okay. So elastic cartilage do not ossify. Hyaline cartilages will ossify. So this one. Okay. You can correlate these two. I'll share the PDF. Now coming to aryepiglottic fold, aryepiglottic. So it is covering arytenoid posteriorly and epiglottis anteriorly. So either side it is covering and forming a lumen, that is aryepiglottic fold. You all know that. Now see this endoscopic view. When this is what I am seeing from above. Okay, this is the red one is your aryepiglottic fold, right? So this is your entire thing is your aryepiglottic fold. Anteriorly you have the epiglottis. Anteriorly you have the epiglottis. Posteriorly on either side, arytenoids are sitting on the cricoid. On the cricoid, arytenoids are sitting on either side. Okay, and aryepiglottic fold is covering. The lower border of the aryepiglottic fold is thickened to form the false vocal cord. So this is your false vocal cord. Down below, the white structures you are having is a true vocal cord. So this violet one is your true vocal cord. In between them, there is a gap. In between them, there is a gap. That gap is called as vestibular ventricle of the larynx. Through which, through this space, I can go laterally on either side, laterally. Behind this aryepiglottic fold, I can go. That is the saccule, right? So these are the. What are these then? Pyriform fossa on either side, post-cricoid area. This is cricoid, this is post-cricoid area. On either side of the this one, arytenoid here, you have the pyriform fossa on either side, right? Post-cricoid area and posterior pharyngeal wall. Posterior pharyngeal wall, post-cricoid area and pyriform sinus. These three are parts of hypopharynx or laryngopharynx. Now, vestibular saccule, already we have told you. This is false vocal cord, lower thickened border of the aryepiglottic fold. This is true vocal cord. In between, there is a gap. Through this gap, if I come to either side laterally, I am entering into saccule, oil can of the larynx, which is rich in mucus and serous glands. Laryngosyllismus, air-filled cystic dilatation of the saccule. You see it in professional wind instrument blowers. So, if I press that swelling, that air will go into the saccule, I mean into the larynx, and it will make a hissing sound. That sign is called as Bryce sign. So, what is the treatment option? Surgical excision will be the treatment option. Professional trumpet blower. So wind instrument blower, swelling on the left side of the neck. Sound, there is a sound when compressing, Bryce side. So CT is showing you. What is the CT showing you? Where is that CT? Yeah, this is the CT showing you air-filled cystic swelling. That is called as laryngocele. And this is your pharyngeal pouch. This is a barium swallow. See the blackish airway here, and see this is the esophagus lined with barium. But see this pouch, what is that? That is abnormal. That is pharyngeal pouch, Zenker's diverticulum, tracheoesophageal fistula, right? Marked structures. What are these? So whenever you are giving barium, it fills in the valvula first. It fills in the valvula. Okay, it fills in the valvula here, right? Isn't it? You are swallowing the barium, it lines the valvula. From here, on either side, it will come. On either side, it will go and it will line the pyriform fossa on either side. So see, first behind the tongue, it will fill in the valvula, epiglottis, valvula. On either side, here, your pyriform fossa is there. Pyriform fossa. So when you are given such X-ray, always remember the upper contrast area, filling area is the valvula, and lower contrast filling area on either side. This one. These are pyriform fossa. Above one is valvula anteriorly, below one is pyriform fossa posterolaterally. Hope you are able to follow this. Understand this. What happened? Yeah, smuggler's fossa. Muscles of larynx. What is the only abductor? Posterior cricoid, safety muscle of the larynx. Others all are adductors. Cricothyroid is the tensor. If you remember cricothyroid tensor, posterior cricoid abductor, all others are adductors. Coming to nerves of larynx. So all muscles of larynx except cricothyroid are supplied by recurrent laryngeal. Cricothyroid is supplied by EBSLN, external branch of SLN. Coming to the sensory supply, above the level of the vocal cords, IBSLN, internal laryngeal nerve is supplying. Below the level of the vocal cords, RLN is supplying. Okay. So left RLN. If you take the left RLN, see the left RLN is much longer going into the mediastinum and rotating around arch of aorta. Whereas right RLN within the neck, it is rotating around the subclavian within the neck. Now, so as it is left RLN is having a longer course, it is more prone to get damaged. Okay. So there is a syndrome called cardiovocal syndrome or Ortner syndrome. What happens? Right atrial hypertrophy here. Right atrial hypertrophy compresses the left recurrent laryngeal nerve. So compression of this will cause, intrinsic muscles of the larynx will get affected. So vocal cord palsy will be there. So that causes hoarseness of the voice. Due to cardiac hypertrophy, voice change is occurring. Cardiovocal syndrome. That is Ortner syndrome. Okay. Which nerve gives sensory supply to the larynx above the glottis? IBSLN. Pyriform fossa injured due to fishbone. Which nerve is damaged? This is very simple. I told you above the level of the vocal cords, it is supplied by internal branch. Below the level of the vocal cords, it is supplied by RLN. So, where are the pyriform fossa located? See, the pyriform fossa are located lateral to your aryepiglottic fold. Where is the aryepiglottic fold? Above the level of the vocal cords, above the level of the glottis. Where is the pyriform fossa located? Above the level of vocal cords, above the level of vocal cords. Now, where is the cricoid? Cricoid is post-cricoid area behind the cricoid. So, where is cricoid sitting? See, the vocal cord is arising from the arytenoid. Arytenoid is sitting above the cricoid, means cricoid is below the arytenoid, means cricoid is below the level of vocal cord, means post-cricoid area is below the level of the vocal cord. So, below the level of vocal cord is supplied by RLN. Okay, fine. Just half an hour will be completing. Okay, half an hour के बाद जा सकता हूँ. Okay. Now coming to the unilateral vocal cord palsy, the vocal cord will be lying in cadaveric position. Here, the vocal cord, whichever one side vocal cord is paralyzed, that is lying in cadaveric position. So this is affected vocal cord is lying in cadaveric position. Whenever you are okay breathing, so as usual, vocal cord should move away. So your normal vocal cord is moving away, and there is no problem for breathing. Now, whenever you are talking, normally, both should come near to each other, but this is paralyzed, lying paralyzed in the cadaveric position. So this, whenever you are trying to talk, this is coming near, but there is a gap. Through that gap, the voice is leaking. Okay, air voice is leaking to the gap. So you will get a breathy voice. Breathy voice will be there, no breathing difficulty, and risk of version. One side ILN is damaged, so this side, if the foreign body comes, can go inside. If the foreign body comes and touches the normal side, it gets expelled outward by cough reflex. So risk of aspiration is partial. Here, the problem is vocal cord is lying away. You just medialize it. Medialization thyroplasty type 1 is shaking. Now coming to the bilateral vocal cord palsy, here both vocal cords get paralyzed and both are lying in the paramedian position very near to each other, 1.5 mm, 1.5 mm from the middle and 3 mm only. Both are lying paralyzed. You are phonating, they may come near. Okay, voice may be normal or strangled. When you are breathing, they are just 3 mm away. So they are not moving away. More than that, they are not moving away. So the 3 mm airway is not enough for you to sustain. So gasping, respiratory difficulty will be there. Emergency tracheostomy needs to be done and wait for 6 months. So if, okay, after within 6 months, if it is becoming again back to normal, then okay. If not, then you will need to go for lateralization procedures, type 2 Ishikis, or you can go for arytenoidectomy to provide more airway. Little bit of anterior vocal cords are touching to each other during phonation, so little bit of voice can be there. Kashimas is the best surgery to give better voice to the patient. So out of these three, if you have to select the best one, Kashimas is always the best one. Posterior transverse cordotomy. Vocal cord ko posteriorly, I am cutting it transversely. Which of the following has the worst prognosis? So compared to unilateral, bilateral is having worse prognosis, that you know. But is it partial or complete? It is partial, not complete, because Simon's law, I'm telling Simon's law, okay? Simon's law states that what happens here? If you take the recurrent laryngeal nerve, in the recurrent laryngeal nerve, inside the nerve fibers, how they are arranged, you know, the abductor fibers are arranged peripherally. So if a tumor is coming from outside and compressing the nerve, abductor fibers are the first one to get affected. Then after, adductor fibers which are lying in the center will get affected. Obviously, okay. So first the soldiers will get affected. Then if the soldiers fail, then the king will get affected. So peripheral fibers will get affected first, then the central fibers. Abductor fibers will get affected first, then the central fibers. Incomplete tumor. Now, when the tumor is compressing partially, only abductor fibers are affected. Only abduction is lost. Okay, both adduction and tension, both are tensor is not. We are talking about RLN. Your tensor means cricothyroid. Cricothyroid is supplied by EBSLN, SLN, not RLN. We are talking about RLN palsy. So here tensors are normal in both situations, be it partial block or complete RLN block. We are talking about RLN pulses. So SLN will be normal, cricothyroid will be normal. So tensors will be normal in both conditions. In case of complete palsy, see, abduction is lost as well as adduction is also lost. The vocal cord is lying in paramedian position here, isn't it? Here, compared to this, okay, adduction is present here, adduction is absent here. Here, you have small 3 mm, at least patient is gasping. But here, even adductors are intact, even that also closed. वो भी बंद हो गया. So now the vocal cords are in median position. So this is highly life-threatening, very serious condition. Patient may pass away. So that's why partial is always dangerous than complete. Okay. Following total thyroidectomy, patient started having difficulty with repeated attempts to extubate were successful. Okay. Most probable cause is bilateral RLM palsy. Remember one thing, unilateral paralysis में voice problem आ जाएगा, bilateral paralysis में breathing problem आ जाएगा. One liner, I'm converting this into unilateral vocal cord palsy में voice problem आएगा, bilateral vocal cord palsy में what is that, breathing problem हो जाएगा. और जो लोग mnemonics को font है BB bilateral breathing. Ishika's thyroplasties. So 1 and 2, you know, medialization, lateralization. 3 and 4 are shortening and lengthening. Shortening is done for puberphonia, lengthening is done for androphonia. So males having female voice, you have to convert female voice to male voice, and you have to convert high pitch to low pitch. Now you have to reduce the distance between them. So you have to, if you, okay, you have to, once you reduce the distance, so this tightly stretched vocal cord will become loosely stretched. So it becomes loosely stretched. So it vibrates with low frequency. So male voice will come. Okay. So immediately don't go for surgery. If puberphonia patient comes, first give speech therapy for 6 months, then go for shortening thyroplasty. Lengthening is done for androphonia, just reverse of that. So a female is having male voice, you have to convert that male voice to female voice. That is lengthening. Coming to vocal nodule, usually seen in professional voice users, teachers, singers, screamers, vendors, etc. What's the most common set? Anterior one third, posterior two third, and usually they are bilateral, very small, less than 3 mm in size. Treatment is for speech therapy and voice rest. If not improving, then you have to go for speech therapy. You may give for 6 months, and still if not improving, then you need to go for surgical excision. Okay. A teacher presented with complaints of hoarseness of voice and examination. Bilateral swelling was noted on anterior one third, posterior two third. Bilateral swelling was noted on anterior one third, posterior two third, and is a teacher, right? So probable diagnosis vocal nodule. If it is a vocal polyp, it should be unilateral and large in size. Vocal cyst also within the substance of the vocal cord, the cyst is present, and it is ringkiss edema, bilateral, but heavy, huge, bulky saddlebag appearance of the vocal cord. Polypoidal appearance of the vocal cord will be there. What is the difference between polyp and a cyst? See, from the surface of the vocal cord, exophytic growth, the polyp is growing outward into the lumen of the airway. Now see the cyst within the substance of the vocal cord. Inside to the vocal cord only the cyst is growing. That is the difference. Endophytic growth, exophytic growth. Anterior तो ये है, posterior तो ये है ना. Anterior, posterior, anterior, anterior का मिशर. ये पूछ रहा अभी मेरे को. ये पोस्टीरियर, दिस इज एंटीरियर, दिस इज पोस्टीरियर. जो बड़ा है वो पोस्टीरियर है. वोकल कॉर्ड्स गो लाइक दिस, नो. ये लैब 3 में लास्ट आवर में पूछ रहा है ये डाउट. A teacher presents with following condition of hoarseness of the voice. See, vocal nodules, right? This is irregular appearance, vocal carcinoma, saddlebag appearance, ringkiss edema, and this is your vocal polyp. Vocal cord polyp unilateral, usually large size, more than 3 mm, sudden vocal abuse. So, okay, loud shouting, quarrel, okay, ek dusre ko upar, okay, they shout at each other. Then there will be formation of polyp. By the next day morning, it will come. So, acute in onset, sudden in onset. Treatment is surgical excision. Ringkiss edema, smoker's larynx, you call it as polypoid carditis, is seen in smoking. Okay, the saddlebag appearance of the vocal cord due to the heavy appearance of the vocal cord. So the vibrations become very hectic for the muscles to move. So painful phonation, voice fatigue will be there. So when the patient can't speak for long durations, surgical excision and stop smoking is the treatment. Recurrence may be seen here. A patient with ringkiss edema will have dysphonia. And remember one thing, whenever there is a Diplophonia is seen in unilateral vocal cord lesions. One vocal cord is normal, other vocal cord is affected. There you will see different frequency vibrations. So there you will see diplophonia, two voices. Okay. Vocal cord granuloma, chest, reverse, anterior two-third, posterior one-third junction, because the reflex will come and fall on the posterior area. So that's why this is common. So reflex is common here, okay, and prolonged intubation. While intubation, the ET tube will pass through the posterior area. So it will rub the posterior area, and chances of formation of granuloma are present in the posterior part. Treatment is surgical excision. Leukoplakia is a precancerous, smoking, alcohol, tobacco is the causes. Whenever a patient comes to you, take a biopsy, and on the biopsy, if leukoplakia is confirmed, you remove the entire lesion and ask the patient to be on regular follow-up, because it is okay precancerous recurrence are highly probability. Coming to acute epiglottitis, streptococcus pneumonia, hemophilus are the most common organisms. So sore throat, fever, cough, swallowing difficulty, doodling of saliva. You see the thumb sign here, tripod sign, child tries to lean forward. So rising sun sign. Treatment is, this is a bacterial infection. So bacterial infection, you need to give antibiotics. Nebulization to reduce the edema over the epiglottis. So epiglottis is huge, bulky here. NSAIDs to reduce the pain. And if severe respiratory distress is there, then you go for tracheostomy. You place a tube here bypassing this area. Croup. What is croup? Acute laryngotracheobronchitis. All this entire lower airway is involved from the larynx onwards. So you have a stridor biphasic, mostly biphasic, sometimes inspiratory, viral in origin. This is purely viral in origin. So fever, barking cough. You see a steeple sign here. So Stevie, this is viral in origin. So you don't give antibiotics here. Corticosteroids will be the main line of treatment here. Systemic and topical nebulizations you can give here. So 4-year-old boy, low grade fever, inspiratory, barking cough, hoarse voice. Whenever you are seeing this word hoarse voice is affected means larynx, vocal cords are affected. So vocal cords are affected means it cannot be acute epiglottitis. Is it epiglottis is above the level of the vocal cords? If the question says vocal cord, voice is changed, it means vocal cords are affected. So moderately inflamed pharynx, slightly increased respiratory rate. Respiratory rate increase means lower respiratory tract involved. So steeple sign is seen. So this is croup. In croup, you don't give antibiotics. You give all other agents which reduce the edema and improve the airway. All of the following organs can cause croup. So rhinovirus causes common cold coryza. Parainfluenza, these are the most common organs causing croup. What type of stridor occur in croup? Biphasic, mostly biphasic. A 2-year-old child with a past history of intubation presents OBD with shortness of breath that began durably approximately 2 months after intubation. So radiograph, what is the radiograph showing? Staple sign. So staple sign is seen in croup. Diphtheria, corynebacteria is a causative organism. If the vaccination is skipped, DPT vaccine is not given, so then the diphtheria can be caused, right? What are the features here? Pseudomembrane formation. If you remove this, it will bleed on touch. Cervical lymphadenopathy. Due to cervical lymphadenopathy, there will be bull neck appearance. Treatment is ADS, anti-diphtheria serum needs to be given. Worried mother brought her 6-year-old unimmunized child. The fever, cough, shortness of breath, pseudomembrane is noted. Bull neck appearance. So likely diagnosis diphtheria. This is your infectious mononucleus. EBV is the causative organism, and this is your candidiasis. TB larynx is the only painful TB part. So vocal cords are ulcerated. Okay, ulcerated. Mouse nibbled appearance, mouth eaten appearance will be there. Turban epiglottis. Epiglottis will become bulky. The treatment is ATT for 6 months. Papillomatosis. This is juvenile, recurrent, respiratory, HPV 6 and papilloma, human papilloma by 6 and 11. The tumor most common site is supraglottis, but actual site of origin is junction of supraglottis and glottis, right? So it originates from that junction, but fills the supraglottis. So during vaginal delivery only, the child will contract the infection, but the child will present at the age of 3 to 5 years. Late presentation will be there. So 3 to 5 years time will be taken for this kind of growth to occur and cause significant airway obstruction. Best treatment is surgical excision. Other medical options are 13-6 retinoic acid and pseudophobia. Adult versus infant larynx. Compared to the adults, infants have high lying larynx. So due to this high lying larynx, simultaneous feeding and breathing are helpful. One more important point is due to the conical shape of the larynx, the lowest subglottic part is narrower compared with the glottic part. Subglottis is narrow compared to glottis. In adults, vocal cords, glottis level is the narrowest one. Coming to laryngomalacia, this is the most common congenital anomaly of the larynx. So a 2 to 3 month newborn born with complaint of inspiratory stridor. The main problem is inspiratory stridor. It increases in supine and while feeding. If you make the child lie prone, the stridor decreases. What's the reason here? The laryngeal cartilages are very weak. They collapse during inspiration, they narrow down during respiration, causing this stridor, inspiratory stridor. What is the finding you see? Omega shaped epiglottis. That is the most common prominent finding you see here. So treatment is wait and watch. Just wait and reassure the parent. And up to 2 years you can wait. After 2 years you can go for epiglottopexy or supraglottoplasty. And but if at this time when the child is brought to you, you are seeing any severe obstruction, respiratory distress or peripheral cyanosis there, then you have to temporarily give a tracheostomy, alternate breathing route you have to give to the patient. Now coming to a child is brought to you with complaints of noisy breathing. On examination, you notice inspiratory stridor in the child. Laryngeal examination is given below. So this is your laryngeal. See the omega shaped epiglottis. Now this is laryngomalacia. Okay. And this is vocal cord palsy. You already know. Subglottic stenosis. Cotton Meyer has given grading for subglottic stenosis. Below the vocal cord level, the narrowing is there. Subglottic. Below the, see, this is the vocal cord. Below in the subglottis cricoid area, you have the narrowing. So 0 to 50% is grade 1, 51 to 70, grade 2, 71 to 90, and grade 3, 100% is grade 4. And this is papillomatosis. See the papilloma appearance. You have to identify with your eyes only. Sir, how to know this is papilloma or any growth? You have to, okay, see it repeatedly. Okay. Which of the following is true about laryngomalacia? So this is most common in newborn. Inspiratory stridor will be there. See, supraglottis में प्रॉब्लम है तो इंस्पिरेटरी स्ट्राइडर होगा. अगर सबग्लॉटिस या अपर पार्ट ऑफ द ट्रेकिया में प्रॉब्लम है, बाइफेसिक स्ट्राइडर होगा. और लोअर पार्ट ऑफ द ट्रेकिया और ब्रोंकाई में प्रॉब्लम है तो एक्सपिरेटरी स्ट्राइडर होगा. Upper part of the airway, inspiratory. Middle part of the airway, biphasic. Lower part of the airway, expiratory. Okay. अरे भाई, अगर आ गए तो 5 मिनट जाके आइए ना. ओके. इतना जल्दी है तो जाके आइए ना, कोई बात नहीं, 5 मिनट में को के एक टॉपिक जाएगा. Subglottic stenosis, okay, it is maybe congenital or acquired due to prolonged intubation. Due to that, okay, cuff, okay, you inflate the cuff, no, that cuff may put pressure on the surrounding walls and can cause fibrosis, thickening, and lumen narrows due to that. Cotton-Meyer grading is given for that. You know that glottic carcinoma has got best prognosis because in the vocal cord area, slightest change in the surface of the vocal cord, voice will change. When the voice changes, patient presents early, diagnosed early, treated early. So good prognosis. Also, there are no lymphatics in the vocal cord level. At the vocal cord level, there are no lymphatics. So no chances of distant spread, no metastasis. So good prognosis. Supraglottic carcinoma has got worst prognosis. Subglottic also almost intermediate prognosis. Now coming to the TNM, remember before the day of your exam, just have a look at this slide. Okay, remember, please remember this. T1, only one subsite means either glottis or supraglottis or subglottis. Okay. T2 means see supraglottis and glottis. Two subsites are involved, or subglottis and glottis. Two subsites are involved. This is T2. Now T3 is the main important thing you need to remember. T3 fixed. If the question is telling fixed vocal cords, it should be T3 or above that. If the question is telling freely mobile vocal cords, T1. Partially impaired mobility. Mobility is not free or completely not fixed, not completely free. Slightly mobile, impaired, slightly impaired. Now that is T2. T3 you have to remember, very important. T3 if you can remember, you can, okay, draw the correct answer from that, fixed. Okay, so in T3 what happens? The vocal cord is getting involved. Okay, fine. So either pre-epiglottic space or post-cricoid space are getting involved in the T3. Now 4A means beyond the larynx they are going. See, they are coming to the anterior wall. Now see, till this level T1, T2 all हो गया. Pre-epiglottic space or post-cricoid area T3 हो गया. Now going towards anterior part of the thyroid, okay, crossing the larynx part and going beyond, that is T4A. Now वहां से और पीछे आके और दूर vertebra में गया, that is T4B. right? So this is how you need see the systematic expansion. Tumor has started here, for example, T1, वहां से नीचे vocal cords को involve किया T2 and T3 में fix कर दिया पूरा, right? Extending into pre-epiglottic space post required, it has fixed the vocal cord T3. Now even वहां से ट्रेकिया को आई मीन योर थायराइड कार्टिलेज को आगे में आ गया, इस स्पेस में आ गया, दैट इज T4A एंड स्टिल पोस्टेड मीडिया स्टेनम में नीचे मीडिया स्टेनम में या पीछे वर्टिब्रे में चला गया, दैट इज T4P एंड N1 N2 N3 3 to 6 more than 6, this you know, this is universal for every tumor, every TNM staging. M0 N1, this is universal for every staging. So for larynx I can explain you this one, so this slide just go through, or if you are unable to just remember this T3. Okay, fixed vocal cord. Now coming, so draw same. So just okay, while coming to the staging, just draw like this. Okay, just put 1, 2, 3, 4A, 4B, 4C. You have to first write down them. You come continuously T1, T2, T3, T4A, T4B. You go on writing them. Next, you start writing N1 from stage 3. I'm always telling you 3 is the most important word to be remembered here. You start giving N1, N2, N3. You start giving N1 staging from stage 3. Next N2, next N3. Okay, and if M1 is there, this is the last stage. Okay, M1 comes for last stage. You imagine why. You cannot write means you just imagine. You have to. The 3 part you have to remember. Stage 1, 2, 3, 4A, 4B, 4C. These are there. T1, T2, T3, T4A, T4B. Now you start, okay, this one, you are N1 from 3, stage 3 onwards. Okay. A patient presents with hoarseness of voice. Ulcer proliferative mass is seen on the right vocal cord. Cord was, however, mobile. Means it is T1. Not impaired, not fixed. So not T2, not T3, only T1. No lymph node involvement, no metastasis, N0 emphysem. So this is stage 1. Radiotherapy is the treatment option. So total laryngectomy, if you have done for a patient of T4A, now you have to give back the voice to the patient. So for that, there is the best method is tracheoesophageal speech. Blom-Singer provoks, Groningen valves are used here. And the image given shows a patient who has undergone total laryngectomy due to laryngeal cancer. The method of voice generation is, see, whenever he wants to talk, he presses and the prosthesis opens up and the air is redirected towards the articulated tract and the voice will be produced. That is your tracheoesophageal. The best method of voice rehabilitation after laryngectomy is tracheoesophageal prosthesis. You have an electrolarynx, which is okay, somewhere it is used, but not that effective. Artificial larynx is still under an experimental stage. Okay, Chicago implant, you call it as. Tracheostomy. So in elective procedures, you take horizontal incision. In emergencies, you take vertical incisions, right? And elective means ICU patient is there, prolonged intubation, prolonged ventilation is needed for that patient. So you cannot put ET tube for longer durations. So you have to go for tracheostomy. That reduces the dead space. So usually the tracheostomy is done around tracheal ring 3-4 level. Tracheal ring 3, tracheal ring 4 level you'll do. But if you are doing at the level of tracheal ring 2, that is called as high tracheostomy. As a part of total laryngectomy, you will do that. Now there are various complications. Hemorrhage, apnea, pneumothorax immediately may happen, may not happen. Hemorrhage obviously while doing sometimes bleed may occur. That is okay, common. So that's okay. But intermediate complications, subcutaneous emphysema, the air may leak into the subcutaneous tissues and from crackly crepitus over the subcutaneous area. So that is called as subcutaneous emphysema. Very dangerous condition. So have to be treated as early as possible. And so these are the late. Okay, that tube inside irritating the tracheal mucosa and fibrosis occurs, narrowing occurs. That is tracheal stenosis. The image below shows a prosthesis. So this is a tracheostomy tube. You can see ambu bag is connected to the tracheostomy tube. Okay, this is the cuff of the tracheostomy tube, and this is your ET tube, and this is your cricothyroidotomy, and this is your Goodell's oropharyngeal airway. A patient presented with surgical emphysema after emergency tracheostomy. Most likely reason is tight stricture around tracheostomy tube. You know that. So what is the given instrument? After a tracheal, okay, tracheal stenosis was there. I have done a tracheal reconstruction, airway reconstruction. So after airway reconstruction, immediately I cannot ask the patient to use the airway for breathing. So till the time the suturing of the remaining tracheal area heals, I will insert a tube called as Montgomery T tube. Once the entire surgery done area, the airway improves and hardens up and heals up, then later I will remove this T tube. Okay, so this is your tracheoesophageal prosthesis. Tracheoesophageal prosthesis. So this, you know, Blom-Singer prosthesis, and this is your grommet, you know that. So this is your oropharyngeal airway. This is your oropharyngeal airway. What's the question? Patient came after road traffic accident with respiratory distress and severe maxillofacial trauma. Remember one basic fundamental thing. If there is any problem in the upper tract, upper parts, like your, okay, for example, there is a severe, okay, respiratory distress, Ludwig's angina is there, or a trauma has occurred and there is some bleeding, random bleeding occurring here, and trauma has occurred. Don't disturb this part, okay? You bypass this area, you bypass this area and utilize this area for giving breathing to the lungs directly. Okay, simple fundamental thing is whenever there is obstruction above, for example, okay, you have a acute epiglottitis over here. Okay, you have a severe laryngomalacia over here. Okay, so you are having some severe laryngeal web over here. So you bypass these areas immediately. You have to provide some airway to the patient. You bypass these areas and put tracheostomy. Where is the tracheostomy indicated? Means have this fundamental thing in your mind. Upper airway block is there. Bypass that area and provide airway from the down. After this upper airway becomes normal, then you can remove it and again the normal breathing will occur. So this is the double ring button batteries, double ring sign you call it as button batteries. You can see two rings here. Okay. And whenever a coin goes into the airway, it lies in the AP view. Among means it originates in the plane will go in the anteroposterior. When I take an AP view, the side of the coin, when I take a lateral view, the face of the coin is seen. This happens when the coin is in the airway. Now, when the coin is in the esophagus, this takes side to side orientation. Now, when I take a face AP view, when I take AP view, what I will see? I will see the face of the coin. I will see the face of the coin. Now, when I take a lateral view X-ray, I will see the side of the coin. So that's how you identify. Okay. Foreign body. So if it is in the larynx, okay, so stridor, voice change, vocal cords are affected, voice change, severe distress, because larynx is the narrowest area, so severe distress. If it is in the trachea, the foreign body can move up and down in the trachea, causing palpatory or audible thud. And if it is in the bronchus, whichever bronchus is filling, that area, lung will not, that side lung will not get ventilated. So one side reduced air entry or blocked air entry, other side, okay, ventilating normally. That means the foreign body is in that bronchus. A 3-year-old child presents with respiratory distress after eating peanuts. Audible third is there, means that is in trachea. 2-year-old child presents with respiratory distress, coughing, inability to speak after eating. 2-year-old child, 2-year-old child. So there is a confusion here. Okay, so it's okay. What is that? Usually, more than 1 year children, you can go for Heimlich maneuver. They say. So if it is as per your Dingra textbook, if the exam is asking this question, you go for Heimlich because it is more than 1 year old. So more than 1 year old, you can go for Heimlich manual. Okay. Now, 2 year old came to emergency department with a complaint of choking due to peanut ingestion. He was unresponsive. Whenever see after foreign body ingestion, unresponsive is there means you have to start chest compressions. Be it less than 1 year, be it more than 1 year, doesn't matter. You have to start CPR. Okay. Now, if the child is responsive, now the treatment changes. More than 1 year तो हेमलिक होगा, but less than 1 year तो होगा तो 5 back slaps and chest thrust or reverse it and okay पैर को पकड़ो और बैक से मारो बस ओके बाहर निकलेगा. Now coming to the pharynx. So anatomy, naso-oro-laryngeo, right? What is the Waldeyer's ring? Ring of lymphoid tissue arranged at the entrance of the pharynx. Adenoids posterior-superiorly. On either sides, the eustachian tube area, you have tubal tonsils and palatine tonsils on either side of the oropharyngeal entry. On posterior part of the tongue, you have lingual tonsils on either side. On the posterior wall, you have posterior pharyngeal wall, scattered granular pattern, lymphoid tissue, lateral pharyngeal bands. So all these are arranged like a ring at the entrance of the pharynx. That is called as Waldeyer's ring. Okay, muscles. three paid and three unpaid. In larynx, three paid and three unpaid cartilages. Here, three paid and three unpaid muscles, right? Longitudinal muscles are paired. Circular muscles are unpaid. Superior, middle, and inferior constrictor. See the superior constrictor, middle constrictor, inferior constrictor. They are present like this, okay, from behind. From behind, they are present like this, okay. They are present like this from behind, okay, semicircular pattern. Now, which structures pass between superior and middle? I told you, first of all, you need to draw this diagram. Superior, middle, inferior. Here is a skull base is there. Superior constrictor, middle constrictor, inferior constrictor, and esophagus is there. So between skull base and superior constrictor, you already know the eustachian tube is passing through. So this area where this eustachian tube is passing through, this is called as sinus of Morgagni. Eustachian tube and muscles of eustachian tube and artery of eustachian tube. What are the muscles of eustachian tube? Tensor veli palatini and levator veli palatini. Artery of eustachian tube, ascending palatine artery. So these structures, eustachian tube and its friends and its colleagues, all those things will be going through the sinus of Morgagni. Okay, and now, now here comes in which partition, which nerves are passing. You know, once you come into the deep into the neck, okay, at this level, you have only two nerves running in the pharynx area and larynx area. Ninth and tenth nerves, you have only those. So ninth and tenth, you already know recurrent laryngeal nerve is सबसे नीचे जा रहा, मीडियास्टाइनम तक भी जा रहा लेफ्ट साइड, isn't it? So recurrent laryngeal nerve सबसे नीचे है. So सबसे नीचे का पार्टीशन को recurrent laryngeal nerve दो. रिकरेंट लैरिंजियल किसका पार्टीशन है? टेंथ नर्व का, ओके, ब्रांच है. दूसरा ब्रांच क्या है टेंथ नर्व का? सुपीरियर लैरिंजियल नर्व. तो ये ऊपर पार्टीशन को दो. तो टेंथ, दोनों ब्रांचेस का टेंथ इन दोनों में हो गया. तो व्हाट इज द अदर लेफ्ट ओवर वन हियर? नाइन्थ. नाइन्थ के साथ स्टाइलोफारिंजियस रिमेंबर करो. हो गया, डोंट वरी. ओके, now you understood how to remember. So between superior and middle constrictor, ninth nerve is passing. Okay. Now Zenker's diverticulum you already know. So there is a Killian's dehiscence between oblique thyropharyngeus and horizontal cricopharyngeus. The mucosal, it is a blind mucosal. So pseudo diverticulum, no muscle is there. So pseudo diverticulum seen in case of chronic GERD, dysphagia, halitosis, aspiration pneumonitis will be there. Barium swallow karo to pata chal jayega. So treatment is okay, Dahlmann's procedure. Okay, so this is your pharyngeal pouch, Zenker's diverticulum. This is corkscrew esophagus. This is bird beak appearance seen in Achalasia cardia. And this is your rat tail appearance seen in your carcinoma esophagus. So these are we have discussed. Dahlmann's procedure is done for Zenker's diverticulum. Now coming to the posterior pharyngeal wall, it's not just a single layer. Behind the posterior, in the posterior pharyngeal, you have multiple layers, one by one facial layers arranged before the vertebra comes. Now if you go from anterior to posterior, so there are various layers. The first one which you are having is the pharyngobasilar fascia. Behind that you have the okay buccopharyngeal fascia. फारिंगोबेसिलर, फारिंग्स के साथ में फारिंगोबेसिलर फेशिया है. तो फारिंग्स को अटक के फारिंगोबेसिलर फेशिया है. उसका पीछे बक्कोफारिंजियल फेशिया और आलार फेशिया एंड प्रीवर्टिब्रल फेशिया एंड पीछे वर्टिब्रा है. Why this fascia is called as prevertebral fascia? It is lying anterior to vertebra, near to vertebra, so prevertebral. So whichever space is there, that space is present behind that fascia. प्रीवर्टिब्रल फेशिया के पीछे प्रीवर्टिब्रल स्पेस है. आलार फेशिया के पीछे आलार स्पेस है. नाउ यू आर लेफ्ट ओवर विथ टू स्पेसेस. Immediately behind pharyngobasilar fascia, you have muscular layer. That is your circular and longitudinal muscles are present here. Now you are left over with one space in between, buccopharyngeal and alar. In between these two, the space that is present is called as retropharyngeal space. It is divided by a median raphe into two equal spaces called as spaces of Gillette, and each space is having a lymph node, and that lymph node is called as node of Rovier. No, we don't need to revise END. Identify the marker structure. See, as I go from anterior to posterior, see, this is vertebra posterior. Now, this is pharyngobasilar, muscular layer, and this is buccopharyngeal. Now, this is my retropharyngeal space, alar fascia, alar space, prevertebral fascia, prevertebral space, vertebra. This is retropharyngeal space, right? Okay. Passavans ridge. What is this passavans ridge? Palatopharyngeus and superior constrictor. See, this is palate. From the palate to the pharynx, some circular fibers are given. How is your superior constrictor arranged? Like this. Isn't it? From posterior, superior constrictor is like this. From the palate, few fibers will go and join with the superior constrictor in this area. Junction of nasopharynx and oropharynx. Whenever you are swallowing, this constricts, this ring of muscle constricts, closes off the nasopharynx from the oropharynx. Okay, so such that whatever food you are swallowing does not go back into the nose, it goes only into the esophagus. So Passavant's ridge helps in preventing nasopharyngeal regurgitation of your swallowed food. Adenoids. So what if adenoid hypertrophy is there? So you have, see, because nose is blocked, so nose breathing will not occur. Nose block, mouth breathing, snoring will be there due to palatal flutter, isn't it? Palatal flutter due to this narrow airway, and chronic sinus, because nose is blocked, sinuses are not getting ventilated, so chronic sinusitis, frequent cold nose block will be there, and child is breathing through the mouth, drying of the mouth, dental caries, pharyngitis, tonsillitis, right? And see, the eustachian tube is getting blocked by the adenoid. So serous otitis media, hardness of hearing, hearing problems, right? Conductive hearing loss. And due to the constant airflow in a curved pattern above the tongue, the palate will also take the shape of the tongue, and this becomes high arched. When the normal palate becomes high arched palate, what happens to the septum above in the midline? It becomes buckled up. So deviated nasal septum, crowding of upper teeth will happen. So the face becomes elongated vertical, and sleep disturbances due to constant nose blocks will be there. Low IQ will be there to the child. So these are all the problems of having chronic adenoid hypertrophy. Child was brought to ENT OPD with complaints of mouth breathing, snoring, and he asked to increase volume of TB. Means hearing problem is there. So treatment is adenoidectomy environment. See, this is vertical, elongated, dull, expressionless face. So that is adenoid phases. Whenever there is a block in the nasal airway, so that leads to hyponasal or denasal voice, also called as rhinolalia clausa. And if there is a cleft palate, okay, there's a wide space present, and there is a voice will be having hyper resonance here, hyper nasal, aperta, hyper rhinolalia aperta will be there. And school going child presents with a history of recurrent URTI, mouth breathing, impaired hearing, high arched palate is noted. So again, adenoidectomy with grommet. 5-year-old girl brought with complaints of mouth breathing, flat, expressionless, long face, open mouth, high arched palate, crowded upper teeth. Again, treatment. This is adenoid hypertrophy. 7-year-old child, okay, snoring, palpitation, mouth breathing, slight decrease in hearing, high arched palate, okay, IQ, low IQ. So the again treatment is adenoidectomy with grommet insertion. 6-year-old boy, recurrent URTI, poor growth, high arched palate, impaired hearing, tympanogram is flat, B type. So most appropriate adenoidectomy and grommet insertion. Coming to the tonsils, if the substance of the tonsil gets infected, parenchymatous, and see the pus gets filled in the crypts, okay, and present as whitish yellowish dots on the surface, that is called as follicular. And if all those follicles fuse to form a permanent complete continuous layer, that is membranous tonsillitis. Most common is against streptococcus. So if it is more than 3 months on and off episodes are there, it comes under chronic. Sore throat, swallowing difficulty, cough, fever will be there. And so bed of tonsil, the chief structure that is forming the major bulk main part of the bed of the tonsil is superior constrictor. Behind that you are having the glossopharyngeal nerve. Okay, so that is important here. Which of the following conditions does not form a gray white membrane over the tonsils? So these are all the causes of membranous tonsillitis: streptococcus, diphtheria, infectious mononucleosis, candida, leukemia, granulocytis, malignancy, after. But Ludwig's angina means it is related to submandibular space abscess. That is Ludwig's angina, not related to tonsils at all. So you don't find a membrane over here. Main arterial supply of palatine tonsils is by tonsillar branch of the facial artery. You have to remember by heart this, no other option. Then coming to tonsillectomy, it is done in Rose's position. And see the instruments, remember Boyle Davis mouth gag, Eves tonsillar snare, Draffin's bipod. This is your Draffin's bipod, Boyle Davis mouth gag. And this is Dennis Brown tonsil holding forceps. I have videos given to you in the previous PDFs. If you want, you can go through them. A 10-year-old girl ate post tonsillectomy, ate a packet of chips 2 to 3 days after the surgery and now came to the hospital with oral bleed. What shall be the management? During the surgery itself, if the bleeding is happening, that is primary hemorrhage, you can directly there itself cauterize or ligate. And in the first 24 hours, when the patient is still in the hospital, post-op ward, if there is bleeding, that is reactionary. This happens due to slippage of ligature. Again, shift the patient back to OT and recauterize or religate. And child has been sent home after discharge, bleeding is happening. That will be due to infections. Child not properly taking the antibiotic post-op treatment given to her. She is not taking properly. So secondary hemorrhage will occur. So here after the surgery, 2 to 3 hours is happening. This is secondary. So this is due to mostly infections. So give antibiotics. Right? Patient post tonsillectomy in the recovery room starts bleeding from the operative side. So in the recovery room, the bleeding is happening post tonsillectomy. So reactionary hemorrhage, shift to OT, remove the clots and cauterize the ligate vessel. And which is responsible for ear pain after tonsillectomy? Bed of the tonsil, the glossopharyngeal is there. So that gets irritated, that can cause ear pain. Referred radiating otalgia, referred otalgia. 10-year-old child presents throat pain, fever, ear pain, recurrent tonsillitis, which is responsible. Again, tympanic branch of the glossopharyngeal. JNA, juvenile nasopharyngeal angiofibroma. So this is mostly seen in adolescent, exclusively seen in adolescent males. And so the main problem here is the blood vessels will not have this contractile muscular part within the vessels. So they won't contract and stop the bleed. Once the bleeding starts, it keeps on happening. What is the most common site of origin is the sphenopalatine foramen posterior to the middle turbinate. And what is the other things you see here? So this from the sphenopalatine foramen it arises, it fills the nasopharynx, grows anteriorly, involves the occupies the sinuses, comes anteriorly. It may go into the pterygopalatine fossa laterally, and from there it may push the posterior maxillary wall anteriorly. The anterior bowing of the posterior maxillary wall is called as Hallman-Miller sign. Anterior bowing of the posterior maxillary wall. This is Hallman-Miller sign. Frog face deformities, playing of nasal bones, all these things you can see here. So during treatment, you have to open the maxilla. You go for again Weber-Ferguson incision. Surgical excision is the best treatment option. 20-year-old complaints of recurrent epistaxis, DNA and imaging shows the following. What's the diagnosis? So again, adolescent male recurrent epistaxis and imaging is showing Hallman-Miller sign, that is JNE. See the nasopharyngeal carcinoma. This is normal fossa of Rosenmuller. See this fossa of Rosenmuller, nasopharyngeal carcinoma, most common sign. This is inverted papilloma. See this is nasal polyp. Polyp do not bleed. Remember this thing, polyps do not bleed. So see the shiny glistening appearance of the polyp. This is normal. See the polyp occupying the nasal cavity here. 13-year-old boy, right side nasal obstruction, recurrent epistaxis for the past 6 months. Adolescent male, recurrent epistaxis, likely JNE. 14-year-old male, recurrent epistaxis, no trauma history, nasal obstruction, rhinorrhea, firm purplish mass in the nasopharynx. So that is again JNE. And 14-year-old boy, football player, no history of trauma, recurrent epistaxis. Okay. And denasal speech, unilateral nasal obstruction. CECT is showing you Hallman-Miller sign. Anterior bowing of the posterior maxillary wall. See, the posterior maxillary wall has moved anteriorly. That is Hallman-Miller sign. 14-year-old boy with recurrent profuse epistaxis and reddish mass, that is JNA. 22-year-old presents with complaints of recurrent bleeding. So regarding JNA, what is true? Tumor vessel lack contractility. That is the reason for continuous bleeding. Which staging is related to JNA? Radkowski. Just remember that word Radkowski. Following sign is seen in JNA. What is this sign? Hallman-Miller. Anterior bowing of the posterior maxillary wall. Investigation of choice. Vascular tumor suspecting. Go for contrast. CECT is the investigation of choice. Nasopharyngeal carcinoma. So mostly seen in elderly, bimodal, sometimes 15 years also you can see sometimes. Unilateral hardness of the patient. How the patient will present? One side hearing problem. You put a scope and see elderly patient presenting to you with unilateral serous otitis media. You are okay. So that should raise the suspicion of something in the nasopharynx. So immediately you have to go for okay nasopharyngoscopy. There you should see, you can see the fossa of Rosenmuller filled with the tumor, right? So the presentation usually will be unilateral hearing problem. You put a scope inside and see serous otitis media, and immediately you put the scope into the nasopharynx and see there is a tumor arising from the fossa of Rosenmuller. Causes are salted fish intake, which will be having nitrosamines. In the Southeast Asia, it is most common. 70-year-old male presents with neck nodes. Examination of left ear reveals dull tympanic membrane, deafness and tinnitus. Type B curve is obtained. So most probable diagnosis. Elderly male, neck nodes, posterior cervical lymphadenopathy, painless cervical lymphadenopathy. This is seen in NPC. Dull tympanic membrane, type B curve, serous otitis media. So nasopharyngeal carcinoma. 49-year-old Nagaland, right-sided hearing loss, tinnitus, dull tympanic membrane, lymph nodes in the posterior triangle. She is from a region endemic for nasopharyngeal carcinoma. See, these are highly radiosensitive. Laryngeal carcinomas and nasopharyngeal carcinomas are highly radiosensitive. Most common set of nasopharyngeal carcinoma is fossa of Rosenmuller. Number two, 60-year-old male presents with painless cervical lymphadenopathy. Right ear reveals conductive hearing loss, decreased mobility of the soft palate. Why mobility of the soft palate is affected? Vagal nerve palsy. Okay, so these are all the things you can notice. Trotter's triad is seen in nasopharyngeal carcinoma, conductive hearing loss, ipsilateral temporoparietal neuralgia, and palatal paralysis. Okay, conductive hearing loss due to serous otitis media, ipsilateral. See the palatal palsy on that affected side, and ipsilateral temporoparietal neuralgia due to involvement of multiple cranial nerves. 50-year-old male, right-sided serous otitis media, cervical lymphadenopathy, nasopharyngeal carcinoma. Identify the structure marked to in the endoscopic image of the nasopharynx. So this is your fossa of Rosenmuller. See the passavants reach here. See the passavants reach here. Okay. See, these are the various first slide we have gone through, right? Quinsy, peritonsillar abscess. It pushes the tonsil medially, uvula opposite side deviation. In the space between tonsil and the bed of the tonsil, superior constrictor. In the peritonsillar space, the collection of pus will occur. Peritonsillar abscess, hot potato voice, sore throat, cough, fever, swallowing difficulty, drooling of saliva. Abscess is there. Incision and drainage is the first treatment option. Wait for 6 weeks and then go for permanent tonsillectomy. You are waiting for 6 weeks interval. This is called as interval tonsillectomy, right? Coming to Ludwig's angina, so from the third molar, the abscess, the infection can drain into the submandibular space and cause submandibular abscess. So third molar case is the most common cause. Immediate incision and drainage. If you delay, this submandibular abscess can push the base of tongue posteriorly and can block the airway. So if the patient already presents to you with severe respiratory distress, now you go for tracheostomy, secure the airway first, then you go for draining the abscess later. A senior medical professional. So you know this is your nasopharyngeal mirror. The curved mirror is nasopharyngeal. The straight mirror is indirect laryngoscopy mirror, IL mirror. You know that, right? Laryngismus stridulus is due to deficiency of vitamin D. Direct Delphian nodes means pretracheal nodes. Those are present in midline level 6. I told you already. 1A submental, 1B submandibular, 1A, 1B. Now come along the anterior border of sternocleidomastoid, jugular, level, okay, 2, 3, 4. Upper jugular, mid jugular, lower jugular. Now go to the posterior triangle, level 5. Now come to the midline, level 6. Now go to the mediastinum, level 7. 1A, 1B, 2, 3, 4, 5, 6, 7. So this is how you need to practice. So coming to oral cavity, Vincent's infection is by Borrelia species and Vincent's, okay. The gum will bleed a lot. So you have this gum bleed, pain, antibiotics and gargles are the oral thrush. Candida is the most common. Fluconazole, clotrimazole, topical candid paint is available. After ulcers, at least now, okay. If you are having it, all the best. Okay, so stress, vitamin deficiency, anaerobic infections, and I have given you a big treatment option for that. Ankyloglossia means tongue tie. So the tip of the tongue is okay attached anteriorly and held anteriorly, so this causes speech difficulty and swallowing difficulty. So cut the lower frenulum attachment, anterior attachment, that's lingual frenulectomy you have to do. Release the free end, anterior end of the tongue freely. So that is what ankyloglossia. And coming to the oral submucous fibrosis, this is precancerous. Those who have that habit of okay right? So those people will be having this most commonly. Submucous fibrosis. Beneath the mucus layer, all the glands are damaged. Dryness of the mouth will be there. Severe burning sensation. Even water drinking also severe burning sensation. Poor oral hygiene. See the hygiene in this picture. Very poor oral hygiene and mouth restriction. Tresmus will be there. The fibrosis will hold the mouth tight. It will not allow him to open the mouth properly. So the injections of triamcinolone and hyaluronidase are very important here. Okay, and coming to the ranula, it is sublingual retention cyst. In the sublingual, it will be there. So okay, it will be in the floor of the mouth. You will see that okay, bulging. Just surgical excision will be enough. Leukoplakia, I already taught you in the larynx. It's a precancerous. Compared to leukoplakia, erythroplakia. Why this is red in color? Because more blood vessels are there. More blood vessels, more blood supply, more distant metastasis, more spread, so more malignant, so poor prognosis. Again, surgical excision is the treatment. So this is your erythroplakia first picture, and this is leukoplakia, erythroplakia. This is leukoplakia, reddish erythroplakia. Fordyce spots are nothing to worry. Koplik spots you see in case of measles. Mumps caused by paramyxovirus, first unilateral, then becomes bilateral. Apart from parotitis, you may have thyroiditis, carditis, pancreatitis, and still go down. Okay, this may be there. Treatment is viral infection, so corticosteroids, NSAIDs, and complications. It may go up also, not just down. Every time don't go down, go sometimes up also. Use this also. Now aseptic meningitis can occur and SNHL can occur. Okay. Now coming to cyalolithiasis, submandibular is most common. Thick secretions and the duct is draining against to the gravity. So while eating, pain and swelling will be their typical finding. If the stone is in the duct, cyaloendoscopy, both diagnostic and therapeutic. If it is in the gland, you have to go for complete cyalectomy, right? And coming to pleomorphic adenoma, this most common benign salivary tumor, very hard. Okay, if you touch it, you feel it as if you are touching some stone there, some wall there. Okay, even if you beat it, also nothing will happen. Very hard. So females, it is seen in usually middle-aged females, stony heart, absolute painless, yeah, along the angle of mandible area. So tail of parotid is the most common side. Treatment is so that's tailectomy. Don't use that word tailectomy. Superficial parotidectomy. Tail of parotid is lying superficially. Okay. Now coming to adenolymphoma or Warthin's tumor. This is second most common benign tumor, most common in males. A 70-year-old male coming with such kind of swelling at the angle of mandible at the tail of parotid area. Here also the treatment is superficial parotidectomy. Everything is same. Then how to diagnose which is adenolymphoma, which is pleomorphic adenoma. Post excision, send it for histopathological examination. If you are seeing lymphoid elements, that is your adenolymphoma, Warthin's tumor. This lymphoid element is absent in pleomorphic adenoma. Now, mucoepidermoid carcinoma, here both mucin cells, mucus cells, and epidermal cells are present. More number of epidermal cells, if they are present in the tumor, more malignancy. How do you know? After excision, send it for biopsy, they will tell you. Now, so you have to go for again surgical excision and then radiotherapy if needed. Adenoid cystic carcinoma, here the main thing is the cancer will have the tendency to go infiltrate the nerves. Which nerve is present in the parotid? Facial nerve. So here along with the tumor you have to remove the facial nerve. Patient will have definite facial palsy after the excision. Which is false treatment? What is this? Mucocil. Okay, so minor salivary gland, okay, obstruction. So most common in the lower lip, minor salivary glands are most densely located. Trauma in this area, your most favorite area. Okay, your that friend's lower, okay, favorite area there. Okay, okay, due to that, okay, a trauma here can block the duct and can cause retention cyst. So this is a retention cyst of minor salivary gland. Most common site is lower. Treatment is surgical excision. Okay, so with this, okay, so with this, we are ending the marathon 3. I told you, okay. So just this is within time. You have taken a break of 15 minutes, no? That only took extra time, nothing else. Okay. So fine. So hope any doubts, please do message me, contact me in any of the okay your comfortable ways. Okay. If I'm not responding, keep on repeatedly, okay, pissing me off. No problem. I'm happy to get pissed off. Don't worry. So you keep on messaging till I reply. So sometimes due to some either and here X, okay, I may miss sometimes, but don't take it in the wrong way. Again, you keep on still repeatedly messaging me. No problem. Nothing wrong. Okay. So with this, all the best for you. Also, a short 5 to 10 minute video will be released at the before the exam day for you. So for a quick revision, right? Chalo. Okay. So with this, I'll take leave, have a lunch, and go for the next session. Okay. Bye. So I'm signing off.
Okay, hi everyone. Good afternoon. I hope you had a good session in the morning. And now we will start with OBG without any delays. Now the marathon, how I take it is I do not switch on the chat box. So I will not be looking at the chat box. If you have any queries, you can ask me later. But we will continue and we will. So this is basically to avoid distractions. We will start with OBS. We will do the initial 4 hours will be on obstetrics and then 4 hours on gynae. Okay, with a lot of emphasis on the high yield topics, right? So if anyone wants to say anything, say now. Otherwise, I will switch off the chat box. Just a second. 1 second. 1 second. Yeah. Let me just share again. There is some problem with the sharing. Just a second. Okay. So, okay, this is not the same as lab 2. This is the marathon. So it's going to be even more concise than lab 2. Okay, it is similar content but more concise. So let's start this. Okay. I will not touch on anything new. It's just going to be the very, very important points all put together. So if you feel you need to attend this, if your OBG is weak or you just want a quick revision, this is the best thing for you right now. So I'm switching off the chat box and we will start again. 1 second. There is some problem with my screen share. Just a second. Okay, I hope there are no more glitches. Just a second. Okay, so hopefully there'll be no more glitches. So let's start. So we start with obstetrics, and this table is extremely, extremely important. This table shows us the important named signs. Remember, whenever there is something named in any subject, it is very important. These are signs of pregnancy in the first trimester because the uterus becomes a palpable organ. When can you first feel the uterus? You can feel the uterus on abdominal examination only after 12 weeks. Before 12 weeks, you can't feel the uterus. So when the patient comes to you, of course, the most common symptom is a missed period. But how can you, on examination, say that she's pregnant? So these are the signs. The first is the Jacquemer or Chadwick sign, which is a bluish hue of the vaginal wall or bluish cervical cervix. That is called the Jacquemer or Chadwick sign. So this is an inspectory finding, and this is because of the increased vascularity. Then we have Osiander sign. Osiander sign is when we do a vaginal examination and we feel the arteries are pulsating. This is the uterine arteries. So what are you basically feeling or palpating? You're feeling laterally Lateral to the cervix, you're feeling the pulsations of uterine artery. This is again a vaginal sign. Remember, all these signs are seen roughly between 6 to 10 weeks of pregnancy. You can just remember for all of them 6 to 10 weeks. Goodell sign is again a palpatory sign. When you touch the cervix, it feels soft. A non pregnant cervix feels like the nose, a pregnant cervix feels like the lips. So it is a soft cervix, it softens during pregnancy. These three signs are the uterine signs, that is on bimanual palpation. When you do a two fingers in the vagina and your hand on the abdomen, you're doing a bimanual examination where you find these three signs. The most common is Hagar sign. What is Hagar sign? Hagar sign is the uterus is very, very soft. So when your fingers oppose below the body of the uterus, the isthmus becomes very, very soft. So you can feel the body of the uterus between your two fingers. This is called the Hagar sign. And this was asked last year. I think these two last exam, Jacomet and Hagar's, were asked. Pisca-sac is asymmetrical uterine enlargement, especially if the gestational sac is implanted on one part of the uterus, on the lateral wall, then you find asymmetrical uterine enlargement. And Palmer's sign is on the same thing. When you're doing Hagar's, you feel gentle, gentle uterine contractions. This is called as Palmer's sign. So these are the named signs of pregnancy. Very, very important to remember these. Second trimester, what are we looking at here is when the uterus will become palpable. It is palpable after 12 weeks of pregnancy and then it increases in size. Quickening is the first time movement is appreciated by the woman. The first fetal movement is called as quickening. And in primigravidas, it is felt at 20 weeks. In multigravidas, it is felt little earlier because the woman knows how it feels like. It is felt at 18 weeks. And amenorrhea persisting, of course. Now, what are the signs in the second trimester? There'll be facial darkening, chloasma, breast changes are more prominent. These two are important. External ballotment is after 20 weeks. So, around 20 to 28 weeks is external ballotment. Internal ballotment is 16 to 24 weeks. What are these? This is a picture showing external ballotment. Like on moving the baby with one hand, you will feel it touching the other hand externally. Internal ballotment is on vaginal examination. You flick the serve above the cervix a little bit and the baby will come and hit your finger back. It moves around in fluid. That is called as ballotment. What is the most definitive sign of pregnancy? The most definitive sign, not symptoms, sign, not test. Sign means on examination is auscultation of the fetal heart rate. How early can you auscultate the fetal heart rate? If you're using a regular stethoscope, you can auscultate it as early as 20 weeks. If you're using a handheld Doppler, you have handheld Doppler which picks up the fetal heart, you can hear it as early as 14 to 16 weeks of pregnancy. So this is auscultation of Okay, apologies for some weird reason. My laptop decided to update right now. So I'm just rejoining some problem it's been giving me. Apologies. Where did I leave off from? Auscultation. Okay. Okay. Just a second. All right. So my laptop decided to update, but hopefully अब वो हो गया है and hopefully things will not go wrong. Okay, so we left at auscultation. Auscultation is on stethoscope at 20 weeks and Doppler 14 to 16 weeks, right? Now, also remember that these are the pictures. This shows external bellotment and this shows internal bellotment. Okay, the external bellotment, which is a picture, it shows the baby. If you move the baby with one hand, you can feel it with the other hand. That is, something is moving in fluid. Internal bellotment is if you flick with one finger, it will come and hit back your finger. So these are signs of pregnancy in the second trimester. In the third trimester, how do we diagnose pregnancy? In the third trimester, we diagnose pregnancy by the Leopold maneuvers. But in the second and the third trimester, both, the surest sign of pregnancy of a pregnancy is auscultation of the fetal heart rate. Okay. Now, very important, these are signs and symptoms. How do we confirm pregnancy? Pregnancy is confirmed. The most accurate determination of gestational age in the first trimester till 14 weeks is the crown rump length. The crown rump length is the most accurate determinant of gestational age. If the patient is not sure, look for a crown rump length on the ultrasound. In the second trimester, the most accurate is the biparietal diameter. This has come as a question in almost every other exam. In the third trimester, what do we look at? We look at the Leopold maneuvers. There are four Leopold maneuvers. You should be able to identify if an image is asked. The first is the fundal grip, okay, where we are determining what part of the fetus occupies the fundus of the uterus. Okay, if it is like here, it is the breech. The breech will feel as a broad, firm, non-ballotable structure. Okay. Then you have the lateral grip. This is the lateral grip. The lateral grip tells us which side, this is the second maneuver, which side is the back. The back will appear smooth, and which side are the limbs. The limbs are going to appear irregular. Then you have the third grip. This third grip is the Pollux maneuver, also called the first pelvic grip, also called the third maneuver. Okay, so the third maneuver is the Pollux grip or the first pelvic grip. This is the one done with one hand. So if a question comes or the image shows only one hand is palpating, it is the third grip or the Pollux grip. This tells us what is the presentation. Like here, it's the head. So if the head is there, the head always feels like a hard, ballotable structure. Then you have the fourth maneuver, the fourth grip or the second pelvic grip or simply the pelvic grip. Okay, this is the one which is done facing the feet of the patient. Again, two hands but facing the feet, and the hands are trying to approximate. If the hands approximate, the head is not entered the pelvis. But if the hands don't approximate, that means something is in the way, the head is in the way, and it has entered the pelvis, right? So if the hands approximate, the head is high. If the hands don't approximate, the head has entered the pelvis. This is the use of the second pelvic grip or the pelvic grip. So important from here, you should be able to identify them on image wise. Fundal grip is grip number one, this one. This is lateral grip, grip number two. Pollux grip, grip number three, and pelvic grip, grip number four. When do we do these grips? We do these grips in the third trimester after 28 weeks of pregnancy. Now, another very important topic is preconceptional care. Two most important aspects of preconception. Before the woman is pregnant, she's planning a pregnancy. What are two important things we need to tell her? First is start her on folic acid supplementation. Folic acid does what? Folic acid is going to reduce the incidence of neural tube defects by up to 70%. That's why it's a very, very important intervention. Now, if the woman is high risk, we start her on a higher dose, 4 or 5 mg, both are correct. Okay, 4 mg, some guidelines say 5 mg. But who are the high risk groups? The highest risk groups are if there is a previous history of a neural tube defect. Number two, if she has been taking anti epileptic drugs because they are associated with a higher incidence of neural tube defects. Number three, if she's an overt diabetic, she's already diabetic, she's conceived and she's diabetic when she has conceived, again a higher incidence of neural tube defects. And if she has known folate deficiency. Okay, these are the main four high risk groups. Other than that, also increased BMI. And if she has a known case of sickle cell disease, these are also little higher risks. But these four are the most important. Previous history of neural tube defect, anti-epileptic drug, overt diabetes, and known folate deficiency are the highest group. In this, what should we do? We should start folic acid 3 months prior, okay, to conception, and continue it for the first 3 months of pregnancy. That is when the neural tube is forming. So that is why we have to give preconceptionally to ensure that at the time of conception her folic acid levels are high, and continue in the first 3 months of pregnancy. So 3 months before to 3 months after is what is recommended. In all other group of women that is low risk, we give 400 microgram or 500 microgram of folic acid. The next important intervention is rubella vaccination. So, whenever a woman comes for counseling, we always get an IgG rubella done. This, if positive, will tell us whether she is immunized or she is non immunized. She may not give the history, so we need to get the IgG rubella done. If it is positive, that means she has been vaccinated earlier. Okay, and she is fine, you just reassure her. But if it's positive, just reassure her, nothing to be done. If it is negative, however, she is at risk of developing rubella in pregnancy. Remember, rubella is highly teratogenic. It is a highly infectious disease. It can cause congenital rubella syndrome. So we don't want the woman to get rubella in pregnancy. What do? We vaccinate her with either RVAC or MMR. These are, but remember, live vaccines. Okay, so whenever we give these vaccines, we tell the patient don't get pregnant for 1 month, because if she gets pregnant, there's a theoretical risk of the baby getting infected. So we give it with the advice not to conceive for 1 month. Okay, and then after 1 month, she can conceive. But suppose she conceives in that 1 month, suppose she doesn't listen and she conceives, what do? You're going to continue the pregnancy because the risk is only theoretical. Okay, so this is what is important for preconceptional care. Next important, that when some the question may come on asking, write the obstetric formula or write the parity index. What are these definitions? You should know what they mean. Gravida means the total number of pregnancies, all pregnancies, including the present pregnancy. All pregnancies, including present pregnancy, is gravida. This is denoted by the term G. So if she is first time pregnant, gravida 1. If she's second time, gravida 2. Irrespective of outcomes. The earlier pregnancy could be an abortion, could be a twin, could be an ectopic, could be anything. Okay, she is still, that will be counted as one pregnancy. Doesn't matter what happened to the pregnancy or if there was one or two or three fetuses. Para means the number of pregnancies that have crossed the period of viability, which for all practical purposes in the exam we take as 28 weeks in the Indian setup. Okay, excluding the present pregnancy. That means all the pregnancies that have crossed 28 weeks in the past, not including this pregnancy, this is called as para. Remember, gravida will always be more than para. Gravida or para kabhi same nahi ho sakte because gravida includes the present pregnancy. Para does not include the present pregnancy. Abortion is defined as fetal loss less than 20 weeks or less than 500 grams of baby weight is the definition of abortion. And L means the number of living children. Okay, so this is what is the parity index: gravida, para, abortion, and living. You will get questions on this. Patient is come. This is her second pregnancy. Earlier, she had a twin delivery. Both babies are fine. What is her parity index? She is gravida 2, para 1, living 2. Okay, so twins is counted as one pregnancy. So the para will be 1, para will not be 2 in twin. This is the most commonly asked question. Previous twin, write the parity index. Okay. Next important, schedule of antenatal visits. How often should the patient come to you in pregnancy? Remember, as per Government of India guidelines, 4 visits. Very important. See what has been asked. MOHFW is Ministry of Health and Family Welfare. As per WHO guidelines, 8 visits, 8 contacts. Okay, so as per WHO visits, it's going to be 8 contacts. As per ACOG or American guidelines, and what is ideal, what should we ideally do? And this also has come as a question. It is 12 to 15. And this is what, as gynecologists, we practice. We call the patient once a month till 28 weeks. Then we call the patient once in 2 weeks till 36 weeks. And then we call the patient weekly till delivery. So this is how it adds up to 12 to 15 depending on when her first visit was. So once a month till 28 weeks, once in 2 weeks, or fortnightly till 36 weeks, and then weekly till delivery. So all have come as questions. It's important to see what has been asked. Is it Government of India 4, WHO 8? Ideally, what is done? 12 to 15. What do we do in pregnancy? Routine. What drugs do we give? So in the first trimester, 3 plus 3 months, we give folic acid. After 14 weeks, what do we start? We start prophylactic iron. Remember, this is prophylactic iron. That means prevention of iron deficiency anemia. If you're treating iron deficiency anemia, iron can be safely started even in the first trimester. But for prophylaxis, because it causes a lot of nausea and GI symptoms, which are anyway there in the first trimester, we want to start after the first trimester. So we start after 14 weeks. We give one iron and folic acid tablet starting from the 4th month of pregnancy. Continue throughout pregnancy. That is, we give it for 180 days or 6 months in pregnancy and then 6 months postpartum. Total of 1 year. 6 months antepartum, 6 months postpartum. Each tablet is red in color. It is a sugar coated red color tablet containing 60 milligram of elemental iron and 500 microgram of folic acid. This folic acid is not to prevent neural tube defect. Neural tube ban chuka hota by 12 weeks. This folic acid is to prevent folate deficient anemia, folic acid deficient anemia, so dimorphic anemia. That's why we give 60 milligram iron plus 500 microgram of folic acid. Also, in the second trimester, we should give all pregnant women deworming. Okay, this is for deworming. We give single tablet of 400 milligram of albendazole anytime after the second trimester. Okay. Now, what about immunization? We also give calcium. Please remember, calcium is also started along with iron. That is 14 weeks pe we start. Again, 6 months antepartum and 6 months postpartum. And we have to give a total daily dose of 1 gram calcium per day is the recommendation for giving calcium tablets. The next is immunization. Remember, in immunization in routine pregnancy, what is important? Tetanus, diphtheria is now the norm. The government, this is the Government of India, says don't give TT. TT has been replaced by tetanus, diphtheria. 2 doses. The first can be given as early in pregnancy, anytime, whenever the patient comes, even in the first trimester. The second dose is given 4 weeks after the first dose. And then if the woman has had a delivery in the last 3 years where she was fully immunized, then you just give her a single TD booster. Okay, so 2 doses, 4 weeks apart, first dose early in pregnancy. But if she's delivered in the last 3 years and she's received both the vaccines, she was fully vaccinated, then you just give her a TD booster. What do the Americans say, and what is actually ideal is that the second TD should be replaced with Tdap, tetanus, diphtheria, acellular pertussis, in the third trimester. Between 27 to 36 weeks is when you give Tdap. So the second dose of TD can be replaced by Tdap. All COVID vaccines are safe in pregnancy. All live vaccines are contraindicated, except the only exception to this rule of live vaccines being contraindicated is the yellow fever vaccine. Rabies vaccine is absolutely, absolutely safe in pregnancy. If a woman comes with a dog bite, doesn't matter the period of gestation, she should receive the rabies vaccine. Okay. Drugs which are teratogenic, very, very important. Usually one drug is asked. Remember, anti-epileptic drugs like phenytoin, phenobarbital, carbamazepine all cause fetal Hydantoin syndrome. But the maximum teratogenicity is with which anti-epileptic drug? It is sodium valproate. This has the maximum teratogenicity. Right. What is fetal Hydantoin syndrome? It has facial features. Remember, a lot of clefting is there. Cleft lip, cleft palate, commonly seen with anti-epileptic drugs, and limb defects. Okay, so anti-epileptic drugs cause clefting, cause limb defects, even cause neural tube defects, other anomalies also. But remember the term fetal Hydantoin syndrome. AC inhibitors and ARBs, we all know, are absolutely contraindicated in pregnancy because they cause fetal renal agenesis or hypogenesis. So there is the kidneys are not developed. This leads to early onset oligohydramnios and leads to a classical syndrome called as Potter's syndrome. Alcohol causes the fetal alcohol syndrome. Lithium causes a heart anomaly called the Epstein's anomaly. Indomethacin given after 32 weeks. Before 32 weeks, it's safe, but after 32 weeks, it causes premature closure of the ductus arteriosus. Methimazole, remember, for hyperthyroidism, the drug of choice in hyperthyroidism in pregnancy is propylthiouracil because methimazole, carbimazole cause cutis aplasia, which is a skin disorder. Warfarin causes warfarin embryopathy. That's why the drug of choice for anticoagulation in pregnancy is low molecular weight heparin. Thalidomide, which is no longer used, historical perspective, known to cause phocomelia or shortened limbs. Methotrexate, absolutely contraindicated, causes clover leaf skull. Basically, the skull bones are fused. This is called as craniosynostosis or clover leaf skull. DES, it is diethylstilbestrol. This again is no longer used. Again, historical perspective से important है. Clear cell adenocarcinomas, T-shaped uterus. These are in girls born to mothers who receive DES. And boys, hypospadias, microphallus. These two you should remember. Okay, so this table is very important for teratogenic drugs. And the question, usually a question comes from here. Screening in pregnancy. In screening, remember the most important screening we talk about is Down syndrome screening. Down syndrome screening can be done at 11 to 14 weeks. This is the common period we screen. 11 to 14 weeks, we do an ultrasound where we primarily look for nuchal translucency. This is a picture. This is an image-based question. This is the NT, the fluid behind the or the thickness of the posterior part of the neck. If it is more than 3 mm, it is significant not only for Down but also for other chromosomal anomalies. Apart from NT, we look for things like a nasal bone. So, nasal bone, if it is absent, it is an important marker for Down. NT more than 3 mm, absent nasal bone, and we see two more things. We see evidence of tricuspid regurgitation, and we look for flow in the ductus venosus. Abnormal flow in the ductus venosus, evidence of tricuspid regurgitation, absent nasal bone, thick NT, all are ultrasound markers at 11 to 14 weeks for Down syndrome. But we don't do this alone. We usually combine it with biochemical tests. This is the dual or the double marker where we do two things. We do a PAP A and we do a beta HCG. जहाँ पे भी B है, बीटा, big, बढ़ा हुआ, it increases. Okay, and pape will reduce in a woman who is carrying a baby with Down syndrome. So we do both together. This gives us a better detection rate. This is called a combined test. So if the question comes, what is a combined test in Down syndrome screening? It is a ultrasound, that is NT, plus dual marker is called a combined test. This improves the sensitivity of the test, because remember, these are all screening tests. They're not confirmatory. If the screening test is positive, do we do a confirmatory test? Now, if the patient misses the first trimester screening, we call her in the second trimester. This can be done usually between 15 to 22 weeks of pregnancy. And earlier there used to be a triple marker, but now we commonly do a quadruple marker. But you should know the components of triple and quadruple. Triple marker consists of three tests, that is the beta HCG plus the alpha fetoprotein plus the unconjugated estriol. Okay, and beta HCG, if it's increased, alpha fetoprotein decreased, and estriol decreased, are markers of Down syndrome. Quadruple, you add inhibin A. Okay, I told you wherever B is there, here also B is there, this is increased. So this is the triple and the quadruple marker. These are for those women who've missed the double marker or the NT and they come later to you in pregnancy. We do a triple or a quadruple marker. Ultrasound in second trimester is called the level 2 scan. It is also called the TIFA scan. TIFA stands for targeted imaging for fetal anomaly. So basically, it's an anomaly scan. Now remember, Down syndrome, that is chromosomal aneuploidies, may not have very clear-cut features on the ultrasound. That's why second trimester screening for Down syndrome, the TIFA scan is not very important. The biochemical screening is more important. Level 2 is more important for structural anomalies like neural tube defects, cardiovascular defects. So for structural defects, it's very important. It is not as good a screening test for chromosomal aneuploidies or chromosomal anomalies. Okay, so beta HCG is going to increase, alpha fetoprotein decreased, unconjugated estriol decreased, and inhibin A increased. So wherever there's a B that increases, this is for Down syndrome. Now, there is a third screening test. So, we have first trimester screening test, we have second trimester screening test. We also have another screening test which can be done any time after 10 weeks of pregnancy. This is called the non-invasive prenatal testing or the cell-free DNA. And what is this test? This is basically looking for placental DNA. This white DNA is placental DNA. This is because of trophoblastic cells which have undergone apoptosis. They release DNA into the maternal circulation. So when a blood sample is taken after 10 weeks, this placental DNA can be detected and subjected to genetic analysis. Okay, so it has a very, very high detection rate, almost 99%. Okay, so it's not a confirmatory test because this is placental DNA. This is not fetal DNA. It is not. It may not be truly reflective of the fetal chromosomal status. Hence, we are always call this a screening test and not a diagnostic test. But it has a very, very high detection rate of 99%, and hence it's the best screening test in terms of picking up an anomaly. Okay, but the downside is, why is it not routinely done? Because of the excessive cost compared to the other tests. It is not routine. Of course, if the patient wants the best test, you explain the cost, get it done, but it's not as routine as the other tests. After 10 weeks is important to remember, 99% detection rate is important. And what are we looking? We're looking for placental DNA. And also remember, it is just a screening test. It is, if this is positive, you still have to get a confirmatory tests. What are the confirmatory tests? These are the diagnostic or the confirmatory tests. If the patient wants an early diagnosis between 11 to 13 weeks, you can do a chorionic villus sampling. If the patient, and this is the most commonly performed diagnostic test, is an amniocentesis, this can be done anytime after 15 weeks. This has the least complications because all of these are invasive testing. Cordocentesis is sampling the umbilical vein for fetal blood, and this can be done anytime after 18 weeks of pregnancy, although the safest and the most common done is an amniocentesis. Okay. Now coming to, so we've discussed normal pregnancy, all the high yield topics. Now we discuss coming to early pregnancy. Then we will go to complications in pregnancy, then labor. Okay, so bleeding in early pregnancy, remember obstetric causes are three. It could be an abortion, it could be a ectopic pregnancy, or it could be a molar pregnancy. Okay, so we discuss in abortions the most important tile topic is recurrent pregnancy loss. Recurrent pregnancy loss means a patient who's had more, the earlier definition was three losses, but now it has changed to more than two recurrent losses before 20 weeks of pregnancy is called as recurrent pregnancy loss, and we need to start evaluation if a patient comes with RPL. Now, if the question that has been asked, they're telling you the patient has recurrent first trimester losses. So she had an abortion at 8 weeks, 10 weeks, 12 weeks, like that. Then what should you think of? Then there's no most common, but you're in your mind, you should think of antiphospholipid antibody syndrome. That is one primary thing you should think of. Also, you should start thinking of endocrine problems, that maybe she's diabetic, maybe she has thyroid disorders, maybe she has hyperprolactinemia. Some of the endocrine disorders you should think of. But primarily, APLA. APLA is what you should start immediately. Alarm bell should ring कि this examiner is trying to ask me APLA. But ऐसा नहीं है कि APLA can't cause second trimester, third trimester. It can cause second, third trimester losses also. But it is more common to cause first trimester losses. Second trimester RPL, you should think of anatomical problems. And in anatomical, I'm mainly talking about cervical insufficiency. Okay, that is a insufficient cervix is how second trimester recurrent pregnancy loss will is the most common presentation. Okay, so in cervical insufficiency, we begin with cervical insufficiency, very very important topic. The typical presentation is recurrent, apparently painless, because it happened so quickly. The patient said I felt discomfort and the baby came out, the fetus got expelled. This is very very quick presentation, so it's apparently painless, recurrent second trimester losses. This is your typical history. Okay, this is usually could be congenital weakness of the cervix, but very commonly it's acquired. So there will be a history of maybe a procedure on the cervix like LEEP, like conization, like cervical biopsy, or a cervical tear in her earlier pregnancy. Some history will be given, might be given to you in the question that is asked. Again, should raise red flags for cervical insufficiency. Now, cervical cerclage is the treatment for cervical insufficiency. We all know this. Okay. And who are the, so when depends on the type of cerclage, which we will be discussing. In whom do you put a cerclage for? There are three indications. One is based on history. On history, if she's had three or more second trimester losses or early preterm births, you will put in a cerclage. So if she's had more than three losses in the second trimester or early preterm. The second indication is ultrasound indicated. If she's had one or two losses in the second trimester or preterm births, plus a short cervix on the ultrasound. When I say short cervix, it means less than 2.5 centimeter length before 24 weeks is what we call a short cervix. Less than 2.5 centimeter before 24 weeks is the short cervix. Okay, so if she's had one or two losses and the patient has come to you, she says I'm fine, but I have some pressure down below. When you examine her, you find the cervix is opening up. Okay, so she has no symptoms as such. She might be a primary gravida, but on examination, you find the cervix is open. You will not leave her alone. You will put in an emergency cerclage. This is called an emergency or a rescue cerclage. Okay, so this is the three indications for putting in a cerclage based on a history, based on ultrasound, or based on an examination that is called an emergency or a rescue cerclage. Remember, cerclage is put before 28 weeks of pregnancy, that is before the period of viability. How do you put in a cerclage? Now depends on there are two types mainly, a transvaginal and a transabdominal cerclage. Transvaginal, the most common is a McDonald cerclage. A McDonald cerclage is a purse string suture. It looks like this. I'll just show you the picture also. And this is put between 12 to 14 weeks of pregnancy. It is removed at term. Around 36, 37 weeks, we remove it, and the patient is allowed to deliver vaginal. So, vaginal delivery can be allowed. This is how McDonald's looks like. Now, okay, so these images came in the last exam. This is how you can see it's taken in a purse string fashion all around. And in the end, when you tie the knot, the cervix bunches together and closes up. Okay, so this is how a McDonald's cerclage looks like. Remember, there is no such thing as modified McDonald's. That was only there to confuse you. There is only a McDonald's suture. The second is Shirodka's. Now, what is Shirodka? Shirodka is slightly higher than McDonald's. So, it is a suture put all around like this, but because it is placed at a slightly higher level, you have to give an incision here on the anterior vaginal part and dissect and push up which structure? Push up the bladder. Otherwise, when putting the stitch, you will end up injuring the bladder. So, Shirotkas is at a higher level. To reach that higher level, you have to open the vagina and push the bladder away. Now, this is Shirotka's circular. So, you can see the vaginal wall has been opened, okay, and then the bladder has been pushed up, and then the suture is put here. This is called a Marceline tape. Okay, but you don't identify because Marceline tape you can even use in McDonald's. Many people use a tape. The main thing is what you still hear, it is called as Shirotkas. Okay, now can you see here what will be done? The knot will be tied and the knot gets buried under the vagina. Once you bury the knot, it is called a modified Shirotkas. The last step of burying the knot makes a Shirodkar a modified Shirodkar. That is the only difference. This image came in the last exam, and this exact image came. This is from Williams, and this is showing modified Shirodkars where the knot, final knot, has been buried. You can't see the knot, whereas here you can see the knot. Right? That is the difference between Shirodkars. अगर यहाँ पे छोड़ दो ऐसे McDonald's की तरह तो it is Shirodkars, but if you bury the knot, it is called as modified Shirodkars. Again, in Shirotkas, same thing. It is done at 12 to 14 weeks, removed at term, and the patient can be allowed to deliver vaginally. There is one more vaginal cerclage called the worms cerclage, not commonly done in our country, but this is how it looks like. It's very similar to McDonald's. One suture is put like this and one like this. यहाँ पे tie कर दो यहाँ पे. So two knots will be there. If you see two knots, it is called as worms cerclage. Okay, and there is a a fourth type of vaginal cerclage called the lash and lash. Now, lash and lash is not actually going around the cervix. So, it's not a cerclage in the true sense, and it is never done during pregnancy. So, lash and lash is the only cerclage which is done before pregnancy and can never be done during pregnancy because it is not actually a cerclage. It is just repair of a defective cervix. Okay, so basically it's cervical reconstruction. So you reconstruct the cervix, and these sutures are never removed. Stitch sutures are never removed. And once you put a lash and lash, delivery is always by a cesarean section. You will not deliver a lash and lash vaginally. Otherwise, it's just going to break up. All the repair that you've done will go waste. Okay, so always done before pregnancy, can never be done during pregnancy. Sutures are never removed. Delivery always by cesarean. It is not a going around suture, it is reconstruction of the cervix. ठीक है, that is lash and lash. It's a transvaginal procedure. Now, transabdominal cerclage, also called as TAC. TAC, what is important about TAC is that TAC is done in those patients who've had a previous failed transvaginal cerclage. You will do a TAC. TAC can be done either before pregnancy, it can also be done during pregnancy. Both times it can be done. It can be done via laparoscopy. This is preferred nowadays, but it was initially done as a laparotomy. Okay, and this was done by two people called Benson and Durfee. That's why it's also called as Benson stitch or Benson or Durfee stitch or Benson and Durfee stitch. Okay, so this is about transabdominal cerclage. Now, why is it done in previous failed? Because it is more invasive, so we don't want to do it as the first procedure. But remember, it is the best or the most effective because it is done actually at the level of the internal os. Okay, it is not done lower. The other transvaginal ones are all lower. This is done at the level of the internal os, so it is the most effective or the best cervical cerclage. If it's asked, it is TAC. What are the contraindications to cerclage? Any bleeding, leaking, infection. So if the question comes, patient has ruptured the membranes, you will not put in cerclage. Patient is bleeding, no cerclage. Patient is having evidence of discharge, foul smelling discharge, fever, not putting cerclage. If the uterus is contracting, your cerclage is not, it's just going to tear. You will not put in the cerclage if the uterus is more than 4 centimeter dilated or active uterus, and if there's any anomaly in the uterus, okay, or sorry, in the fetus, this is fetal anomaly, any fetal anomaly, or the baby's died, there's no point putting in a cerclage, and you're doing it only for fetal, for keeping the growing the fetus. If the fetus is defective or dead, there is no point putting in a cerclage. So any bleeding, leaking, infection, any uterine activity or any fetal death or fetal anomaly. Now, what is APLA? APLA is antiphospholipid antibody syndrome. Just remember these things. It is diagnosed based on Sapporo's criteria, which includes one clinical and one lab criteria. So, this is the first thing you should remember, the name, Sapporo's criteria. The actual criteria are not important. Second important thing is that you should remember the treatment of APLA. What is the treatment of APLA? Treatment of APLA is you are going to you're going to, when as soon as the patient gets pregnant, you're going to start her on low dose aspirin and low molecular weight heparin. This is the treatment of choice in antiphospholipid antibody syndrome. Okay. Now coming to ectopic pregnancy. This is also very, very important. Remember, ectopic pregnancy is pregnancy outside the uterine cavity. The most common site is the fallopian tube, and the most common site in the tube is the ampulla. Why the ampulla? Because this is the widest portion of the tube. It is also the point where fertilization takes place. And usually, ectopic pregnancy happens because of some problem in the tube. The motility is not good, and hence the embryo, which has fertilized in the tube, can't come down to the uterus. Okay, so that the risk factors for ectopic pregnancy usually are something that affects the tube. One of the highest risk factors is a history of a tubal surgery, like the patient has had a tubal sterilization or a tubal recanalization. Second is there's a history of salpingitis. That means the patient has a tubal infection, active pelvic inflammatory disease, or even a history of genital tuberculosis. So one of these histories will usually be given in the question to help you as a clue. It will be given, and you should use these as these clues to help you come to a diagnosis. So tubal surgery, salpingitis, genital tuberculosis, history of IVF. Many times the embryo doesn't implant in the uterus, it goes down and implants in the tube. History of adhesions because of previous surgeries, or history of endometriosis. History of contraceptives, like especially intrauterine devices, increased because IUDs prevent implantation. If they prevent implantation in the uterus, the baby, the fetus might get implanted in the tube. So intrauterine devices, progesterone only pills increase the risk. These are the most, there are a few others, but these are the most important risk factors for ectopic pregnancy, which usually will be a clue in your question. Now, what are we worried about? We are worried about that this ectopic pregnancy might rupture because there is no muscle, there's hardly any muscular layer in the tube as it grows. And usually in the first trimester itself, this is going to rupture. Now, if it ruptures, although that's not the most common thing to happen is कि अपने आप ही खत्म हो जाता है. But sometimes this can rupture, and that is what we are worried about. So, we are worried about a ruptured ectopic, and a ruptured ectopic in the exam is going to be very easy to diagnose. Why? The patient is going to come with a classical triad of symptoms. What is the triad? A positive UPT or a delayed period, with abdominal pain, with spotting or vaginal bleeding. This is going to be your typical presentation plus signs of shock. That means she's going to have hypotension, tachycardia, she's going to appear pale, there'll be guarding, rigidity. Okay, so all these things will be there. So when you have a patient in shock with the typical triad of symptoms, UPT positive, bleeding, pain, think of ruptured ectopic. Ruptured ectopic is very easy to treat. What do you do in ruptured ectopic? You're not going to waste time in anything. Patient is in shock, shift the patient to the OT and do a salpingectomy. This can be done by laparoscopy or laparotomy, but you have to remove the fallopian tube. That is the treatment of choice. Now, unruptured ectopic is where we have certain signs which are picked up on ultrasound. So, the baby is still in the tube, hasn't ruptured. What are we looking for on ultrasound? So, in ultrasound, you can look at, you might find what is called a pseudo sac. This is not a true sac, this is a pseudo sac. It's just a collection of fluid in the endometrial cavity. You may actually find the ectopic gestation outside the uterus. You may even see the yolk sac. You may even see the fetus. You may even see the heartbeat. So you actually see the pregnancy outside. You may even see this kind of sign outside the uterus. This is called a bagel sign. This is how a bagel looks like. So the bagel sign, sometimes you don't see the actual bagel. You may just see a random blob. So it's also called a blob sign. You may not see this nice donut sort of thing. You'll just see a mass in the adnexa. This is called a blob sign. So bagel sign, blob sign, pseudo sac. And if you switch on the Doppler, you find vascularity all around the sac. This is called the ring of fire sign. These are all signs of ectopic, unruptured ectopic pregnancy. Now, if a patient, I'll just come back to that slide. If a patient comes with these symptoms, positive UPT plus pain plus bleeding, okay, in our mind, we are thinking of three things: abortion, ectopic, or molar pregnancy. If the patient is unstable, patient is in shock, then your diagnosis is quite clear. It is a ruptured ectopic and she requires immediate surgical management. Okay. But if the patient is stable, so you have a patient with these triad of symptoms, UPT positive, pain, bleeding, and the patient is stable, what is the next best step? So this is how the question will come. Patient has come, she is a 20-year-old girl who's come, her UPT is positive, she's having pain, she's having some bleeding, her vitals are stable. What is the next best step? Next, you will do an ultrasound because it could be an abortion, it could be an ectopic, it could be a molar, it could be either of the three. So on TVS, if you see an intrauterine pregnancy, you are happy. At least you know you have a diagnosis. Or you may see the bagel sign, the blob sign, the actual ectopic in the tube. You may see the ring of fire, the pseudosac. So you know it's an ectopic pregnancy. But many times, especially in the exam, they like telling you that the ultrasound is normal, nothing is seen. So patient is pregnant, UPT is positive, pain and bleeding is there, but ultrasound is normal, nothing is seen, no sac is seen anywhere. This is called a pregnancy of unknown location or undetermined location. And what do you do in this situation? You do a beta HCG and you repeat it after 48 hours. This is called as beta HCG doubling. Now, why is this important? You should know that there is something called a doubling time. That is in a normal intrauterine early pregnancy, beta HCG values increase by more than 60%. So we roughly say doubling, but the rise should be more than 60% in 48 hours. That means if I do a beta HCG today and the value comes as 100, after 48 hours, it should be 200. This is called as doubling. Doubling is actually a misnomer. The rise should be more than 60%. So if it is more than 160, I'm happy. I know this is an intrauterine pregnancy. Maybe it's very early, that's why I can't see it on the ultrasound, and that is what is called as discriminatory zone. This is the level of beta HCG in the blood at which a pregnancy is visible, at which a gestational sac is visible in an intrauterine pregnancy. That means that if the doubling is happening, when do I get a scan for this patient? I will get a scan for this patient when the beta HCG crosses 1500. So to look at the gestational sac on a transvaginal scan, the discriminatory zone is more than 1500. And to look at the gestational sac on a transabdominal scan, the beta HCG should be more than 6000. This is called as discriminatory zone, the level of beta HCG at which a gestational sac is visible in an intrauterine pregnancy. So this is the role of beta HCG. We do it for the doubling time, we do it for looking at discriminatory zone, and these help in management of a pregnancy of undetermined location. So patient comes with positive UPT, pain, bleeding, stable. Next best step TVS non-diagnostic. You can't find anything. Next best step beta HCG doubling. This has come as a question. This has come as a question. Now, ruptured ectopic is very clear cut. This much blood, tube is bleeding. Do a salpingectomy. But unruptured ectopic, like here, you can see the ectopic is here. Unruptured ectopic, what are we going to do? So we have three possible treatment options. Either we wait. Waiting means expectant management, because we know majority of ectopics will disappear by themselves. So we just do weekly beta HCGs and wait for the beta HCG to fall. Once it reaches zero, the patient will be fine. है ना? So expectant management उनके लिए करते हैं, not for everybody. This is only for a small group of patients who have no symptoms, okay, whose beta HCG is less than 1000. On ultrasound, the gestational sac size is less than 3.5 centimeters, and where there is no cardiac activity, no heartbeat seen on the ultrasound. Only if these conditions are fulfilled can you put this patient for expectant management in the hope कि अपने आप ही गायब हो जाएगा. But if the patient has a slightly higher beta HCG, so the patient is stable for medical management, that is giving injection methotrexate. How much do we give? We give 50 milligram per meter square intramuscular, a single dose, or you can even repeat a dose. 50 milligram per meter square intramuscular injection methotrexate can be given to patients who are hemodynamically stable. Patients whose beta HCG is less than 5000, whose sac size is less than 3.5 centimeters, again, no cardiac activity, and the patient has no contraindication to methotrexate. She should not be anemic, she should not have thrombocytopenia, she should not have renal disease, she should not have liver disease. That patient you can easily give methotrexate. So stable patient, beta HCG here, the cutoff we take higher 5000, but sac size less than 3.5 centimeter, no cardiac activity, and no contraindication to methotrexate. This is medical management. Surgical management कब करोगे? In unruptured, ruptured में तो we do surgical, but in unruptured, when will you operate? You will operate in an unruptured ectopic pregnancy if the patient has severe pain, so severe symptoms, or is hemodynamically unstable. That means maybe she has started to rupture, or the beta HCG is more than 5000, or the sac size is more than 3.5 centimeter, or fetal cardiac activity is present. If any of these are there, you are not going to wait, you are going to operate. Okay, so what surgery will you do? You can do either a salpingostomy or a salpingectomy. I'll just repeat: severe symptoms or unstable patient with very high beta hcg more than 5000, with a sac size more than 3.5 centimeter, with cardiac activity present, you will operate. And you will operate, we prefer laparoscopy in unruptured ectopic because it's minimally invasive, and you can either remove the fallopian tube, that is called a salpingectomy if you're removing the fallopian tube, and this is actually preferred, because if you do a salpingostomy, just a second, I have to take a call. Okay, sorry. So laparoscopy is the preferred management, and salpingectomy, removing the fallopian tube, is preferred over a salpingostomy. Salpingostomy क्या होता है? You just give an incision over the ectopic and remove the products. But salpingostomy is like a surgical procedure on the tube. It is a surgical. It will increase the risk of ectopic in her future pregnancies. So that's why salpingostomy is done only if the patient is very, very wanting to conserve the tube or the family is not complete. Then you will consider salpingostomy, but majority of times the salpingectomy is the better way because it can increase the risk of ectopic pregnancy in the future. Salpingectomy we will definitely advise to those patients whose family is complete. Okay, if this is a recurrent ectopic, if earlier also she had an ectopic in the same tube, again in the same tube, then salpingectomy, remove the tube. That means the tube is damaged. Or ectopic is happened at the site of a previous tubal ligation. That means she had a tubal ligation and ectopic is formed again, then you will remove the tube. Or if it is a grossly distorted tube, that means the tube is grossly looking damaged and it is a huge ectopic, better to remove the tube. So otherwise also salpingectomy, even if it's an unruptured ectopic and you're doing surgery, salpingectomy is the preferred surgery over salpingostomy. You don't want to conserve this tube. Remember, this patient will keep having ectopics in that tube. Now, molar pregnancy is the third diagnosis we had of bleeding in early pregnancy. There are two types of molar pregnancy, more partial mole and complete mole. The main difference is that basically there's an abnormal fertilization happening. In partial mole, the two sperms are fertilizing one ova and forming a triploid gamete. It could be 69XXX, XYY, XYY. And in complete mole, you have a sperm fertilizing an empty ova and it's undergoing duplication. So there is no maternal component in complete mole and it is a diploid gamete only. Okay, so this is one of the most important differences. So partial mole is triploid, complete mole is diploid. Remember that C and D come together in the alphabet. P and T, partial triploid. P and T come also together somewhere in the alphabet. Okay. So partial mole is triploid, complete mole is diploid. Clinical presentation, जो classical presentation passage of grape like vesicles, uterus more than the POG, so big uterus, presence of bilateral ovarian cysts called as theca lutein cysts, history of preeclampsia, hyperthyroidism. These are classically seen in complete mole. Okay, so when you have this classical presentation, think of complete mole. Whereas partial mole is not so dramatic. Partial mole usually presents like how a threatened abortion or a missed abortion will present. So there will be minimal symptoms. They will the so why it is not as dramatic, because complete mole the beta hcg levels are very high, they're in lakhs and lakhs. Partial mole beta hcg is raised, yes, but not very very high. So that's why symptoms are lesser. Uterine height is not so big, theca lutein cysts nahi dikhenge, preeclampsia, hyperthyroidism nahi hoga, and very importantly risk of subsequent gtn. So, molar pregnancy has a risk of becoming choriocarcinoma, and that risk is lesser with partial mole. It's about 1 to 5% with partial mole, and it's about 15 to 20% with complete mole. So, with complete mole, you are more worried about this becoming choriocarcinoma. When you do a histopathology of a molar pregnancy, in partial mole, you will find fetal parts are present. Even on ultrasound, you might see fetal parts. Fetal RBCs are present with partial mole. Here they are absent. Very typical, these are the classical histopathological findings. Villus edema and trophoblastic proliferation. These are found in focal areas in partial mole, and they are found in diffusely all over the area in complete mole. Trophoblastic atypia. So, atypical cells are more common in complete mole, less common in partial mole, because the risk of malignancy is higher, conversion to malignancy is higher here. And very important, this came in one of the recent FMGs, P57 KIP2. Remember where P is there, partial mole mein ye hoga, because this is basically a maternal component immunohistochemistry marker. तो जहाँ maternal component होगा, it's going to be there. In complete mole, there is no maternal component, so it's not going to be there. Very, very important. P57, this is very new also. KIP2 immunostaining. This is the typical image-based question, very, very commonly asked. Snowstorm appearance. This is very classical for complete mole. Snowstorm appearance seen more in complete mole. This is how the grape-like vesicles, when you do a suction evacuation, what is the treatment of choice for molar pregnancy? It is doing a suction and evacuation. Right, so we do, and this is done under ultrasound guidance. And when you do the suction evacuation, you find these grape-like vesicles which come out. And treatment doesn't stop at suction evacuation. You have to do a suction and evacuation, and you have to follow this with by doing beta HCG surveillance, because you are worried about choriocarcinoma. How do we know choriocarcinoma has developed? By following the level of beta HCG. Beta HCG should fall. Okay, so when you plot a graph, the beta HCG should fall. It should reach normal value by around 8 weeks post evacuation. It reaches normal values earlier for a partial mole. So partial mole will return to normal values by 7 weeks, complete mole by around 9 weeks, on average 8 weeks. So how do we do the beta HCG surveillance? We do weekly beta HCG till it becomes 0, and then we do monthly beta HCG for 6 months. This is how we do beta HCG surveillance. So every week after evacuation, we call the patient, do beta HCG, plot it on the graph. Do collar after 1 week, again plot on the graph. Then once it touches 0, then we keep checking every month for 6 months. It should remain 0. At any time during this surveillance, if the beta HCG starts rising, if it plateaus, stops falling, or even after 6 months, you still find beta HCG in the blood, that means this has developed into choriocarcinoma, and you need to start treatment of choriocarcinoma, which is either methotrexate if it is low risk, or imaco if it is a high risk disease. Okay, so this is the beta HCG levels are undetectable by 7 weeks for partial mole, 9 weeks for complete mole. Risk of GTN, I told you, is 15 to 20% following complete mole, and 1 to 5% following a partial mole. So this ends ectopic pregnancy, molar pregnancy. So bleeding in pregnancy. Now just a few images I put together. These are ultrasound images in obstetrics, very, very important. This is the first structure you see on an ultrasound in early pregnancy is a gestational sac. So this what you're seeing is a gestational sac. This is a true gestational sac. Now, when does this appear? Remember, things appear earlier in pregnancy on a transvaginal scan. For transabdominal scan, they appear after 1 week. So, on TVS, the first structure to appear is the gestational sac, which appears at 5 weeks on TVS and 5.5 weeks on transabdominal scan. The next structure to appear is the yolk sac, which appears at 5.5 weeks on TVS and 6.5 weeks on TAS. The next structure to appear is the fetal pole or the embryo with cardiac activity. This appears at 6 weeks on a TVS and 7 weeks on a transabdominal scan. So just remember 5, 5.5, 6, and then add 1 week later for transabdominal scan. Okay, now this is another sign which we see in early pregnancy. It's called the double decidual sac sign. Remember, in pregnancy, this is the uterus. The endometrium of pregnancy is called the decidua. So, all this, once the patient becomes pregnant, all this endometrium is called the decidua. Now, what happens is you have the fetus which is implanting in the endometrium. Say it implants here. Now you have endometrium covering all around the uterus. So you have this decidua. Then you have decidua, which is here, this orange one which I'm drawing here. You have this is also decidua, and you have decidua which is covering the embryo, this also. So the embryo has actually gone and implanted inside the endometrium. So you have it surrounded by decidua on all sides. Now, this decidua, which is going to form which is going to be in contact with the future placenta, is called as the decidua basalis. So, basalis is the one which is going to be in touch with the future placenta. The opposite part, this green one which covers the embryo, is called the which forms a cap over the embryo, is the decidua capsularis. And the remaining endometrium all over the uterine cavity is called the decidua parietalis. Now, as this embryo is going to grow, right, what's going to happen? The capsularis and parietalis are going to come closer and closer till the time all this uterine cavity will get obliterated. Okay, because the pregnancy is going to grow and the decidua capsularis comes in close contact with the decidua parietalis. This close contact, the capsularis, this is the capsularis, this is the parietalis, this is the cavity जो obliterate होता जा रहा है ना? This is called the, before it gets obliterated, you can actually see it as two concentric rings, and this is called as the double decidual sac sign, formed by, remember, capsularis and parietalis. The question that comes from here, which decidua form the double decidual sac sign, or which decidua will eventually meet and obliterate the cavity? Answer is capsularis and the decidua parietalis. This is the yolk sac. So this is the gestational sac. This nice round structure is called the yolk sac. This is what is the, so after the gestational sac, the next structure to appear is the yolk sac. This is now the fetus, okay, which is appearing with cardiac activity at 6 weeks. And how do we measure the fetus? We measure the fetus by the crown rump length. This is called the crown rump length. Now, two important things here. When we see the gestational sac, we measure what is called the mean sac diameter. Remember, so what is mean sac diameter? It is this diameter of the gestational sac. Okay, you measure it in three planes and take the average. Now, this mean sac diameter, remember, at a mean sac diameter of 25 millimeter, you should see what? You should see a fetal pole. A fetal pole should be seen. If it is not seen, so if you measure the MSD and you find it is say 30 mm, but under fetus nahi dikh raha, you can't see the fetal pole. It is called, so if not seen, it is called an embryonic pregnancy or a blighted ovum. Okay. Also remember the second important point. So this is one point you should remember. At a MST of 25 millimeter, a fetal pole should be seen. And once you see the fetal pole, you're measuring the CRL. So at a CRL of 7 millimeter, what should be seen? Cardiac activity should be seen. If cardiac activity is not seen at a CRL of 7 millimeter or more, it is called a missed abortion. And this came in the last FMG exam. So cutoffs of MST and cutoffs of CRL. Cutoff of MST to see the fetal pole is 25 mm. Cutoff of CRL to see the cardiac activity is 7 millimeter. These two numbers are very important to remember. What is this? Is it another sign? So this is outer one is the gestational sac. Yes. This is the yolk sac. Yes. This is the fetal pole, right? What is this third thing you're seeing? This is the amniotic sac. So it's very faintly seen. The amniotic sac which contains the fetus. So it you can see it's forming there are two circles. One is the yolk sac wala circle and one is the amniotic sac wala circle. This is called a double bleb sign. Just a second. This is called a double bleb sign. And this is also seen around 8 weeks of pregnancy. You can see the double bleb sign. These are all first trimester pregnancy signs. I will repeat, first is gestational sac, then yolk sac, then fetal pole with cardiac activity. Now, this fetus is in an amniotic sac, which will gradually expand and fill up the gestational sac. But at this point of time, when you can see the separately, the amniotic sac and the yolk sac together, close together, it is called the double bleb sign. This is the pseudo sac which I told you about earlier. It is seen in ectopic pregnancy. Remember, a pseudo sac versus a true sac, a true gestational sac. A pseudo sac is always central in position. You can see it's in the center of the uterus. Whereas a true sac is eccentric. It's going to be in one corner here. That is one of the most important points. Also, a pseudo sac is not round, it will be usually irregular, whereas a true sac is going to be regular. A true sac is going to contain a yolk sac, it's going to contain the fetal pole, whereas you're not going to see all these structures in a pseudo sac. It's just collection of fluid, nothing else. Remember, pseudo sac central, true gestational sac is going to be in one corner, that is eccentric. Few more images. This is the nuchal translucency which we've discussed. This is the nasal bone. White on ultrasound is bone. Black on ultrasound is fluid. Few more snowstorm appearance we've discussed. This is the bagel sign we've discussed. And this is the Buddha sign. Buddha sign means two concentric circles. This is the baby's head. Around the baby's head, another halo. So this is called the Buddha sign, which is seen in fetal hydrops. There is scalp edema in fetal hydrops. So this is causing the Buddha sign. This is Spalding sign is seen overlapping of skull bones seen in intrauterine fetal demise after the 7th day of fetal demise. You start seeing both on X-ray and on ultrasound, you will see the Spalding sign. It's also an X-ray sign and an ultrasound sign. In fact, initially it was described as an X-ray finding. Banana and lemon sign frequently asked. Banana, both are seen in spina bifida. Banana is increased cerebellar curvature. This is the cerebellum. It's the curvature is increased. Lemon sign is the shape of the skull. It looks like a lemon. So this is in spina bifida. What is this? This is double bubble sign seen in duodenal atresia. It can be detected in the antenatal period. This is the keyhole sign seen in a bladder outlet obstruction, most common cause of which is a posterior urethral valve. And this will also lead to oligohydramnios. Duodenal atresia is going to lead to polyhydramnios. This is frog face or anencephaly. It can come as this kind of picture. It can also come as this kind of picture. Okay, so this is frog face or frog eye sign seen in anencephaly. Very important. This is the lambda or the twin peak sign seen in dichorionic diamniotic twin pregnancy. And then you have the inverted T or simply the T or the reverse T sign seen in monochorionic diamniotic twin pregnancy. We'll be discussing this a bit more later on. But just remember lambda, twin peak in di-di, monochronic diamniotic, you have the reverse T or inverted T. So more images from placenta. This is a normal placenta. Okay, so what you're seeing here, this surface where the umbilical cord is attached, this is the fetal surface. The opposite side where you have the cotyledons, okay, 16 to 20 cotyledons, is the dirty irregular side is the maternal side. Rough weight, approximate weight, average weight of the placenta weighs 500 grams at term. This is a term placenta. Diameter 15 to 20 centimeters. Thickness 2.5 centimeters. Volume, it contains around 500 ml of blood. So this is how the placenta looks like. So this is the fetal surface. This is the maternal surface. Should be able to identify. Easy question. What is this? This is a bilobed placenta. Usually does not have much clinical significance. This is a succensurate lobe. Succensurate lobe has clinical significance because sometimes this placenta can get left behind. The smaller lobe can get left behind. So you can have a patient with PPH or infection. So retained placenta can be there. Also, if this separating part lies over the internal os and this part gets ruptured during an ARM, you can also end up with a complication called vasa previa. So retained placenta vasa previa. In fact, vasa previa can happen with a bilobed placenta also. If the central part, which has so much vessels, lies over the internal os, you can have vasa previa or fetal blood loss. Remember, vasa previa is a cause of fetal blood loss. It also should you remember that the CTG is going to show a sinusoidal fetal heart rate like this. So if you see a sinusoidal fetal heart rate, fetal blood loss, succensurate lobe, bilobe placenta, or even a velamentous insertion, I will come to that. All of these are risk factors for vasa previa. What is this? This is a circumvallate placenta. What do you notice about this? You find that this amniotic membrane, which should have been much bigger, it is less, and it forms a thick white rim around here. This is called a circumvallate placenta. The amniotic membrane is insufficient, and this is associated with a lot of complications. There's a higher risk of abruption, there is a higher risk of preterm. There's a higher risk of intrauterine growth restriction. There's a higher incidence of intrauterine death. All these are higher with a circumvallate placenta. Okay. So circumvallate identified by a thick rim of amniotic membrane around the placenta. What is this? The cord should normally insert here. If the cord is inserting at the margin of the placenta, it's called a battle door placenta. It has no clinical significance. It is not important. Okay, just the image you should be able to identify. If it's shown here, it's called a battle door placenta. This is a velamentous placenta. Velamentous insertion means the insertion happens not in the actual substance of the placenta. The umbilical cord has attached in the membrane and it started branching out before. And if this area again overlies the os, and if this gets injured during ARM, again it can lead to vasa previa. So vasa previa is seen with a succensurate or a bilobed placenta, and it's also seen with a velamentous insertion of placenta. Both are high risk for developing vasa previa. That is, if these big vessels get injured, there's going to be a massive fetal loss, severe fetal hypoxia, sinusoidal pattern, fetal death. Okay. Single umbilical artery, this is called the Mickey Mouse sign on ultrasound. You can see this is the umbilical cord. The umbilical cord, a normal umbilical cord has, remember, one umbilical vein and two umbilical arteries. Okay, so it appears this is the vein, these are the arteries. This is how it looks like. This is called the Mickey Mouse sign on ultrasound. Remember, in fetal circulation, it is ulta. Umbilical vein is the one carrying oxygenated blood from the placenta to the fetus, and the umbilical arteries are carrying deox blood from the fetus to the placenta. Now, sometimes you find a single umbilical artery. Can you see this is the umbilical cord? There's only one umbilical vein and only one umbilical artery. Single umbilical artery has a very strong, almost 30% association with other anomalies, and both structural and chromosomal. So, whenever you see a single umbilical artery, that patient should be counseled to that there is a risk of other anomalies. So, a detailed scan should be done. She should also be offered chromosomal testing because it is often associated with chromosomal aneuploidies also. So, single umbilical artery, think of structural anomalies, think of chromosomal, associated chromosomal anomalies also. Amniotic fluid abnormalities, remember they are different. First important thing, you should know the color of the amniotic fluid. Okay, this slide always comes wrong. I don't know why the colors don't show. So this is the straw colored amniotic fluid. Okay, this is normal color of amniotic fluid. Amniotic fluid is predominantly made of fetal urine. Okay, this one is supposed to be green. Green means meconium staining of amniotic fluid. So whenever you see meconium staining, there are two reasons why the meconium can be stained. Just a second. Okay, apologies, sorry. Some emergency came up. So this is green colored amniotic fluid. Okay, green colored amniotic fluid is meconium. Meconium means either the baby is in distress, there's fetal distress, or it also is indicative the baby is mature. So in a post-term pregnancy, after 42 weeks, you are more likely to see meconium. The baby would have passed stools in utero, and the amniotic fluid becomes green in color. Now, whatever the reason of meconium, the baby has passed meconium in utero either because of distress or because it is mature. If the baby aspirates this meconium, it leads to pneumonitis called meconium aspiration syndrome, where the baby can have respiratory distress, hypoxia, and then it can lead to problems. So that's why meconium is important. The next is this golden yellow colored of amniotic fluid. This is usually seen in RH isoimmunization. It's a deep golden color of amniotic fluid. Then you have this tobacco color of amniotic fluid. This tobacco color is seen in intrauterine fetal demise. It's when the baby dies, the color of the amniotic fluid becomes very darkish, brownish colored. And the last is this red amniotic fluid. Red amniotic fluid is seen in abruption. So in abruption, there is bleeding, the placenta separates, the amniotic fluid appears red in color. So these colors help you in when you're getting a clinical scenario, it helps you identify the possible reason, okay, or why this is there. Okay. Now, if next we have amniotic fluid disorder, volume disorders, we have polyhydramnios, we have oligohydramnios. Polyhydramnios is when the amniotic fluid volume index is more than 25, or the single vertical pocket. Just a second. Okay, so AFI more than 25, or single vertical pocket or deepest vertical pocket more than 8 centimeter. What is a normal AFI? A normal AFI is between 5 to 25 centimeters. Anything more than 25 is polyhydramnios. Anything less than 5 centimeter is oligohydramnios. Single vertical pocket, if we talk about normal values, it is 2 to 8 centimeters. Anything more than 8 centimeters, polyhydramnios. Anything less than 2 centimeter is oligohydramnios. So definitions are very important. What is normal AFI? 5 to 25, normal vertical pocket 2 to 8. More than 25, poly, less than 5, oligo. The polyhydramnios, what I remember amongst all the etiology, the most common cause is idiopathic. There is no cause. So most common is idiopathic. That is, no cause is there. But very commonly anomalies cause polyhydramnios. So you should know the anomalies that lead to polyhydramnios. In anomalies, remember any obstruction to swallowing. So any atresia in the GI tract. So you can have esophageal atresia or tracheoesophageal fistulas, then duodenal atresia, then ileal atresias. All these atresias can lead to polyhydramnios. If there is a large swelling in the neck, like a large cystic hygroma, that can also lead to polyhydramnios. If there is, what else? If there is other anomalies which can cause polyhydramnios are neural tube defects, especially open neural tube defects like anencephaly, meningocele, encephalocele, that can lead to polyhydramnios. Twin to twin transfusion syndrome, where you have one baby with oligo, one baby with polyhydramnios. These are the things that you should think of when you have a patient with polyhydramnios. Either some obstruction to swallowing, a large neck swelling, even you can remember muscular dystrophies. Muscular dystrophies, which are quite rare, but this inhibits the baby's movement, inhibits swallowing. If the baby can't swallow, they will be polyhydramnios. When the patient comes with polyhydramnios, she will usually be very uncomfortable. So there will be a lot of discomfort. There may be respiratory distress because of the huge abdomen. She can't breathe. She will be uncomfortable in standing and sitting positions, especially even lying down. She can have hypotension and feeling of discomfort. On inspection, the uterus is over distended and the skin over the uterus is shiny and stretched skin over the uterus. On palpation, the fetal parts are difficult to feel, and on auscultation, the fetal heart rate is muffled or faint fetal heart rate is heard. You can't hear the fetal heart sounds clearly. This is how typically polyhydramnios will come. Oligohydramnios, AFI less than 5 centimeter or single vertical pocket less than 2 centimeter. Causes of oligohydramnios, remember when there is less renal blood flow, like if there is uteroplacental insufficiency, like in preeclampsia, baby uterus is getting less blood, or in IUGR, kidneys getting less blood, or even in when the baby has died, intrauterine death, or in post-term pregnancies, there's less blood flow to the uterus now, and the baby is mature, less blood, renal blood flow, less urine production. Or there is leaking. Either patient has ruptured her membranes, term or preterm rupture of membranes will cause oligohydramnios. Or if there's any anomaly, which anomalies will cause oligohydramnios? Think of renal, so bilateral renal problems, or bladder outlet obstruction like posterior urethral valves. What else? Drugs. Which drugs can lead to oligohydramnios? In drugs, two groups of drug lead to oligohydramnios. One is NSAIDs. That's why we don't commonly give NSAIDs in pregnancy, because they cause oligohydramnios. Also, AC inhibitors, as discussed, and angiotensin receptor blockers. These are the common causes of oligohydramnios, and of course, twin to twin transfusion syndrome, where one baby is oligo, one baby is poly. These are the causes of oligohydramnios in pregnancy. So, uteroplacental insufficiency, leaking, anomalies, and drugs can cause oligohydramnios. Now, a very, very important topic, antepartum hemorrhage. One question definitely, most definitely is going to come from here. Two causes, placenta previa and abruptio placentae. Placenta previa is a low-lying placenta, and the classification, the newer classification, is based solely on a transvaginal sonography. Remember, ultrasound TVS especially is safe in a placenta previa. What should you not do? You should not do a per vaginal examination, because you don't want to probe inside the cervix. But a TVS, the probe is remember in the vagina. That's safe. That's the best way to look at the placental position. So the classification based on TVS, you can have a true placenta previa or a low-lying placenta. True placenta previa means a placenta that is reaching or covering the os, and a low-lying placenta is a placenta which is within 2.5 centimeters of the os, is called a low-lying placenta. Clinical features of placenta previa, a placenta where you have painless, recurrent, these are called as warning hemorrhages. So painless, recurrent, this painless is very important, painless recurrent episodes of bleeding. Okay, and remember when we talk about placenta previa or abruption, we're talking about pregnancies after 28 weeks, in the third trimester we're talking about. Painless, recurrent, apparently causeless, because everything else is fine and she has bleeding. This is called as placenta previa. Always suspect placenta previa. When you examine her, you will find the uterine height is equal to the period of gestation. You will find that the uterus is usually relaxed, non-tense, non-tender, because tense, tender are signs of abruption. Non-tense, non-tender, fetal heart rate is usually good, But very commonly, you will find malpresentations because the placenta is gone in the lower segment, so the baby tends to be in transverse lie or oblique lie or breech presentation. So, malpresentations are common. How do you manage placenta previa? Remember, when will you deliver this patient? Deliver her at 37 weeks. There is no point going beyond. And how will you deliver her? By a cesarean section. By a LSCS, lower segment cesarean section, is how you deliver placenta previa at 37 weeks. Okay? But if the patient comes before 37 weeks and the patient is hemodynamically stable, there is a role of conservative management. Okay, and when I say conservative or expectant management, that means waiting and watching. This is called as McAfee-Johnson's line of management. McAfee-Johnson says that if she's before 37 weeks, see if you can take her till 37 weeks. But it should be done only if the patient is hemodynamically stable, there is no active bleeding, the fetal heart rate is good, and she's less than 37 weeks. These are the criteria to say that yes, I can allow this patient for expectant management. She should be stable, baby should be fine, bleeding should have stopped, and she's less than 37 weeks. What do you do in McAfee? You admit the patient, keep her on strict bed rest. Okay, and what else will you do? You, if she's less than 34 weeks, you will give her steroids and you will build up her hemoglobin by giving iron or blood transfusion. So this is what is McAfee-Johnson's line of management. When will you stop McAfee-Johnson? Once she reaches 37 weeks, or if she, suppose she has a bout of heavy bleeding, she's hemodynamically unstable, there's fetal distress, anything which is does not fulfill this criteria, you will do a cesarean section. So this is what you do in placenta previa. Few more important points in placenta previa. Remember, placenta, if it is diagnosed as low lying in the first or early second trimester, always confirm the placenta will migrate upwards in majority. In 80% of patients, placental migration takes place. So always confirm, reconfirm the diagnosis at 30 to 32 weeks. After this, if it's there, it's there. It will not move up. So if it moves up, it will move up by the early third trimester. Now, what is abruption? Abruption is premature separation of a normally implanted placenta. So this is a picture showing revealed abruption. This is a picture showing concealed abruption. So there are two types of abruption, revealed, concealed, or mixed abruption. Revealed is all the blood is visible. The placenta has separated and all the blood is visible. Concealed is all the blood is collected behind the placenta and very little, if any, will be visible. So in revealed abruption, you will find that bleeding will be more and pain will be there, but it will be less. Whereas in concealed, you will have more of pain and bleeding will not be so much. Okay, so this is how revealed and concealed abruption will usually present as, right? Now, this tells us that whenever you have a patient with painful vaginal bleeding, always think of abruption. If there is painless vaginal bleeding in the third trimester, placenta previa, painful vaginal bleeding, this is the first clue. Think of abruption. Also, what is the diagnosis is completely clinical. Like in placenta previa, if you have a patient with who's come with vaginal bleeding, painless, you want to confirm, you will do an ultrasound. Abruption is a clinical diagnosis. The patient is going to come with painful vaginal bleeding. Ultrasound is done not to confirm abruption. Ultrasound is done to rule out placenta previa. Okay, and when you examine her, you will find that the patient's signs and symptoms may not be in proportion to the visible blood loss. Matlab, bleeding may be very minimal because it is concealed, but patient will be in shock. So there is no correlation. Bleeding come hoga, but patient will have hypotension, tachycardia. Okay, so that's one thing. That is the degree of shock is not in proportion to the visible blood loss. Bleeding may be very less, but patient will be very symptomatic like that. Okay. Second, you find on abdominal examination, the uterine height is more than the period of gestation. because especially in concealed abruption, the blood is collecting behind the placenta. Third is you find that there is a tense, tender uterus. Fourth, you find the fetal heart rate may be absent, or there may be evidence of fetal distress. So this is how abruption. Abruption is a very acute situation. In abruption, there is no waiting. Remember, if a patient comes with abruption, you have to deliver. Doesn't matter the gestational age. Whereas placenta previa, we can wait. Abruption, you can't wait. Abruption, the rule is SOS delivery. Immediate delivery is the rule. So in abruption, you have to, there are two main mantras of management. One is resuscitate the patient. She's losing blood, give her blood. And second is delivery. Immediate delivery is the rule. You're not going to wait for anything, even steroids. Okay, it doesn't matter the period of gestation, 28 weeks, 30 weeks, 32 weeks, doesn't matter. Delivery is immediate. Now, important here is how do you deliver? Placenta previa was straight away cesarean section. But abruption, you have to see a few things. Now, if it is early abruption means it's mild abruption. Mother is fine, fetal heart rate is fine. दोनों stable है. दोनों stable है. You can try a vaginal delivery. You can induce her if she's not in labor. If she's already in labor, many of these women are already in labor, you can simply augment or increase the contractions by doing an ARM starting oxytocin. So vaginal delivery you can aim for. Okay. If the mother is okay and the fetus is dead, baby has died, है ना, abruption has now become more severe, that fetal heart rate chala gaya. Here also you can plan a vaginal delivery because the mother is fine. You don't unnecessarily want to do a cesarean section for a dead baby. You can try a vaginal delivery. But if the mother is distressed, that means the question says mother has hypotension, tachycardia, pale, shock, or fetus is distressed. That means fetal heart rate is going slow. There's bradycardia. You don't want to waste time. You want to take the patient, the baby out quickly, do an emergency cesarean section. So remember in abruption, these few rules. One is immediate delivery. Immediate delivery means you have approximately 6 to 8 hours in which to deliver this patient since the beginning of symptoms. If you have that much time, and if the mother and baby are fine, you can try a vaginal delivery. If the mother is okay, baby dead, you can still try a vaginal delivery. But if the mother is distressed or the baby is distressed, you want a quick delivery, a very quick delivery, then a emergency cesarean is the best thing. What is cuvallar uterus? Incidentally, if you do a cesarean section for concealed abruption, you find this bluish discoloration on the uterus. This is called a cuvallar uterus. It's seen in concealed abruption as an incidental finding because the blood has seeped inside the myometrium. What do you do if you see this? Nothing. It's just a finding. It's just telling you that blood has entered the myometrium and वो अपने आप heal हो जाएगा. Nothing has to be done to treat this. It's just an observation of concealed abruption at the time of cesarean section. Important points in twin pregnancy. Remember, there are two main types of twin pregnancy, monozygotic, dizygotic. So you have two sperm fertilizing two different ova and forming two different embryos. This is a dizygotic type of pregnancy. Now, because they are two separate embryos, each is going to form its own amniotic cavity and its own placenta. This is called as dichorionic diamniotic placenta. ठीक है, so dizygotic is very clear cut. Dizygotic is the non-identical twin जो IVF में होता है ना. इसमें क्या होता है, टू सेपरेट ओवा जो क्लोमिफिन सिट्रेट में होता है. So two separate sperm fertilizing two separate ova forming two separate embryos. This is called as dichorionic diamniotic twin. Then we have monozygotic. Monozygotic में क्या होता है? What happens here? You have one sperm fusing with one ova forming one embryo, and then this embryo is going to split. Okay, this embryo splits, and depending on when this embryo splits, we have different types of chorionicity and amniosity. If the splitting happens very early means within 72 hours, okay, each baby is going to form its own amniotic cavity. and its own placenta. So again, it's going to form dichorionic, diamniotic kind of twin. If the splitting happens little late, okay, little late means it happens between the 4th to the 8th day. What's going to happen here? So between the 4th to the 7th day, rather, for the 4th to the 7th day, what's going to happen? 7 or 8. So some books say 7, some books say 8. You can remember either. You have a placenta which has formed. This is the chorion has formed, and the amniotic cavity is split. So this is called a monochorionic diamniotic kind of placenta. If the splitting happens later, the 9th to the 12th day, you have a placenta which has formed, you have an amniotic cavity which has formed, and only the baby split. So there's nothing separating the babies. This is called as a monochorionic, monoamniotic placenta. And if the splitting happens after the 13th day, the babies are joined somewhere. It's called a conjoined twin. So again, dizygotic twins are always DCDA, but monozygotic can be anything. Most common, of course, is DCDA. Splitting jaldi ho gaya, it forms DCDA. But if the splitting happens after the 4th day, you have what is called as monochorionic twins. Monochorionic twins are very dangerous because they have shared placenta, shared vascular connections, and that can cause problems in pregnancy. Now, MCMA is very easy to diagnose. Why? Because this is the placenta, both, and this is the amniotic cavity. This is the placenta outside. There's the amniotic cavity, and both babies are in the same amniotic cavity. There is nothing separating, there is no intertwin membrane. So it's very easy to diagnose. The problem comes in differentiating between on an ultrasound, because after delivery it's very easy to diagnose. You examine the placenta, you know. But in pregnancy, it is difficult to diagnose, and the best time to look at this diagnosis is between 11 to 14 weeks of pregnancy, right? This is the best time to look at chorionicity. How do we look at chorionicity here? You have, look at this picture first. Here you have a patient, you have baby 1 and baby 2, and this is what you're seeing. You're seeing the origin of this intertwin membrane. If it is a thick origin like here, the lambda or the twin peak sign, it is dichorionic, diamniotic. If it is a very thin origin, because you have a common placenta and only the amniotic membrane separating the babies, it is the T sign or the reverse T or the inverted T sign, then it is a monochorionic diamniotic placenta. Very important to diagnose this in pregnancy, because if it is a monochorionic placenta, you know to expect complications. Which complications are we talking about? We're talking about in monochorionic diamniotic, typically you're worried about twin to twin transfusion syndrome, where you have, it's also called as oligopoly sequence, where you have one baby is a donor twin, one baby is a recipient twin, one baby gives blood, it becomes anemic, this baby receives blood, it becomes polycythemic. This anemic baby will have oligohydramnios because it has less blood to the kidneys. This baby will have polyhydramnios. Eventually, both will die, because this will die of heart failure because of anemia. This will die of heart failure because of cardiac overload. What else should you remember? Remember, the treatment of choice of TTTS is laser ablation of the anastomotic vessel. So the vessel which is shared has to be ablated by laser ablation. And remember the staging, because I do named things are very important. Just remember the name for staging is called the Quintero staging. Quintero staging is the name we give for staging of twin to twin transfusion syndromes. Okay. Now coming to the most important topic, I always tell you this, hypertension in pregnancy. So one more thing which I forgot to mention, just go back to placenta previa. I wanted along with that to mention about placenta accrete syndromes. So as I said, hypertension in pregnancy, antepartum hemorrhage, postpartum hemorrhage. These are the three very important topics. Placenta accrete syndromes is a part of placenta previa. This is also called as a morbidly adherent placenta. when the placenta is adherent to the underlying myometrium. This is of three types. You have placenta accreta, placenta increta, and placenta percreta. Very easy to remember. A for accreta, it is adherent to the myometrium. I for increta, it is invaded the myometrium. P for percreta, it has perforated the myometrium. So it's like a tumor. It's gone inside the myometrium to various extent. And this is because on histopathology, you find something that there is a absent Nita Bukes layer. This is a layer in the decidua, and this is absent in these patients, absent Nita Bukes layer. This comes as a question. Now, also remember which is the highest risk, which patients have the highest risk for developing placenta accrete syndromes. Those with the highest risk, or when this comes in your question, immediately alarm bells should ring, is any patient with a previous cesarean section with and with a placenta previa now. Previous cesarean section with the placenta previa is the highest risk factor, because जहाँ पे cesarean होता है, where we give the incision, placenta goes and gets stuck there. That is the highest risk for developing placenta accrete syndrome. So if your question says that a patient presents at 30 weeks, she is previous 1 or 2 or 3, जितने ज़्यादा cesareans है उतना ज़्यादा risk. So previous 2 cesareans with a anterior placenta previa, no symptoms, nothing. She's just come to you and you see this report on the scan. What is the next best step? The next best step is you want to rule out accreta. So what is the investigation of choice? The investigation of choice is a ultrasound with a color Doppler. MRI is also a very good investigation, but it's not needed in all cases. And ultrasound plus Doppler is the gold standard. It is the investigation of choice. And if you have a patient with accreta, what are you going to do? How are you going to manage her? Remember, it is a very vascular thing. So it's going to bleed like anything. It bleeds, literally bleeds like a tap when if you try to attempt any removal of the placenta or any incision near that area, she's going to bleed like a tap. But bachcha to nikalna hai, we have to take out the baby. So how will you take out the baby? We have to do a cesarean section. But remember, avoid going near the placenta. So do an upper segment cesarean section. That is a classical cesarean section. Basically, stay away from the placenta. Take the baby out, deliver the baby, and then what do? Leave the placenta. Don't try and separate this adherent placenta. She's going to bleed. With the placenta in situ, proceed directly to what? Proceed directly to doing a cesarean hysterectomy, or what we call an obstetric hysterectomy. You have to remove the uterus. In fact, you may even end up injuring the bladder. That's why a multidisciplinary team of surgeons and people should be there. You should have the urologist, the surgeon, the obstetrician, all senior people, senior anesthetist, blood bank person should be involved. Interventional radiologist should be involved in case you want to do uterine artery embolization. So expect lot of bleeding, expect injuries, especially to the bladder, and expect a hysterectomy. This is very, very important in placenta accrete syndrome. So expect three things: expect blood loss, expect uh, urological injuries, especially a bladder injury, and expect what else? The third thing is expect and tell the patient you will need a hysterectomy. अभी मुझे कल ही a patient, a doctor called me. She said कि मैम एक अक्रीटा घूम रही है फरीदाबाद. मैम फ्रॉम फरीदाबाद, और अक्रीटा इज रोमिंग ऑन फरीदाबाद. Nobody is willing to take the patient. आप लोगे क्या? So I was like, if she comes to me, I'll take her. So it's a very dangerous thing. Nobody wants to operate because of this huge risk. She hasn't come to me yet, but remember, she's 37 weeks, the call I got. You should not wait till 37 weeks. Placenta accreta has to be delivered between 34 to 37 weeks. I don't want this patient now to come in the night and this so I told the doctor send her to me in the daytime, but abhi tak usne bheja nahi. I don't want her to land up in the night. That's why I have to deliver her before 37 weeks, not as an emergency, as an elective case, because I want a good team of doctors with me. So 34 to 37 weeks is when you are going to operate on placenta accreta. Okay. Next is hypertension in pregnancy. Hypertension in pregnancy, very, very important topic, like antepartum hemorrhage, like postpartum hemorrhage. This is important. What is the classification? First, there are 5 subtypes of HDP, hypertensive disorders of pregnancy. If you get this as a short form, HDP, you should know what it stands for, hypertensive disorders of pregnancy. Chronic hypertension is one type. Chronic hypertension means the woman is already hypertensive and she has conceived. Okay. Second is hypertension, which has developed in pregnancy before 20 weeks, is also chronic hypertension. And third is hypertension, which persists after 12 weeks of delivery. So she's delivered, even after 12 weeks of delivery, she's still hypertensive. That is chronic hypertension. So already hypertensive, or hypertension before 20 weeks, or hypertension after 12 weeks of delivery. That is, she was diagnosed as preeclampsia, but after delivery, even after 3 months of delivery, she is still hypertensive. You will reclassify her as chronic hypertension. Is there any problem? Because I'm getting a lot of emojis. What happened? You want a break? Break? Oh, इसलिए इतने सारे emojis. Okay, we'll have a 10-minute break. No worries. 4:45 पे मिलते हैं, छोटा सा ब्रेक, 15-minute ब्रेक. हैप्पी है? You all bombarded me with emojis. 4:45 p.m. तक ब्रेक, नो प्रॉब्लम. ठीक है, ओके. Okay, let us continue now. We have we start with hypertensive disorders in pregnancy. And in hypertensive disorders in pregnancy, we discuss chronic hypertension. This is the first type. इसमें क्या होता है? There is either the woman is hypertensive before pregnancy and then she becomes pregnant, or she develops hypertension before 20 weeks of pregnancy, or hypertension persists after delivery, 3 months of delivery, she is still hypertensive. What is gestational hypertension? Gestational hypertension is when she is hypertensive. After 20 weeks of pregnancy, hypertension is diagnosed, but there is no proteinuria. If there is proteinuria and hypertension develops after 20 weeks with proteinuria, and we take protein, we check a random sample of urine albumin. If it is more than 1 plus, although the Americans say more than 2 plus, we say it is preeclampsia. Blood pressure should be more than 140/90. After 20 weeks with proteinuria, that is in a random urine sample, more than 1 plus, it is preeclampsia, right? What is eclampsia? Eclampsia is any woman with preeclampsia who develops seizures. It is a severe form of preeclampsia. And what is preeclampsia superimposed on chronic hypertension? This is a woman who is already chronically hypertensive, and on top of that, she develops preeclampsia. Okay, so someone says she's hypertension at 10 weeks, she was diagnosed, and then say around 24 weeks, you find urine albumin is now also present. So she is preeclampsia superimposed on chronic hypertension. How do we know there's preeclampsia? Usually we find new onset proteinuria. So she was hypertensive, but she didn't have proteinuria, but now she's developed proteinuria also. So she is preeclampsia superimposed on chronic hypertension. These definitions are important. Next important thing is, why does preeclampsia happen? Now, preeclampsia, remember, happens primarily because of this etiology. This is in a non-pregnant patient. You can see the spiral artery, which is supplying the myometrium, the endometrium, and then the placenta. This is how it looks like in the myometrium, endometrium in the non-pregnant patient. Once she becomes pregnant, what happens? These cells, these are the trophoblastic cells, the endovascular trophoblastic cells. Okay, these are extravillous endovascular. The cells, trophoblastic cells, which are not the placental trophoblastic cells, they are extravillous and they are called as endovascular cells. They invade the spiral arteriole and they make it relaxed. Okay, this happens primarily 2 times, once in the first trimester and then in the second trimester. Okay, this wave of trophoblastic invasion, okay, happens in 2 times, first trimester, second trimester. This invasion, once it happens, the vessel opens up and lot of blood reaches the placenta. But in preeclampsia, what happens? This trophoblastic invasion happens, but it is deficient. So deficient trophoblastic invasion, especially in the second trimester. The second trimester wave of invasion is deficient and the vessel remains partially dilated. It doesn't dilate enough. There is a lot of resistance to blood flow. Not enough blood enters the placenta, and that leads to uteroplacental insufficiency. It also triggers a lot of inflammatory mediators, and that causes preeclampsia. So this is what is happening. Deficient trophoblastic invasion of cells in the spiral arteriole, especially in the second trimester. Okay. Now, because we know why it happens, we can also predict preeclampsia. How can we predict preeclampsia? Number one, based on the history. And this is most important. Okay. In fact, the Indian scoring system for prediction is called the Gestosis score, is primarily based on the history of the patient. There's something called Gestosis score. Just remember the name. It is for prediction of preeclampsia. A woman with a Gestosis score of more than 3 is high risk of developing preeclampsia. What are the high risk factors? Otherwise, you should know. Number one, if she just remember A, B, C, D are the high risk factors. A stands for a history of APLA or SLE. B is a bad history. That means a previous history of preeclampsia. C is chronic hypertension. If she has chronic hypertension, she's anyway at risk of preeclampsia or chronic kidney disease. And D is diabetes mellitus. So if she has any of these 5 high risk factors, she is at risk of preeclampsia. And if you go by the Gestosis score, where there are multiple risk factors, if you add up them and if you find the risk is more than 3, she's at high risk of developing preeclampsia. The second thing we see the uterine artery Doppler. We do a biophysical testing called a uterine artery Doppler. When do we do this? 11 to 14 weeks. What do we look at this? We look at the flow in the uterine artery, and we specifically look for the pulsatility index. A PI is reflective of resistance to flow. तो जितना higher होगा उतना ज़्यादा resistance. PI more than 1, a mean PI. So we take right uterine artery, left uterine artery, calculate the average. If it is more than 1, she is at risk of developing preeclampsia. And the third thing we look at something called as biochemical risk factors. Biochemical risk factors means again at 11 to 14 weeks, we see certain biochemical blood markers which are whether increased or decreased tells us there is a risk. So there are certain markers which, if found in lower levels, placental growth factor, the one starting with P, PAP-A, and also vascular endothelial growth factor. So the growth factors and those starting with P, if they are reduced, it is a sign that this woman is at risk of preeclampsia. And there are certain markers which, if increased, the one starting with S, SFLT1, SENG, if they are increased, just remember the one starting with S. Full forms are not important at this stage. SFLT1, SENG, soluble endoglin, if these are increased, there is increased risk of preeclampsia. So practically, these are very expensive tests. That's why in India, we rely mainly just on the history. But if you go to other countries, you will have a complete preeclampsia profile being done. And this preeclampsia screening is done between 11 to 14 weeks. And if the woman is found to be at risk of developing preeclampsia, what is done? What is the preventive measure? So prevention of preeclampsia, to be more specific, early onset preeclampsia. What is early onset preeclampsia? Preeclampsia happening before 34 weeks is called as early onset preeclampsia, can be prevented by one simple step, is by starting aspirin. This is low dose aspirin, 75 to 150 milligram from 12 weeks. You can actually remember this is before 16 weeks. It needs to be started. So it is to be started before 16 weeks. It is given till 36 weeks. And by doing this simple step, you are preventing the woman from developing early onset preeclampsia. So how do you prevent preeclampsia? Aspirin from 16 till 36 weeks by giving 75 to 150 milligram of aspirin daily to women at risk. Women at risk are those who have a significant history or a Gestosis score more than 3. At least one of these risk factors makes the score more than 3. Uterine artery Doppler, PI more than 1, decreased placental growth factor, PAP-A, VEGF, or raised FSLT1 and SENG. Now, when we have a patient with preeclampsia in the question, the first thing we have to see is this early onset or is this, is this, of course, two things we have to see this. So you can classify preeclampsia two ways. One is early onset, that is before 34 weeks, and one is late onset, that is after 34 weeks. But for managing the patient, for management purposes, we have to classify as non-severe or as severe. Because non-severe, also called as mild preeclampsia, the delivery is different. Mild preeclampsia, you can deliver at 37 weeks. The main thing we have to determine is when to deliver this patient. So mild preeclampsia, we're delivering at 37 weeks. Severe preeclampsia, we're delivering at 34 weeks. Now, severe preeclampsia is when the diastolic BP is more than 110, systolic BP more than 160. This is one of the criteria. Proteinuria is no longer a criteria. It used to be a criteria, so you might find earlier questions asking this, but proteinuria is only for defining preeclampsia, not for categorizing or classifying preeclampsia. If she has any of these three symptoms, it becomes a sign of severe preeclampsia. These are called as imminent signs. So if a patient has headache, blurring of vision, epigastric pain, they are like aura just before a seizure. So this is called as imminent signs of eclampsia. She can have a seizure. You have to give her what can prevent eclampsia. So preventing preeclampsia is aspirin. How do you prevent eclampsia? Eclampsia can be prevented by giving magnesium sulfate. Preventing preeclampsia, aspirin. Preventing eclampsia, magnesium sulfate. So patient has imminent signs of eclampsia, give magnesium sulfate. If there is any deterioration in kidney function test, oliguria, raised serum creatinine, again a sign of severe preeclampsia. Thrombocytopenia, low platelet count, less than 1.5 lakhs, again a sign of severe preeclampsia. Raised AST, ALT more than 40, again a sign, some guidelines say more than 72, again a sign of severe preeclampsia. Evidence of fetal growth restriction, sign of severe preeclampsia. Evidence of pulmonary edema, sign of severe preeclampsia. So if your question gives any of these signs, that means you're dealing with severe preeclampsia. That means you deliver this patient at 34 weeks or earlier. Sometimes you can't even wait till 34 weeks. You might have to deliver earlier also. And non-severe, you will deliver at 37 weeks. Okay, so definitive management of preeclampsia is, if the question comes, what is the definitive management of preeclampsia? Answer is delivery, nothing else. Everything else is temporary. Medicines and drugs are just temporary. Final treatment is deliver the patient, but you can't randomly deliver. You have to decide a safe period for the baby and the mother. So if it is mild or non-severe, you will deliver at 37 weeks. If it is severe, you will deliver at 34 weeks or earlier if the situation arises. For example, if the patient has, this is showing the same thing. If the patient develops, I'll come to that. Let me just take you through this. So diagnosis of, no, if you want to diagnose preeclampsia, if it is mild preeclampsia, you can manage in the OPD also. But if it is severe preeclampsia, you have to admit, start antihypertensives if the diastolic blood pressure is more than 100. If she's less than 34 weeks, consider giving steroids, consider giving magnesium sulfate, and deliver at 34 weeks or earlier. Now, what is this or earlier? Sometimes you can't wait. You have to deliver her ASAP. So, deliver ASAP means deliver ASAP. D is if there is fetal distress. You can't wait. You have to deliver even at 28 weeks, 29 weeks, 30 weeks. You're not going to wait. If there is eclampsia, if she has a seizure, again, no waiting. If there is HELP syndrome, L is the L for HELP syndrome. HELP is hemolysis, elevated liver enzymes, and low platelet count. If there is I is the D in DIC. If there is coagulopathy, if it is a pre-viable fetus, that means very early on, 22 weeks, 23 weeks, she's developed preeclampsia, severe preeclampsia so early that there's no point taking the pregnancy further. You're just risking both the mother and the fetus's life. E is edema, pulmonary edema. You will not wait. R is worsening renal impairment. Say she has come at 32 weeks, creatinine was 1.2, it was raised. Again, after 1 week, you repeat, it is now 1.8. So, worsening, you can't wait till then 34. You have to deliver her earlier. So, worsening renal impairment, and A stands for abruption. So, deliver ASAP. If any of these are there, you are not waiting till 34 weeks. You are delivering even earlier in severe preeclampsia. Fetal distress, eclampsia, HELP syndrome, DIC, pre-viable fetus, pulmonary edema, worsening renal impairment, or abruption, you will deliver earlier. Okay. Now, which antihypertensive drugs can be given pregnancy? Remember, the drug of choice is labetalol. When do we start antihypertensive drugs? If the diastolic BP is more than 100. Diastolic BP more than 100 is an indication to start these drugs. Drug of choice is labetalol. You can give it as oral or IV. IV we usually give in eclampsia. What are the other drugs? What should you remember about labetalol? It is contraindicated in asthma. It is contraindicated in cardiac arrhythmias. What is labetalol? It's an alpha and beta blocker. What are the other drugs we can give? We can give nifedipine, calcium channel blockers. We can give alpha methyl dopa. The doses are not important. Okay. Dose is only important for magnesium sulfate. We will come to that. Okay. What are the drugs? What are the drugs? Hydralazine. Hydralazine, again, usually we prefer to give in eclampsia, in very high blood pressure, which is not getting controlled by labetalol. Then we add on hydralazine. But these are the drugs that are safe in pregnancy: labetalol, nifedipine, alpha-methyl-dopa, hydralazine. Which drug don't we give? We don't give AC inhibitors, ARBs, because they cause fetal renal hypoperfusion, early onset oligohydramnios, and Potter's sequence. Now, Potter's sequence, features of Potter's sequence: facial anomalies, facial flattening. The face gets flattened, facial flattening, limb anomalies or limb defects. What else? You find that there is pulmonary hypoplasia because the lungs don't get space to expand. And then you have amniotic bands or fibrous bands which develop, called amniotic bands, and they can cause limb amputations. These are the features of Potter's sequence. Potter's sequence can be seen in any cause of early onset oligohydramnios, not necessarily AC inhibitors, ARBs. This is just one example which can cause Potter's. Whenever there is mid trimester, second trimester oligohydramnios, the baby can develop Potter's sequence. Now, what should you remember in preeclampsia in management? Delivery is at 37 weeks in mild preeclampsia. In severe preeclampsia, 34 weeks or earlier. That does not mean you'll do a cesarean. In fact, the route of delivery that is preferred is a vaginal delivery. Vaginal delivery is preferred in hypertensive women, right? But a few important points. First is cut short the second stage. That means don't let her bear down too long, because that can lead to higher, the blood pressure can shoot up. So use a forceps or a vacuum, whichever is applicable, but cut short the second stage of labor. Second is, commonly we give a drug called methergin, methyl ergometrin, in the third stage of labor to prevent PPH. ये drug नहीं देना. It's contraindicated in a few conditions. It's contraindicated in hypertensive disorders of pregnancy. It is contraindicated in heart disease in pregnancy. It is contraindicated in Rh negative pregnancies. Remember, these three are the contraindications of methyl ergometrin. And third is restrict IV fluids. Encourage oral intake, but IV fluids nahi dena, because she can go into pulmonary edema and cardiac failure. These are the important points in intrapartum management in a hypertensive woman. Cut short second stage, don't give methergin, and restrict IV fluids. Now, eclampsia is a complication or a type of severe preeclampsia. It is preeclampsia plus seizures. If you have a question on eclampsia, remember the three goals are: number one, control her seizures. How will you control her seizures? By giving magnesium sulfate. Number two, bring down her blood pressure. If you don't bring down her blood pressure, she will have repeated seizures. So what will you give? You will give IV labetalol. If that doesn't control it, you can add on IV hydralazine, but IV labetalol is the drug of choice for eclampsia. And third thing is, what is the definitive management? You have to deliver her. So there's no wasting time. You will have to deliver her. That is obstetric management. Deliver her quickly. Again, vaginal delivery can be attempted. ऐसा नहीं है कि you have to do a cesarean, but every case is different. You want to achieve a quick delivery. Many times you have to resort to cesarean, but you can attempt a vaginal delivery if all the things are favorable. So deliver the patient. That is the third thing. Again, irrespective of period of gestation, even if she's 28 weeks, 29 weeks, 30 weeks, it doesn't matter. There is no time wasting in giving steroids. You can give one dose steroids, but then deliver. You can't wait for 24 hours, 36 hours, ki pura steroid deke, then I'll deliver. No, you have to be quick. All right. What is the drug of choice for seizures? Magnesium sulfate. Magnesium sulfate in obstetrics has four main indications. It is used in prevention of eclampsia. It is used in treatment of eclampsia. It is used in, where else? It is used as a tocolytic, that is a uterine relaxant in preterm labor. It is also used as a neuroprotective agent for the fetus if you give it to the mother. In a woman who is coming in labor and she's less than 32 weeks, and you can't stop the labor pains, give magnesium sulfate. This will be neuroprotective for the baby. It prevents cerebral palsy. Okay, also magnesium sulfate reduces the risk of abruption in hypertensive women, but it's not given specifically for this purpose. Like we give it to prevent eclampsia, we give it to treat eclampsia, we don't give it to prevent abruption. But yes, it has found to reduce the risk of abruption in women who are hypertensive. Now, how do you give magnesium sulfate? Very, very favorably asked question. The most common regime used in India is the Pritchard's regime. Pritchard's regime consists of two things. One loading dose we give, and then we follow it up with a maintenance dose. Loading dose is both IV and intramuscular. So loading dose is given 4 grams IV, but this is 20% magnesium sulfate. Normally, magnesium sulfate is available as a 50% ampule. 50% is too high a concentration to give IV because it's very, very toxic. So you have to dilute the magnesium sulfate, make it 20%, okay? And then you can give 4 grams 20% magnesium sulfate plus 10 grams 50% magnesium sulfate. So a total loading dose is 14 grams. So it is very important. This dosing is one thing which all of you should know. 4 grams IV, 20% plus 10 grams IM, 50%. Total 14 grams is your total loading dose. Once this is the initial, this is going to cause the quiescence. It's going to cause anti-epileptic activity in the brain. It's going to make the brain quiescent. The seizures will stop. But then you have to follow this up with a maintenance dose. Maintenance dose is 5 grams intramuscular of 50% magnesium sulfate every 4 hours. So keep giving 5 grams in alternate buttocks every 4 hours till when? Till 24 hours after the last seizure or the delivery, whichever is later. Okay, so you give it for 24 hours after the till after 20 hours after the last seizure or the delivery, whichever is later. You have to keep giving. So suppose the patient had a seizure at 9 a.m., delivered at 11 a.m., you are going to keep giving magnesium sulfate till 11 a.m. the next day. So 24 hours after the last seizure or the delivery, whichever happens later. That is the maintenance dose. So again, 14 grams is your loading dose. Loading dose is 4 grams IV 20% plus 10 gram IM 50%. 5 grams IM 4th hourly is the maintenance dose for 24 hours after the last seizure or delivery, whichever is later. Now, question on magnesium sulfate which always comes is toxicity. You're always worried about it's a very toxic drug. So we always, before we give any dose of magnesium sulfate, especially the maintenance doses, you're going to check कि कहीं toxicity तो नहीं हो रहा है. So you will do a clinical check of toxicity. Clinical check means we check for 3 things. We check for number 1, deep tendon reflexes. Check the knee jerk, check the ankle jerk. Loss of DTRs. If you can't elicit the knee jerk, loss of DTRs is the first sign of magnesium toxicity. Don't give further mag sulfs if you find loss of DTRs. Second is you find that there is respiratory depression. That is, the respiratory rate is less than 12 per minute. It is again a sign that something is wrong. It's again a sign the patient is going into depression because magnesium sulfate causes respiratory depression followed by cardiac arrest. So, agar respiratory depression hai, it is a sign not to give further magnesium sulfates. You may in fact have to intubate the patient also. And the third sign that don't give further magnesium sulfate is if the urine output is less. How less? Less than 30 ml per hour. So remember, very important, many of you get confused with this. Magnesium sulfate causes loss of DTR. Magnesium toxicity causes loss of DTR. Magnesium toxicity causes respiratory depression. Magnesium sulfate does not cause renal toxicity. It's not a nephrotoxic drug. Then why are we checking the output? Because magnesium is excreted through the kidneys. It doesn't affect renal blood flow. but it's excreted through the kidneys. So if the kidneys are not working, because preeclampsia, eclampsia can affect the kidneys. So if kidneys have shut down, kidneys are not working, magnesium will not get excreted, magnesium will pile up in the body. So magnesium will cause, renal failure is going to cause magnesium toxicity. That's why if you're giving magnesium, make sure the kidneys are working fine. How do we know the kidneys are working fine? If the output is more than 30 ml per hour. All patients who come with eclampsia, we always catheterize them. One of the reasons we catheterize them is, one is because they will be in that confused, drowsy state. They may not be able to pass urine. But a very important reason is because we have to check the urine output. Okay, so output should be more than 30 ml per hour. Then only give the next dose of magnesium. So this is clinical monitoring. We don't routinely send serum levels of magnesium unless there's a problem in the clinical monitoring. Okay, this is very important. HELP syndrome is an acronym. It stands for hemolysis, elevated liver enzymes, and low platelet count. If all three are there, it is called as complete HELP. Okay, but even if one or two are there, so only if there's evidence of, say, only hemolysis, or there's hemolysis plus elevated liver enzymes, or LP plus hemolysis, any combination, one or two, is also HELP syndrome. It is called as partial or incomplete HELP if only one or two are there. If all three are there, complete HELP. How do we know hemolysis is happening? Raised bilirubin levels. LDH, this value you should remember. More than 600 means LDH is high, means hemolysis is happening. Or the peripheral blood smear shows schistocytes. Okay. Then elevated liver enzymes. Elevated liver enzymes, AST, ALT more than 40. Low platelet less than 1.5 lakh. Remember, HELP syndrome is an indication for immediate delivery. Like eclampsia, you're not waiting. Even you will not, should not have time. You will not get time for steroids. Give one dose and deliver. Don't wait for the complete steroid cover to be given. So indication for immediate delivery. It is an acute emergency. You have to deliver HELP syndrome irrespective of the period of gestation. नेक्स्ट इज डायबिटीज एंड प्रेगनेंसी. डायबिटीज से क्या क्वेश्चन आता है? डायबिटीज से आता है स्क्रीनिंग. Now remember, like in hypertension, there are two types of diabetes. We have the pre-gestational diabetes. That is a woman who is already diabetic or over diabetes. She may not know she's diabetic, but she's already diabetic and she conceives. If she tells you, I'm diabetic, I'm pregnant now, that's okay. But many women come to us who don't know, who've never been checked. And when you check, you find they are diabetic. The other is gestational diabetes mellitus. This is diabetes developing for the first time in pregnancy. It usually, like preeclampsia, develops after 20 weeks. So if you find sugars high in a woman less than 20 weeks, it's usually overt or pregestational. After 20 weeks, it's usually gestational diabetes mellitus. Okay, so this is diabetes and pregnancy screening. Now, in this, remember, how do we screen for this? So when a patient comes to us, and say it is her first visit. So what I'm telling you now is the international guidelines, International Association of Pregnancy of Diabetes in Pregnancy Study Group. What the international guidelines says, how do we screen for diabetes in pregnancy? We screen two times. Once in the first trimester, that is in the first visit. What do we do? Here we are checking for over diabetes or pre-gestational. So we can either do an HbA1c. If it's more than 6.5, she's overt diabetic, or we can do a fasting blood sugar. If it is more than 126, or if we do a random blood sugar, if it is more than 200, then we know she is overt diabetic. Right? Now, if these values are normal, then what do? Then we call her between 24 to 28 weeks, and we do what is called a 75-gram OGTT, where as per international guidelines, we do a fasting blood sugar, and then we give the woman 75-gram glucose. Then we repeat a sample at 1 hour and 2 hour. If the fasting is more than 92, or 1 hour is more than 180, or 2 hour is more than 153, any one value abnormal, she is diagnosed to have gestational diabetes mellitus. So the ideal screening is done twice. One in the first trimester once to look for women who may be over diabetic. And if that report is normal, we again screen at 24 to 28 weeks to look for gestational diabetes, where we give 75-gram OGT. We take a fasting sample, give 75-gram glucose, check values at 1 hour and 2 hour, fasting more than 92, or 1 hour more than 180, or 2 hour more than 153. We know she is gestational diabetes mellitus. Right, but in India, we don't, majority of low resource settings in India, if the patient can do this, well and fine, but usually India mein kya hota hai, patients come only once for a checkup or they don't come fasting. So you have to utilize every opportunity to diagnose GDM because it is highly prevalent in our society. So in India, we follow the DIPSI guidelines. DIPSI guidelines say that irrespective of the gestational age, but again the best time they mention is 24 to 28 weeks. Definitely you should do this test, which is the 75-gram OGTT, but this is not a fasting bala. This is irrespective of what the patient has eaten or not eaten. You give her 75-gram glucose, and after 2 hours you check her blood sugars. If it is more than 140, she is diagnosed to be GDM. This is called a one-step test. Okay, so 75-gram OGTT done between 24 to 28 weeks, doesn't require fasting. 2 hour after giving 75-gram glucose, check the sugars more than 140, she is GDM. Whereas in the international guidelines, it is fasting, then glucose, then 1 hour, then 2 hour. Okay, so this is what is the DIPSI guideline, and this is followed in majority of places in the country. Now, just a little bit differentiation between both GDM and pregestational diabetes. GDM is diagnosed during pregnancy, pregestational is present before pregnancy. This requires a OGTT at 24 to 28 weeks. This is diagnosed based on HbA1c or fasting or even a random blood sugar. Now, importantly, pregestational, because the woman is already diabetic and she has conceived, especially if she has high HbA1c levels at conception, there is a higher incidence of anomalies. Remember, I told you we have to give these women folic acid, right? So, anomalies and abortions are common in pregestational diabetes, whereas here they are not common. Here, in fact, complications, if they're happening after 20 weeks because that is when GDM develops. Here you have macrosomia, polyhydramnios, shoulder dystocia. These things are more common. Here you have anomalies in the first trimester, especially the most common anomaly is cardiovascular. In that, VSD is most common. Then neural tube defects are very common. And very specific anomaly is the mermaid baby or mermaid syndrome, caudal regression syndrome. This is when both the lower limbs are fused. That is sacral agenesis. That is the very specific anomaly. It's not common, it's very rare. But if you see mermaid baby, you know that this mother must be diabetic. So GDM is little milder. That's why ketosis is uncommon. Here ketosis is more common. In over diabetes, you commonly find nephropathy, retinopathy, vasculopathies, uteroplacental insufficiency, and hence IUGR, preeclampsia are common. Whereas in GDM, you find macrosomia, big babies, especially with growth on the trunk, the body. That's why shoulder dystocias are common. GDM and pregestational, if the drug of choice is asked, remember drug of choice for both is insulin. Insulin is the drug of choice for diabetes and pregnancy. Okay, but GDM, usually diet and exercise will be enough. If at all, you can add on oral hypoglycemic agents. Metformin and glyburide are both safe in pregnancy. Both are safe. But the drug of choice if asked is insulin. ये है कि insulin rarely require होता है because usually it's mild. Whereas over diabetes, usually the patient is going to require insulin because the sugar levels are on the higher side. Okay. Now coming to labor. So we have labor to finish and then we'll take a break. Then we will start gynae. Maybe by, I don't know, I think we have 1 hour of more of obstetrics and then we'll take a half an hour break and then we start with gynae. In labor, what's important? Types of pelvises are important. So gynecoid pelvis is our normal pelvis, normal female pelvis. यहाँ पे remember the inlet is like a transverse oval. This is the inlet. The transverse diameter is larger, and the outlet is like a vertical oval. That is the shape of the pelvis, and the baby can easily negotiate this pelvis. There is no problem here. Right, so you should be able to identify a gynecoid pelvis. Now, android pelvis is the inlet is heart shaped. This is the typical. The ischial spines are babies get stuck at the level of the. What happened? Lag. Is it better now? Okay, I got the message lag here, but is it better now? Just a second. Just a second. Okay. So um where was I? Yeah. So android pelvis, the baby is going to get stuck because it's a heart-shaped pelvis and the ischial spines are prominent. So you have what happened? फिर से lag है. I'm repeating the android pelvis part. Lag is still there. Should I change my connection? Wait, I'll change my connection. Just a second. No lag. Okay, all fine. Okay, I'll continue then. ठीक है. So this is an android pelvis. Android में the inlet is heart shaped. That's important. Also, what is important is that the ischial spines are prominent. So this plane of least pelvic dimension is very narrow, and very commonly labor gets obstructed. So obstructed labor is associated with android pelvis. Anthropoid pelvis is an ape-like pelvis where you have the inlet itself is vertically oval. You have a very large AP diameter at the inlet. What is anthropoid famous for? Anthropoid pelvis, if you come across the word occipito-posterior positions, anthropoid. If you come across the word face to pubis delivery, because in occipito posterior, the baby can deliver as face to pubis. Or if the baby delivers as, or if, sorry, if you come across the word deflexed head, head is not flexed. Deflection, face to pubis, occipito posterior are all seen with an anthropoid pelvis. Okay. What is this one? This is a platypeloid. Platypeloid is a very transverse oval pelvis like this, grossly transverse shaped. And this is very commonly associated with face presentation and also delayed engagement. The head does not enter the pelvis easily because वो fit ही नहीं हो पाता है. So delayed engagement or high floating head at term, face presentation common with platypeloid. Occipito-posterior face to pubis deflex with anthropoid. Heart shaped, this is a male pelvis, heart shaped inlet, ischial spine prominent, common with obstructed labor, and gynecoid pelvis is normal labor. Now, this is an important picture for the diameters. I won't take you through the entire pelvis and skull, but what you should remember, they are different attitudes. All of these are showing commonly cephalic presentation. All these four pictures are showing the baby in cephalic presentation. What is changing then is the attitude. What is the attitude? Flexion, deflection, partial extension, full extension. So this is an attitude. The attitude is complete flexion. Here it is deflection, also called a military attitude. Here it is partial extension, and here it is full extension. This is the attitude of the baby. The next thing we see is the presenting part. The presenting part is when I do a PV. What part am I feeling? So if I do a PV here, I'm feeling the vertex. Here also I'm feeling the vertex. Vertex is this pura part of the baby's head. Here, what am I feeling if I do a PV? I'm feeling the brow. So the presenting part in a partially extended head is the brow. Here it is the face. Then we look at something called the denominator. Denominator is one specific point on the presenting part, which will help position. So here the denominator is, this is the most prominent part. This is called the occiput. Let me change my connection. Just give me a second. Now it's okay. Is it okay now? Okay. So flexion, the presenting part is vertex. We have the denominator as occiput. Then deflection, the presenting part is vertex. The denominator is again occiput. Partial extension, although because there's no other better point to take for sake of convenience, here also we take occiput. Here, bro, the presenting part is bro. The denominator we take is frontum. And here the presenting part is face. The denominator we take is mentum. Okay, so these are the different terminologies that you should remember. Now, the most important thing you should remember from here is the diameters. Remember, there are two diameters we take. In all of these, the common diameter is the transverse diameter or the engaging diameter. This diameter is common. This is called the biparietal diameter, which is 9.5 centimeter, which it doesn't matter the attitude. The engaging diameter or transverse diameter remains the same. This is the BPD, which is 9.5 centimeter. What is changing then? This diameter, the antero-posterior diameter is changing. So in the first one, in a fully flexed head, what is the antero-posterior diameter? It is this diameter. This is the suboccipitobregmatic diameter. This is a baby in fully flexed head is SOB. How do you remember sobbing? Sobbing matlab crying. When you're crying, you look down, so your head is flexed. So suboccipitobregmatic sob is 9.5 centimeter. That means a baby's head which is well flexed is a very nice head because it is very small, because it becomes a sphere. The BPD and the AP diameter are the same, 9.5. So it easily negotiates the pelvis. Flexion is very important to achieve a normal labor. Okay. Then we have deflection. Deflection here is, this is the antero-posterior diameter now. This is the occipitofrontal diameter. How do you remember office? You're sitting in the office, you're looking at the computer, you're working. Your head is deflexed. So office, deflexed head. This is a larger diameter. Depending on the book you're reading, it is anywhere between 11 to 11.5 centimeter. So that means when you are flexing your head, the baby's head, the diameter reduces by 2 centimeter. That's why flexion is so important. Bro is a very large diameter. Bro is this diameter. It's a very, very big diameter. It's the mentovertical or verticomental diameter from the mentum to the vertex. It is a diameter which is 14 centimeter. It's such a huge diameter that it can't enter the pelvis. And that's why bro is a direct indication for doing a cesarean section. Normal delivery not possible in bro presentation. The last is face. Face, this is the diameter from the mentum to the bregma. This is called as submentobregmatic diameter. This is also a small diameter. It is 9.5 centimeter, but it's not a very good position. Why? Because if so in mentum, when the mentum is the presenting part in face presentation, you can have mento anterior or mento posterior. Like we have occipito anterior, occipito posterior. Mento-posterior cannot deliver vaginally. It can again is a direct indication for doing a cesarean. So cesarean कब करोगे? Bro में करोगे, mento-posterior में करोगे. Men anterior can deliver vaginally, but it is difficult. Why? Because there is no molding. The facial bones can't overlap, whereas the skull bones can overlap. Molding to some extent is good, but there is no molding in face. Also, you can't apply a vacuum. If you want to apply a vacuum, it is an irregular surface. So it's not a very good diameter to have. But remember, mento anterior can deliver vaginally, mento posterior LSCS, bro presentation LSCS. Right, so this is what you should remember. The diameters are important in this slide. Position. Identifying the position is important. If you are given a picture, what is the position? How will you look at it? How will you identify? So remember, there are 8 possible positions because there are 8 quadrants of the pelvis, right? You have anterior. So the first position could be, so first you look at the baby. Look at the baby, like for example, this, suppose you get this picture and they ask you what is the position. You can see the head is down, to cephalic presentation. Head is flexed, matlab the denominator is the occiput. So ये occipito वाला position है ना? So now next thing you have to see is the occiput facing anterior, posterior, transverse. Is it facing left or right? That's the next thing you have to see. So you can see here this occiput is facing anterior. Anterior, how do we know it's anterior? Because it's towards the pubic symphysis. So this is an occipito anterior position. The next thing you have to see if it's right or left. Now it might be labeled in the exam कि कौन सा right है कौन सा left है. अगर नहीं पता है, you see this is a pelvis, this is of a person standing in front of you. तो ये right side होगा, ये left side होगा. So this is right occipito anterior. Then you may also have direct occipito anterior. अगर occiput इस तरफ directly anterior है, it's called as direct occipito anterior. Then you can have left occipito anterior. LOA is the most common position at the beginning of labor. So LOA is here. You can see the occiput is anterior again, but to the left side. Then look at this picture. This is left occipito transverse. Look at this picture. It's now gone posterior. This is left occipito posterior. Then you can even have direct occipito posterior. Then you can have right. This is right side. Occiput is posterior. So right occipito posterior. Then right occipito transverse. So there are total 8 possible positions depending on the quadrant of the pelvis. How does the question? Yes, direct occipito posterior will present as face to pubis. And this is how the position, the question will come, an image will come, and this is how they may ask you, what is the position? That's the commonest question that comes. Next is steps in the mechanism of labor. Just learn whatever mnemonic you know. First step is engagement when the biparietal diameter crosses the pelvic brim. Descent is a continuous process, but we put it as step number 2. Flexion, I told you, is important because it reduces the diameter. It's very, very important. Internal rotation is important because remember I told you the inlet is a transverse oval, the outlet is a vertical oval. So bacha also has to घूमोफाई in such a way कि it's occupying the maximum diameters. So if the baby entered as LOA, it has to become occipito anterior direct. So it's going to move by 45 degree or 1/8 of a circle. If it was LOT in the beginning, it's going to become occipito anterior. It's going to move by 90 degree or 2/8 of a circle. Okay, so this is how the baby is going to move. This is called as internal rotation. When the baby comes out, it is born. If the question comes, baby is born by which movement? The baby is born by the movement of extension. This is just when you see, you find when you don't, when the baby mother is in second stage of labor, she's pushing, bearing down, you see the head. That is called as crowning. And when the head comes out, it comes out by extension. And then what happens? It untwists. This untwisting of the twisted head. Why twisted head? Because internal rotation में क्या हो रहा है? The head is twisting. The whole body is not moving. Only the head twists. So जैसे it comes outside, it's going to untwist. So what is restitution? It is untwisting of the twisted head. So if it twisted by 45 degree, it's going to untwist by 45 degree. If it twisted by 90 degree, it's going to untwist. The same amount of untwisting will happen. Then you have external rotation. This is nothing but internal rotation of shoulders because the head is now out, the shoulders are undergoing internal rotation. This is manifested by external rotation of the head. हमें क्या दिख रहा है? We are seeing external rotation of the head. What is happening is internal rotation of the shoulders. And finally, expulsion of the body. I know now is not the time to understand this. If you've not understood this till now, we just remember the steps in the mechanism of labor. The order, questions come on the order. They'll give you 4 or 5 steps and they'll ask you to put them in order. So, engagement, descent, flexion, internal rotation, extension, restitution, external rotation, expulsion. Every darn fool in Egypt royally eats raw eggs, or whatever mnemonic you know for this, please remember. Okay, now induction of labor. Bishop score is important here. Induction of labor means you are inducing labor in a patient who is not in labor, right? So when we are inducing a patient, we need to determine how favorable is the cervix. What method of induction will we use? Does the cervix require ripening? All this is determined. Remember, induction of labor is with the aim of achieving a vaginal delivery. If you can't achieve a vaginal delivery, then don't induce the patient. If it's placenta previa, you will not induce. This came as a question. Right, only if your aim is yes, I can deliver her vaginally, she has no contraindications to vaginal delivery, will I induce? Favorability of induction. How favorable? What methods will I use? How long will it take is determined by the modified Bishop score. Remember, Bishop itself is a mnemonic. Bishop B stands for Bishop. Then you have ISHOP. I is effacement with an I. S is station of the head. H is hard or soft. That is consistency. Okay, then you have O. O is os dilatation and P is position of the cervix. That is whether it's posterior, mid position, anterior. So you have 5 components. Easy to remember because it's a mnemonic itself. These are the components. Dilatation. Effacement also means length. The earlier bishops used to use effacement in terms of percentage. The modified bishops uses effacement in terms of length of the cervix. Then you have consistency, position, and station of presenting part. Now, a favorable bishops is when it is more than 6, we say is a favorable bishop score. Less than 6 is not favorable. That does not mean she can't deliver vaginally. That just means she will require more cervical ripening before she goes into labor. Okay. Now, so the bishop score, which is not easy to remember, I know, but let me just try and see if I can take you through it because it's something which came in the last exam. So we write down the components first. So we have position, we have consistency. Remember, position and consistency are given a score of 0, 1 or 2. Baki sab mein 0, 1, 2, 3 hota hai. Write it down with me, you'll remember better. Okay, third is we have dilatation. Then we have effacement in terms of length of cervix. And then we have the station of the head. Okay. So position, we know the cervix starts from posterior, then becomes mid position, then becomes anterior. Okay. So here we have same thing. Position is posterior, mid position, anterior. And similarly, consistency also only has 3 components. So it's easy to remember. We have firm, medium, and soft. Okay, so these 2 are easy to remember. Then we have dilatation. Cervix, which is closed, os is closed is 0. Then you have 1 to 2 centimeter, 3 to 4 centimeter, and 5 centimeter. Then effacement in terms of length. If it's more than 4 centimeter, it is score of 0. 3 to 4 is score of 1. 1 to 2 is score of 2 and 0. That means the cervix is completely taken up. 0 length reh gaya. It is score of 3. Station is -3, -2, -1, 0 and +1, +2. Just write it down a few times if you have the time. इतना important question नहीं है. It's like once been asked in so many years, so it's not that important also. But if you write it down with me a few times or yourself a few times, you will remember this. Okay. So this is छोड़ रहे हो तो छोड़ दो, कोई बात नहीं. ठीक है. This is Bishop's score. Now coming to important active management of, इसको मत छोड़ना, this is very very important. AMTSL, active management of third stage of labor. AMTSL, what is AMTSL? AM, AMTSL is, I think I'll switch off the chat box, it's making me distracted. Okay, so active management of third stage of labor is prevention of PPH. The main objective of this is prevention of postpartum hemorrhage. That is why the WHO developed this, and the government of India also uses this. And the government of India has still says that these are the three main components. What are the main components? Administration of a uterotonic, second is controlled contraction, and third is massaging the uterus. In fact, government of India says one more steps, rule out the presence of a second twin or another baby. So first step is rule out presence of a second baby. Second is administer uterotonic. The drug of choice we know is oxytocin. How much? 10 international units IM or IV. Controlled contraction and uterine massage. These are the original steps of AMTSL. Now, over the years, changes have come about. One change came about in 2012, where few steps remained the same, few things were changed. First is uteronic remained the same. The first step is give 10 international units of oxytocin, IM or IV. This remained the same. Second step, which is not to prevent PPH, but it is to prevent neonatal anemia, is because it was doing so well, everybody was following it. So they utilized the opportunity to add another step as part of AMTSL, not to prevent PPH, but to prevent neonatal anemia. They said, let us do delayed cord clamping. So delay the cord clamping by 1 to 3 minutes, and the only contraindication, please remember this, please everybody be very sure of this. The only contraindication the WHO mentions for delayed cord clamping, matlab cord clamping jaldi kab karoge? When will you not waste time? When will you quickly clamp the cord is when there is a non vigorous baby, matlab a baby that's not crying, a baby that's limp. You're not going to waste time, you're going to quickly clamp the cord. Okay, that's the only contraindication. Nothing else matters. HIV and RH negative, no. Only contraindication is a non-vigorous baby. This question has come twice now, once in FMG, once in INI. Please remember this. Third is perform CCT if required. So they said, and only by a skilled birth attendant. So they said, don't do CCT. What is CCT? Controlled contraction. It was found that because everybody was doing it without really knowing how to do it, a lot of uterine inversions were happening. So they said, do it only if it is required. Don't do it for everybody. Only if the placenta is not coming out, then you do it. Okay. Then they replaced the word uterine massage by postpartum vigilance. They said, check if the uterus is contracted. If it's contracted, if it's not contracted, then massage the uterus. And also check the vital signs of the woman. So this whole thing comes under now postpartum vigilance. And they added one more step called oxytocin quality and supply. Remember, oxytocin is stored in a cold chain. You will find oxytocin ampule in the fridge in the labor room. It has to be maintained at 2 to 8 degrees Celsius. If the lights go out or the electricity goes off, the cold chain gets disrupted. So don't make sure that the oxytocin's quality and supply is maintained by maintenance of the cold chain. That's a very, very important step, because if you feel the cold chain has not been maintained, you can switch to other uterotonics. Which other uterotonics can be used? In 2018, the WHO gave a list of uteronics. It said oxytocin is, of course, the drug of choice, but suppose you don't have it, or the cold chain is doubtful, or the drug is expired, you can use carbetocin. Carbetocin is a synthetic analog of oxytocin. It is stable at room temperature. That's the most important thing. You don't have to keep it in the refrigerator. That's the biggest advantage. The dose is 100 microgram IM or IV. And if you doubt the efficacy of oxytocin, you should give carbetocin. It also said in places where there is no one who knows how to give an injection, because you have a lot of rural areas, maybe someone is there who doesn't know how to give an injection, then don't bother about oxytocin or carbetocin, give misoprostol. This is available as a tablet, 400 or 600 microgram oral misoprostol. Just ask her to swallow the tablet of misoprostol, 400 or 600 microgram. Methyl ergometrin is methergin, is also at a dose of zero point 0.2 milligram IM or IV, was another drug which was said can be given. And you also get drugs which have two, both of them, oxytocin and methyl ergometrin. So these were the list of drugs which they said instead of only oxytocin, you can use the other drugs also. But very importantly, this is the newest guideline. Now, I don't know how important or relevant it is for you, because this came out in October 2025, and this is the newest consolidated guidelines of PPH, both prevention and treatment. कुछ important changes हुए हैं. What are the important changes that have happened is that these two drugs are no longer recommended for AMTSL. Methyl ergometrin has been removed from prevention. Treatment में है, prevention के लिए it's not been found to be useful. So for prevention, we are left with only three drugs. That is oxytocin, carbetocin, and misoprostol. That is prostaglandin E1. It has found that methyl ergometrin is not beneficial. This is the first important change that this document says. The second important change which the WHO says is the definition of PPH has changed. It says, earlier we used to say more than 500 ml blood loss following vaginal delivery, right? Now it says that PPH is defined as objectively measured blood loss of more than 300 ml with any abnormal hemodynamic signs, that is tachycardia, shock index more than 1, hypotension, or that is systolic less than 100 or diastolic less than 60. That means they have lowered the cutoff. They have said the cutoff is 300 ml with signs of shock, or if there is 500 ml with or without signs of shock, doesn't matter. या तो 300 ml है with shock, or more than 500 ml which occurs within the first 24 hours of birth with particular vigilance in the first 2 hours. This is the newest definition of postpartum hemorrhage. Why they've changed it? Because a patient might be entering labor with a hemoglobin of 8 grams versus 14 grams. The blood loss mean both may just be 300 ml, but a patient with 8 grams hemoglobin will have signs of shock earlier, है ना, compared to a woman who entered labor with 14 grams. So you don't know what is the starting value of hemoglobin for all. So you can't have a common definition of all. So even if the blood loss is 300 ml with any abnormal hemodynamic signs, that is the newest definition of PPH, or a blood loss as before of more than 500 ml. ठीक है. One more important thing, which this is not only in this document, this has been going on for some time. You should know, in management of PPH, early management of PPH, there is something called the E-motive guideline. What is E-motive? It's an acronym, easy to remember. E stands for early detection and trigger. That is the same thing. 300-500 ml wala same. The definition has changed. That is E. M means massaging the uterus. O means oxytocic drugs. T means tranexamic acid. IV means IV fluids. And E means examination to rule out traumatic PPH. And escalation, that is go quickly to the next steps, Barkley tube and surgical management, other mechanical methods, all that. है ना? So E motive, again, E stands for early detection. That means the definitions have changed. Detect at 300 ml if there is signs of shock. M is massage the uterus. O is oxytocin. T is tranexamic acid. We all know this. They've just put it in an acronym. I is IV fluids. The IV fluid of choice is crystalloid. This has come as a question earlier. IV fluid of choice in PPH is crystalloids because you want volume replacement. And E is examination and start the next steps, escalation. okay, to other management steps. So these are the new things which I just wanted to cover, because although I don't know when your exam paper is prepared, but these were October guidelines, and e-motive has been going on since before that also. So you should know e-motive is for management of early postpartum hemorrhage. Okay. Now coming to this image, what is this image showing? This is showing controlled cord traction. It is called as modified Brandt Andrews technique. You should be able to identify this image. If this is not done, what happens? What complication can happen if it is not done properly? Uterine inversion can happen. Uterine inversion, if it happens, the patient will quickly go into what kind of shock? The patient will go into neurogenic shock. Okay. And what is the treatment of uterine inversion? First treatment is immediate replacement of the uterus without removing the placenta. With the placenta in situ, replace the uterus. Okay. Now, these are doubles. So, in 2018, there were a lot of guidelines which came out by the WHO. I'll just take you through this. This is management of labor. In labor, what are the important things we should know? First is there is a word called RMC, respectful maternity care. The name itself tells you what it is, but it's a very important component of labor room guidelines nowadays. Very, very important to remember RMC. Effective communication, companionship is very important. Every patient should be allowed a companion of her choice. 1:1 care is very, very important. This reduces the incidence of prolonged labor. So it makes labor quicker if she has somebody with her. Then continuity of care. That means the patient should not lack because of people changing over duties. There should not be any lack of continuity in care. Now, first stage, very important. The newest definition of first stage of labor is active labor starts at 5 centimeter. It used to be 4 centimeter, before that 3 centimeter. But since 2018, please remember, active labor means 5 centimeter. What else do they say in management of labor? Routine pelvimetry, routine clinical assessment of the pelvis is not recommended. Routine CTG is not recommended. Routine shaving and enema is not recommended. How often should a vaginal examination be done? Every 4 hours. Remember what is recommended? Analgesia. Good pain relief should be given to all patients. Whether it's epidural, opioids, relaxation techniques, give good analgesia. Allow her to move around, allow her to take food fluids and food during labor, but don't do unnecessary procedures unless indicated. Don't give IV fluids, don't give oxytocin, don't do ARM unless there is a problem in labor. Then only do. So this is important. Okay. Second stage of labor, remember this, very important. Woman's choice for birth position. You cannot tell her ki which position. She will tell you, I want to birth in this position. She should follow the urge to push. This is important. This has come as a question several times now. Which 3 techniques prevent perineal trauma? The 3 techniques that prevent perineal trauma are: number 1, perineal massage. Number 2, a warm towel on the perineum. And number 3, perineal support. So when the baby's head is coming out, someone has to support the perineum. So massage, support, and warm towel to the perineum is going to prevent perineal trauma. Which does not prevent perineal trauma? Episiotomy is not recommended. Remember, episiotomy is given only if you're expecting a difficult birth. Otherwise, not given. Fundal pressure is not recommended. Okay. Third stage of labor is the same as active management of third stage of labor. This we have discussed. Okay, now fourth stage of labor is the 1 hour of observation that we keep the patient in the labor room for, because this is the time you can expect complications like PPH. Now, before we move to abnormal labor, I just wanted to tell you the degrees of perineal tear. Remember, there are 4 degrees of perineal tear at delivery. The first degree tear is when there is a mucosal, only a mucosal tear, the vaginal mucosa is torn, or only the skin perineal skin is torn. Second degree tear is like an episiotomy. An episiotomy is a good example of a second degree tear where three layers are torn: the vaginal mucosa, the muscle, and the skin. So, when you repair an episiotomy, you repair in the same order: the mucosa, the muscle, then the skin. Third degree perineal tear and fourth degree perineal tear is when the anal sphincters are involved. Third degree is divided as 3A, 3B, 3C. 3A is when less than 50% of the external anal sphincter is involved. 3B is when more than 50% of the external anal sphincter is involved. And 3C is when the external anal sphincter plus the internal anal sphincter both are involved. This is a 3C tear. So these are the degrees of perineal tear. Now, this is also important because this has come repeatedly as a question. And what is fourth degree perineal tear? When along with the anal sphincters, the anal mucosa has also torn. That is, there's a complete tear from the vaginal mucosa right into the rectal mucosa. पूरा tear हो गया है. That is called a fourth degree perineal tear. ठीक है, so these are the degrees of perineal tear. Very, very important again to remember. Now coming to breech presentation. Breech presentation is one of the most important malpresentations that you should know. Diagnosed by Leopold maneuvers, you will find the head is in the fundus and the breech is in the pelvic and in the lower pole of the uterus. You will confirm the diagnosis by doing an ultrasound. Ultrasound will also tell you a possible cause. Possible causes could be placenta previa. Possible causes could be multiple or twin pregnancy. Possible causes could be oligohydramnios or polyhydramnios. Possible causes could be an anomaly either in the fetus or maybe there's a Mullerian anomaly. So, along with the confirmation of the diagnosis that it is breech, you also can look for a possible cause on the ultrasound. What is the main treatment of breech? So whenever you have a patient with breech, why are we worried? Because if the baby is in breech, the body will deliver, but the head gets stuck because the head of a baby is bigger than the body. So this breech will slip out easily, the body will slip out, but the head gets stuck. So you end up with a lot of problems. Hence, the first best option is, can you turn this baby? That's the first thing that both the patient will ask you and you will also think, ki, can I turn this? So this is called as external cephalic version. Best time to do this is between 36 to 37 weeks. It has a 60% success rate. It is not done early because it can change back. If you do it at 32 weeks, it will come back. It might revert. Or if you do it early and the patient has an emergency, she develops fetal distress while doing the procedure, you'll end up with a preterm cesarean and a baby will be preterm. And why not later on? Because after 37 weeks, the liquor goes down, amniotic fluid kam hoga, mushkil hoga karna. Baby weight increases, again, difficult to do it. So you best time to do this is between 36 to 37 weeks of pregnancy. It has a success rate of about 60%. This is the first thing you will try to do. Now, what are the absolute contraindications to ECV? Where will you not try this at all? So, any contraindication to a vaginal delivery, because when you're doing an ECV, in mind, you are wanting to turn it. Why? So that the baby mother can have a vaginal delivery. If you can't achieve a vaginal delivery, there is no point doing it. Like in a placenta previa, there's no point doing it and then doing a cesarean section. If the pelvis is chota, contracted pelvis, android pelvis, you don't want to do it. If they're twin pregnancies, in both the twins, there's no space, you can't move the babies. If the head is like this, called a star gazing fetus, you need a good flexed head for a vaginal delivery. If there is a uterine anomaly like a septate uterus, didelphys, unicornuate, it's going to not turn because the space as such is less. The baby is dead. There's no point doing it. You can deliver as breech also. Baby is distressed or the patient denies consent, you will not do a external cephalic version. Remember here, previous LSCS, you can do an ECV. ECV can be done. It's not a contraindication. As per the recent most Williams edition, it is not a contraindication. There were earlier reports of increased scar rupture, but अब वो सब नहीं होता है. You can, more evidence says you can do a external cephalic version in a patient with a previous lower segment cesarean section. Okay. Now, if the patient is multiparous, if the breech hasn't entered the pelvis, if the liquor is good, and if the placenta is posterior, these are favorable factors. ECV इसमें successful होने का chance is very, very good. Okay, multiparous, good liquor, average size baby, posterior placenta, and the breech hasn't entered the pelvis, you can easily turn it. Now, suppose you're able to turn it. So ECV you have done. So patient has come with breech. You have two options, है ना? Either you can do an ECV. If you've done an ECV, it becomes cephalic. Then you are trying. Your patient has a vaginal delivery. Now, suppose ECV failed. 40% it can fail, or patient denied or was not fulfilling the criteria for ECV. For some reason, ECV could not be done. So now it remains as breach. Now what do? Now you have two options. You can again either do you can either attempt a vaginal breech delivery, knowing that the head can get stuck, okay, or you directly do a cesarean section. Okay, so these are the two options. With when if it remains breech, you can still attempt a vaginal delivery, but you have to choose your patient very, very carefully because the head can get stuck. So in which patients will you not do a vaginal delivery? Will you directly take her up for cesarean section? Remember, primary breech. If your question says primary breech, primary में क्यों? We don't know how the pelvis is. The pelvis may not be adequate. A woman who has delivered earlier, we know कि pelvis उसका ठीक है. So primary breech, preterm breech. Remember, preterm breech में the head tends to be bigger. You don't want to. The head can get stuck more easily in a preterm breech. Baby might be smaller, but the ratio of head to body is different. The head is bigger. Huge babies, 3.5 kg and beyond, star-gazing head like this. Complicated breech means breech plus any complication. Any complication means breech plus preeclampsia, breech plus GDM, breech plus IUGR, breech plus RH isoimmunization, breech plus anemia. So breech to hai plus some complication. Do not attempt a vaginal breech. You don't want to put two complications together. Patient has previous cesarean, you can attempt ECV, but don't give an assisted breech delivery. The scar can rupture when you're trying to take that head out. The scar can rupture. Patient, you don't know how to do a breech delivery, do not attempt. And this has come as a question, so it's important. You don't know, don't attempt. Footling or kneeling. So you can only attempt a breech delivery if it's a flexed breech or an extended breech. What is flexed breech? Flexed breech means flexion at the hips and flexion at the knees. Extended breech means flexion at the hips and extension at the knees. Both of these will form a nice covering of the cervix. Okay. But in footling or kneeling, if the foot or the knee is the presenting part, what can happen here? You are worried about a complication called cord prolapse. So you will not allow a vaginal delivery in these patients. Okay. Now, in those patients for whom you're allowing an assisted breech delivery or a vaginal breech delivery, these images are important because where can you get stuck? You can get stuck at the level of the shoulders. This is a very frequently asked image based question. I think it came in the last FMG. How will you deliver the shoulders, especially if the shoulders are like this? The arms are called as nuchal arms, overhead arms, above the neck. You will do offset maneuver where you rotate the baby by 90 degree, then 180-degree. This helps the arms come out. Offset maneuver. The next place you can get stuck is in the head. It's called the after coming head can get stuck. So what can you do to prevent the head from getting stuck? These maneuvers. The one shown here is called the Burn Marshall maneuver. Very, very important image based questions. Expect one image from here. Offset, you should know, Burn Marshall is just holding the baby's legs, sweeping the baby over the maternal abdomen. This hand is going, your assistant is going to constantly give suprapubic pressure that causes the head to remain flexed. Remember, flexion is very, very important. This maneuver is preferred. This maneuver is not preferred because it can cause injuries at the atlanto-occipital joint. The preferred maneuver is this one, Morisot-Smellie-Viet maneuver. The MSV maneuver is where you have two hands. Using both the hands, you're trying to cause flexion of the baby, malar traction, occipital flexion. You're pushing the occiput, you're pulling the baby's face. This is called as Morisot-Smellie-Viet maneuver. And then we have the Piper forceps. This is also an image-based question. Piper forceps is also very, very useful in delivering a aftercoming head of breech. So remember Lofset, Burn Marshall, Lofset, Burn Marshall, MSV maneuver, and the Piper forceps. Next important thing is shoulder dystocia. What is shoulder dystocia? When the head comes out, but the shoulders get stuck. Theoretically, we say when more than 1 minute time elapses between head बाहर आ गया but shoulder 1 minute तक बाहर नहीं आया है. This is called as shoulder dystocia. Another more practical definition if any maneuver is required to deliver the baby, it is called as shoulder. To deliver the shoulders, it is called as shoulder dystocia. Usually we don't wait for 1 minute. है ना? Practically we will अगर shoulder बाहर नहीं आ रहा, we will start the maneuvers earlier. Now, the important remember here something called turtle sign. The head comes out and then recedes back in. The shoulders pull it back in. This is called the turtle sign is seen in shoulder dystocia. Now, what should you remember? The shoulder dystocia drill. Very, very important. This is by the helper mnemonic. These are the first line maneuvers. Call for help, give an episiotomy or extend the episiotomy. The most important maneuver, if it is asked, it is the Mac-Roberts maneuver. What is Mac-Roberts maneuver? It is this. You might get an image also. It is this movement. Hyperflexion of the thighs on the maternal abdomen, hyperflexion and abduction. This is going to push the sacrum piche and the pubic symphysis anteriorly, and this is going to dislodge the impacted shoulder. Along with this, we can also give suprapubic pressure. So these four, and in this order, the order is very important. This order: help, episiotomy, most important Mac-Roberts, and suprapubic pressure. If these are your first line maneuvers, if these fail, we go on to the second line maneuvers. The second line maneuvers are enter the rotational maneuvers. Just remember the name Rubin and Wood corkscrew maneuver is the rotational maneuvers. Then if this fails, remove the posterior arm. Reach in for the posterior arm, try to take it out. If this fails, roll the patient on all fours. This is called the Gaskin maneuver. So these are the second line maneuvers. Help, episiotomy, legs, Mac-Roberts, suprapubic pressure is first line. Rotational maneuver, removing the posterior arm, roll the patient on all fours, Gaskin are the second line. And if these fail, then you go to third line maneuvers where you have the Zavanelli, that is pushing the head back inside and doing a cesarean section, or cleidotomy, that is fracturing the baby's clavicle so the shoulders get decompressed, or a symphysiotomy, that is cutting open the pubic symphysis of the mother, and that will release the impacted shoulder. These are last resort techniques. Remember, these are last resort techniques. 60 to 90% of shoulder dystocias will be relieved by the Mac-Roberts maneuver. That's why it's the most important maneuver in shoulder dystocia. Okay, so first line, second line, third line, you should know. The last topic of obstetrics before we take a break is postpartum hemorrhage. Now, postpartum hemorrhage, that is third stage complications. You have primary and secondary definitions I've told you which have changed. Primary is within 24 hours if there's bleeding. Secondary is 24 hours to 6 weeks post delivery is secondary PPH. Now, primary PPH के main reasons are the 4 T's. Remember the 4 T's. First is tone, that is atonic PPH. Second is trauma, that is traumatic PPH. So 80% of all PPH is atonic uterus. 20 or around 19% is traumatic PPH. Less than 1% is because of retained tissue or retained bits of placenta. And also the last T is if there is thrombin. Thrombin basically means a coagulopathy. Like patient has thrombocytopenia, HELLP syndrome, ITP, something like that. will cause a coagulopathy. Now, how do you manage PPH? Remember, in PPH, these are the causes. I'll just come to management here. Medical and mechanical management go hand in hand. So, especially when we're talking about atonic PPH, remember medical management means uterotonic drugs. Which drugs can we give? Again, the drug of choice is oxytocin. We can go up till 40 units as an IV infusion. Then you can give, what else can you give here? You can give again misoprostol. You can give 800 to 1000 micrograms of PGE1. What else can you give here? You can give methergin. You can also give PGF2 alpha, that is carboprost. Two important contraindications of carboprost are again asthma and heart disease. You will not give carboprost to a woman with asthma or heart disease. It causes bronchospasm. It can lead to arrhythmias. So these are the medical drugs. These are the uterotonics, which will contract the uterus. Along with this, we also give tranexamic acid, which is an antifibrinolytic. This also helps in clotting of the blood. So medical management and mechanical. Mechanical, what are the things we do? Mechanical, we can do uterine massage, we can do bimanual uterine compression. We can also very commonly ask in the exam intrauterine balloon tamponade by what is called a Bakri tube, or you can use a condom catheter or a Seng's taken Blackmore. Basically, fill the balloon, the intrauterine balloon, with 300 to 500 ml of saline or any fluid, and this acts like a tamponade pressure. It stops the bleeding by pressure. So this is what can be done. Or there's something called the non-pneumatic anti-shock garment. If you're shifting the patient to a higher center, wrap her in the garment, which is a very tight garment which maintains circulation till the time patient reaches the higher center. These are important. Now remember, Bakri tube and these mechanical measures are basically following a vaginal delivery. If PPH, and this came last time, if PPH happens at the time of a cesarean section, then you've given medical fine, but then you straight off move to surgical management because the uterus is in front of you. You've done a cesarean, patient is bleeding. You're not going to waste time in mechanical. Remember, mechanical methods are to buy time while you're shifting a patient to the OT. है ना? So medical doesn't work. Mechanical is like a standby. Mechanical methods are used in vaginal delivery, following PPH, following vaginal delivery. Not so see how the question is asked. Okay, the same question came in NEET PG. Following a vaginal delivery, you will put a Bakri. But following a cesarean, if PPH has happened, next best step is to move straight to surgical management. In surgical management, the first thing we do is we can apply compression sutures. What you're seeing here is B-Lynch sutures, which are applied at the time of cesarean section. Okay, the other types of sutures are the Heyman sutures and the Cho's square sutures. If this doesn't stop the bleeding, these act by compressing the uterus. If these don't stop the bleeding, then you move on to devascularization. And the three vessels that we ligate are the bilateral uterine arteries, then the bilateral utero-ovarian anastomosis, and then the bilateral anterior division of the internal iliac artery. Remember this, uterine artery here, here, then utero-ovarian anastomosis. Otherwise, you go at the anterior division of the internal iliac artery, from which the uterine artery is a branch. So 1, 2, 3. In this order, usually we ligate when we do devascularization. And last resort is, of course, a hysterectomy. If nothing else is helping and the patient continues to bleed, then a hysterectomy is the last resort in PPH. So let's take a break. We meet at 6:45, I think, half an hour break, and we continue with gynae. Okay, is that all right? Okay, so now we continue with gynae, and in gynae, we start with uh, so you might feel I'm missing a few topics, but what I did was I took the most important high yield topics. Of course, it's impossible to cover everything in 8 hours. Okay, if you feel I've missed out on something important, you can always revise that yourself. And now the aim is to complete as many high yield topics as possible in these 8 hours, especially the ones which are a little unusual or a little difficult. I'm trying to cover those especially. Okay, so coming to gynae. Now in gynae, we start with a normal menstrual cycle. This is new because certain definitions have changed. Remember, so the ones in white are normal, is what is normal. So what is normal frequency? That means a cycle length of 24 to 38 days is called a normal frequency. Anything happening, and this has come as a question, anything less than 24 days is called frequent cycles. It used to be called polymenorrhea, now it's simply called frequent cycle. Anything more than 38 days is an infrequent cycle. It used to be called as oligomenorrhea. Amenorrhea is also part of the definitions of AUB, and it never used to be a part of AUB, but now absent periods also comes under AUB. So that's the first thing, frequency. The next thing we see the duration. How long is the blood flowing for? Normal duration is up to 8 days. Anything which is more than 8 days is called as a prolonged cycle. The next thing we see is regularity. Regularity basically means that if a woman, so we see the last 6 to 12 months how her cycles have been. Suppose she says her cycle length was 20, suppose it says she says her cycle length was 25 days, then 26 days, then 34 days, then 35 days, then 28 days, then 24 days, like this. So this is a frequent, the cycle frequency is normal because it's between 24 to 38 days. But is it a regular cycle? So we see the shortest cycle 24 days, and we see the longest cycle 35 days. The difference is 11 days. So if the difference is more than 10 days, okay, it is an irregular cycle. So this is important to understand. Frequency and regularity are completely different terms. Frequency means that the cycles are coming between 24 to 38 days, but whether it is regular or irregular, it is determined by the difference between the shortest cycle length and the longest cycle length in a period of at least 6 months. And if this duration is more than 10 days, it is an irregular cycle. So even though her cycle is of normal frequency, it is an irregular cycle. Okay, so the regular variation is with the shortest to longest should be less than or equal to 9 days. And then flow volume is patient determined. Patient says heavy hai to heavy hai, patient kahega light hai to light hai. You may think it's normal, it doesn't matter what you think, but normal cycle, patient will tell you how her flow is. So we don't quantify it anymore because it's difficult to quantify in terms of ml of blood loss. We just say whether patient is saying heavy hai to heavy hai, light hai to light hai. She says as in comparison to her earlier cycles, right? So this is what is the new FIGO classification of abnormal uterine bleeding. Now, when a patient has AUP, we think of the palm, Cohen. So, if anything is abnormal, what could be the possible causes? Structural causes are palm, polyp, adenomyosis, leiomyoma means fibroid, and malignancy and endometrial hyperplasia. These are the structural causes of abnormal uterine bleeding. Then you have non-structural causes. This is coin. Coin with a E is coagulopathy, like the patient has thrombocytopenia or she has some von Willebrand disease or some coagulopathy. Then you have ovulatory dysfunction. Ovulatory dysfunction, a good example is PCOS. Endometrial problem like endometritis. Maybe she has genital tuberculosis. She's having scanty periods. That is an endometrial cause. Then iatrogenic, a good example is a patient on a copper containing intrauterine device who's having menorrhagia, heavy menstrual bleeding. And then if you can't find a cause, it comes under not yet classified. So this is the structural and non-structural causes of AUB. It's called the Palm Cohen classification of abnormal uterine bleeding. Now we come to different important benign gynae disorders. In this palm especially, we'll be discussing adenomyosis. What is adenomyosis? It is globular enlargement of the uterus. Okay, what really happens is you have endometrial deposits going inside the myometrium, and these bleed, and they cause the myometrium to grow in size. And the patient is going to present typically with two symptoms. She's going to have menorrhagia, that is heavy periods, and she's going to have dysmenorrhea, that is painful periods. And typically this is a patient who is usually in the 40s. 40 to 50-year age group is when they most commonly present. They can present earlier also, but this is the commonest age group. And they are usually multiparous. Multiparous means they have children. It's not seen in the nulliparous population. So 40 to 50-year-old, para 2 living 2, para 3 living 3, coming with menorrhagia and dysmenorrhea. And when you examine, you find the uterus is regularly enlarged. If this is what your picture is, think of adenomyosis. Okay, and the uterus is not very big in size. It's usually less than 12 to 14 weeks. Matlab, it is just palpable. It is not a very big uterus, but it is regularly enlarged in size. This is about adenomyosis. Acha, one more thing. How do you diagnose adenomyosis? So the initial investigation and also the investigation of choice, although this is a little controversial, is a transvaginal sonography. Although investigation of choice, radiologists say it is an MRI, but we rarely have to do an MRI to diagnose adenomyosis. TVS will diagnose 99% of adenomyosis. So the investigation of choice or the initial investigation is a TVS, although slight controversy here whether it's an MRI or whether it is a TVS. Management of adenomyosis. So you have medical management and then you have surgical. Surgical is the definitive management. That is doing a hysterectomy, removing the uterus is the definitive management. But you can buy time, you can reduce her symptoms by giving her, if she has menorrhagia, you can give her tranexamic acid. If she has pain, dysmenorrhea, you can give her NSAIDs. Then you can give her combined oral contraceptive pills. This will reduce both the pain and the bleeding during her periods. Or you can put in an LNG IUS, that is a Mirena. This will also take care of her heavy menstrual bleeding. Then you can also give her progesterone only pills. Then you can also give her GnRH agonists or antagonists. So there are several medical management options that are possible, but remember, medical options are all temporary. The definitive treatment, if the question comes, what is the definitive treatment of adenomyosis? The answer is hysterectomy. Okay, so this is about, in brief, adenomyosis. Fibroids is very important. Fibroid, also called as leiomyoma, are the most common benign disorder of the uterus. Now, fibroids are basically of three types. Okay, I'm not discussing the detailed classification, but you should know the basic classification. You have submucosal fibroids, which are within the uterine cavity. You have intramural fibroids, which are in the substance of the myometrium. And then you have subserosal fibroids, which are on the outer surface of the uterus. So submucosal, intramural, subserosal fibroids. These are the three main types of fibroids. Now, in fibroids, what is important to understand is the degenerations. Degeneration means the fibroid itself undergoes some sort of softening or change in the substance. And the most common degeneration is a hyaline degeneration, is the most common type of degeneration. A very common degeneration which is seen specific to pregnancy is called as red degeneration. This is seen typically in the second trimester of pregnancy. Patient is going to come with acute abdominal pain. In the second trimester, always think of red degeneration of fibroid. Right. What else should you remember here? You should remember that the treatment of red degeneration is conservative. You're not going to operate or terminate the pregnancy or deliver her or do a myomectomy in pregnancy. She just requires rest, she requires hydration, and she requires pain relief. So analgesics are given, and this is usually enough to treat the red degeneration. It is temporary, it will resolve. So what should you remember here? Any patient with acute abdominal pain in the second trimester, especially if she's a known case of fibroid, always think of red degeneration. Torsion is even rarer. Torsion is not common. So red degeneration above torsion. Okay, torsion of fibroid, I'm saying torsion of fibroid is extremely rare. Rare degeneration is more common. Treatment is rest, hydration, and analgesics. Now, when we have fibroids, how do we treat them? Remember, asymptomatic fibroids need not be treated. If she's asymptomatic, irrespective of the size, treatment is not required. Many women will have incidental fibroids on ultrasound. You don't have to treat them. You just advise them a yearly ultrasound, every year an ultrasound to see the growth of the fibroid and to see if there's any new appearance. Otherwise, you don't need to treat them. So you treat which kind of fibroids? We treat symptomatic fibroids only. What is the most common symptom or what is the presentation fibroids will have? So it's usually common in nulliparous women, those who don't have kids, or those who have low parity. This is in contrast to adenomyosis, which you will find in multiparous women, right? And here you will find this in nulliparous or women with less number of kids. Common symptoms are menorrhagia and dysmenorrhea again. These are common symptoms, but they can also present with infertility, especially those which are submucosal and those which are large intramural fibroids, more than 5 centimeter or distorting the cavity. Intramural can cause infertility, and submucosal fibroids can definitely cause infertility. And then fibroids, which are very large, can form pressure symptoms. If it's an anterior fibroid, it can cause urinary symptoms. If it's a posterior fibroid, it can cause rectal symptoms like constipation. So these are the common symptoms that are there. Treatment of symptomatic fibroid is based on a lot of things. It is based on the age of the patient, whether she wants children, whether the size of the fibroid, the location of the fibroid, the symptom of the fibroid. So a lot of things go into the planning of management. So we have medical management options, we have surgical management options, and we have newer options. These include uterine artery embolization and MR focused ultrasound waves. So these are two newer options which are less invasive and somewhere in between medical and surgical management. So, as I said, management depends on several things: the age, the symptoms, the severity of the symptoms, the size, the location, whether it's a submucosal fibroid, intramural, subserous, where is the fibroid. Now, first of all, discussing fibroids and infertility. Remember, when do you remove a fibroid if the patient is infertile? As I said, two fibroids which can cause infertility are submucosal. So if she has a submucosal fibroid, it needs to be removed if she has infertility. And if she has large intramural fibroids, when I say large intramural, it means more than 5 centimeters, or fibroids that are distorting the cavity. Now remember, how do you remove these fibroids? So when I say removal of fibroid, I mean the name of the surgery is called a myomectomy. You will do a myomectomy. There's several ways you can do a myomectomy. Now, if the fibroid is submucosal, especially a pedunculated submucosal, this is called a type 0 fibroid, or a submucosal fibroid which has more than 50% submucosal component, that is a type 1 fibroid. So a type 0 and a type 1 fibroid can be removed via hysteroscopy. What is hysteroscopy? You're putting a hysteroscope from through the cervix and you are resecting the fibroid. So these two fibroids you can remove via hysteroscopy. All other fibroids which are 2 and beyond, are removed either laparoscopically or via a laparotomy. Okay, so this is important to understand. Hysteroscopy is reserved for type 0 and type 1 fibroids, and laparoscopy or laparotomy is for any fibroid which is more intramural or subserosal. Okay, so this is the first thing. Fibroids and infertility, which ones will you remove? You will remove all submucosal fibroids and large intramural fibroids. Now, when we say myomectomy, this means removing the fibroid or enucleating the fibroid. And there are some instruments which you should remember which are used in a myomectomy. One is a myoma screw, and I think you all know how this looks like. So I don't have the image here, but it looks like this. This is called a myoma screw. This is to give traction on the fibroid. So you put it inside the fibroid and it allows good traction because fibroids are firm in consistency. It's called a Bonney's myoma screw. Another instrument typically used in fibroid surgery is called a Bonney's myomectomy clamp. Okay, and this is typically used to reduce the blood loss during a myomectomy surgery. Remember, myomectomies are associated with a lot of bleeding. So you have, because they're very vascular. So to reduce blood loss, there is a clamp called a Bonney's myomectomy clamp and Bonney's myoma screw. These are two typical instruments used only in myomectomy. Definitive surgery is, of course, hysterectomy. This is a like adenomyosis. Definitive here is also a hysterectomy. Now, coming to endometriosis. Endometriosis is a very important topic again. Endometriosis is ectopic endometrium. What do you mean by ectopic endometrium? This is endometrium which is growing outside the uterus. Now, one of the theories behind ectopic endometrium, how did endometrium reach outside, like to the ovaries or the pouch of Douglas, is the theory of retrograde menstruation. What does that mean? So, you have the uterus here, and you have the fallopian tubes here, the ovaries here. So, one theory says, and the most commonly believed theory is that menstrual blood, which is supposed to go down, also backtracks through the fallopian tube into the peritoneal cavity. And this contains endometrial glands. They get deposited on the ovary or other sites and then they grow. They grow because every time she has her period, those endometrial glands also will bleed. So the most common site is actually the ovary, where it forms a collection of old blood. This is called a chocolate cyst or an ovarian endometrioma. But they can go anywhere in the abdomen, right? Now, this theory of retrograde menstruation is supported by obstruction. What does this mean? Obstructive Mullerian anomalies. You find that endometriosis is very common. So, what are the obstructed Mullerian anomalies that we can think of? So, obstructive Mullerian anomalies. That means there is some blockage to the outflow of menstrual blood. Like in an imperforate hymen, you find endometriosis is common. In when you have transverse vaginal septum, you find endometriosis is common. When you find something called the O Vera syndrome, which is typically seen in uterine didelphys, you find that there is two uteruses and you have ovira means obstructed hemivagina. That means half the vagina is obstructed. And on that side, the kidney is absent. So obstructed hemivagina with ipsilateral renal agenesis. So what you have here is you have blood collecting here, and going and forming endometriosis. So Ovira syndrome. Other anomalies, vaginal agenesis, the vagina is absent. Cervical agenesis, there is no cervix, the blood can't come out. What else? Unicornuate uterus sometimes have what is called a rudimentary horn. And if that rudimentary horn has endometrial glands, it is going to cause endometriosis. So you have a uterus, a normal uterus like this, a chota uterus, unicornuate uterus, and you have a rudimentary horn like this. So this rudimentary horn may end up having endometriosis. So these are the obstructive Mullerian anomalies which can cause endometriosis, and this supports the theory of retrograde menstruation. Now also remember endometriosis, what are the typical symptoms? Remember the 5 Ds of endometriosis. First D is dysmenorrhea, and this is worsening dysmenorrhea. With every period, her pain will worsen. This is called as triple dysmenorrhea. Triple means she has pain premenstrual, menstrual, and postmenstrual. So all the time she is basically in pain. Dyspareunia, painful intercourse. Dyschezia, painful defecation. Dull, aching, abdominal pain. So basically all the time, as I said, this is a very painful condition. Endometriosis has a lot of pain. And the last D is actually dysfertility or infertility. Just to make it a D, I have made it dysfertility. So basically, endometriosis is all about pain and infertility. Why is there infertility in endometriosis? Because the tubes get stuck. There is tubal problem. The cause is tubal, the fallopian tube. So whenever there's old blood collecting inside the pelvic cavity, you have everything getting stuck to it. So you have the pouch of Douglas, which is the area behind the uterus, and the rectum getting stuck. You have the ovaries getting stuck to the uterus. You have the tubes getting stuck to different structures. You have the bowel stuck. You have the bladder adherent. You have the ureter stuck. So you have lot of everything stuck. So adhesions are there and the tubes are stuck. They are unable to function, and that leads to infertility. Now, these are the symptoms, the 5 Ds of endometriosis. What about the signs? The signs of endometriosis, remember, normally, how is the uterus? Normally, the uterus is, so this is the uterus, this is the vagina, these are the fallopian tubes. Okay. In front you have the bladder, behind you have the rectum. So you have the uterus, which is usually anteverted, anti-flexed. It is towards the bladder. In endometriosis, what happens? You have all the blood coming and getting collected in the pouch of Douglas. This is the pouch of Douglas between the rectum and the posterior vagina and the posterior uterus, this empty space. So all this blood comes and gets collected here. It may form a chocolate cyst, and it will cause obliteration of the pouch of Douglas. So the rectum gets stuck to the uterus. And as a result, what happens is you have the uterus now going backwards, a retroverted uterus. Okay, so this is how now the uterus gets pulled back. You have the uterus getting pulled back because adhesions have formed between the rectum and the posterior part of the vagina. This is called a retroverted fixed uterus. This is the very important. If you see this word, you know the question is on endometriosis. Retroverted fixed uterus is typically seen in endometriosis. And the second thing is nodularity in the pouch of Douglas. So when you do a per vaginal examination, you'll find nodules these are endometriotic nodules. So if you do a PV, this is your finger, and you find you're able to palpate in the pouch of Douglas posterior to the uterus nodules. So two important findings on examination in endometriosis: retroverted fixed uterus, nodularity in the pouch of Douglas. Okay, this is important. Now, um, um, yeah, one more finding, and this is not a clinical finding, but on laparoscopy, which is the gold standard, I'll come to that, is something called kissing ovaries, which I will just come to because everything gets stuck. The ovaries get stuck to the back of the uterus. This is the uterus, the back of the uterus, suppose. The ovaries get stuck like this. And this is called the kissing ovary sign, which is seen on laparoscopy in endometriosis. And the kissing fallopian tube sign, which was asked, I think, last to last FMG, kissing fallopian tube sign. There was a picture, I think. This is seen in genital tuberculosis. Okay, so kissing ovarian sign is in endometriosis. Kissing fallopian tube sign is in genital tuberculosis. Just a second, please. Yeah, okay. Now, when we have a patient with endometriosis, remember, if you do an ultrasound or an MRI, you might pick up certain features like this. This is how a chocolate cyst will look like. A chocolate cyst will have the typical ground glass appearance, right? So you have some idea that there may be endometriosis. But if asked, what is the investigation of choice, or what is the gold standard or the best investigation, then the answer is laparoscopy with a biopsy. Actually looking in the abdomen, in the pelvis, and seeing these endometriotic lesions, that is the gold standard for diagnosis. And this has repeatedly come as a question. Okay. So if you see the chocolate cysts, if you see everything being stuck, if you see the kissing ovaries, think of endometriosis. Now, treatment of endometriosis again depends on several things, whether she wants pregnancy, what is the severity of symptoms, where are the lesions, age of the patient, all that. And there are two basic treatment strategies. We can either give medical management or we can do surgery. The aim of medical management is to make the patient have amenorrhea, to stop her periods, because the problem is the periods. If she's bleeding, these lesions are going to grow. Every time she has her periods, the endometriotic lesions are going to also bleed. So they are so she will, so the aim is to make her amenorrheic. How can you make her amenorrheic? How can you stop her periods? You can stop her periods by giving her drugs like long acting progesterone. So progesterones given for a long time cause endometrial atrophy. You can, and the common way to do this is by putting in a Mirena, a levonorgestrel intrauterine system. Or you can give OC pills but without a break. Give it continuously for 3 to 6 months. Don't let her bleed. That will start resolving the endometriosis inside her. Okay. Or you can give GnRH agonists. These are also going to cause suppression of estrogen progesterone and lead to amenorrhea. Or you can give GnRH antagonists. And this is the recent most drug developed oral GnRH antagonists. A drug in this group is called as elagolix, which is now increasingly being used in practice. And this is an oral GnRH antagonist, which is given. Right. So medical treatment involves the drugs. The purpose is to make her have amenorrhea. Surgical treatment is laparoscopy. And what do we do in this? We basically get rid of the lesions. We burn the lesions. Burning the lesion is called as ablation, or we excise the lesions, excision. Or if there's an ovarian cyst, we do a cystectomy, ovarian cystectomy. Okay, basically we get rid of the lesions. So this is what we do. So remember, the rule of the thumb is if the patient's main symptom is pain, we prefer medical management. But if her main symptom is infertility, we want to restore normal anatomy, we want to make the tubes mobile again, then we will prefer surgical management. So pain, prefer medical management. Infertility, prefer surgical management. And very importantly, is a question came in last FMG, is if the patient is having, I think the question was a woman, 35-year-old woman, family complete, has been operated twice before for endometriosis, symptoms not settling. What is the last resort? Finally, what is the treatment? Now you've done everything, nothing is working, she's in so much pain. Final treatment option or last resort is to remove the uterus. So a hysterectomy, but not only the uterus, you have to remove the tubes also. I mean the ovaries also. Why the ovaries? Because if you just remove the uterus, the problem doesn't end. The endometriotic lesions are all over the abdomen. The ovaries, as long as they are there, as long as the HPO axis is intact, those lesions are going to grow under the influence of estrogen progesterone. So you have to remove the ovaries if you want to get rid of the disease. Okay. So last resort is hysterectomy plus bilateral ovariectomy. So here medical management, I've written here, just add here GnRH antagonists. And surgical management, as I said, ablation, excision, adhesiolysis, cystectomy. This is last resort, hysterectomy, plus very important, please add here bilateral ovariectomy, because without removing the ovaries, the disease will not go. This is a picture showing a chocolate cyst. You can see the brownish old collected blood. This is a very important image-based question. What is LUNA? LUNA is laparoscopic uterosacral nerve ablation. So this is another technique that is helps. It's a surgical technique which helps in pain. So if pain is the main symptom and she's not responding to any medical therapy, then you can ablate the uterosacral nerves and this will reduce her pain considerably. If she doesn't want a hysterectomy, but she wants something in between, laparoscopic uterosacral nerve ablation is one possible option for pain relief in endometriosis. Okay, so endometriosis, remember, pain primary symptom, medical treatment. Infertility primary symptom, surgical treatment. And last resort is hysterectomy plus bilateral ovariectomy, removing the ovaries. Now coming to another very important topic, endometrial hyperplasia. What is endometrial hyperplasia? Endometrial hyperplasia is a histopathological diagnosis. It is a diagnosis made on endometrial biopsy. But how will the patient present? When will you suspect? So this is a woman usually in her 40s, again 40 to 50, nulliparous or low parity usually. Okay, because this is a condition of hyperestrogenism. When estrogen is more, you get this condition. So conditions of hyperestrogenism are endometrial hyperplasia, endometrial cancer, endometrial polyps, fibroid uterus, and endometriosis. All these conditions are seen when excess estrogen is there in the body. It makes the endometrium grow. Remember, estrogen causes the endometrium to grow. So 40 to 50-year-old nulliparous woman, she's going to come with heavy menstrual bleeding. This is the typical presentation. And when you examine her, you will find everything is normal. Her uterus is normal in size. The there is no enlargement, there is no other feature, everything is absolutely normal. So a normal sized uterus, always think of endometrial hyperplasia, especially if the age group is 40 to 50, nulliparous, and her main symptom is heavy menstrual bleeding. So if you get this question and the question asks what is the next best step, the next best step is to do an ultrasound, a transvaginal ultrasound. And on transvaginal ultrasound, what will you look at? You're looking at the endometrial thickness or the ET. Okay, the endometrial thickness is this part of the uterus. This whole thing is the uterus. You may get an image also, that's why I'm showing you. And this is the endometrium. What you're seeing right now is called a trilaminar endometrium, or you can see three lines in the endometrium. This is called a trilaminar endometrium, and this is typically seen in the proliferative phase of the menstrual cycle, right? If the endometrium is thick, like this picture, look at here, you find an increased endometrial thickness. You should suspect endometrial hyperplasia. Now, how much of the thickness be increased by? So, if the ET is more than 12 millimeter, okay, in the reproductive age group, remember postmenopausal cutoff is separate. I'm talking about a patient who is menstruating. In the postmenopausal, in the menstruating woman, if the ET is more than 12 mm, what should you do? You should take a biopsy of the endometrium. We need to rule out hyperplasia or even cancer. Remember, hyperplasia is a pre-malignant condition for malignancy. So ET more than 12 mm, take an endometrial biopsy. Even if you see this kind of picture, this is again a thick endometrium and you have cystic spaces inside the endometrium. Either this picture or this picture means there is a strong possibility of endometrial hyperplasia. So again, if the question comes, say 45-year-old nulliparous lady with heavy menstrual bleeding, what is the, and on examination uterus is normal size, what was the next best step? The next best step is to do a transvaginal scan. If they give you till here that on TVS the ET is thick 13 mm, 14 mm, 15 mm, what is the next best step? Next best step is take an endometrial biopsy. Okay, now on endometrial biopsy, remember, there are three ways to take an endometrial biopsy. The best way, how do you take an endometrial biopsy? The best way is to do a hysteroscopy guided biopsy. That is, actually look inside the uterus and take a biopsy. Okay. The second way you can take is doing a dilatation and curettage. And a third way you can do is by doing what is called an endometrial aspiration. That is an OPD procedure where you don't have to dilate the uterus also. These are blind procedures. That's why they are not preferred. Okay, the preferred one, the gold standard is, this is the gold standard of taking a biopsy, is a hysteroscopic guided biopsy. Now, what possible reports can you get in the biopsy? The possible reports are two. Okay, you can either get simple or complex hyperplasia. What is important to look for is there atypia or is there no atypia? So you can get without atypia, or you can get atypia present. So look in the question, and this very commonly comes in the exam. If you pick up any question paper from FMG, it's one of their favorite topics. Without atypia or atypia, what do you do? Now, when there is no atypia, the risk of malignancy is less. It's hardly 1 to 3%. So, what can you do? You want to suppress the endometrial hyperplasia. What is the best drug to reduce the endometrial hyperplasia? What will counteract the action of estrogen? Progesterone. So, progesterone is known to cause endometrial atrophy. You can give either oral progesterone, but a better long acting one is the Mirena, which you can put for 5 to 8 years. The newest recommendation is you can use it for 8 years, and this will cause endometrial atrophy. But if there is atypical endometrial hyperplasia, then what is the treatment? Then the risk of malignancy is very high. It's almost 8 to 30% approximately. You have to risk of conversion of endometrial cancer. You have to remove the uterus. There is no waiting. Hysterectomy with removing the ovaries also, you will basically get rid of the uterus if there is any atypical endometrial hyperplasia. So no atypia. Without atypia, whether it is simple or complex doesn't matter. You will put in a Mirena. Atypical hyperplasia, you will do a hysterectomy. So again, typical history, 45-year-old lady, nulliparous or low parity, comes with heavy menstrual bleeding. Uterus is normal in size. Next best step, TVS. TVS में endometrium is given to be thick. Next best step, endometrial biopsy. Best way to take an endometrial biopsy is a hysteroscopy guided biopsy. If the report is hyperplasia without atypia, put in a Mirena. If it is hyperplasia with atypia, do a hysterectomy. Similarly, postmenopausal bleeding, another favorite topic. Remember, postmenopausal bleeding, the main aim is we need to rule out cancer. That's the most important thing. But it's not the most common cause. Remember, the most common cause, and there should not be any confusion here, the most common cause of postmenopausal bleeding is endometrial atrophy or a thin endometrium, a senile endometrium. A very thin endometrium easily bleeds because the capillaries underneath tend to break through. Okay, but it is not what we are worried about. We are worried about cancer. And the most common cancer to cause postmenopausal bleeding is cervical cancer. So we're worried about cervical cancer. The second most common cancer to cause postmenopausal bleeding is endometrial cancer. So we're basically worried about cervical cancer number one and endometrial cancer number two. Right? That is what we do in evaluation of PMB. Right? We know the most common cause is not to worry, but we can't leave the patient alone. We have to see her. So if a patient comes with PMB, we take a history and examination. And suppose on an examination means you're doing a per speculum examination. You're looking at the cervix. If you see a growth on the cervix, you know the cause. It is cervical cancer. We take a biopsy and done. Okay. But if the cervix looks normal, okay, then what are we worried about? We are worried about, so we've ruled out cervical cancer. We are now wanting to look at endometrial cancer. So the next best step is to do a transvaginal scan. Yes, a pap smear will be taken, but if the question comes that patient has come with postmenopausal bleeding, cervix looks normal, what is the next best step? The next best step is not pap smear. Cervix looks normal basically is telling you कि cervical cancer नहीं है. Yes, you'll take a pap smear because you don't want to miss the opportunity for screening, but now you're worried about endometrial cancer. So what will you do? You will do a transvaginal scan. And on in the postmenopausal woman, the cutoff we take is 4 millimeter. If the ET, the endometrial thickness, is less than or equal to 4 millimeter, we are happy. This means it is endometrial atrophy. I have nothing to worry about. Okay. But if the ET is, I'll write it here as 5 or more. That's easy to understand. Anything which is 5 or more needs to be biopsied. Okay, so 4 or less, leave her alone. You know the diagnosis is endometrial atrophy. But 5 or more needs to be biopsied. You can't ignore it. We have to take a biopsy and see what the problem is. Okay, then we're thinking of endometrial cancer. Again, postmenopausal bleeding patient comes, do a speculum examination. What happened? Lag. Lag is there? No, it's okay. Sure. Okay. Okay. So if there is postmenopausal bleeding, what are we worried about? We are worried about, 1 second. So if there's postmenopausal bleeding, we're worried about, and we're worried about cancer, right? So the first thing we do is we do a speculum examination. There is, it's okay, ना ठीक दिख रहा है. Can I continue? Just a second. My mouse is not working now. This shadow is coming, nahi? Shadow कहाँ से आ रहा है? I don't understand. Okay, some problem. Okay. Okay, so coming back here. Okay, if the ET is less than 5 milli, if the ET is less than or equal to 4 millimeter, then, sorry, let me come back to the beginning. Postmenopausal bleeding, you examine the patient, cervix looks normal, you ruled out cervical cancer. If the cervix looks normal, next thing is to look at the endometrial thickness on TVS. Endometrium is 4 millimeter or less, you are relaxed because this is a thin endometrium. The likely cause of bleeding is postmenopause, is a senile endometrium. But if the ET is more than 5 millimeter, then you are worried. Then you need to biopsy the endometrium. Okay. Next important topic is vaginal infections. This table is very important. You have three most important causes of vaginal infections. First is bacterial vaginosis. How does this present? This presents as a whitish, grayish white homogeneous discharge. There's no foul smell. Sorry, there is foul smell, but there is no other symptom. No dysuria, no on examination, no abnormal vagina, cervix, everything looks fine. Just the discharge is there. pH is alkaline. This is important. And Amsel's criteria is important. This is the clinical criteria. There are four. Any three out of four, if it is there, what are the three out of the four? One is the pH more than 4.5. Second is the type of discharge, the white, grayish white, thin discharge. Third is the whiff test. What is whiff test? On adding potassium hydroxide to a vaginal smear, you get a fishy odor. And fourth is the presence of clue cells. What are clue cells? Clue cells are these cells. Okay, so normally vaginal epithelial cells will appear like this. They will have very clearly defined margins. But if these margins get blurred, like you can see all these cells, the margins are blurred because they have been studied by abnormal bacilli. This is called a clue cell. So clue cell is typically seen in bacterial vaginosis. Any three out of four of these, it is BV. What is BV? BV is an overgrowth of abnormal bacilli. So lactobacilli is the normal bacilli. ये कम होके if other bacilli like Gardnerella and mobiluncus, these if they increase, it is called as bacterial vaginosis. What is the treatment of choice? Treatment is metronidazole. This could be either oral or vaginal tablet of metronidazole. Also remember, this is the clinical criteria. There is also a microbiological criteria where they actually count the number of bacilli, how many lactobacilli, how many other bacilli, and they give us scoring called the Nugent scoring. Nugent scoring is the gold standard. If the question comes, what is the gold standard diagnostic test of BV? Answer is Nugent scoring. Okay. Second is trichomoniasis. Now, trichomoniasis presents as a yellowish, frothy, greenish, yellowish, frothy, foul smelling discharge. Remember, it is a sexually transmitted disease. It is caused by a protozoa, the trichomoniasis organism. It also, the patient will not only have this gandawala discharge, she will also have itching, she will have painful micturition. And when you examine her, very favorite question, strawberry vagina, strawberry cervix. Okay, it's called as colpitis macularis. Okay, pH is going to be more than 4.5. Okay, and you find these motile organisms on the smear. So this is the how the organism will look like. So if you see this flagellated motile organism, think of trichomoniasis. Treatment again is metronidazole. Oral metronidazole is preferred, or secnidazole or tinidazole. But very important is you have to treat the partner. So not only the woman, you will also give her partner the treatment. Okay, so that's important because it's a sexually transmitted disease. Then we have candidiasis. Candidiasis is important because it is very common in acidic environment. So especially in pregnancy, candidiasis is common because the pH goes very low in pregnancy. It is also common in immunosuppressed conditions, diabetic women, women on steroids. It presents as a thick, curdy, odorless discharge, but she will have a lot of itching, pruritus. Remember, yeast fungal infections always cause itching. So pruritus, dysuria, and pH is the ulta. It is acidic, very, very acidic pH. On examination, it will be inflamed vagina, red vaginal walls will be there. Treatment is by giving antifungals. Common antifungals are fluconazole or clotrimazole. These are common antifungals which we give. Oral fluconazole or vaginal clotrimazole is given. Okay, and this is what you see on microscopy. You see these pseudo hyphae or spores in candidiasis. Now coming to benign ovarian cysts. Benign ovarian cysts, we have functional ovarian cysts are the most common type of benign ovarian cysts. In this we have two types. You can either have follicular cysts or you can have luteal cysts. Luteal cysts are like the theca lutein cyst in molar pregnancy. Sometimes in twin pregnancies we see. So these are related to pregnancy and they don't require any treatment. Once the pregnancy part settles, the luteal cyst disappears. Follicular cysts are commonly seen. They are also called as simple ovarian cysts and they usually do not require any treatment. They are usually because of an unruptured follicle. So the management of a follicular cyst or a simple ovarian cyst basically depends on the size. If the size is less than 6 centimeters, we leave them alone. We either reassure the patient or we can give combined contraceptive pills for 3 to 6 months. Okay, that is one option. Some guidelines will say 5 centimeter, less than 5 centimeter. If they are between 6 to 8 centimeters, ये वाला थोड़ा सा tricky वाला आता है कि should you operate, should you not operate. If they are more than 8 centimeter, clear cut, they need to be removed because now they're so large, even there though they are simple cysts, they can rupture inside, they can undergo torsion, so they need to undergo a laparoscopic ovarian cystectomy. But the beach wala 6 to 8 centimeter wala fibroids, sorry, ovarian cysts, benign ovarian cysts, simple ovarian cysts can be, you can either leave them alone or you can operate. And this decision is based on several things. For example, a raised CA 125 level, it is better to operate. Or any suspicious ultrasound features, you can operate. Or if the patient is symptomatic significantly, you can operate. So this middle wala range, usually you will not get a question because this depends on so many other things. But less than 6 centimeters, combined contraceptive pills or simply reassure the patient. And large ovarian cysts, more than 8 centimeter, you should do a laparoscopic ovarian cystectomy. Okay. Now, very commonly asked question as an image-based question and otherwise is a dermoid. This is how a dermoid looks like. Favorite question in the exam. It's a mature cystic teratoma. The other name is a mature cystic teratoma. And this shadow is not going. Okay. This is this basically how you identify this. It has components of all three cell lines. So you have hair, teeth, sebaceous material. You may even find thyroid tissue on histopathology. So a lot of different things grow inside here, but typically you'll see this hair and teeth and bone. Now, with dermoid, what is the treatment? Treatment is straightforward. Laparoscopic ovarian cystectomy. They are usually benign tumors, nothing to worry. But one of the typical complications of a dermoid is it can undergo torsion. Torsion means twisting around the pedicle. And if it undergoes torsion, It will make the ovary also undergo twisting, and that will lead to ovarian ischemia necrosis, and the patient can lose the ovary. So, what is the typical presentation? Pain not relieved with any medication, with any medicine. And on ultrasound plus Doppler, what do you find? You find the whirlpool sign. Okay, this tells you this is torsion. Now, again, when you have this kind of picture, then treatment is only surgical. So, what will you do? You will do a laparoscopy and you will detort, untwist the twisted ovary. Once you detort, you will wait to see if the circulation returns. Matlab, does the ovary become white in color again? So if the color returns to normal, you can just do a cystectomy, just remove the cyst. But if the ovary remains black, ischemic, necrotic, then you will remove the ovary. You will do an ovariectomy. Okay, so this is important. On laparoscopy, you untwist the twisted pedicle and then you wait for a few minutes. If vascularity resumes, the ovary will become white and you just remove the cyst. But if the color does not resume, then you do an ovariectomy. If it appears black, necrotic, then do an ovariectomy. So this is important because one of the most common presentations of dermoid is torsion. It's a very light cyst. It tends to float on the peritoneal surface and undergo twisting. Okay, so this is about dermoid. Next is endometrioma. Endometrioma, we've discussed this. This is chocolate cyst, ground glass appearance. And treatment is again laparoscopic ovarian cystectomy. Okay. Next, a few things about epithelial ovarian tumors like tumor markers, risk factors, all this. Can someone just tell me the time? Because the time my laptop has hanged. I think I'll have to restart my laptop. 7:40. Okay, okay. We'll take a small dinner break around 8 o'clock. Is that okay? 8 to 8:30, and then we'll resume. Okay, yeah. Okay. Now coming to epithelial ovarian tumors. Epithelial ovarian tumors, remember, these are the most common ovarian malignancies, and there are several risk factors which are important to know. The risk factors are: number one, it is more common in those women who have an early age at menarche and a late menopause, because one of the hypotheses of ovarian tumor is repeated ovulation. Those women who have ovulation, more ovulations, they have a higher risk of cancer. Third is similarly nulliparous women, because they don't have the protection of pregnancy. Pregnancy causes an ovulation, so they don't have that protection of pregnancy. So they are a higher risk of ovarian tumor. Very important, a drug called clomiphene citrate. This increases the risk of ovarian cancer. What else? What else? So, early menarche, late menopause, nulliparous woman, clomiphene citrate. Also, remember there are certain genetic disorders like BRCA1, BRCA2, which also increase the risk of ovarian cancer. What else? Remember, there is a oncogenic agent called asbestos, which earlier used to be part of talcum powder. This is also a risk factor for epithelial ovarian tumors. So all of these increase the risk. Now it's important to understand what decreases the risk. The risk of ovarian cancer is primarily reduced by combined oral contraceptive pills. Remember, combined pills reduce the risk of three cancers: CEO. This is colorectal, endometrial, because the progesterone component is helping in endometrial cancers, and ovarian cancers because it inhibits ovulation. Combined contraceptive pills basically act by inhibiting ovulation. Okay. What else reduces the risk? Women who get pregnant, so those with higher parity, more number of children, rescues the ovary. Those who are breastfeeding mothers, because breastfeeding also inhibits ovulation. Also, women who have had a salpingectomy, that is, the tubes have been blocked. or the tubes have been removed. How does this prevent ovarian cancer? Because toxic substances like asbestos or other substances will not enter the ovary through the fallopian tube. So these are known to reduce the risk of ovarian cancers, right? So this you should remember. Yes, OC pills increase the risk of two cancers, breast cancer, and to some studies, according to some studies, cervical cancer also. That is important to know. This is also a very important slide, ovarian tumor markers. So CA125 is the tumor marker for serous cyst adenocarcinoma, which is an epithelial ovarian cancer. Alpha fetoprotein, it has the word feto, so remember it is increased in yolk sac tumor. LDH has a D, so dysgerminoma. Beta HCG in non-gestational choriocarcinoma. This is not the normal choriocarcinoma, this is ovarian choriocarcinoma. Inhibin is released by the granulosa cells. So granulosa cell tumor, you will find inhibin A and B. Also to this list, just add two more, CEA and CA199. These are increased in mucinous cyst adenocarcinoma. However, these are not specific. Even CA125 is not specific. Although we say it is a tumor marker for serous cancers of the ovary, they are also increased in many other conditions like fibroid, like endometriosis, like genital tuberculosis, like pelvic inflammatory disease, and also it is increased in pregnancy. Okay, so this is what you should remember. Fibroid, endometriosis, genital tuberculosis, PID, pregnancy, all of these CA125 is raised. However, it is raised significantly. The value will be in thousands in serous cyst adenocarcinoma. Okay, so I think we can break here because I wanted to restart my laptop. It's giving me problems. Okay, and so I think we can break also because restarting will take about 5-10 minutes. Okay, I know it's a little early, but we're keeping good speed, so I think we'll finish early. And if we finish early, we'll also finish a few more topics which I haven't included here, but which I think we can cover. That is prolapse and MTP. Also, I will want to cover, which I hadn't put here because we've discussed enough in the past. But let me discuss those also. But let's take a break till 8:20 तक लेते हैं, ठीक है? I'll just restart my laptop and then we'll get back. Okay? All right, so let us now continue. I hope everybody is back and things are better now from my end. So let us continue. Very important topic. So in all the cancers in gynae, the most important is cervical cancer. So we start with screening and the HPV vaccine. Now, first important thing we should know is that what part of the cervix are we concentrating on when we are screening? We are concentrating on this area. This is called the transformation zone, which is an area of squamous metaplasia. Okay, and this area of squamous metaplasia is very prone to malignant transformation. This is where the HPV is going to attack and the HPV is going to cause malignancy to happen. So when we are testing mainly from the transformation zone. The next important thing you should know is what are the screening methods that we have and what is the method of choice. So all the guidelines now the world over, American, British, WHO, Indian, they all say that the preferred or the best method for screening for cervical cancer is an HPV DNA. And if you're doing this, it should begin at the age of 21 to 25 years, depending on the guideline that you are reading, and it should be done every 5 years, once in 5 years. Another test which is acceptable means it's not the best, but yes, you can do this. If you don't have an HPV DNA or if cost is an issue, you can do a pap smear. That is an acceptable test. And if you're doing a pap smear, it is done once every 3 years. Another test you can do which is acceptable is a co-test, and this came in the last FMG. What is a co-test? A co-test is both. It's HBV DNA plus a pap smear or a LBC. LBC is a cytology, liquid based cytology. Pap smear is also a type of cytology. So pap smear or LBC are looking for cells, abnormal cells from the transformation zone. So HPV DNA plus a pap smear is called a co-test. Now this would seem the ideal test, yes, because it's you're taking both the HPV plus a pap smear. Why is it not the preferred test? Because of the cost. If you're doing both, it adds up to the cost. That's why the preferred or the best test is an HPV DNA alone. But other tests that you can do are a pap smear or a co-test. Co-test is HPV DNA plus a pap smear. And in low resource settings, if they typically this word is used, low resource settings. Low resource means you don't have access to a laboratory or a pathologist. If you don't have access and you're in a low resource setting, then what are you going to do? Then you are going to do what is called the investigational screening test of choice is VIA, visual inspection under acetic acid. You can even do visual inspection under Lugol's iodine, but this is the best test in a low resource setting. So see what the question has been asked. If they've asked the preferred or the best test and they've not mentioned anything about the setting or the cost, then HPV DNA. Other tests that you can do are a pap smear or both a HPV DNA and a pap smear. And in low resource settings, you will do a VIA or a VILI. Now, these are the things you need for a pap smear. You need a Cusco's speculum. The first thing you do is you insert the Cusco's speculum, then you visualize the cervix, then you take a sample from the ectocervix. This is an IR spatula. So the first sample is taken from the ectocervix and then from the endocervix. IR spatula is taking a sample from the ectocervix and the cyto brush is taking a sample from the endocervix. And then what do you do? So first is you visualize the cervix, put in a Cusco speculum. Second is you take the smears first from the ectocervix and the endocervix. Third is you prepare the smears on a slide. Okay, and fourth is you fix the slide. You fix using a fixative, which you can either dip the slide in the fixative or spray the fixative using 95% ethanol. This is what is done for when we take a pap smear. Okay, so this is for a pap smear. And this is frequently asked, put in the correct order, or what is the fixative used, or identify the instruments. Usually this is asked. Now, if we are going for HPV testing, okay, HPV testing is also done in a similar way. We put the cusco speculum, visualize the cervix, but instead of using these two instruments, we use this one instrument. This is called a cytobroom. It will take samples from both the endocervix and the ectocervix. So you just need one instrument instead of the IR spatula and the cyto brush separately. We use a cyto broom to take a sample for HPV DNA testing. So you should be able to identify this instrument also. This is how visual inspection under acetic acid looks like. The abnormal areas or dysplastic or malignant areas will appear white in aceto white in color. So these are abnormal areas. So you know that these areas need to be biopsied. And if you apply Lugol's iodine, you find that the abnormal areas, what do they become? They become iodine deficient. They don't take up the stain, whereas normal tissue will take up this brownish colored stain, and abnormal areas will be iodine deficient. So you look at areas which are aceto white and iodine deficient, and these are areas which need to be biopsied. Right. So this is what we're doing. So HPV is the best test. You can also take a LBC or a pap smear, which is a cytology test, or you can do a VIA or a VILI. Now, if HPV is positive, then what do you do? So ideally, what should be done is, if HPV is positive, the woman is at risk of developing a cervical cancer, right? So what should you do? You have to then take a pap smear. Ideally, this is what we do. HPV positive, take a pap smear. Pap smear is abnormal. When I say abnormal, what does this mean? If the report says ascus, or the report says LCIL, or the report says HCIL, you have to then do a colposcopy and take a cervical biopsy. So if the HPV is positive, what are we doing? We are taking a pap smear. If the pap smear is abnormal, matlab abnormal means any of these abnormalities come, what are we doing? We're doing a colposcopy. Colposcopy means looking at the cervix under magnification, and koi bhi abnormal area dikhta hai, we're taking a cervical biopsy. If this is there in the option, this is the best test. But sometimes HPV positive, directly also you can take a colposcopy and cervical biopsy. You can actually skip the pap smear wala part, because patients sometimes they're like, why do you keep wanting to take tests? Just let's confirm it. So confirmatory is always cervical biopsy, especially if she has HPV 16 and 18. Sometimes the lab will give you the genotype. 16, 18 are high risk. In high risk, you will definitely take a colposcopy or cervical biopsy. So again, if the question is giving you the option of pap smear, if HPV positive, this is the better answer. But if pap smear is not mentioned, you can directly also do a colposcopy and cervical biopsy. The second part of the question, what if the pap smear is positive? Okay, so if pap smear is positive, then what? Suppose the patient has not had a HPV. She's come for a checkup, and in your setup, you do pap smear or LBC. If LBC is abnormal, then what? So first, you should know what is a normal pap smear. A normal pap smear is called as NIELM. This is negative for intraepithelial lesion or malignancy. This is normal smear. Negative for any lesion or malignancy. But abnormal smear में क्या आएगा? So abnormal smear में you can either get, as I said before, ascus. Ascus is atypical squamous cells of undetermined significance. Atypical squamous cells of undetermined significance. Or if it comes as LCIL, what is LCIL? LCIL is low grade squamous intraepithelial lesion. So these two are both low grade lesions. So suppose the report in pap smear comes as ascus or LCIL. What is the next best step? The next best step is, now you have to take an HPV. So it's ulta. If HPV is positive, take a pap smear. If pap smear is positive, take an HPV. And if the HPV is negative, then you don't have to worry, because even though their lesions, their cytology is abnormal, they're low grade lesions. HPV is negative, you will just follow up with a co-test maybe after a year, Okay, but if the HPV is positive, then what do? Now this is concerning. She has a low grade lesion, HPV is positive, you will do a colposcopy and a biopsy. Okay. Now, if the lesion comes as, if the pap smear says HSIL, HSIL is high grade squamous intraepithelial lesion, then what will you do? Then there is no need to take an HPV. It's a high grade lesion. Even if HPV is negative, you will not ignore. You have to directly do a colposcopy and a biopsy, irrespective of HPV. HPV, there's no point doing because it's a high grade lesion. So again, if you've taken an HPV first and HPV is positive, take a pap smear. Pap smear, anything which is abnormal, do a colposcopy biopsy. You can even skip the pap smear and directly do a colposcopy biopsy. If you're taking a pap smear first and the report is normal, nothing to worry. If it is ascus or LCIL, these are low grade lesions, do an HPV. If HPV is positive, colposcopy biopsy. And if it is HSIL, this is a high grade lesion, you don't have to take an HPV. It's a high grade lesion, better to just do a biopsy. Okay, this is the same thing which I've explained, same thing I've written. Okay, no, okay, this is different. So if now you've taken a cervical biopsy, okay, if you've taken a, so now you've reached the point where you've taken a biopsy. Now, on biopsy, what are the possible lesions? This is now going to be your precancerous lesions of the cervix, right? So, on biopsy, you can get three things. You can get CIN1, CIN2, CIN3. Again, CIN1 is low grade, 2 and 3 are high grade. Now, if it is CIN1, these are your precancers. Like we had endometrial hyperplasia is precancerous for endometrial cancer. Similarly, CIN1, 2, and 3 are precancerous for cervical cancer. But CIN1 is a low grade lesion. You're not that worried. Okay, so you can either call her after a year for a co-test, or better, however, would be to do an ablative procedure. Ablative procedure means you're destroying the surface of the transformation zone either by cryotherapy, that is you're freezing the cervix, or by thermal, you are burning the cervix, है ना? So this is what is called a cryotherapy machine. You can see the cryo probe. This is a cryo probe. At freezing temperatures of minus 89 degrees Celsius, nitrous oxide is applied on the cervix and the cervix is frozen. This will destroy the cervix up to a depth of 5 millimeter. Or you can even do thermal ablation, heat, jala do usko, or laser ablation. Laser will also burn the tissue. So these are called as ablative. Ablative means destroying the surface of the transformation zone either by cold freezing or by heat. This is done in CIN1. Okay. But if it is CIN2 or 3, these are your worrisome lesions. CIN2 or 3, the risk of progress to malignancy is higher. Ablation is not enough. हमें क्या करना चाहिए? We have to excise the transformation zone. We have to remove that transformation zone which has high risk of malignancy. Okay, so forget this line. Ablation, what is the treatment of choice? Treatment of choice is LEAP or LETS. What is LEAP or LETS? LEAP stands for loop electro-excisional procedure. And what is LETS? LETS is large loop excision of the transformation zone. Both mean the same thing. Some people call it LEAP, some people call it LETS. What are you doing? You're excising or removing the transformation zone. How are you removing it? This is how LEAP is done. Okay, this is exactly an image-based question might come. This is a wire loop. You see this wire here, through this current is passed, electrical energy is passed, and you just sweep it over the cervix, and this transformation wala area zone gets cut off. So you're excising the transformation zone. Sometimes you want a deeper chunk. Okay, if you want a deeper chunk, you can do another procedure called a conization, especially if you're expecting endocervical involvement. Mostly cervical cancers are ectocervical. But if you're suspecting deeper endocervical involvement, you can do a conization. That is, with the scalpel, you take out a cone of cervix. You excise this much area of the cervix. So if asked the treatment of choice, and this is very commonly asked as a question, treatment of choice for CIN2 or 3, answer is loop electro-excisional procedure or large loop excision of the transformation zone. is the treatment of choice, right? This is very important. Again, I will repeat from the beginning. If it's CIN1 on biopsy, you will do an ablative procedure, cryothermal laser. If it is CIN2 or 3, you will do an excisional procedure. Best treatment of choice is loop excision. So this is creating a loop. This is a wire loop. It excises the cervix, the transformation zone. If you want deeper tissue, you can even do a conization, which is done with a simple scalpel. So these are excisional procedures. Now about the HPV vaccine, very important topic again. HPV vaccine primarily prevents against 6 main cancers. Which cancers? Cervical cancer, okay, then vulval cancer, vaginal cancer, because these are all known to be caused by the HPV. Also cancer of the anal canal, also oropharyngeal, and in men, penile cancer. These are the 6 cancers HPV vaccine protects against. It also protects against CIN, which is the precancerous lesions of the cervix, and also against genital warts, which are caused by low risk type of HPV. So primarily when we are giving HPV vaccine, especially in our country, in India, why do we give HPV vaccine? We give it for prevention of CIN and cervical cancer. It is also effective against as I mentioned, all these things. Now, it contains, commonly asked question, it contains the L1 synthetic capsid protein, and we have 4 types of vaccine. Here I've written 3, but there are actually now 4 types. What are the types? So we used to have Cervarix. This is no longer available in India. This is a bivalent vaccine. So the most important genotypes are 16 and 18. Any vaccine has to have coverage against these. So Cervarix is a bivalent vaccine. Gardasil is a quadrivalent against 6, 11, 16, and 18. And also the Made in India vaccine, which was introduced 2 years back, called as Cervavac, is also a quadrivalent vaccine. This also is effective against 6, 11, 16, and 18. Gardasil 9 is the nonavalent vaccine. It is effective against 9 subgroups of the virus, that is 6, 11, 16, and 18. So, hey, apart from this, you have 31, 33, 45, 52, and 58. If you can remember, if you can't remember, chuck. But you should remember Gardasil and Cervavac. ये सबसे important है. Cervavac is most important for you guys because it is made in India vaccine and it is very, very recent. Okay. Also important, in according to the Indian Academy of Pediatrics, how do we vaccinate our girls? So vaccination is for girls as per the Indian Academy of Pediatrics, Indian Association of Pediatrics, sorry. So the recommended age group is 9 to 26 years, right? And if she's less than 14 years, there are 2 doses given at 0 and 6 months. If she's between the age of 15 to 26, then 3 doses, that is 0 at 1 or 2 months, depending on the vaccine, and then at 6 months. There is also a catch-up vaccine. So if a woman has not been vaccinated, so ideally she should have the vaccine before the age of sexual activity. But you can also give a woman the vaccine till the age of 45 years, although the efficacy may not be as good, but it can still be given, right? So this is the age groups where you can give. 9 to 26 is recommended. Less than 14, 2 doses. 15 to 26, 3 doses. But you can give catch-up vaccine till 45 years. Importantly, Cervavac clearly says only 9 to 26 years. Gardasil says till 45. Gardasil 9 says till 45. But Cervavac is clearly 9 to 26 years as per the information in the vaccine. So this is what is the HPV vaccine, right? Now coming to cervical cancer. As I said, this is the most important cancer. We know it is caused by the HPV. We know the most common type is squamous cell carcinoma, less commonly adenocarcinoma. The spread is mainly either direct spread or lymphatic spread. And in lymphatic spread, we should know it goes initially to the pelvic group of lymph nodes, from there to the para-aortic group of lymph nodes. Which are the 5 pelvic group of lymph nodes? You should know the 5 group of pelvic lymph nodes are the external iliac group of lymph nodes, the internal iliac group of lymph nodes, the common iliac group of lymph nodes, Then we also have the sacral group of lymph nodes and the obturator group of lymph nodes. So these five group of lymph nodes, because when we're doing a radical hysterectomy, these are the lymph nodes we remove. When we're giving radiotherapy, these are the lymph nodes that are targeted. So external iliac, internal iliac, common iliac, sacral, obturator. These are a group of pelvic lymph nodes. And from here it goes to the para-aortic lymph nodes. So remember, spread is direct spread and lymphatic spread. Now, how will a patient present with cervical cancer? Common clinical features, common symptoms are: number one, she's going to have foul smelling vaginal discharge because there's a lot of necrosis happening in this tumor. Second, there will be postmenopausal bleeding if she's postmenopausal. If she's not postmenopausal, intermenstrual bleeding in between the cycle, she will have bleeding. She can also have what is called as postcoital bleeding, that is after having intercourse she has bleeding, and also loss of weight, loss of appetite, so cachexia. These are the symptoms of typical presentation of cervical cancer. When you put in a speculum and you do a speculum examination, you'll see this kind of growth coming from the cervix. So a necrotic growth, okay, which could be fungating or ulcerative growth, which is seen, which typically bleeds on touch. It is a friable growth which bleeds on touch, is typically how we describe the growth of cervical cancer. Now, once you see this kind of picture, if the question comes, a patient comes with intermenstrual bleeding, on examination, you see a friable growth which bleeds on touch. What is the next best step? The next best step is to take a punch biopsy using this instrument. This is a punch biopsy forceps. So punch biopsy forceps is used to take the biopsy. And remember, we always take the biopsy from the periphery of the lesion, never from the central necrotic part, because then you will not get any cells. So periphery of the lesion biopsy has to be taken. Staging, remember, is clinical. Remember, for cervical cancer, for vaginal cancer, for vulval cancer, these are all staged clinically, right, with the help of investigations. Whereas ovarian cancer and endometrial cancer are staged surgically. In such cancer, surgery has to be done, right? Whereas in cervical cancer, we don't do surgery for everyone. We stage the disease clinically with the help of investigations. What is the staging? Very, very important. Stage 1. Stage 1 is cancer limited to the cervix. So, stage 1 is when it is limited to the cervix. It has not gone beyond the cervix. In this, you have 1A and 1B. 1A is microscopic cancer, right? It is on biopsy you have diagnosed. You can't see the cancer. And in this, you have further 1A1, 1A2, depending on the size, less than 3 millimeters, 1A1, and 3 to 5 millimeter is 1A2. 1B is now, it is visible cervix, cervical cancer. And so anything more than 6 millimeter will become 1B. So now, but it is confined to the cervix. In this, you have 1B1, 1B2, 1B3. 1B1 is small lesions. Okay, so 5 millimeter to 2 centimeter, 2 to 4 centimeter is B2, and more than 4 centimeter is B3. If you can remember the subdivisions, well and good. Otherwise, remember, cervical cancer limited to cervix is stage 1. 1A is microscopic, 1B is macroscopic. Stage 2. Stage 2 is now it's gone beyond the cervix. Where has it gone? In stage 2A, it's gone till the upper part of the vagina. And 2B, it's gone to the parametrium, but not till the lateral pelvic wall. Not all the way, not till the pelvic wall. So it's somewhere in the middle. It's gone sideways, but not reached the pelvic wall. So this is stage 2B. Again, 2A is further divided as 2A1 and 2A2, depending on the size. Less than 2 centimeter, 2A1, more than 2, it is 2A2. Why is this important? Why I tell you this? Because remember, cervical cancer has two treatment strategies. Either we do surgery or we give chemoradiation. Remember, surgery is amenable only for very early cancers. When I say very early cancers, you can do surgery only till 2A1. So surgery for cervical cancer is only till 2A1. Beyond 2A, 2A2 and beyond, it is only chemoradiation. Also remember, 1B3 you will not operate because 1B3 is a very large tumor. 4 centimeters size is a huge tumor. So surgery till 2A1 excluding 1B3. If you can remember this, otherwise just remember till 2A1 is surgery. For all rest, it is chemo radiation. So this is stage 2. 2A is upper vagina, 2B is parametrium, not till the pelvic side wall. What is 3? Stage 3 is again divided as A, B, and C. A is it's gone till the lower part of the vagina. So lower vagina becomes stage 3A. Stage 3B, it's gone till the pelvic side wall, all the way in the parametrium, it's gone till the pelvic side wall. And very commonly, you find so plus minus hydroureteronephrosis because you find the ureters here through the broad ligament and it causes obstructive uropathy. In fact, the most common cause of death in cervical cancer is renal failure secondary to obstructive uropathy. Okay. And 3C is lymph node involvement. So on investigations on MRI, if you find there is pelvic, this is 3CA, 3C1, sorry. 3C1 is pelvic and 3C2 is para-aortic lymph nodes involvement. So once the lymph nodes get involved, it becomes 3C. Okay, so this is stage 3. A is lower vagina, B is pelvic side wall plus minus hydroureteronephrosis, and 3C is now the lymph nodes have got involved. And stage 4 is metastasis. So you have A and B. A is local metastasis, B is distant metastasis. So this is very important. Cervical cancer staging you should not be missing out on. Very, very important to remember. Now, treatment, as I said, is surgery and chemoradiation. Surgery is done only till 2A1, excluding 1B3. Till 2A1 only you can do surgery. And chemoradiation, remember, you can actually do for all stages, okay, especially those beyond 2A2. And this is on not only radiotherapy, it is chemoradiation. The chemotherapy treatment of choice, this is a previous repeat question, is cisplatin or carboplatin. Cisplatin causes it is a radiosensitizer. It makes the tissue better. It makes the tissue more responsive to the radiotherapy. So cisplatin based radiotherapy is given, and this is for all stages, especially those which you cannot operate. Okay. I'm not going into the types of surgeries and type of hysterectomies. Those are not very important. Okay, next topic is Mullerian anomalies. Mullerian anomalies is a very easy topic, commonly asked. Mullerian anomalies basically is there's a problem in the Mullerian duct development. The first is Mullerian agenesis, that is complete absence of the Mullerian duct. So what are the structures formed by the Mullerian duct? The structures formed by the Mullerian duct are the uterus, the cervix, the fallopian tube, and the upper part of the vagina. These are the structures formed by the Mullerian duct. If these are absent, if Mullerian agenesis happens, all these are going to be absent, right? So how is this girl going to present? She has ovaries. Remember, ovaries are present. Ovaries, there's nothing wrong with the ovaries. Ovaries are normal. So she's going to present as a woman or a girl with primary amenorrhea, that means no periods, with secondary sexual characters present. That means she's going to have breast development, pubic hair, axillary hair, because her hormonal axis, HPO axis, is normal. But she doesn't have a uterus. So when it's time to attain menarche, puberty onset happens, but menarche doesn't happen. So she's going to come to you with primary amenorrhea with secondary sexual characters present. Very commonly, 30% renal anomalies are associated. Also, skeletal and abnormalities can be present. When you examine her, when you evaluate her, you will find her karyotype is 46XX because she's going to be evaluated like a patient with primary amenorrhea. So you'll do a karyotype 46XX. When you do an ultrasound, first of all, the uterus is going to be absent. When the uterus is absent, you do a karyotype that is 46XX. Remember the hormonal profile, her FSH, LH, estrogen, progesterone, everything is going to be normal because the problem is not in the HPO axis. The problem is there's just no uterus. Treatment, what do you treat? What is the treatment options for her? So, can she get her period? No, she can't get her period. She doesn't have a uterus. Can she get pregnant? So, fertility, how, what are the possible ways you can get her pregnant? One is by offering her surrogacy, IVF, using her oocytes but borrowing a uterus. It's called as gestational surrogacy. Another newer innovation is uterine transplantation, which is although not very common, but yes, it is started the world over. So, uterine transplant is one possible option. Surrogacy, uterine transplant are what are the two options for getting her pregnant. What else? If you she will also be concerned, or you should tell her that sexual function is also important. Now the vagina, the lower part is there, but the upper vagina is absent. So the vagina is generally short in length. The vagina is short in length. So what should happen? What should you do? You can do what is called a vaginoplasty for penetrative intercourse. A good length is important, so vaginoplasty is advised. This can be done surgically or non-surgically. If there is some length, dilators can be given. If there is no length at all, surgical vaginoplasty is done. So this is what is about MRKH syndrome, Mullerian agenesis, right? Other anomalies. Now, whenever we say they're Mullerian duct, I told you the structures. How does the Mullerian duct form? There are actually two Mullerian ducts like this, and then they join, they become like this. Then there's a septa which dissolves, and then you find a normal uterus. In uniconvate uterus, you find only one Mullerian duct develops. The other one either disappears or remains as a rudimentary horn. So, uniconvate uterus is a very small uterus because there is only vascularity from one side. It's a small cavity. It commonly presents as infertility, as recurrent pregnancy loss, as preterm labor, as IUGR, and as mal presentations, transverse live breach, all that. So this is what you find in unicornate uterus. Also, if there is a rudimentary horn, this can also present as endometriosis, as I've already told you. So endometriosis can be there. Also, you can have an ectopic pregnancy developing in the rudimentary horn. And if an ectopic pregnancy develops here, remember this rudimentary horn is not like a fallopian tube which will rupture early. It will rupture a little late. It will rupture, yes, but not in the first trimester. So if you get a scenario of a ruptured ectopic, but not in the first trimester, in the second trimester, ruptured ectopic, think of a pregnancy in a rudimentary horn. Okay, so second trimester ruptured ectopic, typically think of a pregnancy in a rudimentary horn. So infertility, RPL, preterm, IUGR malpresentations, and two classical separate presentations, endometriosis and ectopic pregnancy, which ruptures in the second trimester because it has some muscle, some myometrial tissue exists. What is the treatment for unicornate uterus? Sadly, there is no surgical way to correct it. If there's a rudimentary horn, you excise. So if there's a rudimentary horn, it needs to be excised, but there is no surgical treatment which will increase the size of the uterus. So surrogacy can be advised for those women who are unable to conceive with a unicornate uterus. Septate uterus is the most common Mullerian anomaly, okay, and it is going to present with the same set of complications. You can have infertility, recurrent pregnancy loss, preterm labor, IUGR, and malpresentations. What is the investigation, or what is the way we diagnose this? If you do an HSG, so an HSG you find this kind of picture. I think I've put all together, yeah, here. This is the HSG of a septate uterus. How do you identify this? It has a very narrow angle. If it's less than 75 degree, the intercornual angle, it is a septate uterus. If the angle is wider like this, it is a bicornuate uterus, more than 105 degrees. It is a bicornuate uterus. Okay. And if it is two separate cavities completely like this, no communication whatsoever, it is a uterine didelphys. So although HSG is not the best test, it is usually the test done first because the patient comes with infertility. You get an HSG or you're looking at the tubes, but inadvertently you find a uterine anomaly. So it's not the best test, but in case you do a HSG, you find this kind of picture. You find a narrow angle between the two horns. What is the treatment of choice? Treatment of choice for septate uterus is this one. This is a hysteroscopic. This is a hysteroscopic. You can have. Okay, I'll have it. Thank you. Hysteroscopic septal resection. Okay, so hysteroscopic septal resection is the treatment of choice for a septate uterus, right? Uterine didelphys. Now, this is two cavities. They are basically two cavities which have developed separately, but they are nice big cavities because they have a lot of vascularity in between them. Like a unicorn uterus is very small, these are very big cavities. And as a result, they usually have a good outcome. You don't find too many problems in a didelphys, but three problems that you should know can happen, which Williams gives, is number one, there's a higher risk of abortions, there's a higher risk of preterm labor, and there's a higher risk of malpresentations. Okay, so these three risks as per Williams, although didelphys, again, I'm repeatedly saying itne problems nahi hote, but if at all, these three are what you should remember. Also remember that the O-Vera syndrome, which is a rare type of of didelphys uterus, here you will also find endometriosis. As I've already explained, that there is obstructed hemivagina, so it's an obstructive Mullerian anomaly, and ipsilateral renal agenesis. So this is rare. So this question has come as a previous year question. There's a lot of confusion here. All four options were given, and the question was which is not seen in didelphys. If you have to choose amongst them, then ovira is the rarest. So it's unlikely you'll see endometriosis. The other three can still be seen. Okay. Bicornate uterus is when there's incomplete fusion of the Mullerian ducts, okay, and it remains like this. Here again, same complications: infertility, recurrent pregnancy loss, preterm labor, IUGR, malpresentation, same thing. Okay, and I've told you how this looks like on HSG. The angle is very, very obtuse. It's like this. The angle is quite obtuse, right? Again, treatment is for a bicornate uterus. If the treatment options, there is surgical options. This is called a metroplasty. You can see this is a bicornate uterus on laparoscopy. It's like a heart-shaped uterus, and what is done is this part is excised. This part is excised, and the uterus is reconstructed, and it's made into a single uterus. So this is called as Strassman's metroplasty. So for bicornate uterus, you have a surgical choice. Didelphys, unicornuate, no surgical treatment option is there. For septate uterus, you have hysteroscopic septal resection. So bicornuate is Strassman's metroplasty. Okay. Transverse vaginal septum, this and imperforate hymen, two very, very important obstructive anomalies. So I'll discuss them together. Now, this is the uterus, the fallopian tube, the vagina. Imperforate hymen is at this level. So the obstruction is very low down. This is the level of imperforate hymen. Transverse vaginal septum can have, it could be a low septum, it could be a mid septum, it could be a high septum. So a TVS could be low, it could be mid, it could be high. Okay, so depending on the level of obstruction, the blood is going to collect accordingly. A low TVS and an imperfect hymen will present a little similarly. How? Because in both of them, you'll have a lot of blood collecting. So you have hematocolpos throughout the vagina. The entire vagina will be filled with blood if the obstruction is lower down. This is called as hematocolpos, blood in the vagina. Once this fills up, then the uterus will fill up. This is called as hematometra. Then there will be hematosalpinx and finally endometriosis. This is how it's an obstructive anomaly eventually leading to endometriosis. Now, if the obstruction is higher up, like in a mid or a high septum here, so you'll have the obstruction also will be higher up. So niche ka vagina will be khali, but the blood will collect more in the upper part of the vagina. Right. So this is one way which helps us differentiate based on the level of obstruction. You know how where the blood is collecting. Now, if we talk about, let's talk about how these girls usually present first of all. What is the typical clinical feature? The typical clinical feature is, again, she's going to come with primary amenorrhea, whether it is imperforate hymen or TVS. She's going to come with primary amenorrhea. Along with primary amenorrhea, she's going to have what happened? I'm saying classy, but I can't. 1 second. Okay, so primary amenorrhea with secondary sexual characters present. Okay, this is how the girl is going to present. And very importantly, she's not only going to have primary amenorrhea, she's going to have cyclical abdominal pain. That is called as cryptomenorrhea. This means hidden periods because even though she's getting her periods, the blood is not visible. So cyclical abdominal pain, cryptomenorrhea, many of these girls will have an abdominal mass. So you'll find a pelvic mass which will be palpable on abdominal examination. Some of them will even come with retention of urine because this is pressing against the urethra. So these are the typical presentations. Now in imperforate hymen, when you look at a local examination of an imperforate hymen, you will typically see a bluish bulge because the hymen is very flimsy, very thin. You can see the blood through the hymen and it's very easy to treat this. What do you do for treatment? Treatment is going to be a cruciate incision on the hymen. Whereas in a transverse vaginal septum, you won't see the bluish bulge. You'll just find that the vagina is short. Okay, or there will be a thick septa there. And that is, you won't, because it's a very thick septa, you can't see the blood bulging through. So a transverse vaginal septum is best diagnosed by an MRI. An MRI will actually tell you the level of obstruction, whether it's a low septum, a mid septum, a high septum. And treatment of a transverse septum is excision of the septum. You're going to excise the septum and that is let the blood drain out. So it's more complicated the procedure because the septum is thicker. Hymen is very easy, just give an incision and done. So this is what is important about this topic, right? Now coming, since we've discussed a few topics of primary amenorrhea, we will discuss more topics of primary amenorrhea. Now primary amenorrhea, सबसे important is the definition. Primary amenorrhea or delayed puberty is defined as in the so the first thing we're going to see is whether the girl, or the first thing we read in the question is number one, the age. That's the first thing you look for. And second is the presence or absence of secondary sexual characters. Now, if the girl has not developed secondary sexual characters, the cutoff taken is earlier. We take the cutoff as 13 years. But if she has developed secondary sexual characters, we can wait a few more years. So we can wait till 15 years. So these two numbers are important. In the absence of secondary sexual characters, the cutoff taken is 13. In the presence, the cutoff taken is 15. And also one more definition is if there is no menarche, even after 3 years of thelarch. What is thelarch? Thelarch is the first sign of puberty, that is breast development. So breast development may usually we expect menarche to start 2 to 3 years after thelarch. But if there's no menarche even after 3 years of thelarch, it is a third definition for primary amenorrhea. Now, when a question comes on primary amenorrhea, you need to know how to approach the question. So I'm not going to discuss all the causes. I'll just tell you the approach to the question. The first is normal secondary. So when the question comes, I said, look at one most important, look for secondary sexual characters. If they are present, what does this mean? This is indirectly telling you that the HPO axis is intact. That means the hypothalamus, pituitary, ovary are working fine. That's why she has estrogen. That's why she has secondary sexual characters. Okay, so this is telling us it's not an ovarian cause, not a hypothalamic pituitary cause. So what is the next thing we look for? The next thing we look for is we either examine her or see that do an ultrasound. That's the best way to look for the presence or absence of a uterus. If the uterus is present, that means secondary sexual characters are normal, uterus is normal, then what are we thinking of? Look lower down. Maybe there is a obstruction in the vagina. Maybe there is imperforate hymen or transverse vaginal septum. But if that is also normal, then you think of that is what is constitutional. Constitutional means kuch nahi karna. Reassure her everything is fine. She will eventually get her period. है ना? May some women will have delayed cycles. So constitutional, leave her alone. Everything is normal. HPO axis is normal, uterus is normal, vagina is normal. This is constitutional. You can also think of adolescent PCOS, early PCOS, or hyperprolactinemia, although these are rare causes. The problem comes when the uterus is absent. If the patient has secondary sexual characters and the uterus is absent, there are only two possibilities. Either this is MRKH syndrome, which we have discussed, or this is androgen insensitivity syndrome, also called as AIS, also called as testicular feminization syndrome. So, both will present with secondary sexual characters present with the uterus absent. How do you differentiate between the two? You will do a karyotype. MRKH, I have told you, is 46XX. AIS is 46XY. Wherever there's a Y, it is 46XY. Now, what happens in AIS? A little bit about AIS. Androgen insensitivity syndrome is a syndrome where androgens are present, testosterone is present, but it's unable to act because receptors are not working. Androgen receptors are not working. So, this is a male, this is basically a male person who even during intrauterine in utero life testosterone never worked, so the external genitalia never developed into a male, was assigned the sex at birth as female. Okay, and since the androgen receptors never acted, nothing male has developed. No internal genitalia, Wolffian duct didn't develop, external genitalia didn't develop, everything looks like a female. And then this person is going to present at puberty with no periods. Okay, looking like a female but no periods. But I mentioned secondary sexual characters are present. How is that possible? That is possible because the androgens are getting converted inside to estrogen. Okay, and because the androgen can't act on the androgen receptors, so it starts getting converted to estrogen. And this estrogen is going to cause breast development to happen. Pubic axillary hair are not going to be there. So there is no pubic or axillary hair because these are again testosterone dependent in the male person. So no pubic axillary hair. Okay, and but breast development will be present. So typically in AIS, they are 46XY, come to us with primary amenorrhea. Breast development is present, uterus they don't have because they're not women, they are 46XY, but they don't have any male internal or external genitalia because the testosterone has never acted, right? So this is androgen insensitivity syndrome. Now coming to absent secondary sexual characters. Your question has said primary amenorrhea, no breast development, no pubic hair, no axillary hair. What are you going to look at next? What clues will you look for in the question? Look for height. Specifically, if short height is mentioned, alarm bells should start ringing that maybe this is a question on Turner syndrome, because Turner syndrome, classically, all these girls are short. But it could also be a hypothalamic pituitary problem. Remember, absent secondary sexual problems, now you are thinking of a problem in the hormones. Estrogen नहीं है. Estrogen क्यों नहीं है? या तो ओवरी में प्रॉब्लम है या हाइपोथैलेमस पिट्यूटरी में प्रॉब्लम है. तो कहाँ प्रॉब्लम है, we have to identify. One clue is the height. Height short, think of Turner. But it could also be a growth hormone deficiency. So we need to see what will help tell us whether the problem is in the ovary or the problem is in the hypothalamus pituitary. The thing which will help differentiate is an FSH. Remember, if the problem is in the ovary, that means ovary is not functioning, streak ovaries in Turner syndrome. So estrogen is going to be going to be low, sorry, and this is in turn going to cause the FSH and LH values to be high. So estrogen low will make the FSH LH high. So if FSH is high, we know we are dealing with Turner syndrome. Short height, no secondary sexual characters, FSH high, you have your answer. Plus, they will be giving some more clues: widely spaced nipples, cubitus valgus, streak ovaries, and a short neck. All these things will be there. This will point to Turner syndrome. If the FSH is low, the problem is in the hypothalamus pituitary. Okay. Now, if the height is normal, again, we need to know that is the problem in the ovary, because one ovarian problem is Turner syndrome. There could be other ovarian problems also. One is called as 46XX gonadal dysgenesis. One is called as 46XY gonadal dysgenesis. This is known as Swyer syndrome. Remember, where there's a Y, it is 46XY. What is Swyer syndrome? Swyer syndrome is a type of gonadal dysgenesis. इसका मतलब क्या है? This is a person who has 46XY chromosome. मतलब the gonad is the testes, but the testes is dysgenetic. It is not acting. There's no point of the testes. It is just not acting. So you have a testes which is not functional. As a result, there is no testosterone, so no male development takes place, either internal or external genitalia. But very importantly, you have, since the testis is not functioning, remember in the embryo, the testis secretes two things. It secretes testosterone through the Leydig cells, and it also secretes a hormone called AMH through the Sertoli cells. Right? So AMH is anti-Mullerian. That means AMH is responsible for getting rid of the Mullerian duct. Okay. If there is no AMH being secreted, the testes aren't functional in Swyer. So AMH testosterone nahi hai body mein. So what's going to happen? The Mullerian duct is going to grow. The Mullerian duct is present. So Swyer syndrome is a patient who is actually 46XY but has a uterus. Remember, 46XY without a uterus, is AIS, and 46XY with a uterus is Swyer syndrome. There are only two 46XY abnormalities, and this is one important way you can differentiate. Without a uterus, AIS; with a uterus, Swyer. Another important feature is 46XY will have breast development. AIS will have breast development. Swyer will not have breast development because there is no testosterone here at all. Nothing to get converted to estrogen. Okay. So this is what is important to remember. And if FSH is low, then it could be an isolated GnRH deficiency. Okay, so like Kalman syndrome. So this is what is important in when you get a question. The first thing, see whether secondary sexual characters are present or absent. If they are present, then you are thinking of a problem in the uterus, not the or the vagina, not the HPO axis. So you look for uterus. If uterus is absent, look for the karyotype. It's either MRKH or AIS. If the uterus is present, then you're thinking of an outflow obstruction, that is imperforate hymen or TVS. If the secondary sexual characters are absent, that means there's a problem in the HPO axis. So one big clue is the height, because after all, the most common cause of primary amenorrhea is what? Turner's. This is the most common cause of primary amenorrhea. So it's very frequently asked in the exam, right? So how do you know it's Turner syndrome? You have a short girl with no secondary sexual characters with high FSH values, right? And the other important question that comes is usually on Swyer syndrome, 46XY, which has a uterus. A male with a uterus is 46XY. This is Swyer syndrome, absent secondary sexual characters. 46XY without a uterus is androgen insensitivity, and there, because testosterone is there, breast development also is going to be there. Okay. Now, since we've discussed primary amenorrhea, we come to secondary amenorrhea. Secondary amenorrhea is no periods for more than 6 months. Now, when you talk about secondary amenorrhea, again, the problem could be in the uterus, it could be in the ovary, or it could be in the HPO axis, similar to primary amenorrhea. But the most common cause of secondary amenorrhea is what? The most common cause of secondary amenorrhea is pregnancy. So that's the first thing that has to be ruled out, even if the woman is not married. And this has come as a question earlier, that's why I'm mentioning it. It doesn't matter. Pregnancy rule out karna hai. So rule out pregnancy, that's number one. Also rule out thyroid disorders and also prolactinemias, hyperprolactinemia. These are also very common causes of secondary amenorrhea. Once you've ruled out all three, pregnancy nahi hai, thyroid nahi hai, prolactinemia nahi hai, then what do? Then the next best step is you give what is called a progesterone challenge test to the woman. Progesterone challenge test means you give progesterone and then you see if she has withdrawal bleeding or not. Okay, so you give 7 to 10 days of progesterone, and then there are two possibilities. Either she has bled or she has no bleeding. If she has bleeding, this means that she was progesterone deficient. That's why on giving progesterone, she has had bleeding. So, what is the cause of progesterone deficiency? Is anovulation. She's having anovular cycles. Ovulation causes the corpus luteum to be produced, and that causes progesterone to be released. प्रोजेस्ट्रॉन नहीं है मतलब anovulation है ना. And a common cause of anovulation is PCOS. So you start thinking of PCOS. Suppose she has no bleeding on giving progesterone challenge test. Then what do? Then we give estrogen also. So we give 10-15 days of estrogen, 10 days of progesterone approximately, and see if she has bleeding or not bleed no bleeding. So again, there are two possibilities. Suppose she has bleeding on giving E plus P both, that means she was estrogen deficient. So on giving this, she has had her period. That means there's a problem in the hormones, because on supplementing the hormones, she has had bleeding. So that means there's a problem in the HPO axis. Now, where in the HPO axis is there a problem? How do I know? I will do an FSH. If the FSH is high, that means the problem is in the ovary. If the FSH is low, the problem is in the hypothalamus or pituitary. Ovarian cause of secondary amenorrhea, you will think of premature ovarian failure or premature menopause. Time से पहले menopause हो गया है. 40 years से पहले she has reached menopause. So FSH levels are going to be high. If the FSH levels are low, you will think of a hypothalamic or a more commonly a pituitary cause, that is Sheehan syndrome typically causes secondary amenorrhea. You will have a classical history of following postpartum hemorrhage. Patient has secondary amenorrhea. But if suppose there is no bleeding on giving E and P both, that means you've supplemented the hormones, apne HPO axis ko correct kar diya, still no bleeding. Then the problem is in the uterus. Which problem in the uterus can cause secondary amenorrhea? You will think of Asherman syndrome. What is Asherman syndrome? It is intrauterine synechia. The uterus develops adhesions inside the uterus. The endometrium gets destroyed. And how do these adhesions develop? Asherman's can develop mainly following either someone has done a very vigorous DNC and has destroyed the endometrium, or it can be secondary to genital tuberculosis. So Asherman's can be secondary to DNC, Asherman can be secondary to genital tuberculosis. What is the investigation and treatment of choice? Both is hysteroscopy. So diagnosis by hysteroscopy, treatment is hysteroscopic adhesiolysis. You cut up the adhesions. This is Asherman syndrome. On HSG, what do you see in Asherman syndrome? You see a irregular uterine cavity with irregular feeling defects. It's called a moth-eaten appearance of the endometrium. It's an irregular endometrial cavity. Right, now since we're discussing secondary amenorrhea, PCOS, very important topic we cover here only. PCOS is diagnosed by the Rotterdam criteria, where 2 out of 3 criteria are essential to diagnose it. One is hyperandrogenism, second is delayed periods, and third is polycystic appearance on the ultrasound. If any 2 out of 3 are there, it is called as Rotterdam's criteria for polycystic ovarian syndrome. This is the polycystic morphology on the ultrasound, the necklace pattern or string of pearl patterns or whatever. Now, when we talk about PCOS, we have different treatment options. Okay, remember the primary treatment. Remember, PCOS usually happens in girls who are, what's so funny? Anything happened? Okay, so primary treatment is weight loss or basically optimize the BMI. So always look for this option. If you have a question on PCOS, your first treatment option is optimize BMI. Irrespective of her complaint, she has acne, she has hirsutism, she has delayed cycles, she has infertility. First thing, optimize BMI. Also, counsel her about the risks in later life of metabolic syndrome. That is, she is at increased risk of developing hypertension, diabetes, obesity, cholesterolemia, all these, the risk is higher. Okay, so always look for this option. Apart from this, if her main complaint is acne or hirsutism, what will you do? You will give her combined oral contraceptive pills where the progesterone has an anti-androgen like drospirenone. The progesterone component of the combined pill is an anti-androgen like drospirenone. Okay, this is if she has acne, hirsutism. First treatment is again optimize BMI. Tell her that only first. Secondly, you can give her combined contraceptive pills. Similarly, if she has irregular delayed periods, again you will advise her combined contraceptive pills. Again, first option optimize BMI. This is the second option I'm telling you. If she has infertility, you're going to tell her that again optimize BMI. If that doesn't work, you will give her ovulation induction. And the drug of choice for ovulation induction is letrozole. Letrozole is the drug of choice. All right. We'll come to more about other options in a while. And the fourth is if she is not concerned about anything at all, but one very important thing is you have to tell her that she has to reduce her risk of endometrial cancer. Remember, which cancer is common in PCOS girls? Endometrial cancer. Why? Because of unopposed estrogen. There's no progesterone. Remember, progesterone reduces the risk of endometrial cancer. So, what should you do? You have to ensure that she gets at least 4 cycles every year. That is, every 3 months, give her what? Give her progesterone every 3 months for withdrawal bleeding. Make sure she bleeds every 3 months, and this will reduce the risk of endometrial cancer. So, this is what we do in PCOS. First treatment is always optimize the BMI, and then you see what her symptom is, and if she can't optimize her BMI or if you want to help her out with other things, you can give her these things. Now, ovulation induction in infertility, treatment of anovulation in infertility, what do we do? The drug of choice is letrozole, yes, but there's another drug also called clomiphene. Clomiphene is, what is it? It is a aromat, it is an anti-estrogen. It's an anti-estrogen. So it's going to reduce estrogen levels. That is going to cause FSH levels to go very high. And that is going to recruit multiple follicles and cause multifollicular development. So this increases the incidence of twin, triplet, quadruplet pregnancy because of more multiple follicles being stimulated. So it's a higher incidence of multiple pregnancy. There's a higher incidence of ovarian hyperstimulation syndrome. And that's why it is no longer the drug of choice. The drug of choice is now letrozole. Letrozole is also an anti-estrogen. It is actually an aromatase inhibitor. Right. So what is aromatase? Aromatase is the enzyme which converts androgens to estrogen. If this enzyme is inhibited, estrogen is going to go down, FSH is going to go up, but it's not as strong an estrogen inhibitor as clomiphene. So it causes only monofollicular development. Only one follicle will form like a normal menstrual cycle. And that's why it is the drug of choice in PCOS. You don't want twins and triplets. Those are high risk pregnancies, right? You only want one baby. So monofollicular development, that's why letrozole is the drug of choice for ovulation induction in PCOS. Other drugs, second line drugs you can give for ovulation induction is you can directly give FSH. You can directly give FSH, or you can give LH, or commonly we give a combination of FSH plus LH. This is called as HMG, human menopausal gonadotropin, right? So these are drugs which can be given as second line. Another second line option is to do a procedure, and this is called as laparoscopic ovarian drilling. Remember, it's only for women who have infertility, who have not responded to letrozole or clomiphene. Only for these patients are we doing this procedure, for no other indication, only for infertility. What are we doing? We're making multiple holes or multiple drills in both the ovaries. This is reducing the ovarian bulk. This is reducing the androgen levels in the ovary, and it's causing spontaneous ovulation to happen. Here, important is a rule is called rule of four. You don't want to overdo the procedure. If you overdo the procedure, you're going to damage the ovary. So you want to do the rule of four, where you do four drills in each ovary to a depth of 4 millimeter. You switch on the energy for 4 seconds at an energy power of 40 watts. 4 drills, 4 millimeter depth, 4 seconds, 40 watts is the rule that is done for laparoscopic ovarian drilling. Okay. Now contraception. Contraception is a very, very important topic. Contraception we'll discuss the very high yield stuff. Question usually comes, one or two questions come from here. In natural contraception, remember lactational amenorrhea method, or LAM, is what is usually asked. LAM is beneficial, or I would say effective, if the Bellagio criteria is met. What is the Bellagio criteria? There are three Bellagio criteria in the Bellagio criteria: that the woman should be having amenorrhea, her baby should be less than 6 months old, okay, and she should be exclusively breastfeeding, because the premise of LAM is that high prolactin levels are going to inhibit ovulation. That's why she remains amenorrheic. So if she's exclusively breastfeeding, the prolactin levels are high, and she's amenorrheic, and within 6 months of delivery is when you tell her that LAM is an effective method for contraception. Once these criteria are not met, you have to tell her she has to use additional methods, because she can get pregnant. Okay, so Bellagio criteria: amenorrhea, less than 6 months old baby, and exclusively breastfeeding. Now, intrauterine devices, what should we know? We should know that there are three generations. The first generation, this came as an image-based question last exam, is the Lippes loop. It's an unmedicated device. Okay, it's common one available in India was the Lippes loop, no longer available now. Second generation are the copper containing ones, and third generation are the hormone containing ones, commonly levonorgestrel containing intrauterine device, right? Now this is copper T380A. A means copper on the arms, 380 means the amount of surface area covered by the copper. Lifespan is 10 years. Okay, this is copper T375, also called as the multi-load. This lifespan is 5 years. So 5 years lifespan is the multi-load. Now, very important question which usually comes in the exam is the timing of insertion. Remember, the first important time you can put in a copper T is in relation to delivery. So, in relation to delivery, we have something called, the first is called a PPIUCD, or post placental intrauterine copper device. Post placental means if you're inserting it within 10 minutes of placental delivery, then only will you call it post placental. Okay, post placenta has come out, 10 minutes के अंदर you put the copper T. This is the best time. If you are in relation to delivery, PPIUCD is the best or the ideal time, right? Now, suppose the patient wasn't sure and said, Ki, I haven't decided, let me think and I'll tell you afterwards. So, the next day she tells you in the ward, Ki, ab dal do. That is no longer called as PPIUCD. It's called as early postpartum insertion. And this can be inserted till 48 hours of delivery. So, after 10 minutes, till 48 hours, it is called as early postpartum. You won't call it as post placental. Post placental is only within 10 minutes. You can also put in a copper T intra-caesarean. At the time of a caesarean delivery, it is called as intra-caesarean. Okay? And the last is called as late postpartum. Late postpartum means after 6 weeks. That means you are not going to insert a copper T after 48 hours or less than 6 weeks, because at this time the uterus is rapidly involuting. There's a very high chance of expulsion if the copper T is put after 48 hours and less than 6 weeks. So, this is in relation to delivery. When all can you put in a copper T? Okay. Second is interval insertion. Interval insertion means that no, delivery is nothing to do with delivery. She's just come. She's a woman. She delivered 2 years back. She wants a copper. So when is the best time? The best time to put in a copper is post menstrual. Post menstrual means immediately after her periods. Why is it the best time? Because you're sure she's not pregnant. Although the government of India says you can put it at any time of the menstrual cycle, as long as you are reasonably certain that she is not pregnant. So, how can you reasonably be certain she is not pregnant? Is if she's post menstrual. If she comes premenstrually, you can put in a copper T, but you're not certain enough, है ना? So it's best to avoid premenstrual. Best time is post menstrual. You can even put during periods also. During periods भी डाल सकते हो, post menstrual भी डाल सकते हो, premenstrual भी डाल सकते हो. But premenstrual is the scary part. You don't know. Maybe she's pregnant. You don't know. So always avoid premenstrual insertion. Okay. The third is post-abortal. Following a first trimester or second trimester MTP, you can put in a copy. And fourth is as an emergency. Emergency means emergency contraceptive within 120 hours of unprotected intercourse. You can put in a copy. Why 120 hours? Because fertilization, the day fertilization takes place, implantation takes place 5 days later. So, implantation starts on day 5 of fertilization and is complete by day 11 of fertilization. So, copper T acts by preventing implantation. So, that's why within 120 hours it can act, because it's going to prevent implantation. Implantation starts on the 5th day after fertilization. These are the absolute contraindications for putting in a copper T. You can't get pregnant, so pregnancy and IUCD. If you have an IUCD, I stands for infection, U stands for undiagnosed genital bleeding, C is for cancers. Which cancers? Of the genital tract. So cervical, vulval, vaginal, uterine, that is endometrial, and choriocarcinoma, gestational trophoblastic neoplasia. Anything to do with the genital tract, don't put in a copper T. And D stands for distorted cavity. Maybe she has a didelphys uterus, maybe she has a unicornate uterus, maybe she has a large submucosal fibroid which is distorting the cavity. So don't put in a intrauterine device if she has a distorted uterine cavity. Also, one more you can add here is after 48 hours, less than 6 weeks following delivery, also you will not put in a copper T. These are the absolute contraindications for putting in a copper T. Now, important points in hormonal contraception. In hormonal contraception, remember we have mainly two types. We have estrogen plus progesterone containing contraceptives. Then we have progesterone only contraceptives. E plus P contraceptives are the pills, right? Then there is the ring and there is the transdermal patch. And progesterone only, again, you have the progesterone only pills. We have the Antara, that is the injection depomedroxyprogesterone acetate. Then we have the implants, and then we have the Mirena, LNG, IUS. So these are the types of hormonal contraceptions that we have. Now, when we have estrogen, combined contraceptives, estrogen plus progesterone, remember the primary mechanism of action is suppression of ovulation. That is why they are protective for ovarian cancer. They suppress ovulation. This is the primary mechanism of action. The absolute contraindication, remember, estrogen is bad for thrombosis. It is known to cause thrombosis. So, whenever there's a risk factor for thrombosis, you will not give. For example, if she's a known smoker, you will not give her the combined pill because estrogen can cause thrombosis. Already, she has a risk factor. You're not going to combine two risk factors. If she has a past history of deep vein thrombosis or pulmonary embolism, if she's a known case of ischemic heart disease, if she's a known diabetic with vasculopathy, if she has uncontrolled hypertension, if she has a history of prolonged immobilization, that is, she's had major surgery or something, she's not mobile too much, you will not give her the copper T. If she is within 6 weeks postpartum, whether she's breastfeeding or not doesn't matter. The immediate puerperal period, 6 weeks, she's at high risk of thrombosis. Remember, pregnancy and the puerperium are hypercoagulable states. So, all these will increase the risk of thrombosis. So, you will not give her the copper, you will not give her the combined pill. Right? What else? Remember, the pill is bad also for estrogen is bad for the liver. So, any active liver disease or a history of hepatocellular carcinoma, you're not going to give estrogen containing pills. Also, it's bad for breast cancer. So, if there's a history of breast cancer, you're not going to give estrogen containing pills. Also, it's bad for breastfeeding mothers. So, within 6 months, if she's breastfeeding, you are not going to give the pill because it reduces the quantity and the quality of the breast milk. It is also bad for women who have migraines. You're not going to give women who have migraine the estrogen containing pill. So these are the absolute contraindications for combined contraceptive pills because the bad thing is the estrogen. The harmful one is the estrogen. I don't want to give estrogen to women who are at risk of thrombosis, breast cancer, liver disease, and migraine, and breastfeeding mothers. In breastfeeding women, remember, they are contraindicated till 6 months of breastfeeding. But after 6 months, even if she is breastfeeding, it is safe to give the pill because after 6 months, the baby is going to be weaned. Breast milk is not as important and it can be given. The benefits of giving, that is preventing pregnancy, that is much higher. The benefit is much higher than the risk of little bit reduction in breast milk. Before 6 months, baby is exclusively breastfed, so you don't want to mess with the milk. But after 6 months, it is safe to give even in breastfeeding women. Remember this, it is contraindicated only till 6 months of pregnancy. This we've discussed, it increases the risk of colorectal, endometrial, ovarian cancer. It reduces the risk. My bad. Sorry. It reduces the risk of colorectal, endometrial, and ovarian cancer, and it increases the risk of breast cancer and to some extent cervical cancer also. Okay. Now, vaginal rings, what is important in the vaginal ring? You should know it contains ethinyl estradiol. Okay, plus it contains a progesterone called as etonorgestrel. Importantly, remember the ring is worn for 3 weeks and then 1 week break. So, like the pill is taken daily for one day, daily, one tablet she takes for 3 weeks, then 1 week break. Similarly, the ring is worn for 3 weeks, and then 1 week break is given when she will get her period. The patch contains ethinyl estradiol plus the progesterone component is called as norelgestromin. Remember the patch, one patch every week. So 1 week new patch, then 1 week patch, then 1 week patch. So every week she changes the patch. She wears it for 3 weeks and then 1 week patch free. She doesn't wear the patch for 1 week when she will get her withdrawal bleeding. Progesterone only contraceptives the Antara is very important. Antara contains depomedroxyprogesterone acetate, which contains 150 milligram. It is given as a deep intramuscular injection. Okay. And it is given once every 3 months. Right. Now, important with DMPA is the main problem is it causes irregular bleeding and it has a delayed return to fertility. That means if she wants to get pregnant, it will take time. It will take a good 6 months to a year for her to get pregnant. That is the problem with Antara. A new version of Antara is now available. I haven't put the picture here, but a new version of Antara available is the subcutaneous Dimpa. Subcutaneous Dimpa is 104 milligram of the same injection DMPA, and the advantage of subcutaneous Dimpa is she can self administer the injection. She doesn't have to go to the hospital or the health center. She can inject herself at home. So that's the advantage of subcutaneous Dimpa. The only difference is this is 104 milligram and depot is 150 milligram. IM injection is 150 milligram. Implants, may remember, these are the most effective. They are progesterone containing, and amongst all the temporary contraceptives, they are the most effective contraceptive. And the one available in India, which was introduced in 2023, and very soon it's going to be freely available throughout the country, is something called as Implanon Next. Now, Implanon Next is it's a subdermal, so just below the skin it's inserted, and it is very important. You should know it contains 68 milligram of etonorgestrel, and it is has a lifespan of 3 years. And unlike Dimpa, it has or Antara, it has a quick return to fertility. As soon as you remove it, the patient is fertile within 24 hours. So quick return to fertility, very, very effective contraceptive, 3 years, implant non-next, 68 milligram etonorgestrel. This is important. Just a second. All right. So, okay. So this is Implanon Next, what you should remember. And the only problem with Implanon Next is it requires training to be inserted and training to be removed. So that is the disadvantage, that it's a little difficult to insert, little difficult to remove. But other than that, it's a very good contraceptive. Mirena, this is how Mirena looks like. It's completely white in color. It doesn't have any copper or anything like that. This contains levonorgestrel. It contains 52 milligram of levonorgestrel and 20 microgram is released every day. It is like any other intrauterine device, the same contraindications, the same timings of insertion. But remember, it is not used as an emergency contraceptive. Like copper T, we can use as emergency. This we can't use as an emergency contraceptive. In fact, more than contraceptive, we use it for non-contraceptive benefits. What are the benefits or what are the uses of Mirena? Mirena again will reduce bleeding. It causes endometrial atrophy. The primary mechanism of action is endometrial atrophy. So whenever there is and you want the bleeding to be reduced, like women who have heavy menstrual bleeding, women who have endometrial hyperplasia without atypia, women who have endometriosis, it will dry up all the endometriotic implants, women who have adenomyosis, women who have fibroids that are not distorting the cavity, you can put in a Mirena. So anywhere you want the bleeding to come down, we've discussed all these already. Heavy menstrual bleeding, endometrial hyperplasia without atypia. With atypia, you'll do a hysterectomy. Without atypia, you can put in a Mirena. Endometriosis, adenomyosis, fibroids, it will help in all these conditions. Because it's so expensive, we don't use it, in fact, for contraceptive. We use it more for these conditions commonly. Okay, so contraindications to Mirena are the same as contraindications to other intrauterine devices. You can't get pregnant if you have an IUCD. Very commonly asked question, what are LARCs? LARCs are long-acting reversible contraceptive devices. You have three I's in this. We have injections, intrauterine devices, and subdermal implants. So the three I's are what are there. So injections, devices, and implants. Very important to remember. So the three I's. Okay. Now, what is this? This is Centchroman. This is the made in India contraceptive. We have, what does it contain? It contains orniloxifin, orniloxifin, which is a selective estrogen receptor modulator. It was earlier available by the name Saheli. Now it is available by the name Chaya. It is a made in India thing, so very commonly asked in the exam. Important to remember, it's a non-hormonal contraceptive and it basically is given twice. How is it given? That's important. So it started by given twice a week for the first 3 months and then weekly thereafter. So initially we give it twice a week and then we give it every week. This is important to know. Also remember the contraindications to Centchroman is it is not given in women who have polycystic ovarian syndrome. It is not given in women who have any allergy to the drug, in women who have any active liver disease because it is metabolized in the liver, and those who have cervical intraepithelial neoplasia. So cervical CIN basically. It is not given in women who have CIN. These are the contraindications to Centchroman or Chaya. Okay. Now, again, very important emergency contraceptives. You can use the USPACE regime. USPACE regime means giving a high dose of combined estrogen and progesterone tablets. And these are effective up to 72 hours, but they cause a lot of vomiting. And hence, they are not preferred. They are not the preferred drug at all because they cause, giving high dose estrogen at one point of time will cause a lot of emesis, hence not preferred. The preferred drug in India is LNG. LNG is available by the name Easy Pill. 1.5 milligram single drug can be given up to 72 hours of unprotected intercourse. The world over, however, if overall it's asked not specific to India, then the best drug is the most effective drug is ulipristal acetate. Ulipristal acetate is also a selective progesterone receptor modulator. And a single tablet of 30 milligram is given. This is effective up to 5 days of unprotected intercourse. It is the best overall drug. But if in India they've asked you, the answer is LNG. It's called the Easy Pill. Intrauterine copper device within 5 days is effective. In fact, overall, the most effective is actually the intrauterine copper device. But amongst hormonal contraceptives, if they've asked emergency, then the most effective is ulipristal. And in India, the most effective is LNG. Intrauterine copper device we don't give for all for obvious reasons. It is for those women who are looking for a long acting. So she's come for emergency contraceptive, but she's looking for a long acting contraceptive also. Then a good idea is to give the intrauterine device. Now, before we end, because this was the last slide, I just want to quickly take you through MTP. MTP is an important, usually expected question from here. Okay, MTP, remember, as per the new MTP Amendment Act of 2021. What does this tell us? So, MTP Act of 2021, remember, there's a lot of confusion in this area, so that I'll tackle this before we break for the night. Is that MTP is um, uh, uh, can be done in three categories. If she's less than 20 weeks pregnant, we can do it for either maternal indication, fetal indication, that means the risk to maternal life, risk to fetal life by continuing the pregnancy. If there is the pregnancy is because of rape, or if there is failure of contraception, you can do a MTP till 20 weeks. And here you need the opinion of only one registered medical practitioner. This is as per the new recent most amendment. The second category comes if she's between 20 to 24 weeks. Here, certain indications only remain. One is if there is a threat to maternal life, this is continuing. If there is a substantial fetal anomaly, you can do an MTP. If there is a pregnancy because of rape, you can do an MTP. If the pregnancy is in a minor means it basically means rape only, but minor girls, they usually present late because they don't know or they're scared, so you can do an MTP till 24 weeks. If there is a change in marital status, say she has lost her husband, or she has a divorce, she can get an MTP till 24 weeks. Or if there is she's suffering from a severe disability as defined by law, she can get an MTP. And on humanitarian grounds, if the government declares war, or there is a natural disaster, or there is a earthquake or something like that, in under humanitarian grounds, the government can allow till 24 weeks. Here, failure of contraception is not there. It doesn't make sense. And other patients usually will realize they are pregnant before 20 weeks. Failure of contraception does not apply from 20 to 24 weeks. So, risk to maternal life, risk to fetal life, rape, minor change in marital status, disability, or in on humanitarian grounds, this is with the opinion of two registered medical practitioners. After 24 weeks, remember, after 24 weeks, you can do an MTP only for one indication. So, after 24 weeks, only one indication remains, and that is for substantial fetal anomaly. And I can't decide if that fetal anomaly is substantial, neither can the patient. Who will decide? The medical board will decide whether the fetal anomaly is substantial enough to warrant a termination of pregnancy. The medical board is at every district level hospital. There is a medical board constituted who consists, the members are a gynecologist, a pediatrician, a radiologist, and a doctor, an expert who's a doctor from that field. For example, if it is a cardiac anomaly, a cardiovascular surgeon or a cardiologist will be there. If it is a neural tube defect, a neurologist will be there, like that. So you have an expert from that field who will decide, and these four people will sit and decide whether she can go ahead with an MTP or not. So anyone above 24 weeks, only for fetal anomaly, that too decided only by a medical board. This is very, very important. Okay, so I think we can end here, and all the very best. OBG is very easy. It is very straightforward. In fact, all subjects, I can't speak for other subjects, but I can speak for OBG. OBG is one of the easier and very high scoring. So I mean, just use your the information that you have, and you will be able to answer 95% of questions. I can guarantee you will be able to answer with the information that I have provided. The few topics which you feel I've missed out, like I saw instrument